Yeah, I think we are live on YouTube, Dr. Nurul.
Mm, yes. Yeah, we
Oh,
are live.
okay. Good morning, everybody. This is Dr. Sonal Yerpude welcoming you all to the third day of International Orofacial Pain Congress 2024. This is an association with MedSkills and National Health Academy. Good, uh, Good morning to all the distinguished speakers and our patron, Dr. Davis Thomas, sir, who will be joining us soon. We had 2 days of session wherein we had our patron, Dr. Davis Thomas, enlighten us about what is the scope and exactly what this specialty of orofacial pain is about. Then we had a jury presentation, the paper presentation, and the jury for which was Dr. Ratin Das and Dr. Seema Rathi. And we had enthusiastic around 19, 20 participants this time who were eager to present their cases and delve into this orofacial pain world. And later on, yesterday was a running marathon, I would say, because we were scheduled with around 19 speakers. And finally, we had 17 speakers presenting over 10 hours. And the sessions were so engaging that the audience stayed back till the very last speaker. And we started with the topics that we touched yesterday were totally amazing in a way, because I got responses from the delegates, from the participants, that they have literally opened a new arena or no, new dentistry for them. So I'm sure this Congress, the theme for the Congress, what I was trying to achieve is making orofacial pain practice a daily routine practice for each and every dentist in and around India as well as abroad. So I think the theme is setting in its goal right now. In dentistry, pain is nothing new. We come across pain symptoms. Patients walk into our clinic for pain. They don't want the best of the implants or best of the restoration. They don't know about it. They come to our practice when they feel pain. And it becomes our responsibility, and the responsibility is very great because these patients are chronic pain sufferers. We as dentists, we know how to treat odontogenic related pain, and we are taught very well. But there are symptoms and there are signs at times which show, and they are so multifactorial that we also get confused that what is the patient exactly suffering from. There are patients who are suffering from years. Yesterday, there was a case presentation by Dr. Chinna where the patient was suffering for 25 years. Can you imagine the pain, the suffering the family and the person involved has gone through? A debilitating condition wherein you cannot comb your hair, a splash of water starts or triggers the pain, and these conditions are very real. One out of 100 patients, imagine if walk into your practice having neuropathic pain conditions or conditions related to temporomandibular joint disorders or mimicking conditions which are showing phantom pains in teeth or pains where you are not able to diagnose them. Imagine the situation will be so sorry for the dentist as well as the patient. We as orofacial pain specialists have seen such patients, and lucky that our knowledge has increased tenfolds by attending sessions with Dr. Davis Thomas and other eminent speakers and eminent fellowship speakers who have enlightened us that there are different causes, not only odontogenic cause for which the patients will walk into our practice. And that's how the curiosity for orofacial pain practice should be developed, that there is something else. Before I touch this tooth, I'm seeing a tooth which is very healthy. There is absolutely no reason for me to touch this tooth or start a root canal procedure or start the scaling procedure on this tooth. Do I really touch this tooth? Before you do something irreversible, you need to increase your knowledge, increase the parameters with which you are screening these cases. And this Congress, the whole idea, the theme started with this being this November being TMG Awareness Month. So dentistry is no more limited only to the teeth and the pink and white tissues. As we say, we balance the triad, the jaw joint, the muscles, and the teeth. Similarly, the knowledge also has to be encompassing in a way that we are including all these parameters in our daily screening. How many of us take proper clinical history? How many of us ask the patient what is their HB level? What is their vitamin D3 level? Time has come that we become a physician in a way that we are treating the person as a whole and not just the tooth. Dr. Ratin Das and Dr. Davis Thomas on the day one were emphasizing the need to do a holistic or systemic treatment for our patients. And yesterday, it's all the speakers. If you are lucky enough to get the YouTube link, please go back and see how they have decoded certain factors which everybody in our daily routine practice come across, and we generally treat them as a regular dental case, and we are sorry that we are not able to help them. So now a simple little thing as trigger point injection, which can relieve 25-year-old cases of pain. So that's a miracle actually. Magics don't happen in one day. So the treatments will also not happen in one day. That is the whole theme behind understanding orofacial pain study. This Congress seeks to address the challenges that this multidisciplinary and multifactorial orofacial pain conditions that we come across, and the challenges that we are facing day to day. So I hope today's session with our 18 speakers, I think we have 19 speakers today, and I hope it will enlighten you and increase the curiosity to understand this topic very well. And those who are already practicing orofacial pain practice or screening their patient for orofacial pain, at least I'm sure you will have certain take-home points, because all of you are here in for treat today. And the speakers are the topics are going to really make you think twice now before you touch any case which is showing non-odontogenic origin of pain. So on that note, and there's one more person I would like to thank uh, because he's been the backbone of this whole Congress, and that is Dr. Noodle, who has been at the backstage and always helping each and every speaker or the delegates also. So thank you, Dr. Noodle. And with only one mission in mind, that we need to have a standardization strategy for managing orofacial pain cases, for diagnosing orofacial pain cases. Let's begin this day 3 of our Congress. Welcome, everybody. Welcome to International Orofacial Pain Congress 2024. This is Dr. Sonal Yerpode. With that, I would like to welcome our first speaker for the day, Dr. Nivedita Kumar. Dr. Nivedita, can you switch on your camera, dear?
Yes, I'm on.
Okay. Dr. Nivedita Kumar is a board certified. I think you are a diplomate also, doctor. Yes,
Right.
yeah, because I don't have that information about you. She is a diplomate in American Board of for dental sleep medicine and orofacial pain. And one thing about Dr. Nivedita I would like to emphasize is that she is the director of NK Snoring and Sleep Apnea Center, and it is one of its kind. When I met her, she was showing her appliances and all that she does in her lab, and I was really spellbound. I was like, is this possible, like, at a dentist level, and having a lab of her own dedicated totally towards sleep medicine? So this was something new, and every dentist who would want to have some career in sleep medicine should attend Dr. Nivedita's course. Her center is in Bangalore, that is under NK Sleep and Breathe Academy. And her core practice is focused on sleep medicine and management of sleep-related breathing disorders in adult and children. So Dr. Nivedita, welcome to our forum, and it's a pleasure having you here, and always a pleasure talking to you also. So topic for the day today for you is OSA burden on pain. I'm sure it is a fellowship topic in itself, and you will be doing justice in just 30 minutes of this forum time. Welcome, and the stage is all yours. Can you just share your screen, dear, so that I can tell you about the screen?
And thank you so much. So I need a share.
Yeah, please go ahead with share
Symbol.
screen.
Actually, it's I've not been given the co-host permit.
Yeah. Yeah, Dr. Nivedita, can you just till that time, can you tell our audience what sleep dentistry or sleep medicine is all about? Like, uh, before you start, I know it's this question I had not planned for you, but then I would like to
Right, no
know
issues.
what does a dentist play role in managing the sleep medicine part? So
Right. So when you look
elaborate a
at
little bit.
sleep disorders, there are a whole spectrum of different sleep disorders. Within that spectrum, as dentists, we are looking at one is sleep-related breathing disorders, and then airway issues. So within sleep-related breathing disorders, we're actually looking at screening the OSA cases, diagnosing and management of all these cases. So when I say OSA, it's again a broad term. We are also looking at the initial part of the spectrum, including snoring, obstructed airway issues. Then we look at OSA, and then also on a few other spectrums like UARS, upper airway resistance syndrome. So we look at all those different aspects. And one of the main things with dental sleep medicine is knowing how to screen, recognizing what patients that we should be looking into. I would say that with a quote unquote, because technically, all patients need to go through sleep screening. All the patients, you need to look at craniofacial features, you need to look at their sleep history, a whole gamut of things for us to actually address what's going on. As you said, it's all about holistic approach to the patient. So, Sonal, you're muted. And I think I have my share screen on right now.
Yeah, please go ahead and share your screen.
Is my screen on?
Yes, doctor. Can you go on
Presentation
the
mode?
presenter? Yes, please go ahead, doctor.
Okay, all right. So the topic that I'm going to talk about is OSA's burden on pain. So initially, when I had a conversation with Dr. Sonal regarding the topics, she suggested that I talk something about sleep. And she also mentioned that I'm known as the sleep dentist in India. So I do take that title with a lot of humility. And that's what I'm going to be talking about. So before I start, I'd like to call out a thanks for the IOPCON team, Dr. Neural, Dr. Sonal, and the MedSkill team. So thanks for giving this opportunity to be able to share my clinical experiences in dental sleep medicine. So before we start learning about OSA's burden on pain, we need to understand what OSA is about. So OSA is obstructive sleep apnea, which is a respiratory event that occurs during sleep. Now, this is characterized by brief, partial, or complete collapse of upper airway during sleep. So what the obstructive events lead to is cessation of breath, and also it causes increased respiratory effort and drop in oxygen saturation and microarousals from sleep. So when I say OSA, OSA is not a solo phenomena. It is actually part of a whole different group of sleep disorders called sleep-related breathing disorders. So within sleep-related breathing disorders, we have obstructive sleep apnea, central sleep apnea, hypoventilation disorders, hypoxemia disorders, and then the isolated. Now, this is a classification made by ICSD 3 back in 2015 or so, right? So we as dentists, we will actually be concentrating on what's in this blue slot here, which is obstructive sleep apnea. Now, also when we look at treatment and management and recognition of obstructive sleep apnea, the adult OSA and pediatric OSA do present with different characteristics, and their management protocol is different. One thing I do need to point out is when we talk about OSA as a sleep disorder, we are looking at something that's already in the funnel, like the OSA, the UARS, and the snoring, which are already happening during the nighttime, right? But we need to be cognizant of the fact that a lot of these phenotypes who have OSA also exhibit a lot of dysfunctional breathing when they were awake. So somebody with mouth breather, somebody who has an obstructed airway, blocked off nose, deviated septum in the nose, all of those guys are huge risk factors for forming SRBDs. So we as dentists, we should actually be looking a lot more closely into the pre-SRBD spectrum, meaning the mouth breathers, the craniofacial development and all that. So when we look at sleep-related breathing disorders, we're looking at two different phenomena. One is breath and the other is sleep. So as dental sleep medicine specialists, we should know the physiology of both of these, and we should know the pathogenesis of what's going on when we during sleep issues and breathing problems. So let's look at these things, right? So when we look at sleep stages, there are 4 different stages that we go through when we are sleeping. We're all aware of this, the N1, N2, N3, and REM sleep. Now, the significance for us, as far as today's topic is, N3 is called a restorative sleep. So this is where the tissue repair, cell regeneration, growth factors, body hemostasis, and immune system works. And then when you look at the REM, that is where the brain activity is more increased. And that's where the lymphatic system works the best. So then we also have percentage of each of these sleep stages. The N1 is about 5%, N2 50, N3 20, and REM is 25%. So if the person has a full architecture, proper architecture of sleep, they go into all these sleep stages and according to this percentages. Now, what is the relevance of these different sleep stages in SRBD, right? Again, when we look at what's related to sleep OSA, we are looking at N3. If a person does not get enough duration of N3, there is reduced body restorative sleep. There's also reduction in their immune system. The body hemostasis control is out of whack. The HPA axis, you have more of cortisol production. Same thing in REM. If the person doesn't get enough of REM sleep, there is less of brain restorative sleep. And this is where the mood regulation, the memory consolidation, all those get affected. So when we look at effects of sleep on general health, we can categorize them as physical health, mental health, and health-related quality of life. So when we look at physical health, as we just talked about, sleep is important in cell response, in the immune system, hormone function, lymphatic system. In the mental health, it also helps regulate mood, irritability, depression and anxiety issues, and also importantly, regulates the autonomic nervous system. So that's why sleep is very important as far as general health. What are the effects of poor sleep? When we do not get poor sleep, so let me go back a step. When we say poor sleep, right, there's either poor quality of sleep, where a person is sleeping for sufficient hours, but does have very disturbed or fragmented sleep, or also they may not have enough sufficient duration of N3 and REM. Or when I say poor quantity of sleep, then they're not sleeping enough. And this may be seen in disorders like insomnia. So when you look at poor sleep, the effect of poor sleep, physiologically, we do have hormonal imbalances, poor immune system, increased inflammatory response, and then also mood imbalances, reduction in cognitive function, and so on. So now that we've learned about sleep, let's look about breathing. Breathing, when we are not breathing properly, what happens is there is an imbalance of all the blood gases. Your O2, CO2, nitric oxide, there's bicarbs, there's an imbalance of all these. And what it leads to is when there is improper breathing, you have hypoxia, which is low O2 in tissue, hypoxemia, low O2 in blood, hypercapnia, which is increased CO2, there's activation of sympathetic nervous system, there's increased cortisol production, and also increase in the stress of oxidative stress, cardiac stress, and metabolic. So when you look at pathophysiology of OSA, right, it's a cyclic process that goes on all night. So first there is airway collapse, there's cessation of breathing, there's hypoxia or hypercapnia, and then there is arousals because the brain doesn't have oxygen. There's arousals, there's CNS activation, then you have muscle tone increased, there's opening up of the airway, and then the person resumes breathing and CNS relaxation happens. So after person resumes breathing, they're able to go back to sleep, but it's a vicious cycle. What happens during that time is there's increased sympathetic drive, disturbance in cardiovascular hemostasis. As we discussed, oxidative stress, inflammation, endocrine dysfunction, and of course, hypoxia and hypoxemia occur. On the sleep spectrum, we see a lot of sleep fragmentation, neurocognitive effects, dysfunctional sleep, or disturbed sleep architecture. So if you see some of the common symptoms of OSA and then pain patients, we actually see a lot of shared symptoms like fatigue, unrefreshed sleep, memory fog, depression, anxiety. All these are common to both OSA and pain patients. And of course, we know that OSA has a lot of systemic comorbidities. So I usually say from head to toe, OSA affects everything in the body. So when we are talking about OSA, there is another phenotype of OSA that we need to be aware of, which is upper airway resistance syndrome. What happens in UARS is when there is upper airway obstruction, the person puts in an increased respiratory effort to breathe. So what this causes it causes sleep arousals, which are called respiratory effort related arousals. And this results in fragmented sleep and then in turn causes sleepiness and fatigue throughout the day. So some of the characteristics of UARS are, it's more common in younger adults. And also the person doesn't have to be obese or overweight. It's also common in less overweight people. Some of the other characteristics, as we discussed, are they have excessive daytime sleepiness, morning headache, fatigue, also a lot of sleep disturbances, fragmented sleep, unrefreshed sleep, frequent awakening, and also sleep parameters. They may be more prone to sleep bruxism or restless leg syndrome. And then when you look at their comorbid conditions, this is where we are looking at as far as OFP people. UARS does have a lot of comorbid conditions, including functional somatic syndrome associations, depression, anxiety, chronic fatigue syndrome, fibromyalgia, IBS, myalgia, TMD, and GERD. So if you look at this list, again, we see a lot of commonality with our OFP patients. And PSG also, you have a lot of PSG parameters that are different from OSA. Another thing we need to know about OSA is there is a sex difference in how it is clinically present. Men typically have this classic symptom of snoring and apneic events, whereas in women, it's typically present as insomnia, headache, irritability, or fatigue. Again, this is what we are seeing, right, with all our TMD OFP patients. So let me go through a small clinical case. 30-year-old female with a chief complaint of pain in jaw, the right side. She had a history of migraines, history of septoplasty and turbinectomy at age 25. So when we see these patients, of course, we take a history of the chief complaint. But now, because we're all OFP spectrum field, we should be looking at a detailed history now, detailed history of the migraine events as to what's happened, detailed medical history and comorbidities, and also importantly, detailed sleep history. So this particular patient came with a history of unable to sleep properly, reports sleeping only 4 or 5 hours, average morning headaches, teeth grinding, and snoring and EDS. So, and then we need to do a clinical examination, right? So before I knew more about the dental sleep medicine and the effect of sleep history or the effect of improper sleep on the systemic effects, I would have probably just managed this patient symptomatically for TMD, or maybe even given her a night guard to manage the teeth grinding. But knowing better, we would want to pursue this and see what else is going on behind the scenes. So that's where we come in, as far as when we do clinical examination, we have to screen for a lot of other features like the posture, craniofacial features. So if you see this patient on the right side, she has a dolichocephalic face, a steep mandibular angle. All these are characteristics of a narrow upper airway. So this is a red flag here. Then we also look at breathing patterns. This patient again has mouth breathing issues. Airway patency is where we look at nasal examination, the oropharyngeal area. We do the TMD, we are all familiar with this part. And intraorally, as Sonal said, we are looking at beyond the 32. We have to look at the soft tissue that's gone beyond the 32. So we're looking at tongue tone, posture, any tethered tissues, oropharyngeal crowding, are all features that we look at. And then in the diagnostics, we have to decide when do we do sleep studies. And if we are doing sleep studies, what level of sleep studies to prescribe is something we need to know before we just put in a prescription. Then we have a blood panel, blood sleep panel that we do recommend for patients with positive sleep history. So when we look at sleep study, there are different levels of sleep study, which you probably know, the level 1, 2, 3, and 4. Normally, we do the level 1 studies where we have about 20 electrodes that are placed on the patient when he's sleeping. And the study is done when the patient is sleeping. So we have these electrodes like the EEG, EOG, and EMG, the chin EMG, which gives us information about the sleep staging, on the sleep efficiency, sleep latency, and all that. Then we have electrodes that go around the nasal and the mouth, where they're called nasal thermistor transducer. Or we have these belts, which are called plethysmography belts, and pulse oximeter that we're all aware of. So these 4 sensors give us information about the respiratory flow and the oximetry data. Then we have ECG that gives us information about cardiac, and leg EMGs, which gives us information about movement. So this is a sample of how we hook up the patient before our sleep study. This is one of a patient that we have done. And when you see all these sensors that are hooked up, you'll wonder if the patient is able to sleep with all these gadgets that are all around him. Surprisingly, yes, the patients do sleep, and we do get good data as to what's going on with their physiology when they sleep. Now, the information that we need or that we get in sleep studies are sleep-wise. We get sleep stages, sleep architect, efficiency, and arousals. In the respiratory parameters, we are getting information about snoring, apneas, hypopneas, flow limitations, duration of events, RARAS, and oximetry data. When we look at cardiac information, we are getting heart rate, cardiac arrhythmias, or HRV. And leg movements, we get information about sleep-related movements. Bruxism, we're getting information about RMMA, rhythmic masticatory muscle activity. And here, the difference is the EMG sensors actually have to be placed on masseter or temporalis, not on the chin. So a lot of sleep flags are not aware of it. So if you do get a sleep study, if you do suggest a sleep study, I would recommend you talk to the sleep technician, make sure these things are placed on the muscles of masticatory muscles. So after you do your sleep study, this is the raw data that you get. So you get information, they're all in wave activity. So you get information about how the eye movements are, the brain wave activity, and this particular here, which says flow, shows us how the respiratory flow is. So here the patient is breathing, 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 stops, breathing, 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 stops again. So that's how the respiratory flow is, apneas and hypopneas are counted. And of course, we get the SpO2. So once you see the raw data, score the sleep study, then you can pull out a report. Report gives you information about the sleep stages, the respiratory summary, arousals, if any, the oximetry data. So coming to this particular patient, what we found is in her PSG report, that is a sleep report, her sleep efficiency was 68.6, which is very low. The different stages of N1, N2, N3, and REM. So we see REM was only 8.7, N3 was 12.5, which is again low. She had apneas, more of hypopneas. Her RERAs were 56, and all of them were during the REM, non-REM sleep. So her AHI is apnea hypopnea index is 18 and RDI is 29. Her arousal index was 47 and wake after sleep onset, that's WASO, was 126 minutes. So when you do sleep medicine and when you start looking at sleep reports, you should be able to interpret all this data. You should know what each of these mnemonics mean, what is the clinical significance. So when I say LSAT, that is the lowest saturation, which in her case was 88. T90 is duration of time where the SpO2 was below 90, which was 44 minutes, and the ODI. So all in all, her clinical, after all the diagnostics and all that, her clinical diagnosis was myofascial pain, active stage, migraine, moderate obstructive sleep apnea, and then we share the deficiency. So how do we manage this case, right? So before I, as dental sleep medicine, jump into a mandibular advancement device, I have to make sure she's stabilized in all the other aspects. So first is we control her myofascial pain with trigger point injection and physiotherapy. Because she does have issues with sleep, sometimes we also have to make sure it's not insomnia based and go through sleep instructions, cognitive behavior therapy for her. Then we put her on all the supplements to counter her deficiency. Biofunctional therapy is very important in management of OSA cases. This is where we do all oropharyngeal exercises. And then we got, at the last, we actually go into mandibular advancement device. And there is a protocol that we follow. We need to know what kind of device to use. We need to know how far forward to take. We need to know how to titrate to the efficiency. Now, once it's titrated to the subjective efficiency, we do repeat a sleep study. So after titration, there are two things we look at. Subjectively, how is the patient feeling? Objectively, what does the PSG value show? So subjectively, we had reduction in the myofascial pain. Patient was sleeping better, wakes up refreshed, able to focus and function the rest of the day, no daytime sleepiness. In the PSG, we also found better sleep efficiency and architecture, reduction in AHI and all the other parameters, including oximetry parameters. So this is how we compare the before and after and make sure the patient has responded optimally to our treatment. 3-year follow-up, it's a telephonic follow-up that we do because the patient has moved out. So she continues to wear MAD, she continues myofunctional therapy, nasal hygiene, and sleep hygiene protocols. These are all protocols that we give to our patients, and this is what we teach in our academy. So subjectively, this patient has also been sleeping well, and more important, very few migraine episodes over the past 3 years. So something has happened to help the patient because she was not getting as frequent migraines as before. So let's take a look again at OSA and see what's going on. When you look at OSA, there are two main consequences of OSA. One is nocturnal intermittent hypoxia, which is low O2, and then sleep fragmentation, right? There are two pathophysiology issues that happen. So now let's look at what research shows. When our discussion for today, I'll confine to these topics, not the whole textbook of OSA and OFP. So we'll look at prevalence, we'll look at hypoxia and pain pathway, we'll look at sleep fragmentation and pain pathway, OSA and pain correlations, OSA and TMD correlations, and then the treatment of OSA. Does it have any effect on pain? Is what we'll be looking at. So when we look at prevalence of OSA, there are reports that show a wide prevalence, starting from 3 to 23%. In both men and women, there's a range of 3 to 49%. Now, there is a wide variation because of the methodology. How was it? Was it just a questionnaire based, or was it actually an objective screening with PSGs? So also when you look at ethnicity, OSA presents higher in Asian population because of our craniofacial features. And of course, the rates have increased worldwide because of awareness and the screening methods, and also obesity pandemic, which is high globally. Now, there was a recent study, 2024, just a month ago, by Dr. Abhishek Goyal from the AIMS group. What they did was, it's a blessed cohort study, and where they studied the prevalence of OSA in Indian population, and more importantly, in healthy Indian population. So these are not diseased people, not people from the hospital or so. And also importantly, they used objective data using PSG studies. What they reported was the prevalence of moderate to severe OSA was 30% in healthy individuals. So imagine this number. This is almost a third of our population of healthy individuals. And where do we see most of these healthy individuals? They're not in the hospital. They're all in the dental clinics, right? The walking, talking patients. So this is a heads up for all of us dentists to concentrate and start screening these sleep disorder patients. Now, the next part is, just a minute. If something is hidden in the screen. So what does the current literature suggest about OSA and pain? So there is quite a number of papers that have reported on this. I've just picked a few important ones. And I'll just give the gist of what these articles say. So one article, a lot of articles say that the prevalence of chronic pain in OSA patients is 51 to 76%. So that's a fairly high percentage. Another article says patients with OSA have decreased pain threshold, increased pain sensitivity, and spontaneous pain. And OSA and pain have bidirectional relationship. So continuing with that, OSA patients also complain of poor sleep quality, and chronic headache is particularly a common condition in patients with OSA. And as we discussed, OSA was associated with increased risk for pain, impaired health-related quality of life, and psychological problems. So to conclude, not so much to conclude, but a gist of all the studies, what we find is several cross-sectional studies have demonstrated that OSA is associated with a higher odds of many painful conditions such as headache, chronic musculoskeletal pain, fibromyalgia, rheumatic arthritis, orofacial pain, TMD, and chronic widespread pain. So let's look at the next category, which is intermittent hypoxia, which is what we see in OSA, right? And then pain. So what literature has published, what people have published is, hypoxia causes activation of your peripheral macrophages to release pro-inflammatory cytokines, which primes the nociceptors to go into a hyperalgesic state. Also, hypoxia causes formation of reactive oxygen species, which again sensitizes pain receptors. It increases inflammatory mediators, that contribute to neuronal pain and sensitivity. So then also hypoxia-induced carbonic anhydrase mediated dorsal horn neuron activation and induction of neuropathic pain has been suggested. And also hypoxia has been shown to upregulate the TRPV1 receptors. So what we need to look at is, collectively, all these data indicate that Chronic intermittent hypoxia upregulates pro-inflammatory cytokines capable of sensitizing nociceptors into hyperalgic priming phenotypes. Additionally, these primed nociceptors cause longer duration of pain through peripheral nervous system plasticity. That's one. And there are also studies that suggest in OSA, the hypoxia factor of OSA, and maybe not the sleep fragmentation, predominates the hyperalgesic priming phenotype. So these are two points that we need to take home. Then what about sleep quality and pain? So sleep and pain have unidirectional and bidirectional relationship, is what we know. Studies with experimental sleep deprivation have reported increased pain perception in healthy adults. And one more study has shown that poor sleepers have increased pain, catastrophizing, and elevated pain-related emotional distress. So this counters the psychosocial component of OFP. So now when we look at the different pathways where poor sleep can affect pain, there are different pathways, like in the CNS effect, poor sleep impairs endogenous nociceptor inhibitory function, which increases pain. Sleep deprivation causes myalgia, chronic fatigue, and impairs the descending pain inhibition pathways. There's also central sensitization phenomena that happens with poor sleep. The HPA axis gets dysfunctional when there is poor sleep. There is less of N3 sleep, which also causes impaired function of lymphatic system when there is poor sleep. Poor sleep causes dysfunction in the dopaminergic and serotonin pathways. These have been implicated in dysfunctional endogenous analgesia. Again, the other parts are, it does predispose a person to widespread pain and also neuroinflammation because of the inflammatory cytokines. So all these have been reported as far as the physiological effects of sleep. So what this means is these findings suggest that sleep disturbances might not only perpetuate CNS hyperexcitability in people with chronic pain, but may also serve as an etiologic factor. This may in turn start a vicious cycle where poor sleep lowers pain threshold, which then contributes to hyperalgesia and subsequent increased incidence and severity of insomnia. So when we look at both the intermittent hypoxia and sleep issues, then we can deduce the association between OSA and pain. So in OSA, we have intermittent hypoxia and poor sleep. In chronic pain situation, we have peripheral sensitization and central sensitizations with all dysfunction of or altered pain pathways that predispose a person to these issues. So this is where we need to see what the relationship of OSA and pain is. Now let's look at what some literature has proposed. Chong in 2023 published a paper about the prevalence and characteristics of pain in OSA patients. What they found was pain in OSA patients was much more than in healthy controls. And also the headache in OSA patients was much more, prevalence of headache was much more in OSA patients and healthy controls. And when they looked at different locations like the abdomen, head, chest, back, joint, and others, they found that OSA patients had a higher prevalence of headaches. So this is something that we need to keep a note of. And then what about OSA and pain intensity in young adults? So the Charokopas group did a study on pain intensity in young adults. And what they found was in patients with OSA, the pain intensity, the headache diagnosis, major depressive disorders, PTSD, substance abuse disorders was definitely much more in OSA patients than in patients without OSA. Then what about OSA, pain, and mood disorders, right? There have been a lot of studies about this also. And mood disorder is also a prevalent comorbid condition of OSA. It has been reported that 20 to 35% of OSA patients have depression. 14 to 32% of OSA patients have anxiety. most of these patients with chronic pain have worse mood symptoms when compared to patients without chronic pain. Also, in addition, depression and anxiety induce stress and increases the production of pro-inflammatory cytokines, which could worsen sleep. So taken together, all these findings suggest that mood disorders play an potential role underlying the association between OSA and pain. So another study by Larson's group found that 51% of patients with high impact chronic pain were diagnosed with clinical OSA. So this study shows patients with pain and what was the prevalence of OSA in those patients. There's another study that looked at people with OSA and what was the prevalence of chronic pain in those patients. So this study showed 37.9% of patients with OSA were diagnosed with chronic pain. So you're seeing this bidirectional pattern of OSA and pain, right? And also Charakopa's group also conducted another systemic study. This is actually a great study if you want to look further. This was published in 2018 by Charakopa's group. What they found is they looked at 12 studies to assess whether OSA is a risk factor for pain. What they found is the variability was there among study outcomes, because all of them were not positive. There were some negative factors also, but this they explained in terms of what parameters were used in the methodology. And what the review basically reported was there is increasing rate of OSA and chronic pain. And they did propose an association of OSA and increased pain intensity or decreased pain tolerance. Now, whenever we talk about OSA, there is another phenotype that we need to be aware of. It's called COMISA, which is comorbid insomnia and OSA. So this is a recognized phenotype that has been described more and more. What we know is about 38% of OSA patients overlap with insomnia symptoms. The study by Moon reported that up to 100% of patients with COMISA had chronic pain, which is high. And then also patients with primary insomnia have been shown to have lower mechanical and thermal pain threshold, reduced pain facilitation, and attenuated pain inhibition than normal controls. So this again is a factor in comorbid OSA and insomnia. So when you look at features, a lot of the features are common between OSA and insomnia, like arousal, sleep fragmentation, excessive daytime sleepiness, brain fog, cognitive impairment, and also depression, anxiety, and decreased quality of life are fairly common in both of these disorders. The other part is, what is the role of OSA, sleep, and TMD? What is the relationship, right? So when we look at studies, 51% of OSA patients have exhibited signs and symptoms of TMD compared to normal controls. Now, 36% of TMD patients have insomnia. Over 28% of TMD patients have OSA. So a prospective long-term cohort study suggested that OSA is a risk factor for painful TMDs in the long run. There was another cross-sectional study that showed patients with chronic TMD have poor sleep quality and increased risk of OSA. So most of you are aware of this OPERA study, which is a longitudinal study. What they found that OSA could predict the risk of developing TMD. And they also reported that patients with poor sleep quality were observed to be associated with an increased risk of developing TMD over the 3-year follow-up in their study. So what it means is OSA could be a risk factor for developing TMD. Poor sleep quality could also be a risk factor. Now, there are different studies that were done showing objective data of PSG parameters, and they proposed that TMD patients with myofascial or muscle components presented with a higher levels of sleep disturbances, respiratory events, and arousals. So the myofascial or the muscle component is pain is noted to be more in OSA patients. So the bottom line is, although a causative effect of OSA and TMD has not been proved, a strong correlation has been reported in multiple studies, and OSA may have a potential influence on the development and persistence of TMD. So that's an important point to remember. Regarding OSA and sleep bruxism, I may not be able to go into details here because of paucity of time, but do know that there are some phenotypes of sleep bruxism that do occur along with respiratory events of OSA. And we also know there are phenotypes of bruxism that may predispose a patient to more of TMD issues. So these are factors that you need to remember, maybe read a little bit more about this. Then coming to the effect of treating OSA, right? In general, when we treat OSA, we're looking at treating the respiratory parameters on the sleep parameters. So we know it improves sleep. We know it improves respiratory parameters. It improves oxygenation. It also affects systemic problems like hypertension, diabetes, libido, all the cardiovascular problems. It improves metabolic function, also improves quality of life, cognitive function, excessive daytime sleepiness. We know this for sure that it's been proved again and again, lot of publications. But what is the effect of OSA treatment on pain? There are a number of studies that do show that treatment of OSA does result in reduction in pain intensity. A lot of these studies are actually based on CPAP therapy, but still it is therapy of OSA. So when I say CPAP, CPAP is a machine that we wear, which basically pushes air into your oropharyngeal area and splints open the oropharynx, prevents it from collapsing. Another study, few other studies regarding CPAP and headaches. They found that treatment with CPAP markedly improved headache intensity and frequency. They also showed that in patients with migraine, CPAP therapy was effective in controlling migraine. And also implementation of CPAP led to 92% reduction in morning headaches. So all of these do indicate that therapy of OSA does reduce the pain. There's another study where they actually experimentally induced pain and used CPAP to gauge the latency when the patient experiences pain. So after 6 weeks of CPAP usage, they did report decreased pain sensitivity in these patients. Now, interestingly, after only 2 days of CPAP discontinuation, what they found is the apnea events returned, and the pain perception also increased significantly. So that does show that usage of CPAP and controlling OSA does again reduce the pain sensitivity. So this is another study which similarly showed that patients with OSA who were CPAP adherent were more likely to show improvement in headaches than patients that were intolerant or did not use CPAP. Similarly, another study which shows PAP and decreased chronic headache outcomes.
Dr. Nivedita, if you
Yes.
up in around 1 or 2 minutes.
Yeah. Okay. Done. So then we have mandibular advancement devices and headaches. So they also showed that patients who have used mandibular advancement devices are also caused reduction of headaches. They also found decrease in rhythmic RMMA in patients who used MADs. And also patients who used MADs, they found reduction in plasma cytokine levels. So again, all these do show effect in controlling of pain. they showed there was another study which used different treatment modalities like CPAP, MADs, surgery, and they all found that there was decrease in the pain intensity. So in conclusion, in patients with chronic pain, various studies have shown that treatment of OSA results in better pain, sleep quality, reduced hypoxia, and reduction in pain intensity. So when there is a high prevalence of OSA and high incidence of OSA in chronic patients, it obligates us as OFP specialists to screen, manage SRBDs and airway issues as part of the protocol for pain management. So there is a lot of data that is still not available. The studies have yet to improve. We need to know more about specific OSA and phenotypes. And our take-home message is breath and sleep are important parts of the OFP puzzle. All patients, when I say all patients, it's not just OFP patients, all your dental patients, everybody needs to be screened for sleep disorders. If sleep disorders are suspected, we should know what is the diagnostic criteria, what sleep studies to recommend, and know the clinical significance. In dental sleep medicine, we need to know the risk factors. We need to know different phenotypes of OSA patients and airway issues and craniofacial development protocols. So the management protocols, when you're looking at MADs as dental sleep medicine doctors, you need to be able to predict responders for MAD. You need to know which designs to use and the indications for MAD. So thank you all. This is my contact number. If anybody needs to contact, you can WhatsApp me.
Yeah, thank you, Dr. Nivedita. Sorry to interrupt you, but
No issues.
yeah,
Time
and,
issue, right?
yeah, time issue is there,
Yeah,
and
yeah.
there are many questions for you in the chat box.
Oh,
I
wow.
will not take in a personal question because the issue is that there are almost 10-15 questions now. So I
Okay.
would like you to sit back and answer these questions, and please wait and listen to other speakers also.
I will.
Some of them are your friends only. Dr. Sumit is the next
Definitely.
presenting. Yeah, so very sorry to have interrupted you.
No, that's issue. No issue at all.
Thank you so much, ma'am. This topic in itself, sleep medicine, the reason I kept it in the early half of morning of Sunday is that we really need to concentrate on our sleep, and we are disturbing their sleep to get up early in the morning.
Right.
But still, I said no. This topic needs a thorough, detailed discussion and the importance and prevalence. And you have done a superb justice, but very sorry to say
No
that
issues.
questions you
Yeah.
will have to take it in the chat box.
I'll go through the chat and look at the
Yes,
questions.
yes, it's
I'll
very
try to answer
overwhelming,
most
the
of them.
response that you have received. It's really overwhelming. And thank you, audience. And without audience, I say the conference is of no use. So thank you for being such active listeners. And because if they have queries, that means they are listening to your lecture very properly, or they are attentive. Okay, with that, I would like to call in our next speaker, that is Dr. Sumit Gupta. Dr. Sumit, can you switch on your camera?
Yeah, I hope you can see me.
Yes. You are living in heaven right now. I think that's your background, the place where you live. Okay. Dr. Sumit Gupta is a well-known orofacial pain specialist all over, not only in India, but abroad as well. I mean, actually, introducing him would be, it would take another 1 hour's lecture for me to introduce him. But in short, I will say he is Dr. Sumit Gupta did his master's in orthodontics from GDC Ahmedabad in 1998, topping the Gujarat University in all the branches of dentistry. He is a diplomate of American Board of Orofacial Pain and runs a successful multi specialty practice in Ras Al Khaimah, UAE, since 1999, and consulting in clinics in Dubai and UAE. And he is a speaker, mentor, and he's also the founder of, member and director of Indian Academy of Dental and Facial Pain. He is a well-known speaker for orofacial pain and sought-out speaker, I would say. So he's he's received many awards in 2023 as the orthodontist of the year, and one more recent award in 2023 October in Bangkok. And congratulations on all the awards and all the accolades you have collected all these years. So, Dr. Sumit, the stage is all set. Just a second, 1 second. There's a technical error. Okay. Welcome to International Orofacial Pain Congress 2024. And Dr. Sumit has a very unique topic for you all, the mystery cases. That's what he called them. In fact, he was not ready to tell me also what mystery cases he's going to be presenting. So this lecture will be a mystery lecture for me also. So welcome, Dr. Sumit, and the stage is all set for you. Dr.
Yeah,
Nivedita,
thank you,
you can
Sonal.
answer questions. Yeah, thank you.
Thank you, Sonal, for the kind introduction. It was quite an elaborative one. Really a pleasure being here, and good morning to you all. It's a real pleasure being here with MedSkill again. Last year we had NOPCON 2023, and here we are again with IOPCON 2024. I hope I'm audible and my screen is visible.
Yes, doctor, go ahead.
Okay, great. So I remembered having a word with Sonal somewhere in late September, early October, and we discussed on having another webinar or a program on orofacial pain. And thanks to and kudos to MedSkill and Dr. Nurul. Here we are with IOPCON 2024 with yet another program on orofacial pain. Dr. Sonal is doing a great job, an excellent program for 3 days. The foundation of orofacial pain was laid by our mentor, Dr. Davis Thomas, fondly known as Dr. T, who introduced us to the specialty of orofacial pain in India, UAE, and many parts of the world. And we are following his footsteps, taking baby steps, and with the kind of awareness which is coming up, and I'm sure orofacial pain will be a specialty soon in India, in UAE. Our talks are going on for recognizing it as a specialty. And one day, I'm sure instead of having these webinars, I'm sure we will be having a full-fledged on-site conference soon. So these days are not very far. And I'm here in, as Sonal was saying, in an emirate of Ras Al Khaimah, which is one of the 7 emirates in UAE, about 100 kilometers from Dubai. It's a beautiful place with pristine beaches, serene mountains, a beautiful desert. Yeah, there's a short video which will be playing. Yeah, so Dr. Sonal had a little bit of difficulty in pronouncing Ras Al Khaimah. So in short, it is known as RAC. And that's where my clinic's name comes from, RAC Dental Care and Implant Center. And as I said, it's a beautiful place, December and Jan being the best months of the year to visit Ras Al Khaimah as well as Dubai. And with the latest announcement of the biggest casino in the world coming up here, one of its kind in the Middle East. Ras Al Khaimah will be again on the global map. They are promoting it as RAC Vegas. So instead of going to Las Vegas, come to RAC Vegas and have a great time here. So yeah, what do you see here? So here we see something known as the homunculus, which in Latin means a diminutive man, a little person. And it is nothing but a graphic depiction of the functional areas of the somatosensory cortex. So if I take you back to year 1 of your BDS days, we all studied Chaurasia. We studied that the brain has a motor cortex, which controls the motor movements of the body, and a sensory cortex, which is responsible for the perception of pain. So every part of our body has been allocated a specific area in the brain, which is represented here in the homunculus. And you'll be surprised to see that about 45% of this is dedicated to the face, mouth, oral structures, and the throat. So this shows how much importance our body, our brain in particular, has given to this area. And we dentists are probably the only healthcare professionals who can manage problems, especially pain problems in this area. So kudos to all of us. We are doing a great job. we are masters in managing acute pains, whether they are pulpal, whether they are periodontal. But what about chronic pains? What about chronic non-odontogenic pains? I'm sure we have come across patients in our practices whom we have done everything possible, done our diligence to sort out their pain, but still we are left perplexed, scratching our head, thinking, why is this patient still in pain? What have I missed? I'm sure you would have come across, a lot of you would have come across such a diagnostic dilemma. And I'm very sorry to say that our lack of knowledge and confidence in diagnosing and managing these chronic pain patients often leads to misdiagnosis, inappropriate care being given, unwanted costs, and possible harm to these patients. And because of these, it can lead to the loss of trust and faith in our society, in our profession of dentistry. So let's start thinking out of the box, remove our dental hats, wear a medical hat, be a true physician, and learn to at least start diagnosing these cases. So without wasting any time, let's go clinical. I'll be showing two cases. My first case is a 45-year-old Yemeni female who complains of pain in the upper right second premolar, which is there for past 6 months. Please note that she has a congenitally missing lateral incisor. The canine is transposed. The first premolar and the first molar have been extracted. She also complains of headaches, pain in the cheek area. She has periorbital pain as well as pain around the lips and the chin. Her pain started about a year or 2 years back in the upper molar area. Similar pain she had in the upper first premolars. Sorry, but because the floating panel keeps coming, I'm not able to see my screen. Yeah. Sonal, can we do something, because it keeps coming to admit people who are in.
Just ignore the admit part. I'll take care of it. Don't worry. Just
Okay.
ignore it, doctor.
Okay, because it keeps coming on top of my screen and I'm not able to see my screen then.
Okay,
the location. The location is the second premolar. As I said, the pain started in the first molar area, went on to the first premolar, and now she has pain in the second premolar. It's a chronic pain with a frequency about 2 to 3 times a day, lasts about 10 to 30 minutes. Sometimes it goes on for 5 to 6 hours. On a visual analog scale, so with 0 being no pain and 10 being the maximum, her intensity is somewhere around 7 to 8 on 10. And she describes this pain as a throbbing, pulsating kind of a pain. So we being as dentists, what is the first thing which comes to our mind when we hear of throbbing or pulsating pain? Definitely it is pulpitis. What aggravated her pains? Cold foods and drinks aggravated her pain. Again, our diagnosis moves towards pulpitis. What was giving her relief? Sleeping in a quiet, dark place gave her relief. Well, pulpitis, on the contrary, while you sleep, while you lie down, increases. So this takes away moves the diagnosis away from pulpitis. Okay, sorry. What are the past treatments she has done for this case? She has seen a dentist with a pain in the upper right molar. Deep scaling and curettage was done. She didn't get any relief. A month later, root canals were done in the first molar, followed by the first premolar. The patient felt a bit better for a few months, went back to the same dentist, who this time extracted the first molar and the first premolar. She was fine for a year or so, and now she started complaining of pain in the second premolar. Went back to another dentist who did a class 2 filling, a composite filling first. Pain continued, the filling was removed, and now she has a temporary filling sitting in there now. What are the associated features in this case? She has tearing from her from her eye on the same side. She complains of photophobia and phonophobia, and she feels as if her cheek is swollen on the same side. I'm sure you all know what photophobia is. It is sensitivity to light, and phonophobia is sensitivity to sound. When the pain is severe, it refers to the ipsilateral gum, vestibule, cheek, and then sometimes to the temple as well. Patient gives a history of past medical history of migraine, which started at the age of 11. She's stressed at home and at work. Rest of the clinical examinations are all within normal limits. This is the OPG of the patient when she came to us with pain in the second premolar with a temporary filling sitting in there. Okay, we'll just take a quick poll. If you have your mobiles, you can use your mobile to scan this QR code, and it will take you to this poll question. And my question is that you have taken a detailed case history and done a thorough clinical exam. What is your next diagnostic step which will help you to differentiate odontogenic from non-odontogenic pain? So it's a very, very simple question. I'm sure everyone would be able to answer this. So are you able to scan the QR code? I don't know if anybody is able to scan it. So whether you're going to refer this patient for an MRI or CBCT, whether you're going to do a diagnostic block for these patients with a local anesthetic, will you refer this patient for a full blood workup, refer them to a neurologist or to a psychiatrist? Great. I'm starting to get answers, and most of you, 60% have answered it correctly. Some of you also want to refer the patient for an MRI or a CBCT.
They are answering in the chat box also, doctor, and most of them are saying it's the block.
Okay, great. So wonderful. That's what we did for our patient as well. We did a local anesthetic infiltration with 2% lidocaine. There was no change in pain. However, cold application, we used ethyl chloride applied to a cotton pellet, which was applied to the tooth as well as the vestibule, increased the pain. And whenever you have listened carefully to your patient's history, you reproduce the pain. And as Dr. T often says, that the next question you ask your patient is this your familiar pain? Is this the pain which is bringing you to me? And yes, this application of cold increasing her pain was the familiar pain of this patient. So what do you think is the differential diagnosis of this case? Moving on to our second patient, a 42-year-old Filipina. She's a doctor herself, a general physician. She presented to us with chief complaint of pain in the upper left premolar and molar area. Also, she had pain in the upper jaw. And her pain in the premolars was so severe, she kept on insisting that I just want to get rid of these premolars. She also complains of pain in the lower jaw, sometimes which is on the left, sometimes the shift sides goes to the right. Also complains of neck pains. The onset was about 10 years back, started as a gradual onset. She very well remembers she came from a party. She cleaned her face to remove her makeup using a toner, which started her pain. And this repeated a couple of times, and that makes her, she was sure that what is triggering her pain. Okay, and this. The pain started in the upper left, first and the second molar 10 years back. Similar pain she has sometimes in the lower right quadrant, sometimes on the lower left quadrant. Now she's complaining of pain in the upper left premolars, and the pain varies from right to left, but it is never bilateral. A chronic pain 6 to 7 times a day. Initially, it was once a week, and now it is about 3 to 4 times a week. Lasts for about 10 minutes to sometimes around 15 hours. 6 to 10 to 6 on 8 on 10 on the visual analog scale. She describes this pain as a throbbing, pulsating kind of a pain. What is aggravating her pain? Physical activity, cold blow of air, and putting the toner aggravates her pain. Analgesics give her mild relief. What are the associated features? She often has redness of the eye when she's in attack. She feels as if she has sinusitis, there's nasal congestion, and she feels nauseated, feels better after she vomits. It has been progressively increasing. When it is severe, it refers to the cheek and the sinus area, to the temple, and then she gets a full-blown headache, which is unilateral. She also gave a history of hypothyroidism, IBS, hypertension, and menstrual migraine, which started at the age of 13. She got an ovarian cyst removal in 2010. Her sleep is disturbed. A cold blow from the AC wakes her up with pain. What are the lifestyle changes she has done because of this pain? She has stopped jogging in the morning. She was a very athletic person, used to go for frequent walks and jogs. She has stopped jogging. She has stopped using perfumes and toners. She stopped going to parties and socializing. She was a very party person, frequently going for parties. But because of all these severe pains, she stopped doing that. And now she has even quit her job, sitting at home. Dr. Nivedita was just talking about the OSA burden patients have, and this is what chronic pain can bring to a patient. A well-established physician quitting her job, sitting at home just because of these chronic pains, which have been there for about 10 to 12 years. But she's been wandering from practice to practices, seeking a relief for their pains, but hasn't got any relief. These are the past dental treatments she has done. There are huge number of treatments which she has done. I'm not going into the details, but it will take another 30 minutes for me to finish what she has done, starting from root canals to extractions to consulting ENTs, neurologists. Bridges were done, removal of bridges. The last dentist even suggested removing these third molars, saying that these are the culprits. She hasn't removed those. The current medication, she's on ibuprofen and paracetamol. She's taking thyroxine, telmisartan for blood pressure, and the neurologist whom she consulted started with pregabalin, a neuropathic medication. No relief got. Local infiltration didn't give any relief. Infraorbital nerve block again didn't give any relief to this to her pain. However, cold application increased her pain, and yes, this was a familiar pain. What do you think is this case? So both these cases which we saw, none of them had any dental caries, any periapical or periodontal abscesses, loss of lamina dura, or trauma from occlusion. So the lack of local dental pathology is the key to diagnosis in these cases. We have been seeing about
what people are writing in chat box regarding the cases, what they feel their cases are. You want me to tell you?
I'm not able to see the chat box.
Should I tell you that? That most
Yeah,
of them,
please.
yeah. So, SCUNT, TACs are the answers that you've got, most of them.
SCUNT and TACs. Okay, so I think this was a lecture which was taken yesterday.
Yes.
Trigeminal autonomic cephalalgias.
Yes.
Okay, so we'll be seeing the diagnosis now in the coming slides. So as we have been discussing in the past 2 days, what orofacial pain encompasses. This is one entity which I'll be talking on is neurovascular pains, which is the diagnosis with this for these two cases. It's known as neurovascular orofacial pain, also known as mid-face migraine or a migrainous toothache. So we all know that the usual sites of migraine is predominantly in the head area. It is whether it is supraorbital, parietal, temporal, occipital. However, they may occur in the mid-face region, the orofacial facial region as well, without affecting the head. Referral to the maxillary teeth is quite common, and because of the uncommon location, patients are often misdiagnosed with TMDs, probably with trigeminal autonomic cephalalgias, often misdiagnosed with odontogenic pains. And if the orofacial region is the area of concern, the ICOP classification, the international classification of orofacial pain, which came in 2020, labels this as mid-face migraine or trigeminal autonomic orofacial pain. So please take notice, these are not autonomic cephalalgias. It is a case of mid-face migraine. Benoliel termed it as neurovascular orofacial pain or migrainous toothache. So facial pain in migraine can be subdivided into two categories. It starts as a headache, which is the most commonly seen migraine location, and then it spreads to the lower part of the face. This is kind of low facial pain seen in migraine is more frequent. However, the rarer version is it starts only in the lower part of the face, can be seen intraorally without affecting the head. So what is the prevalence? The onset is around 40 to 50 years of age. Both our patients were in this age group. It has a female predominance, 4:1. It worsens perimenstrually, may be absent during pregnancy. It is usually diagnosed secondary to dental pathology A lot of patients wander from dentist to dentist, doing various treatments, seeing even ENT doctors and neurologists without getting any relief. What are the clinical features of neurovascular pain? It's a throbbing kind of a pain. Look, excuse me, this again, my slide is being. Yeah, it has a gradual onset. Previous history of migraine may or may not be present. Mostly it is unilateral. It may begin around the nose, spreads to the cheek. Sometimes it starts with intraorally, affecting only the upper and the lower jaws, the alveolar process and the mucosa. Mostly the upper canines and the first premolars are involved. However, the adjacent molars can also be involved, which was the case in the first case. Slide is not moving. Okay. It's an episodic pain. Duration, it lasts from between minutes to hours, sometimes are even greater than 24 hours. Moderate to severe kind of a pain. It is usually throbbing, pulsating kind of a pain, and that's why always mimics pulpitis. Aggravated by physical activity, head low position, and cold. Both patients' pain was aggravated by cold food as well as the toner which she was applying, giving a cooling effect. Patients have undergone numerous dental treatments ranging from root canals to extractions, consulted ENT specialists. They usually have associated features. They usually have ipsilateral autonomic signs. We'll be seeing in the next slide what autonomic signs are. They complain of nausea, phonophobia, and photophobia. They have hypersensitivity to cold. I think Dr. Maithili would have covered allodynia yesterday. It is pain to a non-painful stimulus. So even touching a part or combing your hair causing pain, it's a non-painful stimulus which is causing pain. And in this, in NVOP, in mid-face migraine, there's hypersensitivity to cold, which is known as cold allodynia. And not only the tooth, but even the adjacent vestibule is involved. It refers to the perioral areas, lips and the cheek. Side shifts are seen. We saw in our second patient, sometimes the pain was on the right, sometimes on the left, but it is rarely bilateral. So what are the autonomic signs? There's excessive perspiration, sweating. There's redness of the cheek. There's miosis, that is constriction of the pupil. So if you compare the right pupil with the left, this is constricted. This is known as miosis. There's drooping of the upper eyelid. So if you compare the level of the upper eye on the right eyelid and the left, there's drooping of the upper eyelid. This is known as ptosis. There's redness of the eye, conjunctival injection, it's known as. Tearing from the eye or lacrimation. Stuffiness of the nose, nasal discharge, watery discharge from the nose. Redness of the ear, stuffiness in the ear, and the patient feels as if the cheek is swollen. It's not literally swollen, it's only a feeling of cheek swelling, which is noticed, which is not noticeable. So when you see these signs, what do these signs mimic? They more or less mimic allergic phenomena, but how do we distinguish between the two? Allergic signs are usually bilateral. It's seen on both the sides. However, whenever autonomic signs are present, they are unilateral. They are ipsilateral to the side of the pain. So what are the neurovascular variants which we see? One is the migrainous toothache. The toothache is episodic, recurrent in behavior. It's a pulsating kind of a pain. Analgesic blocking of the tooth shows an equivocal response. What does that mean? Sometimes the patient's pain may stop on a local anesthetic. Sometimes it gives no response. Sometimes it might even aggravate her pain. Endodontic treatment and extractions give temporary relief for these pains with recurrence in due course. And as we saw, the ipsilateral autonomic signs are present. And when this neurovascular orofacial pain is seen on the orofacial pain is seen on the midface area, it is known as neurovascular orofacial pain. What are the main distinguishing features of NEOP from migraine? It is the oral or the perioral location. The neurovascular pulpitis with its unique pain characterization of throbbing pain and the late age of onset. So as we saw, both our patients were in the age group of around 40 to 45. ICOP, International Classification of Orofacial Pain, came up with the diagnostic criteria fulfilling at least one of all these 5 criteria. The pain is moderate to severe in intensity. It's toothache which is pulsating in quality. It can be either short lasting or long lasting, less than 4 hours or greater than 4 hours. And at least one of the following autonomic signs are present. So we saw in both our patients, at least one or more than one autonomic signs were present. Pain is unexplained by any local cause. There's no local dental pathology clinically as well as radiographically. The oral cavity is absolutely normal, and it is not accounted for any ICOP or other ICHD3 diagnosis. So what is the pathophysiology of NVOP? It may be similar to that of migraine, with the interaction between the nervous system and the vascular systems. There's something known as the hypothesis of convergence. So if we see this diagram, it shows the cross-section of the brain, the cortex is there, the thalamus, and the brainstem. Within the brainstem, there is the main sensory nucleus of not only the trigeminal nerve, but also nucleuses of various other cranial nerves like the 7, 9, 10, and even the cervical dermatomes. So what happens? The pain input from different parts of the head, face, and neck is brought to this area, in this small area, with anastomosis when different areas, different nerves takes place, crosstalk between different nerves happens, and that's why it makes pain referral very common. The anastomosis between the facial nerve, the trigeminal nerve, and the facial nerve, and the facial nerve and the cervical dermatomes can explain the mechanism why headaches can be perceived as facial pains and facial pains as headaches. There's something called neurogenic inflammation, which is inflammation caused by release of chemical mediators like substance P, CGRP from the nerves itself, and this causes neurogenic inflammation. It has shown that C fibers in the dental pulp release these inflammatory mediators, causing inflammation and thereby leading to pain. We saw in our patient that the pain had started in the molars, spread to the premolars, the second premolar to the first premolar. Why this happens? It has been shown that there's a collateral innervation exists within the same dental quadrant. So pulps of the premolars and the molars have collateral C fiber innervation, which explains the cross referral which goes on. Even if the tooth is extracted, the nerve fibers, the collateral circulation is there, causing a reference of pain from one tooth to another. And there's lack of NVOP reported in children. It has been shown that most of the neurotransmitters, the inflammatory neurotransmitters, are released mainly in the permanent teeth and not in the deciduous teeth. And that explains the lack of NVOP reported in children. And there's something known as trigeminal vascular system activation, where the trigeminal sensory nerves excite the corresponding parasympathetic autonomic fibers, which can explain the autonomic signs which are seen in NVOP. And there's again something known as the compartmental effect. We all know that the brain is encompassed in the skull and the dental pulp in the heart tissues of the enamel and dentine. And because of this closed system, pressure builds up, which excites the nociceptors, which are the receptors responsible for pain. And because of this excessive buildup of pressure, the compartmental effect, pain can be elicited. A lot of comorbidities are seen with migraine: TMDs, hypothyroidism, irritable bowel syndrome. And if you remember our patient, the second patient, she had both hypothyroidism as well as IBS, and even GERD, PCOS, interstitial cystitis, and vulvodynia. So taking a detailed history, rule out a non-odontogenic cause, an odontogenic cause is very, very important. A lot of these comorbidities are present. So if you are not taking a detailed history, you will never know what other comorbidities exist in these patients, and you will miss the diagnosis then. What is the differential diagnosis? Of course, as we saw, dental pathology, local dental pathology is diagnostic. The lack of it, temporomandibular joint disorders, even sinusitis can mimic these pains, cluster headache, which we saw yesterday, trigeminal neuralgia, atypical facial pain, as well as cold stimulus headache. How do we successfully manage orofacial pain? So we start with a detailed case history detailed history, listening carefully to your patient's chief complaint, taking a history about the past medical and surgical history, past and current medications, review of system, including a detailed sleep history, which Dr. Nevi was just talking about in the previous lecture, and a psychosocial assessment. Following this, we go for a comprehensive clinical exam, which should be very thorough, gentle, well-narrated, trauma-informed, system-based. Based on this, we refer patients for appropriate diagnostic tests, which should only be done if they are going to aid in our diagnosis and our treatment plan, and they should be definitely scientifically valid. We formulate a differential diagnosis followed by a multidisciplinary evidence-based management plan. How do we manage NBOP? Well, I'm not here to preach about the management. The main thing I want our audience to understand is to identifying these pains, identifying the triggers such as lack of sleep, missed meals, stress, excessive caffeine intake, alcohol, as well as ingestion of nitrates. Once you have identified these triggers, known the signs and symptoms, the best thing I would urge you is to refer these patients. So in conclusion, NBOP is becoming increasingly recognized in dental clinics. It's often characterized by episodes of throbbing pain in the teeth. It can be seen periorally in the mid-face region and the jaws. Very important for us dentists to rule out local dental pathology and thereby avoiding unnecessary treatments. Always start with the most conservative, least invasive, and irreversible treatment. Careful history taking, looking for lack of evidence of any sinus or dental abnormality will help us to correlate to correctly diagnose these pains. And a collaboration between various specialists, between neurologists, facial pain specialists, as well as other medical professionals and dentists is the key to increasing awareness and education for this disorder. So as I said, a multidisciplinary approach, incorporating all these specialties in your practice will definitely give you the best of results. So from today, I'll urge you to start thinking beyond teeth, observing beyond occlusion, practicing beyond position, and caring beyond cure. So if you start doing this, this will make you the top clinician. And as they say, a good clinician treats the disease, and the top clinician manages the patient who has the disease. So thank you for your patient listening. These are my references. I'll be happy to take any questions now.
Yeah, thank you, Dr. Sumit. And I'm sure the responses that came in really proved that these were mystery cases. And like you said, that they will generate some amount of curiosity about the subject of orofacial pain and the multifaceted clinical representation that it shows. Thank you, Dr. Sumit. There are a few questions that I would like to ask you. Is the history of migraine at young age or younger age a must for clinical diagnosis of mid-face migraine?
That's a great question, Sonal. See, as if you look into the ICOP criteria, there's no mention of a mandatory existence of history of migraine being a mandatory criteria. But in most of the cases which we see, a history of migraine is usually present. I have seen cases even where there's no history of migraine was there. So patients don't follow textbooks. Also, it happens that a lot of headaches have been misdiagnosed. A lot of patients, no matter what kind of headache they have, they themselves label them as migraineurs. So even if they are giving a history of migraine, which will they might not really be migraineurs. It is just a diagnosis which was made by themselves. So yes, a history of migraine is usually present, but cases can be seen without a history of migraine as well.
And what about these autonomic signs? Are they always present, or they are the criteria for diagnosis? Like, are they always?
Yeah. As per the ICOP criteria, again, at least one of these signs and of autonomic signs must be present. But I have seen patients where not only one, a lot of signs were present, again, there were patients where none of the signs and symptoms of autonomic signs were present. So even migraine exists with autonomic features. So migraine is it mimics the trigeminal autonomic cephalalgias, which we saw yesterday. Autonomic features can be seen in migraine as well, and usually NBOP comes with at least one autonomic sign. Yeah.
And Doc, one more thing, like at dentist level, like in our dental offices, are we equipped with treating mid-face migraines?
Well, what I really want the audience to understand is to start recognizing these patients, identifying the comorbidities, the red flags, making the correct diagnosis, and stop doing irreversible invasive treatments. They should know when they have to stop and then learn to refer. I would definitely urge not to dentists not to start treating these cases, because one, they should identify it, as I said, identify the triggers. And the management part of NBOP is basically pharmacotherapy. And a lot of these medications have their own side effects. So having a detailed knowledge about the pharmacokinetics and the pharmacodynamics of these medications is very important before our dentists start prescribing these. So I would urge not to start treating this, just identify them and make appropriate referrals.
And there are audience questions also. Can TACs, migraine, and NBOP coexist?
Yes, definitely they can coexist. They might start as a TAC, end up into a migraine. A migraine can end up into a TAC, and this is why orofacial pain is so complex. I mean, there are so many complexities in the orofacial region, and a lot of different disorders can coexist as well.
Yeah, and there's Dr. Sandeep, who is a very active participant of this whole Congress. So he also has asked some question. Can you address those questions in chat box, Doctor? Because
Yeah,
our next
sure.
speaker is already here.
Yeah,
So
sure.
thank you so much, Dr. Sumit, and it's always lovely and wonderful to actually, if I must say, he has been the backbone also about this for this Congress, because when it came to scientific planning, I had one person who was always there to help me out, and that was Dr. Sumit. At
It's
times I
always
got
a
stuck,
pleasure.
and he was there. Yeah, is this your screen, Dr. Sumit? Can you stop
Yeah, I'll
sharing
stop
your screen?
sharing. Yeah, I'll
Yeah.
stop sharing. Yeah.
Dr. Sandeep, Dr. Sumit will answer your question in the chat box and other questions also. And I love the poll questions that was asked. Wonderful.
Yeah,
Thank you,
great.
Dr.
Thank you.
Sumit. And there is a surprise for you all. Dr. Sumit is going to be back with us again in the later half of the day. So, and with again some mystery things around. So, see you around, Dr. Sumit. So, just hang on there. Okay.
Yeah, sure.
Please
Thank you.
wait and listen to our next speaker. I think you know her very well, Dr. Dipti Bhatnagar. So, I would want you to wait and listen to her also. Dr. Dipti, are you there?
Yes, I'm there, Dr. Sonal.
Yeah. Hi, ma'am. How are you?
I'm good.
I love the dishes and the design that is there at the back of your screen. Lovely, beautiful house. Okay, Dr. Dipti, yeah, just a second. Dr. Sumit, you may answer the chat box questions. Okay, Dr. Dipti is a professor and head of department of professor and head of department of oral medicine and radiology. She has completed her MDS in Savita Dental College and Hospital, and a fellowship and mastership in orofacial pain and sleep medicine from Roseman University, USA. She is vice president of IMOMR. I'll ask her the full form for it. And she's an editor-in-chief of Journal of Indian Academy of Oral Medicine and Radiology. So, Dr. Dipti Bhatnagar, welcome. And I'm thankful that you took out time from your busy schedule. I know Dr. Valli and Dr. Dipti were our last minute entrant, and we were like, very happy to have them around with us. Thank you, Dr. Dipti, for joining us. And Dr. Dipti is going to be talking about unveiling the mystery of chronic headaches, a diagnostic challenge. So I would say this morning has been a mystery morning, starting with sleep medicine. So everybody were awake by the time Dr. Nivedita brought about the topic of sleep medicine and the orofacial pain relation. And Dr. Sumit has already fired the neurons, I would say. Now everybody's thinking, okay, what the diagnosis was. And Dr. Dipti is here to again fire your neurons with cases which will definitely take you to another level. So Dipti, Dr. Dipti, can you just share your screen, doctor?
Sure. One
The
minute.
button down. Share screen. Audience, today also I have a goodie bag for you all, a virtual goodie bag, I would say. So please stay tuned and keep responding on the chat box and attend all the lectures. I have a keen eye on the audience list also. Dr. Sandeep, you are in for a real treat today. Ma'am, can you see a share screen button down at the...
I'm able to, I'm seeing that share screen button, but I'm not able to share my screen.
Dr.
Mm.
Nurul, can you help around here?
Dr. Dipti, you came with the name of Dipti Bhatnagar, all block letters.
Yes, yes, yes.
Yes, of course. And you are the co-host, but you are struggling to share the slide. Could you please, can you do one thing? Can you share your presentation on the group, or I'm saying hi on WhatsApp. You can share, and my team can share the slide, and you just guide him to move the slide.
Actually, it is on my it's on my desktop.
Okay.
So, 1 minute. Just see.
Are you able to?
Yeah, now
it's
I can.
coming.
Now.
Yes, yes, yes. Dr. Nurul, can we do something about that admit screen line? Yeah, every time it is disturbing. The technical team, please help me around here. Yeah, Dr. Dipti, can you go to the presenters mode? Thank you, Dr. Dipti. The stage is all yours.
Yeah. Are you able to see the screen and
Yes, ma'am. Yes, ma'am. Yes, ma'am. Please continue.
First of all, a very good morning to one and all. And thanks a lot, Dr. Sonal, for the elaborative introduction. And it was my real privilege to be a part of this Congress, to be amongst all the pioneers of orofacial pain. I thank Dr. Nooral also on. So another mystery, as Dr. Sonal said, is coming up. I have basically a case, a novel case today, which sometimes I feel leads you to think out of the box. And for this case, I would like to acknowledge my mentor, Dr. Davis Thomas, sir, because it was with him we sorted out this mystery, and we help the patient in getting his diagnosis. I dedicate this lecture to him. What the mind does not know, the eyes do not see. So it is basically the knowledge what you have, which helps you in seeing your case from that perspective. According to International Headache Society, it defines headache as a pain in the head above the orbitomeatal line and or nuchal ridge. A headache may appear as a sharp pain, a throbbing sensation, or a dull ache. It can be a primary headache, which the examples are migraine, cluster, or tension type headache, or a secondary headache, which is basically because of some underlying systemic conditions, tumors, or stroke. Then there are certain comorbidities of the headache like TMDs, neuropathic pain, and fibromyalgia. I won't go into detail of headaches since the topic has been presented by the previous presenters yesterday. But there are certainly red flags when you are seeing a case of a patient suffering from chronic headache. What are these red flags? Numbness, paralysis, disorientation, vision changes in the vision acuity or double vision, inability to talk, accompanied by headaches, these are the symptoms that may demand immediate evaluation. And I won't say that we are the best people to treat these kind of cases, at least because these patients, they usually come up with some of the common complaints and this case, which I'll be presenting today also, he happened to came to me with a complaint, thinking of it to be as a case of a TMD. So it is basically, as Dr. Sumit said, our main goal should be to diagnose that case, and thereafter, if it is not in our perspective to treat that, refer the case to the concerned specialist. So this patient, who is a 39-year-old Asian male, started having severe bilateral temporal headaches and eye pain in early 2021. The patient also had neurological symptoms, including diplopia, motor weakness, and transient numbness. History dates back to year 2021 when he had undergone a very stressful period, and what he's recollected was that after a month the pain started in his right temporal region with pain in the eyes. It used to be on the right side, and sometimes it used to be on the left side. After 4 days, he experienced double vision on looking on right side, and for which he visited the neurologist. MRI was advised, which showed no significant lesions. Hence, he was asked to take tablet tryptomer. Tryptomer is amitriptyline, 10 milligrams, and a beta blocker, propranolol, 40 milligrams. And he was given diclofenac with serratiopeptidase. The treating doctor thought it to be a case maybe of a migraine, and he was also advised steroids since he was having diplopia. Gradually, the pain got very severe. This time he had no effect. Well, this is after few months. This time he had no effect of any of the opioids, or rather, steroids stopped working. Now they thought it on the grounds of trigeminal neuralgia, and the treatment was initiated for the same. But somehow the patient did not find any relief in his complaints. So intravenous corticosteroids followed by oral steroids were given, which improved the patient's condition. However, the patient started experiencing severe headaches. Therapeutic dosages of beta blockers, antidepressants, anticonvulsants, and tramadol failed to provide any appreciable pain relief. Past medical history: there was no history of hypertension, diabetes, or thyroid, no coronary artery disease, no history of hyperlipidemia, no history of migraines, no history of autoimmune disease. He was as such a perfectly healthy guy. Physical examination, the vital signs were all within the normal limits. The cranial nerve screening was normal. Muscle palpation, however, the middle temporalis and the deep masseter were tender on both the sides. The family history, there was no significant family history of TMD or any sort of orofacial pain. But patient, his profession was, he usually works on computer, and he was a daytime fluxer. Sleep, he had trouble going to sleep, and even if he used to get sleep, he could not maintain the sleep for a longer duration. Patient had visited psychologist in the past for the same illness. Talking of the characteristics of the pain, the onset, the headache was sudden in onset. Location, it was usually on the temporal region involving both right and the left sides. Frequency, it was chronic, non-progressive, and occurs usually daily and was continuous in nature. Intensity, the quality of pain was aching, piercing, and sharp in nature. And on VS scale, the intensity was 8 to 9 out of 10. So that means he was in a really, really bad state. The temporal pain was associated with diplopia initially, but later on it disappeared. The pain got aggravated on exertion and with seasonal variations. The pain got relieved on taking corticosteroids. There were no autonomic features like tearing of eye, weakness, numbness of face, sinus congestion, and sweating. The pain did not radiate to any other region. Patient has trouble going to sleep when he was in pain, and he also pain wakes him up when he was sleeping. There were various medical tests which were done for this patient, even the blood tests, and later on the lumbar puncture was done to take the CSF. CSF is cerebral spinal fluid. It's the fluid was clear, colorless. The total leukocyte count, although, was raised. It was 20,000 cells per cubic millimeter. Mononuclear cell count was also raised. Neutrophil count was bit raised. Anti-nuclear antibodies were negative. Even anti-RO for these antibodies for autoimmune diseases were all negative. Anti-nuclear cytoplasmic antibodies were negative. However, antigen detection for Cryptococcus to rule out any sort of fungus it also came out to be negative. Tuberculosis, RT-PCR was done. That was all normal. There was no malignant cytology, except the IgG4 levels were raised, and they were quite significantly raised. Glucose and protein cerebrospinal in the cerebrospinal fluid, they were within the normal ranges. As I discussed, the CT and the MRI scans were done. Even the PET scan was done for this case. A high-resolution CT scan of the brain showed a well-marginated, heterogeneous, mixed-density lesion around the right petrous apex. So, then, which was inconclusive. A subsequent MRI with contrast showed extraaxial soft tissue thickening and enhancement in the retroclival region on the right side, with dural enhancement extending to the midline. That means we have meninges in the brain, and we know there are 3 layers in these meninges. That is your dura mater, your arachnoid mater, and your pia mater. So there, in the dural layer, dura is also called as pachymeninges. It's a part of meninges, so it is pachymeninges, and the innermost layer is the pia mater, which we call it as leptomeninges. So there was an enhancement seen in the dural layer, and which was extending till the midline. This dural enhancement was also seen on the medial and the posterior aspect of the right inferior temporal lobe, and with sheet-like thickening and enhancement was extending to the right foramen ovale along the mandibular division of the right trigeminal nerve. Ill-defined soft tissue enhancement was seen in the right carotid canal anteromedial to the jugular foramen. PET was advised, which showed no apparent abnormalities. MRI plain and with contrast was again advised in February 2022 as the patient's symptoms persisted. It revealed few punctuate non-specific T2 and flare hyperintensities bilaterally in the frontal deep white matter. MRI was repeated again. This was I think, the 4th MRI which was done in September 2023, which revealed an enhancing lesion at the right petrous apex. In this MRI, what was noticed was the lesions which were seen in the previous MRIs, they had almost, they were on the resolving side, they were resolved, and there were new lesions which were seen in the posterior flanks, measuring approximately 6 millimeter in thickness, which were actually not seen in the previous scans. So this was the new finding. The final diagnosis for this case was given to be as an IgG4 related disease with hypertrophic pachymeningitis. So we'll be talking about what is actually it is. Since being a dentist, we rarely come across these type of cases, but then this case came to my setup, and I was literally into dilemma, what to do and how to go about. Basically, IgG4 related disease is a multi-organ chronic inflammatory process which is caused by infiltration of IgG4 positive plasma cells in one or more organs. There are various synonyms for this. As we go into the literature, somewhere it is IgG4, IgG4 related disease, IgG4 related intracranial disease, IgG4 related hypertrophic pachymeningitis, IgG4 meningitis, or IgG4 related neuropathy. The pathogenesis of this is not very well understood. We know we have immunoglobulins, antibodies. So out of 4 IgG antibodies, IgG4 constitutes 1 to 4% of the total IgG. The disease mainly affects organs like pancreas, kidney, lungs, thyroid, salivary glands, and orbits. It was also called as the pancreatitis. Initially, it used the first time when IgG4 was diagnosed, it was like the pancreas is the most commonly affected organ. We don't know why. The intracranial IgG4 related disease is very rare and it presents with imaging features of hypophysitis, that is involvement of the pituitary gland, pachymeningitis, cerebral parenchymal tumors, granulomatous disease, tuberculosis, or malignancies. By tuberculosis, I mean tuberculous meningitis and malignancies like nerve sheath tumors like schwannomas and lymphomas. IgG4 related disease is one of the manifestations of IgG4 disease. It is a multi-organ, as I said earlier, chronic inflammatory process which is caused by infiltration of IgG4 positive plasma cells in one or more organs. Most commonly affected organs are pancreas and kidney, as I said earlier. Intracranial manifestations are hypophysitis, pachymeningitis. IgG4 related pachymeningitis, if we talk of, it involves inflammation along with diffuse or focal thickening of meninges, usually the dura mater, in the brain or in the spinal cord. It was first described by Nefziger and Stern in 1949. Our case contributes to the few published cases in the literature of intracranial IgG4 related hypertrophic pachymeningitis. Coming to the clinical features of this particular disease, it is commonly seen in males as compared to females. Between the age group of 32 to 82 years. Common presenting neurological features is they are headache, vision problems like diplopia. It was actually taken out from one article where the authors have done a randomized systematic review and they have taken up 33 to 34 cases of IgG4 pachymeningitis from 1949 or 50 till 2019. So according to them, the headache was the commonest neurological feature, followed by vision problems, then motor weakness, cranial nerve palsies, and it was misdiagnosed. It is a case which can be misdiagnosed for TMD since the patient complains of pain usually in temporal or the preauricular regions. This is the thing taken from JAMA 2014 from Lucy et al., where they show, as I said earlier, it basically IgG4 related diseases, they involve multiple organs. But in their study, they said it may not be necessary that IgG4 related hypertrophic pachymeningitis may have an organ involvement, which was similar in our case. Our case also did not show any other organ involvement except the involvement of the seen intracranially. If we talk of a bit of pathogenesis, there is basically the inflammatory infiltrate which is getting which gets collected. It's an antigen-driven disease. This inflammatory infiltrate, it activates the fibroblasts, thereby leading to deposition of the collagen, and which causes tissue hypertrophy, which increases the thickness of the dura mater. It is an antigen-driven disease with collaboration with CD4 T cells and activated oligoclonal IgG4 B cells. B cell dependent activation of pathogenic T cells mediates inflammation and fibroblast activation. On CT or MRI, you may see a dural thickening or a bulging mass. There are various scans which show a thickening or an hypointense with scattered foci of hyperintensity, which suggests of inflammation. The probability of lesion and the enhancement of the lesions is basically more commonly seen in the cerebellar tentorium, followed by cerebral falx region, frontal, temporal, parietal dura mater, occipital dura mater. The most characteristic imaging manifestation is the enhancement of the cerebral falx or cerebellar tentorium, that is double track or Mercedes-Benz sign. I don't know why they gave this name. Then there is an orbital enhancement on both the sides of the dura mater, and the center of the dura mater is linear without enhancement. Coming to the serological part, the blood picture shows normally the ESR levels are raised, and in some patients, even the CRP, C-reactive proteins, are raised. CSF picture, on lumbar puncture, we take the CSF to rule out any sort of CNS infections and malignancies. So if we talk of infections, infections like tuberculosis or sarcoidosis, or malignancies like schwannomas and lymphomas, which were ruled out in our case, increased IgG4 levels will be seen, which are significantly high. IgG4 related hypertrophic pachymeningitis differs from other systemic diseases. What I mean is that there can be a hypertrophic pachymeningitis without IgG4. So, but in IgG4 related hypertrophic pachymeningitis, it differs from the normal in the process that the fibroinflammatory processes occurs in close proximity to blood-brain barrier and cerebrospinal fluid, although the glucose and the protein levels may be normal in concentrations. Biopsy is considered to be the standard, the gold standard for the diagnosis of IgG4 related hypertrophic pachymeningitis, and the differential diagnosis based on the imaging features are, it could be an inflammatory, it could be granulomatosis with polyangiitis, malignancies, infections, multiple sclerosis, because MS also shows these kind of relapsing and recurring nature of the disease. Sir was actually into dilemma because we know he's a pioneer in multiple sclerosis, and we have heard his lectures so many times on MS. And these lesions, they were very much similar in appearance to those, but there was no demyelination seen in our case. In 2020, international consensus diagnostic criteria was a revised diagnostic criteria was given, where it says the first thing is clinical and the radiological features should be positive. One or more organ involvement can happen along with the imaging features. Second thing is serological diagnosis, and third serological means the IgG4 levels should be raised, and third is pathological diagnosis. So they said the diagnosis is definite if all the three, first 1, 2, and 3 are present. It could be a probable if first and third is present, and it could be a possible diagnosis, which could be first and second, which was a possible diagnosis in our case. We did not go for histopath since the patient was not welling, and he was responding gradually he was finding like he was better off with steroids. So that was not done. If we go into this literature, there was again a study done by and it was published in Annals of Palliative Medicine, which showed the gender prevalence to be male within the age group, what was described before. And the common main clinical presentation, if you see here, the patients presented with right temporal or the temporal headaches or the headaches. CSF levels were of IgG levels, IgG levels in CSF, they were raised. Oligoclonal bands were negative and they were positive for 2 patients. Serum IgG4 levels were again raised. We see the normal range of IgG in CSF is 10 to 40 milligrams per liter, and the normal range of IgG4 in serum is less than 135 milligrams per deciliter. So in our case, it was significantly very high. MRI shows meningeal thickening as or dural enhancements as seen in all these cases. Similarly, here also there were various the literature shows raised lesions. ANCA may be negative or may be positive. CRP is usually raised. CSF lymphocytic pleocytosis is positive, which was also seen in our case. Elevated ESR levels and positive imaging. Treatment, if we talk of treatment of this, there is no definitive treatment, but review of the published reports reveal glucocorticoid treatment, glucocorticoids as the treatment followed by immunosuppressive drugs if there are events of reoccurrence. So glucocorticoids are basically given for in a higher dosages in initial days or initial months, and then gradually they are tapered and they are left for on maintenance dosages for quite some time. If the lesions they do not, or if the symptoms they do not resolve, then there are certain immunosuppressive drugs like methotrexate or mycophenolate mofetil. A newer drug, that is rituximab, which is a monoclonal antibody, has shown promising results in this treatment. But I again admit here that we are not the right people to prescribe any sort of treatments for these kind of patients. If we have some kind of we come across and we are in this thing that it could be this, we should refer a case to a concerned or a super specialist. IgG4 related pachymeningitis is a rare immune-mediated chronic brain or a spinal cord inflammatory condition primarily affecting the dura mater with characteristic tissue and organ features. Headache is one of the most prevalent features of the disease. It is associated with lesions manifesting as an IgG4 rich plasma infiltrate, often appearing with raised serum IgG4 concentrations. The disease may mimic neoplasms, infections, inflammatory processes due to its varied clinical features. Our case depicts extensive pachymeningeal lesions with soft tissue thickening and enhancement in the retrocleval region on right side, with adjoining mild smooth dural enhancement extending up to the midline and extending also up to the Meckel's cave along the posterolateral aspect of the right cavernous sinus, enhancing lesions at the right petrous apex, which resolved in the later scans signifies a remitting nature of the disease, with relapsing lesions seen in the posterior fossa once the treatment was stopped. Although biopsy was not performed in this case, IgG4 pachymeningitis was strongly suspected given the elevated serum IgG4 levels along with improvement following the steroids. The dural thickening or enhancing lesions seen in hypertrophic pachymeningitis results in compression of the vascular structures or nerves, resulting in symptoms like headache and cranial nerve deficits. Headache, we can contribute in this case, it can be due to a meningeal inflammation. The negative RT-PCR for TB, negative cryptococcus, and no enhancing seen on PET scan ruled out infections and malignancies in our case. However, absence of demyelination of trigeminal nerve ruled out multiple sclerosis, which usually presents with similar clinical and imaging findings with remitting and relapsing nature of the disease. In general, intracranial pachymeningitis consists of a localized form of IgG4-related disease. The increase in dural thickness was speculated to be attributed to dense inflammatory infiltration, primarily composed of B and T cells. The patient usually presents with symptoms including, but not limited to, affected vision, paralysis of the cranial motor nerves, and changes in sensation. One of the classic findings of IgG4-related disease is high IgG4 levels in the blood. The disease manifests as a linear dural thickening or a bulging mass when viewed on a CT or an MRI. And rituximab is a novel emerging drug which not only alleviates systemic symptoms but also decreases the IgG4 levels in the blood. To conclude, I would say IgG4 related neurological disease should be considered in the differential diagnosis of diffuse involvement and thickening of meninges on imaging. IgG4 related disease should be considered in DD of chronic headaches. The growing literature depicting the patterns of varied patterns of intracranial involvement of IgG4 related disease remains a diagnostic challenge to both the radiologist and the orofacial pain specialist, given its non-specific imaging features and the clinical presentations. So every dental specialist, irrespective of any specialty he's been on, has the moral and professional obligation in making correct diagnosis and treating or referring the case to a specialist. So I end up my presentation by putting a quote which my professor in oral medicine, or he used to say, make a careful diagnosis, discover the true cause of the disease, think out the proper remedy, and apply it effectively. These are my references.
Thank you, madam. Thank you, Dr. Dipti. It was really lovely. And in fact, when you started, it was like a Pandora's box, this case. You were telling me that, you will be wizarded by the kind of findings you found and the systemic factors that had affected the patient so much that, at a dental level, it was difficult for us to.
It was a rather we, sir and myself, we used to sit and we used to think what the hell it is now.
Yes,
What we can do.
Yeah, this is the typical Pandora's box case. So beautifully presented, doctor. And I would urge you to wait and check the chat box in case if there are any questions. So you can take them in the chat box, doctor.
Yeah.
Thank you
Thank
so
you so
much.
much.
Thank you.
Thank you.
With that, I would like to call our next speaker, Dr. Ruchika Sood. Dr. Ruchika Sood, are you there?
Yes, I'm here. Good morning.
Good morning. Okay, smile for the camera.
Okay.
Okay, so Dr. Ruchika Sood is again, what should I name you? We have named Dr. Davis Thomas and Dr. Maithili as grandparents, so we'll call you auntie of orofacial pain, or maybe
Granny of OSP? Okay, all right.
Yeah, granny only then. Okay. How are you? And wishing you a very happy belated birthday. And I'm sure you were traveling. That's what you told me, right? Today you were traveling. So we pulled you from your birthday party.
Well, thank you very much for your wishes yesterday. I've been spending the last weekend doing things that I really enjoy in life.
Lovely, lovely. I think you, as it is, do things which you enjoy in life all the
That's
more.
right. That's what I
post, your tea post says a lot.
Oh, yes. Oh, yes.
Okay. So let's welcome Dr. Ruchika Sood. I mean, she's been an integral part of the sessions. I think this is the third year we are hosting you, Doctor. So
Yes.
thank you so much for being a part of NIPCON and this session also. And Dr. Ruchika Sood, in fact, when I asked her for a bio, what she told me, she didn't mention that she's a diplomat, nothing. She says she wants, her goal is to deliver compassionate care that truly makes a difference in people's life. So this is a different bio that I received. She didn't tell me that, okay, I'm a diplomat, I'm this and that, nothing. So that was her bio, and that really says a lot about the person that we are going to be listening for the next half an hour. She has 10 years of experience, and the first name that comes in when we think about orofacial pain consultant in Mumbai, that's Dr. Ruchika Sood. She comes with high references also. Like last year, Dr. Mayekar was all set for praising her, and he had no words to, he was like overwhelmed praising her. So this is Dr. Ruchika Sood for you all. She is mostly known for giving impromptu lectures and on-the-spot case discussions. So this time we have a presenter, Dr. Ruchika Sood, with us. So Dr. Ruchika Sood, can you share your screen so that we'll take a test on it?
Yes.
Dr. Ruchika Sood's daughter's photo you can see at the background. And I'm sure she is the one running the show nowadays for her.
Not yet.
Not yet?
Teaching
Okay.
too. But yeah, she runs my life.
Yeah, life. Yeah, that's what I said.
And thankfully, she shares it with OFP. So yeah.
Wonderful. So another budding OFP specialist around.
No way. She's going to teach all of us how to make money with OFP.
That's something actually we can keep a full day session for it. How to manage money.
Is my screen visible?
No, start sharing, Doc.
I just did.
No, I can see you.
This is I just did. So this is here.
Dr. Nurul, is she the co-host only? She can present, right?
Yeah, she's co-host now.
Yeah. So just,
Multiple participants sharing simultaneously, right?
no. Only you will be sharing.
Participant sharing at a time. Okay. Yeah. Now is it visible?
Yes. Go to the presenters mode. Great. Just maximize the screen first.
Yeah, that's what I mean. Okay.
Yeah, all set to go.
All set to go.
Yeah.
So thank you very much. And as you rightfully said, I live for the love of my patients, and this presentation is going to have a very different way to present because I've been hearing to the speakers before me, and I think the aspect of orofacial pain has been very beautifully covered, and I think Dr. Sumit covered it very, very completely. We begin with thanks to God Almighty. His grace is what runs the OFP energies and the life for everyone. And a heart full of gratitude to my mentor, Dr. Gary Hare, and my friends who made this journey of learning for OFP possible for me. Whatever I am doing with each and every patient, I owe it to Dr. Gary Hare and my life coach, Dr. Sandesh Maikar. In terms of trainings, yes, after OFP, I trained on a lot of things. I'm a trained and licensed acupuncturist. I have done manual therapy courses and varied forms. I did palliative care. So I'll take a minute to share here this aspect because I see a lot of people who are looking at developing in orofacial pain. Orofacial pain and dentistry don't go hand in hand, according to me. It helps us establish the differential diagnosis, yes. But if we want to be in the clinical world of orofacial pain management, we should jump wholeheartedly into it and not think dental, doing dental work every day in and day out. Because the thought process and the way we train ourselves and align ourselves needs a shift. And we are like a bridge between medicine and dentistry. So every time I got a case, I went ahead and did a course. Like I got a patient who got into very bad pain after root canal treatment. And this person had a motor neuron disorder. And when the root canal treatment was done, immediately 2 weeks after that, this patient also developed dysphagia. What do you do if you see cases like that? I didn't know at that time. That's when I did palliative care at AIMS Delhi. And each of these courses is like that. So keep training and keep getting better with each patient that each one of you are treating here. Everybody here knows what orofacial pain is, what it encompasses, what are the possibilities of it. We have spent some time understanding what is the difference between acute and chronic pain. What the fact that needs to be communicated to patients and the public is that chronic pain is a management domain. When patients still come with the expectation to the office that they have walked in and started the treatment and they'll see the end of it, you have to really explain them. This is like diabetes. We'll help you. We partner with you in your journey to live a good life, live a pain-free life. But this is not the domain of 100% cure. Yeah, though as like we work today in an integrative manner, we are able to rehab some of the patients, not all of them, some of the patients. So it's very important that the reality of chronic pain be communicated very well to the patients. Okay. What's my screen? So hunger, love, pain, fear are some of the inner forces which rule the individual's instinct for self-preservation. We titled it Clinical Pulse because these are your take-home messages that I would like to communicate from this presentation. Because looking at a person as a whole is where the beginning of chronic pain management begins. We have to understand there are people who would want to live in pain. I'll tell you a patient story whom I saw very early on in orofacial pain practice, a very well-established, renowned industrialist of Mumbai city. He came to me with a simple temporomandibular joint disorder. Yeah, when you become the granny, TMJ disorders become simple. And this guy got about 70% better and came back to the clinic and picked a fight with me. And he said, "Why have you healed me? How come I am better?" And we believed that patient इसीलिए तो आया है. तो बोलते हैं नहीं, मेरा कर्म था कि मैं डॉक्टर के पास जाऊं और अच्छा अपना इलाज कराता रहूं. But my astrologer had told me that this suffering is essential for my karmic redemption. So he blamed me for becoming a barrier in his karmic redemption. I said, now what do? You stop doing this, you become 70% better, stay with it. And that's the reality. That guy stopped his treatment when the point where he became 70% better. And this taught me that every human being is unique. And as a clinician, we have to understand their uniqueness and connect with their needs. Okay. The dental office usually gets a very mixed presentation. And one of the hardest spot is to be able to establish the differential diagnosis of the patient then. And there aren't many people who are treating it. So the patients keep circulating amongst a lot of dentists, and that's how OFP came in. When we begin an OFP, like I run an exclusive orofacial pain office, we do nothing but only OFP care for patients in this office. So if it's a psychiatrist, if it's a nutritionist, if it's a pulmonologist, whatever you need is in-house in this clinic for taking care of our patients. But this is a bare minimal requirement to be able to rehab a chronic pain patient. And we have to be able to ask, like Dr. Hare used to say, orofacial pain is onion peel management. We take one layer away and then the next one is going to show. Until we find complete relief or comfortable spot in the journey of healing between the patient and the doctor, the work is on. We know that there are 3 basic types of pain in orofacial pain. The epidemiology is high, and with so many Indians on this forum today, I think also I would like to request all of you to let us come together, design and create some epidemiological data and studies from the Indian subcontinent. The Asian phenotype is not the same like the Caucasian phenotype. I have stayed in United States for 9 years, and I have seen the OFP practice there very, very closely. And the kind of response, and this was one of my biggest challenge in the first year of practicing in India. How do I adjust the drug dosages? Because if a US patient could take 30 milligram, maybe an Indian patient was struggling with a 10 milligram also. They do not take to drugs very easily. Our mindsets are different. Our food is different. Our genetic pool is different. Our phenotype is different. So we must design Indian studies around this subject. And with so many people practicing orofacial pain, I think this is the time and our opportunity, and we owe it to the generations to come. So we must come together and try to put some effort in that direction. We now have understood, after hearing to such interesting case presentations, that diagnosis is the first step. The ability to diagnose comes with knowledge. Yes, one thing. With experience, another thing. But the most important thing is listening to the patient. We have to be able to listen to our patient, work backwards, connect it with whatever theory we have learned, and come up with a treatment plan that can put patients on the journey to heal. So listening is the crux and the key of being a successful orofacial pain practitioner. And that is why that tea time is so sacrosanct in our office. Patients are telling and sharing with you what they want to say. So just don't hear what they want to say. Hear what they are saying. Try to understand what they are saying and what is inside of them. Okay. When you come to our office, there is no big paraphernalia, there is no big presentation, and it's by design. Because we want our patients to be able to connect and find their comfort and start their healing journey. These management strategies are the hallmark or the bane of treatment therapies, therapy design. Mixing and matching all of these things, yeah, we are able to successfully treat most of the patients, but the crux is the diagnosis. And in India, we have mixed presentation, and very, very commonly mixed presentation. I am yet to see a patient who has shown to the office for treatment and giving when you ask for the pain intensity, nobody gives a rating of less than 6 on 10. Why? Because anything at 1 and 2 चलता है. हम एक जुगाड़ का कंट्री हैं, हम एक चलता है का कंट्री हैं. उसमें डिजीज को एक सिग्निफिकेंस देने के लिए it has to come to a significant point. We'll walk through some cases where we will try to get our pearls registered. So this patient had pain in 3 different parts: zygoma, neck pain, headaches. Okay, you can, if you look at it knowledge based, हमें उसमें सब कुछ मिलेगा. But where did it begin? Begin from the very beginning. Like Dr. Hare used to say, first question always used to be, there was a time when you had no pain. Let's begin from there. Okay. So this guy had history of injury, and the symptoms which made it worse were function. Any patient who comes to an OFP office usually will see ENT, neurologist, pulmonologist, and maximum number of dentists. And what are the findings on the examination? We had findings with the muscles, we had findings with the lymph nodes, and we had findings with the joint also. Lekin, what is it that made us think otherwise? Is it the CBCT that established its diagnosis? No, it is connecting the dots. There is an internal derangement as per the CBCT suggested. So the next thing was that, okay, we must do an MRI, evaluate for what is wrong with the disc. But, you learn. This is a 2016 case and we are talking about in 2024 for a reason. But you learn. This patient, we put him for sonography. Why? Because there were enlarged lymph nodes. The enlargement of the lymph nodes has to be ruled out first, because on clinical examination, it was palpable. So that's why I placed this patient for a sonography first. And we diagnosed it to be thyroiditis. So we referred to an endocrinologist. We brought his thyroid function within normal range, and that helped 80% of the pain go away. Now, should we go back and treat him for the other problem?
સાંભળ આશા રવિ એના કોઈના કામના નથી પ્રોપર ઇસ્ત્રી વાળું જોઈએ આ જોઈએ આપણે એમ નહીં.
So we do that. We started his treatment with ultrasound because we wanted to bring him the relief with the secondary muscle changes and address the perioditis also. Then we did the trigger point manipulation, not the injection. We did the manipulation because we have to keep the patient comfortable and wait for those 3 weeks period. Why 3 weeks? Because 3 weeks is the duration that, remember long-term potentiation from the physiology lectures, that much is the time that human brain is going to take for any neuroplastic change to register in the body. Okay. And we have pharmacotherapy ongoing to keep the patient comfortable. Okay. Yes, that's his testimonial. You can find all the patient testimonials online on Facebook, on Insta, and you can hear their stories. This patient found relief after 12 years, but that is what he says. We don't know. He came to me when it became peak 10 on 10, but he had a 3 on 10 pain, 2 on 10 pain ever since he got injured. So he ignored that disc internal derangement for so many years, where it brought in the change. Is he all right today? No, he's not. But is he managed? Yes, he's well managed. He's still using the splint. Now, what is the challenge in managing this patient is he loves to work out. When he got into the pain-free zone, he wanted to build his muscle. So he joined a gym. He does not like to use his splint while working out. And he will come and not tell me that because he saw me as a miracle doctor who could get him out of everything. So it took my associate making friends with him, going for lunches with him, and following up with his gym instructor to figure out what is he doing in the gym. And that's how we came to know why he keeps getting into pain very frequently. We worked with his trainer and modified his exercise regime. It only convinced him not to do weights like 100 kg, 150 kg. And then it is that, okay, he lives pain-free. So, the pearl that we have is that systemic correlation of pain is to be considered in management. It's very, very important to look patient as a whole and understand their systemic correlation, which means as an orofacial pain clinician, it's very important to have understanding of internal medicine and physiology. This is next case for us. So root canal treatment done, diagnosis of trigeminal neuralgia. See, every patient who comes to our office would have undergone a lot of dental treatment, would have been treated for trigeminal neuralgia, would have been treated for migraine and atypical facial pain. These diagnoses का treatment हो ही चुका होता है by the time patients come to us. So the history is right there. Everybody can read it. What was significant was that this was pulsating pain, but was being treated as trigeminal neuralgia. So, is pulsating pain the quality of trigeminal neuralgia pain? That's something that all of us need to think. We did the local anesthesia injection. It could not block the pain. So our differential here is that the treatment was on for one root canal on and one trigeminal neuralgia treatment on. So if tooth was the culprit, anesthesia would have blocked the pain, but it did not. And if trigeminal neuralgia was the right diagnosis, medicines should have helped, but he never once had and he was already on a lot of meds for us to see the refractory period or a lot of other things. We sent the patient for MRI. Vermian atrophy was seen, nothing else was seen in this patient. Okay. The following prescription was there, and by adding tapentadol, which is a synthetic opioid, the pain came to 2 on 10. After a few days, we added duloxetine because like we learned in the previous lectures, neurogenic inflammation is what sustains pain. And duloxetine will help us with that neuropathic state. So neuropathy will be taken away. The pain did come to zero, but he came back to clinic in 15 days with excruciating pain. That's when we did HRCT of temporal bone. Nothing was diagnosed with it. Everything was inconclusive. Differential diagnosis still stayed in these many domains, okay? But pain of odontogenic origin was eliminated by anesthesia injection. Was it cracked tooth syndrome? Okay, now when he has come back with excruciating pain, we did the injections with tramadol and it helped the pain. It did not go away, but it helped the pain, okay? This was his diagnosis. Pulsating pain, it was atypical with a background dull achy pain. It was atypical chronic paroxysmal hemicrania. And one of my mentors is Dr. Benoliel. And Dr. Benoliel is like looked as God with neurovascular pain. And he is the person who helped me with this case when I saw it for the first time. I'm sharing this information because orofacial pain is also a domain where discussions and the grand rounds, like we used to call them, are of great significance. And sharing openly is very much the need to build a cohesive community. Okay. So Dr. Benoliel was in Israel at that time, and definitely I shared the case, and he had helped me put up the regime. Now, only thing I did different was I made lamotrigine dose very less, 100 milligram per day. That's where this patient found complete relief. Symptoms went away and he could live his life comfortably. He followed up very well for 2 years, 2.5 years. And then because he was pain-free, he stopped taking the medicines also. We are blessed to be in India, and we have great therapies in yoga and Ayurveda. At our office here, we integrate them for our patients because most of our Indian patients want to get off the medications. And this patient is also one such case where he got off the medications with yoga and Ayurveda subsequently for getting the detox with the side effects of lamotrigine or all other medicines. What we want to register here is that atypical presentation of known entities are not rare. We see it routinely. Every week, there are 2 or 3 cases I see which are atypical presentations of the known entities. So thinking out of the box can never go old-fashioned. Always keep thinking. Let's talk about myofascial pain now, which is 70% of the cases that we see and the bread and butter in orofacial pain. We spend a lot of time trying to understand it, but what I want to highlight is that emotional stress is a very, very big reality. Most of the people of myofascial pain get disproportionate flare-ups with pain intensity when the exacerbation is happening with the emotional stress. For us as clinicians to be able to diagnose this and help our patients, we need their trust and we need that space where they will open up about their problems in reality. And then we, of course, need the understanding and knowledge about the convergence mechanisms and which muscle refers where and what. And then identify those muscles and block it and establish our diagnosis. Source of pain and site of pain are different. And this is the whole mess. And in India, patients do not come with one problem. It's not just SCM that will be referring. It will be SCM, it will be digastric, it will be trapezius, and they don't want to pay for multiple injections. So you have to be really thinking, well, either you will have to be doing charity And then you will be working from morning till midnight, and still, I don't know if there'll be food on the table. So we have to use a lot of discretion in understanding our patients and trying to decide on which is the most significant muscle there. And you know, Dr. Curtis, one of my teachers, always used to ask us this question, that if you have a magic wand, which is one pain that you want to take away? And patients will always answer this question. If it is the headache which is bothering them, then you have to block the SCM. Then you have to block the trapezius. Ask them to show you what location they are showing. And then block the source of pain, understanding the site that the patient is pointing out. Ear pain is a very, very common problem. 1 in 10 in ENT office is our patient from orofacial pain. The ENTs, yes, understand when we reach out to them. So I have done a couple of presentations at ENT forums, and the ENTs who know me, they do refer it back to our office. But I'm sharing this here with so many people as budding OFP practitioners that please make sure all the ENT specialists in your area know about your line of work, because they understand temporomandibular joint and they refer very, very encouragingly. Okay. The trigger point pain can be a 10 on 10 pain. Trigger point pain can be associated with autonomic signs. So every time a patient is tearing, it is not sunk. Every time there is an autonomic sign like a rhinitis, it's not a TAC that we need to rush for. The basics and the simple facts have to be ruled out first. And it is very common in India to see very severe pain with trigger points, and a lesson learned very hard way for me that I'm sharing. It took me 6 years of practicing OFP in India to understand this. And the day I resolved that I will accept it, mentally became peaceful, and my patient communication became very easy. Every patient believes that they have neuropathic pain. It has been drilled by so many people into their head that इतना severe तो nerve का ही pain होता है, तो आपको ना nerve की problem है. And then here you sit with the diagnosis of MPDS and try to tell them, do this trigger point injection and this and that. They don't accept it. And then they will, it's very easy for them to say कि ये doctor जो है ना मेरी problem समझ नहीं रहा है. So very happily tell them, ठीक है, आपका ये नर्व का पेन है, अब इस नर्व के पेन के साथ में दूसरा पेन जो है ना उसका ट्रीटमेंट पहले करते हैं, फिर नर्व के पेन का इलाज करेंगे. And that's how I started getting compliance for trigger point injections and the treatment for MPDS. And once patients got all right, yeah, then it builds up. Today, a patient only brings a patient for me. So build it up that way. Coming to neuropathic pain, we have spoken a lot about it, and I think theory part of it I will skip, and I will go to another presentation and I'll share a case from here, which will be interesting for this cohort. This lady had come to us with sudden severe sharp shooting pain in 2008. Okay. That should not come to us. Her pain had started in 2008 as a sudden sharp pain right after childbirth when she was eating a laddu. But nobody thought at that time it could have been a cracked tooth syndrome, because गोंद के लड्डू में एक stone आया था, and she bit on that right after her delivery, and that's where the pain began. It was should last for 1.5 to 2 millimeter. At that time, she was not finding any relief, and air was aggravating her pain. Maybe it was a cracked tooth syndrome. We do not know. Today, we do not know. So dentists extracted the wisdom tooth but the pain still persisted. Okay, sorry, what happened? How do I get out of this now? Sonal, can you help me?
What happened? You cannot go to the next slide, is it?
No, the meeting chat is, the chat box has come.
No, the chat box, you can just shut it. There's an X button there.
Can you guys see the screen or the chat box?
I'm seeing
Okay.
the screen.
So I'll keep going then.
No,
Okay.
we are able to see your screen, doctor. Go ahead.
Wait, just a minute. No, this is not, slide stop moving. Okay, so, at that time, rhizolysis was done for this patient. You give steroids, you give carbamazepine, you give pregabalin, a lot of things. This patient could not feed her first child because she was put on all those medications. Rhizolysis was done for a few years. It was taken care of. She was diagnosed as trigeminal neuralgia, and, procedure after procedure was done. She never found relief completely. It kept coming back again and again for her. Okay. And CT guided radiofrequency ablation was done. So every time the duration got better, but the pain kept coming back. Okay. We get to see patients in our office really at the end of road. And RF, V2 ablation done, V3 ablation done. And this is when we have seen the patient. You can see the profile pictures. This is the history that we took. Okay. Slight touch was aggravating the pain. Okay. Was it multiple surgeries that had been done for trigeminal neuralgia that were creating it? We don't know. I never rush for starting the treatment for patients. I'm again hung. Why? Okay. So medical history was non-contributory. Psychological assessment, yes, will have some factor with so much of stress in life. Yeah, this is going backwards now. Now escape it. So patient has come to us in 2014. Okay. Can't see anything.
Yeah, your slides are not visible, doctor.
Okay. Patient had come to us in 2014. And what I wanted to share here was, can I stop getting these requests to admit? No, my slide stops moving every time I get a request for admitting.
Don't worry about that admitting part because you're a co-host. You are seeing that message, but just ignore. You keep on continuing with your slides.
So this is an intraoral picture that we took just to see what was happening. Blood test done, trial therapy done, final diagnosis was PTTN. Painful peripheral traumatic trigeminal neuropathy. That's what we treated the patient for. Medications that we started were on gabapentin, oxcarbamazepine, and Tidal. Tidal enhances the modulatory capacity of the patient. And that's my research work, exercise-induced analgesia. Since most of you have studied with Davis and you would be understanding now what DINIC is, that is a drug that really helps build up the modulatory capacity and helps in these kind of cases a lot. It took us 1 month to bring the pain to zero for this patient by working on adequate drug titrations. We keep the patient comfortable by a lot of local therapies. We take away the secondary musculoskeletal pain for the patient at all the times. And this is what I wanted to share with neuropathic pain, because these patients, I saw that there was a lot of things that got shared in terms of theory in the previous lecture. So I really wanted to discuss a case where in neuropathic pain, what is it that I see commonly? It is neuropathies, traumatic neuropathies, because a lot of pain physicians patients are referred to pain physicians. Two diagnoses are very common there, trigeminal neuralgia and atypical facial pain. And they do ablation for trigeminal neuralgia. And patients I have seen patients of periodontal problems undergoing ablation for trigeminal neuralgia because patients don't treat periodontal problems. And dentists do not acknowledge or see the intensity of pain in periodontal problems. So odontogenic first, odontogenic first, odontogenic first. Please believe it, live it as a mantra. Any source of infection, treat it. Remember, periodontal fibers go to the motor nucleus. And as a feedback back, you patients can possibly get pain of very, very high intensity. Okay. So these are the common diagnoses, and all of these things you have learned in theory part that I skipped has been covered. Think beyond trigeminal neuralgia and atypical facial pain. Whenever suspecting neuropathic pain, please think of the mechanism of pain. I think I turned lucky because mechanism of orofacial pain based classification has been designed by Dr. Benoliel. And Dr. Eliav and Dr. Benoliel and Dr. Hare, at the time when the job was on for these mechanism-based work, I was a resident. So वो एक पीजी होने, एक अच्छे पढ़ाकू पीजी होने का फायदा हुआ. सारे मेंटोर्स का काम करने को मिलता था और उस प्रोसेस में my brain got wired. But I really encourage each of you to please read it thoroughly and think in terms of mechanism. We just saw a case by Dr. Deepti, right? What is it? Mechanism-based thinking. We have to think mechanism. Any kind of problem, this has been the way that we manage for years together. This is 2025. And I have been with the world of pain management since 2009 in different capacities. I graduated in 2013, but this is all that I have seen gets us the results. What is of utmost significance? See, my mentor, Dr. Eliav, I call him my research mentor. Dr. Eliav, he is like the god for quantitative sensory testing in the world. And QST, unke saath seekhte, we learned the value of sequence. You know, the German neuropathic group has done a lot of work on the sequence of QST testing. And there, what I learned after coming to India, because today is the first time I'm using these words in a presentation at a dental forum. But what do you talk about conditioned pain modulation? What do you talk about QST when differential diagnosis is only not being understood? That's where I started my practice in India. So I started applying that same thought process to the protocols of treatment that was existing in India, which is Ayurveda, which is homeopathy, which is yoga, and you can fit it back with our modern mechanism-based understanding. And we get outstanding results if the day we are able to put the sequence to the therapeutic approach that we design for each patient. But what is the key for us to be able to do it? Diagnosis. Like Dr. Hare always used to tell us, you cannot find what you don't look for. So keep looking until the pain is at 0 on 10. It is very, very important to know what sort of a patient has the disease. Rather than what sort of a disease a patient has. You know, if it's a CFO, I cannot work with the trigger point manipulation. Their life is always on fire. I have to have trigger point injection as my first line of therapy. If it is very, very important to design the treatment based on the patient that we have. And like everything, it's always about the people who are there as a part of our life which design our journey. So my special thanks to all the people who have partnered my journey. And thank you so much for all of you for your patient hearing. And I'm open to all the questions that you may have, if there are any.
Dr. Ruchika, thank you so much. And as usual, you made the most difficult of the topics seem so simple, that you need to be human first to understand what is happening with the other person. So this human touch of yours is really commendable, because what I understood from your lecturing is, yes, you are concentrating on the most debilitating health condition and conditions of patients, but you are treating them as individuals first, humans first, and not just a case history. So that makes a lot of sense. When we are treating our patients, they're not just case numbers or a case that has walked into your practice. Look at them as humans. That is very important. And thank you so much, Dr. Ruchika. And you may look into the chat box. If there are any questions, then you can answer the chat box. The chat box which was worrying you up till now. So
Yeah, because it keeps popping up.
I know, and you're presenting from Mac, so I can very well understand what is happening. So this learning curve all dentists we have to go through. Otherwise, have a husband who's an IT tech who can help you around, or have a person around who does that. That's what I always tell everybody. Thank you, Dr. Ruchika, and it's always a pleasure listening to you. Just listening to you, I don't say don't prepare slides, just talk. That is also a learning lesson for everybody. Thank you so much, Dr. Ruchika. With that note, I would like to invite your good friend, Dr. Ajay Nayak.
My lifeline, because
Okay, Dr. Ajay Nayak, can you just switch on your camera? Dr. Ajay? Dr. Ruchika, I think you shut down your camera screen in the excitement. I guess that your laptop is shut. Yeah, Dr. Ajay Nayak is here.
because we both chose to sit in my office here together. Thanks for giving us some time together. But when I started practicing in Mumbai, and I had nobody knew what TMJ radiology was. There
Okay.
was somebody I could call and I said, please, let's get started. इसमें क्या है ऐसा? And there were some, he was clueless in those days, like I'm talking about 13 years back. And he would be like, मैंने कहा अच्छा सुन तो, मैं जो कह रही हूँ ये history सुन तो. And then that's where the journey started. The moral of sharing this is, please work on developing that cohesive ecosystem. See, OFP is not an individual game. OFP is always teamwork.
Yes.
And you need band mutti ki taakat hai OFP. ये सबके लिए है.
Exactly. Do you see any forum or any conference with 39 speakers? At one go in 3 days, 39 speakers are presenting cases, and they're decoding orofacial pain. The reason is that because as the cases are multifactorial and multidisciplinary approach we need, similarly we need different brains working on that. And I just want a streamlined method. Maybe there are ifs and buts and agree to disagree kind of situation. Hello, Dr. Nayak. But I would want a streamline for orofacial pain practice in India. And that was the motive behind this whole session. Dr. Ruchika, thank you so much. And with that note, I will welcome Dr. Ajay Nayak. Dr. Ajay Nayak comes in with a lot of recommendation. Dr. Sonia Bhatt from UAE spoke highly about you. And Dr. Ruchika was all so excited. I could see the way she shut down her laptop screen. That says it all. She forgot that she's not she's presenter here. She forgot about it and she started talking to you. So that says it all. And we all need buddies. We all need these kind of this friendship is all that we need. That is what is the need of our. We all are here for one motive, and that is patient care. And the excitement and the kind of collaboration you two showed, that actually is the glue what we need. Thank you so much, Dr. Ruchika and Dr. Nayak, for showing us what we really need, this friendship. With that note, I would like to welcome Dr. Ajay Nayak for the first time. Yeah, others please mute. Don't disturb my script. Yeah, forget. I keep forgetting my script. Then please don't do that to me. Okay, Dr. Ajay Nayak is he's an exclusive. Please mute yourself. Okay. Dr. Ajay Nayak has an exclusive practice in oral medicine and maxillofacial radiology, and he's worked in colleges and at Mangalore, Manipal, Nasik, Karad, and has as an academic role. And currently, he's the chief radiologist in Insight CBCT, that is India's first exclusive 3D maxillofacial imaging center in Mumbai, managing 8 Insight CBCT centers. He is a keynote speaker at various state, national, and international conferences and workshops, and developed a CBCT based grading index for TMJ and cervical spine osteoarthritis. Received copyright for GOI. Doc, that's commendable. Like receiving a patent kind of a thing for something like as critical as TMJ and cervical spine screening. This is commendable, Doc, and
That's again a collaborative thing. I'll be speaking in my talk about
yes,
it.
yeah, we would like to know if there is a future and if somebody wants to do more in research work. So it's not
Absolutely.
everybody's cup of tea. I
Absolutely.
try writing papers. My husband is into PhD. He's a PhD doctor, and I've seen the way he's always like, "Is this A category?" And he keeps talking terms and they're layman for me, and I'm like. And the referencing in the Harvard and the API style. I was like, what are you talking, man? This is the case. This is the patient. He's like, no, then you need to have a different kind of dedication to reach to this
Absolutely.
level. And
Absolutely.
my daughter is also into something like a research work and all, and she and her father keep talking about this, and for me it is all layman's language. So it's nice to have a researcher or somebody who has had patent in such a niche field. Welcome, Dr. Nayak, to IPCON 2024, and the stage is all set for you. You may start sharing your screen. Yeah, please go to the presenters mode.
Yeah. Is it visible now?
Yes, please go ahead, Doctor.
Yeah. Thank you so much, Sonal, for such a wonderful introduction. And, as Dr. Ruchika mentioned, that it has to be a collaborative thing. So everything that I show now is based upon collaborative things because, like Dr. Sonal mentioned, that I am a maxillofacial radiologist. So whatever is sent to me are the cases by other OFP specialists. So that's where I stand upon their shoulders when I bring you this presentation. So I will be talking primarily about an insight in CBCT imaging because that's what I've been working on for the past 11 years and little things here and there apart from CBCT as well. So as Dr. Sonal introduced me, I'm Dr. Ajay Nayak and I'm the Chief Maxillofacial Radiologist at Insight CBCT. And primarily, I'll be talking on this outline where I'll talk very briefly about imaging, then talk about heart tissue imaging, then we'll go to the focus on the CBCT imaging, then the TMJ degenerative joint disease or osteoarthritis grading system that I developed in conjunction with another colleague, and then a very brief note on soft tissue imaging, and then finally, I'll give you some prescription tips as to how you may incorporate them in your practice when you go about getting these investigations done. So whenever we start with imaging, it's very mandatory to talk about Sir Röntgen, who discovered X-rays and created the first radiograph in 1895. That's about. You'll have to mute your.
Others, please mute once
Yeah, no, that's only here. So Sir Röntgen made this radiograph about
Dr. Nayak, is there
130
a
years
device that is running around with
Dr.
you?
Ruchika, she's moved away. Now can you hear better?
Yeah, now there's no echo. Thank you so much.
Right. So Sir Röntgen made this first radiograph of his wife's hand, and that was done about nearly 130 years ago. So in that 130 years since, it's been a constant evolution from this very blurry image that came to like highly sophisticated, detailed images that we now get. And from the 2D images, we have evolved into 3D imaging through CT, through MR. And from that came the birth of CBCT, so that brought about a profound change in maxillofacial imaging, just the three-dimensional imaging. And then the advent of CBCT in the late 90s came about in the world in Japan and in Italy. And from there, then it's come to India in 2009. Various colleges got it and a few machines came in Delhi on the medical side. And then finally in 2010, Insight CBCT in August opened its doors. And I have begun my journey from 2013. And that's when I have been completely immersed in CBCT imaging and the various aspects of it. So what I present today is my experience based upon these past 11 years. So I also authored a chapter on orofacial pain about 15 years ago in this textbook of oral medicine, oral diagnosis, and oral radiology by Ravikiran Ongole and Praveen BN. I believe this is taught in the dental colleges. I don't know how many of you have actually read it, but this was the chapter that I wrote way back then, given my interest in orofacial pain. And combining it with imaging, imaging is the third eye that we have. It's completely non-invasive, though it may have certain side effects related to radiation. There are, of course, other imaging modalities which do not use radiation, but then it's completely non-invasive, where the patient is not subject to much, where you need the investigation and you get the investigation done and the patient is not cut up or anything of that sort. Primarily, what we look for is hard tissues, but also the soft tissues are seen on the imaging modalities. And now some imaging modalities give very good soft tissue, better than hard tissue. And therefore, we have these various modalities, beginning from the dentist perspective, you will say from a very simple periapical radiograph to a panoramic radiograph, and then the higher imaging modalities. So some of them are very easy and some of them are very difficult. What do you mean by that? Some of them are very easy to obtain. Some of them are very difficult to obtain. Like an MR scan is not at all easy for the patient. So many patients get scared of it because they have to be through the procedure for a prolonged duration. They are claustrophobic. That becomes a nightmare for them. And when they come in for a CBCT scan, the first thing they ask is isme letna padega, andar awaaz aayegi? And then we show that it's an open machine and you either sit or stand. There's so much relief. And the other perspective from the clinician's aspect is some are very easy to interpret and some are quite difficult and require absolute expertise. So it may not be possible for every dental clinician to then look and interpret these images. So let's go into hard tissue imaging and see what it's all about. So hard tissue imaging primarily started with 2D radiographs. So even in orofacial pain, when we didn't have the benefit of 3D imaging, we used to get images like this. So I don't know how many people have seen these images, but about 22 years ago, when I was doing my post-graduation, these were the kind of images we had to go through a lot of circus to obtain these kind of images. So this is called as a transcranial view of the TM joint. So what you can see is there are a lot of shadows, there's a lot of superimposition. So essentially what we need to see are these pertinent structures. So when you want to see that, look at the amount of clutter that comes around with it. So this is something of the past, and I would not recommend anyone go back there because it's all history now. And we have better imaging modalities. Then came the panoramic view or the OPG. Now, every dental clinician is very familiar with this. Even the medical personnel are very familiar with this. And what happens is OPG is prescribed very randomly and routinely at times. And sometimes that's what causes problems is what I feel, So this is now a digital version of a panoramic radiograph, but when panoramic radiograph initially started, it used to come on radiographic films, and that had to be obtained through an analog process in the machine. They had to be processed manually in a dark room, etc. But now with digital radiography, it has come much more clearer. And then that has evolved into these kind of 3D image, panoramic radiographs, which can be obtained from a CBCT scan. So you see a lot of the superimposition is taken away. But at the end of the day, I would caution not to, rely too much on a panoramic radiograph, 2D radiograph, because it's a very good screening tool. But remember that this is a flat image of three-dimensionally complex tissues. So a lot of normal things appear abnormal and a lot of abnormal structures start appearing normal on this radiograph. So that creates a lot of problems at times. And I usually in my practice, what I see is patients have a radiograph and they have been told that there's absolutely no problem in the TM joint. Now, if you look at this TM joint will look perfectly all right. But now by the experience of, multiple thousands of scans that I have seen through, I absolutely do not believe in looking at 2D images like this because a whole plethora of findings lies in the three-dimensional sections that we see, which I'll show later. But this is absolutely deceptive. So I would recommend that, you absolutely stay away from this radiograph until this is the only option remaining to do and there's no other imaging modality available around you. Then you can maybe look into it. But otherwise, I find this highly unreliable. And then we also have this panoramic TMJ tomograms that used to come through the panoramic machines. I think Dr. Asrani also showed this yesterday. And he too said the same thing. These are of absolute limited value. All you can see is the position of the condylar head and versus the articular eminence and the glenoid fossa. and that too is fraught with so much superimposition. So that becomes a very painful thing to be absolutely certain to tell that this is what it is and this is what it is not. So I would, recommend that people stay away from these. Now, these are the other modalities that are there that for, especially of the hard tissues of the TM joint, that's a very common OFP part that people deal with. So these are the various modalities that are there and we do use them, but my sustained expertise now lies in CBCT. So that's what I'm going to present. And given the paucity of time, it's not possible to talk about all these modalities today. So I'll concentrate on the CBCT aspect. So in the hard tissue, like I said, but CT and MRI give a lot of information, and many clinicians very commonly ask me that which one should I go for? Should I go for a CT or should I go for an MRI? So I would say that they are complementary to each other. One cannot survive without the other because a lot of information comes from a CT scan. Similarly, a lot of information comes from the MR scan, and they have to be put together to get what you need to find out for that particular patient. And in that aspect, we have now the CBCT imaging. So in the CBCT imaging, I would focus on the TM joint imaging, like I said right now, for this talk, right? But there are so many other osseous structures that are there in the maxillofacial region. These are very well shown up on the CBCT imaging. And like you heard the speaker, Dr. Ruchika Sood, speak just before me, she's a very demanding clinician. She is going to ask me, what is this structure? Tell me what happens here. Tell me what happens in the maxilla. Tell me what happens in the maxillary sinus. Tell me what's happening in the pterygoid region. Tell me what's happening in the cervical spine. She even demands what happens at the base of the skull. And there are so many discussions. We have had detailed discussions based on cases, sometimes weeks or months later, and then I have found something and she's found something, and then there's this constant give and take that happens. And even with the other clinicians that I deal with, so when they ask me certain questions, so these are the various structures that we can definitely see on a CBCT scan. And a lot of information comes out from a CBCT scan that may be done for whatever other reasons, yet it can be still interpreted with the OFP perspective in mind. So in TMJ CBCT evaluation, what are the things that we look for? So primarily, we are going to look for the condylar head contours because osseous structures are the ones which are going to be glaringly seen on a CBCT scan. The soft tissues are not so well seen, right? So we're going to look at the condylar head contours. So these are the first kind of images that we get. These are called as the parasagittal sections because they are around the sagittal plane but lateral to it. And they may be at a certain angle depending upon the condylar head position, okay? And so this is how it appears. You can see very well in this. Now let's look at this image particularly. So you can see the complete contour of the condylar head. So this is where the superior contour is. This is the anterior contour, the posterior contour. You can see the contour of the glenoid fossa, how the bone is, the temporal bone. You can also see the pneumatization that might be happening. You see this is the external auditory canal, right? So all these structures can be very well evaluated, and these are sequential slices. Now, for the sake of understanding, I've just put 9 slices, but you can go through multiple slices, and that's how I go through when I look at a scan. And you go from the medial pole up till the lateral pole, you see the complete glenoid fossa, everything from this perspective. So what do you see on these parasagittal sections? You see the superior inferior aspect, and you see the anterior posterior aspect. So these two aspects are very well delineated on these parasagittal scans. So the next part you have is the coronal scans. So this is how the coronal scans appear. The same TM joint, when we look at it from, suppose from the front, these are the slices we get. These are parallel to the coronal plane, right? Again, you evaluate the superior contour, you get the medial pole or the medial contour, the lateral pole. Again, you see very well the glenoid fossa. You see the temporal bone that is there. You see the infracranial fossa. So all these details are very well seen. And again, these are sequential. So they have to be seen in slices. For the sake of presentation, I'm just putting these fixed images, but these are very dynamic images where you have to scroll through them and then look at it and then understand what they are showing and then correlate their interpretation to what you might be seeing clinically, right? Then you have to look at the cortical architecture, how the cortex is, how the trabecular pattern is inside it. So what's the subcortical appearance, Then you look at the glenoid fossa contours on both these type of slices. And then finally, you have to see the condylar head position. This can be in occlusion. So in occlusion, this is how the condylar head is. Usually it lies in the center of the glenoid fossa. And then you have this in the open mouth position. So now this is a patient with severe pain on opening the mouth, and the patient had opened the mouth maximum and where it didn't cause him pain. As soon as the pain stopped, that's where we asked the patient to hold the position and we took the scan. And you can see now the condyle has translated forward, but not completely. So this is your articular eminence. So you can see that the condyle is definitely hanging behind. So now there it seems to be some, issue with the disc, which we can consider by elimination, because we don't see the disc. We say that the base is the condylar position. Then now this patient was, further referred for MR, and then the MR was taken, and then further findings were seen in this particular case, right? So this is how you're going to evaluate the temporomandibular joint on a CBCT scan. Now next comes is the contentious point of joint space measurements. Now, why do I say contentious? Nobody else contests it. I am the only one who contests it. And why? So this is something that many clinicians have asked me, that why can't you give joint space measurements like this? Because somebody else has given them like this. So now in this, the joint space measurement is written as anterior, posterior, superior, medial, lateral, etc. There's a measured value on that particular scan, and then there is a normal mean value. Now, from where this normal mean value has come, no reference is given. And like Dr. Ruchika Sood was saying, that in India, we have an absolutely great variance in terms of geography, culture, phenotype, everything that is possible. So standardizing something as a normal mean value for the entire country of India without a deep epidemiological studies which are multicentric in nature, I highly doubt how we get these mean values. I have not read any literature where it is extrapolated for the entire Indian country or the Indian subcontinent, right? And more than that, let me show you this. Now, this is what is shown as the measurement that is there. So now you can see that there is a measurement, okay, from some part of the glenoid fossa up till the condyle, okay? And this is all given like this, so be it on a parasagittal slice or a coronal slice. Now, my contention is this, that this measurement has been done on just a single slice. At the end of the day, this is still a two-dimensional image from a three-dimensional scan, right? So what's happening is this is just a measurement on this particular slice. So how are we extrapolating that to the entire joint? Let me show you by an example. Now suppose let's take this condyle. All of you are able to view this condyle. So now let's take 3 slices of this condyle. Now if you see, there's an orange color slice, there is a blue color slice, and there is a pink color slice. So this is not a slice right now, I've just drawn a line. So what do I mean by a slice? I take a knife and I chop the tissues along this orange line. Then I will get a slice like this. Now, if you see the difference between these 3 slices, first that each slice has a different thickness, right? So this slice is first of all at the lateral most aspect of this condyle. This slice is at the medial most aspect of this condyle. Look at the thickness of this slice, look at the thickness of this slice, and then look at the thickness of this blue slice. Entirely different, right? So when I do that, this measurement is definitely going to change. Now, if you see the anatomy of the condyle, can you see this? At the lateral pole, this is more anterior-posteriorly wider, right? So when that is there, how is this measurement going to be justified? What's the scientific premise for it? I absolutely refute that this measurement can be then used to talk about the entire joint. How are we talking about a joint space, which is a volume, basis just one slice? So I want each one of you who's dealing with OFP to think about this. Don't take it at face value because I'm saying so, but I would like you all to think about this and then work. And if there's a counter argument, I'd be very happy to read or see it if somebody tells, because I need to broaden my perspective as well. But this is what I think bases my understanding of the CBCT scan and three-dimensional imaging with slicing, right? So now see, this is the same patient in another slice. So now this is there, this is there. Now you see, this is giving 350 here, 3.50, and this is giving 1.61. Which measurement are you going to take in this very same slice for this particular joint? Are you going to average it? How is the average going to work? So that doesn't work at all, in my opinion. So this is very, very problematic when things are written like this, because the biggest problem that comes along with this is that it is not reproducible. Now, this is another problem that I have seen in many things where measurements are done on these 3D images. Now, these are 3D reconstructed images. The software is reconstructing this image by stacking each slice one upon the other. So now if you see, this is the same image correlated here. The actual measurement has been given on this slice, but you can see that nearly 80% of this styloid process is not seen on this slice. So what are we measuring? That means this process is curved. So this measurement is not going to hold good. And these days, especially when these are written in the reports, the patients read it, and patients are highly educated these days, and they're going to come and question both the radiologist and the OFP specialist who has referred this. So then that becomes a problem if you're not able to justify it. And like I said, these are highly non-reproducible. So I absolutely abhor this, and I am completely against writing such measurements in these joint measurements. And that's why I called it contentious. And later, maybe we can have a discussion on this. And if somebody has other points to add, I'm very much open to it. But this is my opinion. Don't take it at face value, but do consider it, please. So now the osteoarthritis severity index that was mentioned by Dr. Sonal. So this is a CBCT based index. And how did it come about? So past 11 years, I have been assessing TM joints on CBCT scans. And before that, I was assessing it on either CT scans or 2D images. And given that time, every time we would see certain osseous changes in the condylar head or the glenoid fossa, I would always find that there was a lacunae the way I would convey it and describe it. I mean, I could describe it by writing, lines and paragraphs, but at the end of the day, as an OFP practitioner, you would want something quite objective. Now, everything can't be made completely objective because some things are going to remain subjective. But this so happened that a year and a half ago, a colleague of mine, Dr. Sunanda Bhatnagar, she's an associate professor at Prerna Dental College in Navi Mumbai. She wanted to do a study and she came up to me and wanted help with the CBCT scans. And when she sat about discussing, the one question that she came and asked is, "Sir, आप ये कैसे करते हो? इसको आप कैसे बताते हो and how do you categorize this?" So I said, I don't have any literature to go by as such, but I usually, classify them as 0, 1, 2, 3. So she's like, "But ये sir कहीं आपने लिखा नहीं है, तो ये how will others come to know?" So she was very insistent, and like Dr. Sonal said, this requires a lot of paperwork and back-end work. And to be very honest, I have not done any of that work for getting the copyright because that required a lot of paperwork. And I just did my assessment part of the scan, and then she again assessed it because we did it as a multiple examiner thing. And then what she did is she completed all the paperwork and she applied for the copyright. And then that's how we got the copyright. So though it's written that I have gotten the copyright, absolute credit to Dr. Sunanda Bhatnagar because she did all this work. The paperwork was absolutely done by her, and she has the inclination and the aptitude, and she's an absolute taskmaster in this, and she does a lot of these things. And she did this very smoothly, and very sincerely, I did 0% of this. And then we wrote this study up, the study that she was doing, we wrote it up, and then this is how we have published it recently in the Curious Journal. And it is there on PubMed, and it's an open access article. All of you can do read it. And in that, the entire grading system is completely discussed in that. And I'll now explain the grading system as well, right? So the grade 0 starts with absolutely normal TM joint where there are no osseous changes related to any degenerative pathology. So this is how the condyles appear. Like I was mentioning, we have to assess the contours. The contours appear very smooth in this. There's absolutely no abnormality. The cortical outline is complete. You can see the smooth outline or the contour that the glenoid fossa has, the articular eminence has. All the osseous tissues are very beautiful is what I would say. I mean, you might find it ridiculous that this guy says beautiful, but as a radiologist, this is what I see day in and day out. And these are beautiful images for me, right? And so grade 1 comes to where there is mild flattening of the contours, if you're able to visualize. Now, for the sake of presentation, I have just put 3 slices. There are multiple slices that I go through with. And when I do that, so this is how the contours are assessed. So you can see that there is mild flattening in this anterior superior contour. The posterior contour appears good. The anterior contour appears good. All the glenoid fossa contour appears good. The articular eminence appears well and good. So there's just this mild flattening. Then there's mild thinning of the cortical outline. Can you see that? There's still a cortex, but it's not as well corticated here, right? So this is another case. So this is how a mild thinning is seen. Then we go to grade 2. Here we see there is a moderate flattening. You can see that the flattening is much more than what we saw previously. There's some flattening here in the posterior contour as well now, okay? And this is how it appears with erosions. So you can see that there is some erosion which is there here. There are more erosions that are there here on these slices. When we take other slices, we'll see it better, right? But there are usually less than 3 erosions. Then there is pseudocyst formation that is seen. So what used to be called as an Ellis cyst. So these are usually erosive areas. But in the 2-dimensional imaging, what used to happen is this used to appear as a cyst because it was usually subcortical erosion. And this is how it appears. So it used to be labeled as a cyst. It's not a true cyst, it's a pseudocyst. Then we have small osteophytes which are forming. So these small osteophytes are usually like this. So it gives a very initial beak-like appearance. So you can see there is some amount of flattening of the condylar contour, superior contour, and then there is this beginning of it. So that's still grade 2, where the disease has not manifested as much in grade severity yet. And then there is mild to moderate sclerosis of the cortical outline as well. Okay. Now we go to grade 3. So how do we characterize grade 3? There's severe flattening of the contours. What do I mean by that? Look at it now. It's almost like a tree stump. The tree has been chopped off and there's just a stump that is remaining. So this is how it looks, right? Then you have severe or multiple erosions. Now can you take a look at this? So severe. There are multiple erosions and this is like terrible. The patient was in absolute severe pain, right? Then look at this now. So not only the condylar head is having these erosive areas, if you see the glenoid fossa is having that, you can see here as well the glenoid fossa, and you can see that there is a reactionary bone formation also that is getting deposited. So it's a constant process of, bone getting osteoclastic activity and osteoblastic activity. And this is how it appears on an image. This is what I mean by a beautiful image, not so much for the patient who was in pain, but from a radiologist perspective, these are the stark findings that we see, right? Then we have the large pseudocyst formation. Now look at the pseudocyst that I had shown earlier, and now look at how large this is. So there's absolute amount of erosive changes that are happening in this condylar head, right? Then we have a large osteophyte forming. Now this is how it is. Can you see this? This is almost like a duck beak appearance. So there's a definite beak-like appearance here. And this is a very large osteophyte. And I'll show you one more case which is even larger, right? And there is severe sclerosis also. So now you see the amount of beak formation that is there. This is a coronal view, and look at how this coronal view is. So in this coronal view also, there is a osteophyte which is formed at the lateral pole now. And look at the amount of sclerosis that is formed in the condylar head as well as in the glenoid fossa. So all these are factors that you have to evaluate when you're looking for degenerative joint disease of the TM joint, right? So just to compare together, because I showed individually, this is how grade 1 is, this is grade 2, and this is grade 3. Can you appreciate the difference? Mild flattening, moderate flattening, and severe flattening. And now, of course, then the beak-like appearance that is there, a large osteophyte. This is a small osteophyte beginning here, initial beak-like appearance, a large beak-like appearance, and then this is definitely the largest beak-like appearance that I could have, right? Then we go on to the upper cervical spine. So now why upper cervical spine? So this grading system was done not just for the temporomandibular joint, but very often we saw that these patients also had problems in the upper cervical spine. So why upper cervical spine? Because the CBCT scan usually gives up to the C3 vertebra in the scan, sometimes C4 and very rarely up to C5 it comes. So primarily this is to be applied to C1, C2 and C3. That is the atlas, the axis and the C3 vertebra. So this is a normal vertebral appearance where you have the clear cortical outline, you have a very nice trabecular pattern. Everything is, again, like I said, beautiful. The same vertebra, if I take it in a thicker slice, so this is at a 0.25 millimeter slice, and the same vertebra when I see in a 5 millimeter slice, this is how it appears. So like I said, in the scan itself, a lot of manipulation can be done and different appearances appear. So you have to interpret all this with caution, and it has to be interpreted with right amount of experience and clinical information, right? So let's see how grade 1 is. Now, if you see in grade 1, there's mild thinning of the cortical outline. And here you can see there is rarefication of the trabecular pattern. So this is how grade 1 appears in the cervical spine. Then we have grade 2, where there is more rarefaction of the trabecular pattern. Sometimes there are erosive areas, if you can appreciate. Dr. Sonal, are you able to see the cursor as I'm moving it?
Yes, yes.
Okay. So you can see the erosive areas that are forming. Now, again, this is just one slice. The entire spine is not defined by this one slice, but for the understanding of, for this presentation, I put this one slice, but you have to evaluate the entire spine from the tip of the odontoid process of the C2 up till now. In this case, I'm getting C3, right? So like that, you have to evaluate and in various slices. So it takes a long time, but all these detailed evaluation has to be given, especially if the referring clinicians that you have are very demanding, right? So they ask me, इधर क्या दिखा, उधर क्या दिखा, ये क्यों है, वो क्यों है, क्योंकि clinically ऐसा है. So that's very pertinent because the clinical information that comes along with it is very relevant. And then I can see according to that what I can see on the scan, and I can relate that to them. Then they correlate. So this give and take is very essential. Then you also see moderate sclerosis of the cortical outline. Can you see this here? You can see sclerosis here. You can see the sclerosis here. And then there is small osteophytes that are forming. This arrow points to that, very small osteophyte. And then sometimes there is narrowing of the intervertebral joint spaces. I'll show you that in the next slide. Okay. So this is how usually a intervertebral space is. And this is another case of grade 3 now, where everything becomes more severe. So there's severe thinning of the cortical outline. In this case, it's not so severe, but there's sclerosis happening. Now look at this. This is supposed to be the anterior body of the cervical vertebra. You see these large osteophytes that are formed. You see these erosive areas. You see the sclerosis that has formed. So a lot of things. There's a small osteophyte here. There's a large osteophyte. But the small osteophyte is actually in this particular slice. It has other parts of the osteophyte in other slices. But here it appears like a small osteophyte. So you have to be very careful when you interpret this, right? And now this is another case where there were spinal osteophytes. Can you see that? So these spinal osteophytes were forming and they were compressing the spinal cord, right? So this was a very important finding, and then this had to be relayed to the clinician, and then they worked, got the MR done, and then involved the neurologist in it. So all such multidisciplinary approach comes out from sometimes as simple scans as the CBCT scan of the maxillofacial region. And then you have the C1, C2 rotation. So you can see now this is C1 and this is C2. Look at the same case, and these are sequential slices. Look at how these two vertebrae are rotated on each other. So this is something that you have to see. Now, very briefly, I'll talk about soft tissue imaging, right? In soft tissue imaging, what would be your need as an OFP practitioner? You would want to see the articular disc. You would want to see the retrodiscal tissues. You would want to visualize the capsule, the associated ligaments and the musculature, and the blood vessels, because they can also have calcifications. And we have had cases like that, Dr. Ruchika's case itself. And one more case I'll show, right? So in soft tissue imaging, again, we started with radiography in the way back when, and they were just shadows that we could see. And from that, we have progressed on. Now, in my CBCT scan, most of it comes as a dirty gray thing, right? But that's not helpful at all for diagnosing soft tissue perspective. But in the three-dimensional imaging, CT and MR, the medical CT, MDCT, and the MR scans show a lot of valuable information of soft tissue, right? I'm not speaking about those too much in detail today. Ultrasonography has been another blessing, which is the non-ionizing radiation. Already quite a few speakers have spoken about how they are using ultrasound guided for trigger point therapy and for other things, right? And I would say that the MRI, that's usually the best visualization that is there for soft tissues in the maxillofacial region. Then comes the airway analysis. Now, this is something that can be very easily done on a CBCT scan, because though the airway is a muscular tube, what it has is an empty space, and that is very well shown by CBCT. And like Dr. Avinash Shah mentioned yesterday, he usually sends this, and I will show you that. The other thing is arthrography can be done, where you inject a dye and you can see the positioning on CBCT scans. This is not my case. I do not do CBCT scans with the arthrography, but there are clinicians in India who do this, right? And you can also do it on CT scans, the medical CT scans, where you can then see the joint space. You can delineate how the disc is, the superior joint space, the inferior joint space, etc. All those details. I'm not going into it. Let me go directly to the airway analysis now. And the airway analysis, you start with the nasal cavity. You look at the nasal septum. You look at the inferior concha that is enlarged here. All these particular things. These are from the CBCT scans that come out. These are the sequential slices that you get, right? And you can evaluate this. You can also look at the sinus. You can see the frontal sinus sometimes. They will be there. You can see the ethmoidal sinus. You can see the sphenoidal sinus. So all these correlated areas, the adjacent structures can be seen on the CBCT scan, right? In this case, you can see now this inferior concha is highly hyperplastic, right? So then that was taken care of. That relieved some of the airway obstruction that the patient had, sorry. And now this is a case where there were bilaterally enlarged palatine tonsils. So you can see now this is a tonsil in one slice, that is this. This is the right side, the left side I have not put, but you can see it's exactly the same. So large tonsils, that was causing a lot of obstruction, so that had to be taken care of. This is another patient where the adenoid was enlarged. Look at it. Again, I'm just putting a slice, but there are sequential slices that we'll look at, right? So these are the tonsillar enlargements that we have. This is how a normal airway should look. It should be a nice tube. If you can see actually here, this is what a very nice patent airway is beyond the adenoid. So this is a very large, nice airway. And this, when we do an analysis where the CBCT software, what it does is it puts in this color in this particular airway space, and it also tells the minimum area that is there. So this is how it appears. So this is how a normal airway appears. And then let me show you a video of how the normal airway appears. So you can visualize how it is anterior-posteriorly flattened usually, but mediolaterally it is quite wide. It's a muscular tube. This is the oropharyngeal region that we're looking at. And you can see now completely from the nasopharynx to the epiglottis how it is. So let's now look at a narrowed airway. Now these are other measurements again that have been shown to me by quite a few clinicians. But again, this measurement is a midline slice. You can see now this is an incisive canal here. So this is at the midline. So these all measurements do not remain valid if you just remember the video I showed previously, because what happens at the midline may not be the same thing what happens in the lateral aspect of the airway. So extrapolating these kind of measurements or angulations that come is a very little high-handed in my opinion. So which is why I don't do this. But there are a lot of clinicians who give these values. And if you think that those are suitable, please go ahead and use this. But this is my contention that should not be used to extrapolate it to the entire airway just on the basis of one slice. So this is how a narrowed airway looks like. Now, if you see, the narrowing is here, distal to the soft palate, and just a little distal to the base of the tongue that we have here, the posterior third of the tongue, right? So, but the superior part of the airway and the inferior part of the airway seem to be still much better. The constriction is happening seemingly at this point, right? Let's look at another case where the constriction is much more severe. Now you see the entire area distal to the soft palate is constricted, entire area distal to the base of the tongue is constricted, and only when it comes near the epiglottis, it's a little opened up, right? Let's look at these two cases via the video and you'll be able to understand it better. So now you can see that the upper part and the inferior part of the airway is much more patent, and this is where the minimum area is. So this is quite severely restricted, where it's only 71 millimeter square. So that tells us that this is the smaller the minimum area is, the more progressive the problems can happen. A lot of literature is there upon it. I'm not going into those details, right? This is a second case that we had where it was completely restricted from the superior to the inferior aspect. So the other aspect that I would like to add is these videos are very educative and informative. You can show these to the patients. That helps us, explain what's happening to them. Because commonly what happens is you're sending for a 3-dimensional imaging, you tell the patient कि ये 3D scan लेना है. So the patient is very fascinated, and at times the clinician is also very fascinated by 3D images. But like I showed you, 3D images are reconstructed, so they have to be interpreted with caution. But where it is useful and essential, like these videos, it can be used very well to show them to the patient. And once you show them, it becomes very easy for the patient to understand what you're talking about, and then for them to understand your treatment plan. And you can also then do follow-up scans and then, get that verified. Then we have this
There is
case
a
of
question from where to where the airway is calculated. So if you can show it in the same slide so that, I know it's a discontinuity of your lecture.
no problem. I'll show you. So usually the airway that we see in the CBCT scan, what we see is the oropharynx, right? So here is where the nasopharynx is, right? And from the level of the hard palate where the posterior nasal spine comes up till the epiglottis. Because once the epiglottis comes, what goes here, this becomes the esophagus. So again, like all the other speakers have been saying, your basic anatomy has to be perfect. And in radiology, it's everything about anatomy itself. So what we are checking for the airway is the oropharynx. So in the oropharynx, we are going to look from the posterior nasal spine, this level, up till the epiglottis level. So that is the airway that we are concerned with, and that is very well delineated on a CBCT scan, and the CBCT software gives us this output. So very well visualized for us to look at it, for us to explain to the patient. I hope that clarifies the question that was there.
Yes, doctor. Thank you.
Yeah, so this is the case of which had come for surgical guide but look at the amount of neck calcification that we saw. Are you all able to appreciate it? So this entire carotids on both the sides were so heavily calcified that the moment we saw this, we immediately told the referring clinician, we sent this patient to the relevant neurologist. And unfortunately, this patient had a stroke after about 8 months once the scan was taken. And then they had to further follow it up, but the patient didn't come back to us. But this is what we saw when we did for an implantology scan, but this is what we saw. So sometimes incidental findings are also seen, which can give a clue to as to what might be happening, right? It's a long video, it keeps on going. I'll stop here this video, right? So at the end, I'd like to give some prescription tips based on the past 11 years that I have been dealing with OFP clinicians, and then they ask me for relevant scans and the details in the scans. The very first thing, like so many of the speakers have been saying, and the speaker just before me, Dr. Ruchika Sood, said that share the clinical notes with the radiologist. Dr. Asrani was speaking yesterday and where he said that sometimes the medical radiologist just report it on MR with no idea of the clinical aspect that is there. So that's where your role comes into picture. Please share the clinical notes and discuss with the radiologist what you see. Because when you discuss what's clinically seen, it becomes easier for the radiologist to go into relevant areas and then look at it with a fine comb and then find pertinent findings. So that helps with this kind of give and take, like I told. Then comes the panoramic view or the OPG. I would highly recommend against using it for most of our OFP cases, other than to see any major abnormalities that are there. Apart from that, this is not of much value in my opinion, right? And you develop a standard imaging protocol in conjunction with the radiologist. You discuss with the radiologist, with him or her, what exactly do you want? Like some clinicians want it in occlusion or in the natural rest position. And then some scans will have to be taken in the open mouth position. In the open mouth position, do you want it to be the maximum open mouth position? Or once the pain starts, you stop at that point? So all these discussions need to be standardized. You need to discuss with the radiologist so that the radiologist can relay this to the radio technician. And once the technician can understand this, and then it becomes a routine, because different clinicians want different things from the same scan. So that's why it becomes pertinent that the particular thing is done at the time of taking the scan itself, right? And then preferably take it from a large FOV CBCT machine, because this will give you the entire thing. So all the things that I have been showing, we do it at our large FOV machines. So what happens in this is the entire tissue gets collected in there. So if you just do restricted TMJ related scans, then you will not get the airway. You'll have to get a separate scan done. So if it's a large FOV machine, everything gets taken from the nasion up till the hyoid bone and everything that comes in between. So you get to see everything in totality, and that helps a lot in my opinion, right? And the last point that I would like to make is interpret three-dimensional reconstructed images with absolute caution, because many things will appear like they are there, but they are not really there. So be very careful when you do these 3D volume image interpretations. So always take the consultation with the radiologist. He or she should be able to sort out whether it's actually a pathology or it's just an appearance that is coming on that. So in conclusion, I would like to say that there are multiple imaging options available. And in those imaging options, you will have to choose judiciously. Just because there are 10 investigations possible, don't order all 10 of those, right? That's not fair on the patient. That's not possible at times, because in India, we operate a lot under cost restrictions. Not every patient will be able to afford all the investigations that are there. So judiciously, you have to choose it. That does not mean that you eliminate investigations as well, because you should not be like this man where you have the resources but you didn't use them correctly, right? So that's very pertinent, that you have to take care that you know what investigations are available, when to use it, and more importantly, when not to use it as well, right? Because when you collaborate as a team, and that's what I have been working for the past 11 years with all these OFP practitioners, and they will usually tell me all the findings, we will discuss, and that helps them both in the diagnosis and prognosis, because you take follow-up scans and you maintain those records and you compare it, and a lot of things come out of it, you know. So that's how you can use it for both diagnosis and prognosis. And I would like to acknowledge that these are the OFP clinicians that I work with on a very routine basis, and these are the clinicians who, three of them are the speakers on this platform in the past 2 days itself, right? And I would also like to mention my colleague, Dr. Sunanda Bhatnagar, who helped me with the, the copyright thing and developing our grading system. So she did all the work, so credit to her, right? And I would like to leave you all with this quote from Frank Gaines, where he says that one who sees the invisible can achieve the impossible. So I would end my presentation here, and I'm
Thank you,
open to
Dr. Ajay Nayak. And it was really insightful to see this black and white world and what happens when we send for a prescription and what we are just seeing the images. And at times, uh, right up to 5 or 7 years into practice, I used to just rely on those reports, what used to come. And thereafter, I started reading actually the slides, because it was just a black and white image for me, and I was just
absolutely.
reading it. So,
Yes.
thank you, doctor, for showing us what we are actually gaining by prescribing such images and what not to do. Because at times, the overuse or misuse of these imagings were, as you correctly put it, that forget about the cost effective. Why are we subjecting our patients through all that? So,
Absolutely.
yeah, and congratulations on having a patent and grading system, which is very much I could relate to it. I know this must be just the tip of the iceberg of your whole theory, but I could relate to it, and that says a lot about you also, because you did not snatch the credit to yourself, and you
Absolutely.
humbly accepted
No,
that there.
all these clinicians I work with, all of them are like that. They are selfless and they discuss, and that's how it comes about. Like it has to be a multidisciplinary effort in every possible way. And that's the way it is to go forward. Because if I just see my scan and I keep it as a very beautiful scan on my computer, how is it going to help anybody else?
Yes, the objective is that we learn together, and I say we need more
Absolutely.
of buddies, I would say, more
Yes,
than
because we all grow together then, with
yes.
our unique perspectives. Now, that's the problem with specialization. We are sometimes horses with blinkers, where we look at only what we want to see. But then when somebody else brings a fresher perspective, it, completely broadens what we are seeing. And that brings about a lot of change to the patient management. And that's what our ultimate goal is at the end of the day. It's the patient, doesn't matter how beautiful the scan is, doesn't matter how beautiful the appliance is, how wonderfully you arrived at the diagnosis. If his or her pain doesn't go it, it's all down the drain.
True, very true, doctor. And the tunnel vision needs to go, and we need to have a broader perspective. And it's definitely going to go along with, we need that, as I said, we need more and more collaborations like such. And it was an honor to have you here, Dr. Ajay Nayak. And I
Thank you
would
to you
really,
and to Dr. Nurul for giving me this platform to speak to these budding OFP specialists, because it's very much the need of the hour in India, and absolutely wonderful work.
yeah, we rely our 80% of our work relies on the diagnostic tools. What are we using? So thank you so much, doctor. And I'm sure you will be on my radar for the next conferences also, wherein even if it's a radiology conference or maybe an orofacial pain conference,
Sure.
definitely we would
Glad to
like
be
to
here.
hear or listen to you more. So thank you so much, doctor. It was really, truly great of you to discuss your patent topics and all. There are certain questions, and many of them are congratulating you, and they like the presentation and all.
Thank
So,
you, everyone.
yeah,
Thank you.
I would like you to visit the chat box and
I will
have
do
a look
that.
at them.
Yes.
On that note, I would like to welcome our next speaker, Dr. Saurav Shah. Saurav, are you there?
Yes, hi, Dr. Sonal.
Hello, and here is another stalwart. And today's patency day, I would say the people who have received certain accolades with designing their patents and all. And here's one more stalwart. And congratulations, doctor. I had no idea about this one, but thanks for sharing this information. And Dr. Saurabh, I just met him recently when he received his fellowship in orofacial pain, and I was lucky enough to be a part of that ceremony. I think that convocation ceremony, I was there. And one thing I would say is, more than anything else, Dr. Saurav had walked in with his wife over there, who was literally handholding him, as a diligent wife. She was there, and you are lucky to have a spouse who is so supportive. So
Definitely.
congratulations to both of you. It's a team effort, not only at home front, but in the clinic also. So thank you so much for being a part of International Orofacial Pain Congress 2024. Dr. Saurav is a dentist by choice and not by chance. So very few of them say that, okay, I wanted to be a dentist first, and then I wanted to become an MBBS doctor or something like that. Because the story is always the other way around, wherein people have missed their MBBS by 0.5 marks or as less as 0.3 marks also. I've heard of the stories. So congratulations, doctor, that you're pursuing what you always dreamt of.
Yes.
He graduated from prestigious PM Dental College and Research Center from Nagpur, and is a in clinical practice since 2010. His core areas are of practice are prosthodontics, full mouth rehabilitation, and TMDs. Yes, you keep bombarding your cases on social media, so everyone knows Dr. Saurav's cases on full mouth rehabilitation. Having achieved post-graduation diploma in medical legal sciences, certificates in TMDs from University of Vienna, and fellowship of orofacial pain and sleep medicine, what I was mentioning. Just recently, he received it from AOP through under Dr. Davis Thomas's guidance. He
Yes.
also holds a GOI design patent on detection of TMJ disorder detection devices. Besides dentistry, he was currently inducted as an independent director in Coral Laboratories, an NSC listed pharmacological company. So, doctor, I know your topic for the day is conservative management of TMDs, but I would like you to throw some insights on this detection of TMJ disordered detection device, that patent what you have received. So, Dr. Saurav, the stage is also yours. Can you just share your screen, doctor?
Yes.
And welcome.
Yes. Thank you, Dr. Sonal, for a very wonderful intro. And yes, the meeting you during Dr. Davis's graduation ceremony, the feeling was absolutely mutual. It was nice meeting you. And yes, regarding that patent, it is a group effort of a few doctors which we have done together. So it is a soft patent design. So it is a design patent. So first we made a design patent wherein we can work with the engineers to make a software or a website where we can do distance consult evaluation for few patients who are in the remote villages or where are somewhere cannot get proper care. So to bridge the gap of distance between the consultant and the patient, that is our aim. So now we have the soft patent. So now we are into the designing that software, website or an app. So yes, it is a long process, but slowly but surely we are working on it.
Congratulations. That's a very noble cause you're working on, and actually the need of hour also. So let's utilize the digital world more, and more than abuse, let's use it for our purpose.
Yes.
Start
Yes.
sharing your screen. Doctor, the stage is all yours.
So my presentation is visible. I'm audible clearly, right?
Yes, doctor, please go ahead.
Yes. Yes. Thank you, Dr. Sonal. And to begin with, let me thank Dr. Sonal and Dr. Nural to bring so many acclaimed and new speakers for the orofacial pain, temporomandibular joint disorders. It is definitely a new field, an upcoming field, wherein we need more awareness for this orofacial pain and temporomandibular disorders. So coming to my topic today is treatment modalities for temporomandibular disorders, which we have categorized into two parts. One is the conservative approaches, which I would be talking about, and another is the surgical, minimal invasive and the surgical approach, which my next speaker and my good friend Dr. Taufik would be taking up, so that we cover the complete spectrum of managing temporomandibular disorders. So going ahead, I will begin with my slide to thanking my mentors and inspirations from starting from the occlusion, prosthodontics, full mouth rehab, temporomandibular disorders, and finally orofacial pain under Dr. Professor Davis Thomas. Everybody knows him there. I do not need to talk more on him. And what I have come to realize is majority of the speakers, probably more than 50%, are either his colleagues or his mentees. So yes, thank you all very much. We are what we learn from our mentors. Going ahead, what is the scope and aim of this presentation? So since we are listening to this conference from the past 2.5 days, what I've come to realize that majority of the topics have been talked upon either in a very brief or in continuation with other treatment modalities. So my aim here is to present simple, evidence-based and easy to implement diagnostic and conservative management practices for temporomandibular disorders. Most importantly, which can be immediately inculcated from tomorrow onwards in your clinical practice. So either you are a newbie, a student, or you are planning to get into management of temporomandibular disorders. If we start from the basics, we have a good foundation, we can build up a huge skyscraper over it. So we begin with learning the diagnostic criteria and classifications of the temporomandibular disorders. The temporomandibular disorders are basically majorly categorized into the muscular component and the articular component, where muscular component is or comprises of the masticatory muscles, cervical muscles, and accessory muscles of mastication. And articular component consists of our TM joint, which presents glenoid fossa, cavity, disc, intra-articular components of the joint. So yes, conservative management for TMDs, evidence-based conservative management of TMDs, which basically we can broadly categorize them into 5 categories, which are physical self-regulation, pharmacological armamentarium, physiotherapy, oral orthopedic appliances, and counseling. So broadly, majority of evidence-based management, conservative management, falls under these 5 categories. We will definitely see some clinical cases of mine which we have treated in the past years, and the surgical approaches and the minimal surgical approaches are reserved for almost 10%, 10 to 15% of the cases who are refractory to the conservative management. Yes, those who have been treating TMDs for long enough know that there are some patients who are whose pain and whose complaints are difficult to overcome, give them a healthy life with the help of conservative management, and we need to take help of minimal invasive procedures like arthrocentesis, arthroscopy, or surgical procedures depending on their severe symptoms, or we need to go for an open joint and joint replacement, which my your dear friend Dr. Taufik would talk upon in the next lecture. So yes, to identify any disease, to come to a diagnosis, we need to have a criteria, a terminology which majority and is accepted internationally. DCTMD is presently an evolving diagnostic criteria for temporomandibular disorders. Another criteria is of ICOP, International Classification of Orofacial Pain. But yes, DCTMD is fairly much more recognized internationally, which consists of temporomandibular joint disorders under having many categories, masticatory muscle disorders, headaches due to TMD, and associated structures. So today we will talk upon the muscular component. So again, this is the screenshot from the same classification which you can take up. What I would like to spend time talking on is very common clinical presentations of how patients would present in your clinic with the signs and symptoms. So first and foremost, the most common symptom is reduced mouth opening. So how would the patient present to your clinic with reduced mouth opening? Is if you tell the patient first thing is open your mouth, and patient would just open their mouth for 2 fingers, and patient says I cannot open beyond that. But if you try to manipulate physically and gradually ask the patient to open with some manual support, the mouth opening increases, and this is pathognomic sign of reduced mouth opening due to muscular component, which is basically due to an acute response to trauma or stress to the muscle. We might have seen similar situations when patient has undergone difficult disimpaction, third molar removal surgery, or a very long dental appointment for root canal or something. The second common clinical presentation would be vague, dull, aching pain, either in the temporal region, in the preauricular region, or in the angle of the mandible. So patient will not be able to pinpoint with his one hand, but will spread out to an area that this is the area of pain, doctor, which is vague, dull, aching, continuous background pain, which is again a type of muscular component. Patient would complain that pain aggravates as the day progresses. So this is again a very good sign indication that as the patient is using their muscles while chewing or doing their functions, the pain aggravates during the day. The pain is at peak at the evening of the time and then gradually reduces with the help of rest. So aggravating and the relieving factors are on function, and relieving factors are on when they are at rest. Trigger points. Yes, this is a very important term which we have been listening and we have seen in details of trigger points. So what basically trigger point is it is an hyper irritable spot, a palpable nodule on a taut band in a skeletal muscles fascia. So we have trigger points in all skeletal muscles, which is pathological. It is not physiological. But in our arena, in orofacial pain, the trigger points most commonly encountered are in the temporalis muscle, masseter muscle, sternocleidomastoid, trapezius, and cervical muscle. identifying the trigger point is very important. And another concept which we have seen in detail or heard speakers talking on is myofascial pain with referrer, where the site and the source of the pain is different. So what I mean by myalgia or muscle pain. So broadly, the muscle pain categorizes falls under these three categories. One is the local myalgia. So what does local myalgia mean? If you see, these red spots are the trigger point spots which we have depicted here for representative purposes. These red spots are trigger points which, when palpated on patient experiences pain. So local myalgia is the patient will represent pain only where you are palpating and nowhere else. That would be termed as a local myalgia in the masseter muscle or the temporalis muscle or the sternocleidomastoid muscle. So myofascial pain here. So what differentiates between local myalgia and myofascial pain is when you palpate the trigger point in myofascial pain, the whole of the muscle would elicit pain. If you palpate trigger point in the masseter, the complete length of masseter muscle would pain. The patient responds that the whole muscle is paining. And the third category is myofascial pain with referral, which is a very important point which generally we tend to miss, is when the trigger point is palpated, the site and the source of pain are different. So the site of the pain would be in the masseter, and the source of the pain would be in the masseter, and the site would be in the body or in the temple region. So this image, again, we must have seen many times, but this is a very descriptive image from the textbook Travel Simmons and Simmons, where we see the trigger points and their referral patterns. The red dots indicate the study done by Dr. Travel Simmons and Simmons, indicating patients where the pain is referred. So the more the concentrated region of red shows common signs of referral pain. So if we see the masseter, we can see almost whole of our dentition, where patient may present to you with pain in the molar region, but that would be just the site of the pain and not the source of the pain. So here, if we treat the site of the pain, no matter what we do, the patient would not have relief. Similarly, sternocleidomastoids having two bellies, they have different source of pains. The sternal head has different source referral patterns. The cladial head has different source referral patterns. Temporalis. So if we see the posterior, the middle, and the anterior temporalis has again their referral pattern. So if a clinician misses here and has a tunnel vision of looking only at the teeth, the periodontium and the dentition without having knowledge of the muscle having referral pattern onto the teeth, the patient would land up having iatrogenic treatment without any pain relief. So this would be my takeaway point from my first takeaway point from the lecture, that please, unless you identify and reproduce the familiar pain from the patient, do not begin any treatment. Please do not begin any treatment unless you have reproduced and identified the site and the source of the pain. Moving ahead, going to the articular component. Again, we on the same lines, we would discuss the categories. The patient suffering from an articular component needs to be placed in one of these categories. And now patient presenting to us clinically with articular component would again come with reduced mouth opening. So reduced mouth opening is a very common complaint along with pain, definitely, which brings patient to our clinic. So here, reduced mouth opening is where patient gives a hard end feel. So soft end feel with the muscular part and the hard end feel. The hard end feel here, if we know the anatomy, which many speakers have taken in detail, the disc gets interposed between the bony components of the condyle and the glenoid fossa and restricts the movement. That is where the patient feel it's a hard end feel. And if we try to manipulate or open the jaw forcibly, the jaw does not open and patient experiences pain due to the disc interposed between the joint. Then we have a pathognomic sign of deviation with and without correction. So deviation with correction and without correction are the new terminologies for deflection and deviation. So with correction is generally seen in disc displaced with reduction, and without correction is seen in disc displacement with with correction and without deviation with correction is seen in with reduction, and deviation without correction is seen as disc displacement without reduction. So patient again presents with pain in normal functions like talking, yawning, clicking. Again, clicking can be asymptomatic and symptomatic. We do not treat asymptomatic clicks, but please be aware to make patient aware of this asymptomatic click. Is the patient is highly predisposed to undergo symptomatic clicking if patient does not take care or of the jaw movements. Loud popping, crepitus, history of repeated jaw locks, closed lock. So closed lock is where patient cannot open beyond 2 fingers or only till the rotational movement of the condyle. And open lock is subluxation or locked jaw, where patient cannot close the jaw after opening very wide. Again, an important point over here is very rare cases, but especially young females who presents with a sudden anterior open bite in a very short span of time needs to be assessed radiographically. These patients generally present to the clinic with complaint of anterior open bite, but with no pain in joint whatsoever. We'll see the clinical cases. So moving ahead, how do we do a basic temporomandibular disorder examination chart? So we can make a subjective component and an objective component. Subjective can be done by a questionnaire forms while patient is waiting in the waiting room, where you can easily elicit information from the patients like jaw pain, location, duration, whether it is acute or chroma. Was there any trauma? Is patient aware of joint noises? Is patient aware of any parafunction? Are there any changes in bite? Does patient suffer from vertigo, headaches, tinnitus, etc.? Depending on this information, the clinician can objectively look for the signs and symptoms and categorize patient either into the muscular or the articular part. The TM joint palpation, I personally prefer palpate from the lateral pole of the joint, which helps us to elicit the inflammatory and the health of the capsule of the joint. An intra-auricular palpation with our pinky finger from the intra-auricular meatus while patient is opening and closing help us to evaluate the retrodiscal health and what is the situation of the retrodiscal tissues. Palpation of masticatory muscles, their referral range, the trigger points, measurements of jaw movements is very important so as to evaluate the range of movement. Please note clicking, crepitus, load testing needs to be done. Mahan test is a very good informative test where we can have a patient bite on a bike stick or a cotton rolls, and elicit pain is on the ipsilateral side or on the contralateral side. Occlusal evaluation is also very important for patients coming to you for TM joint disorders. Debunking the old myth that occlusion may cause TM joint disorders. It is current research which is finding in the OPERA study that TM joint disorders may cause occlusal disturbances. So yes, either it may be vice versa, but we need to evaluate occlusal evaluation for posterior support, dip bite, anterior open bite, etc. Dentition, where in case of parafunctions, clenching, and mobility. So with this information, we should be able to have a rough idea in our mind so as to where are we looking for. Is it a bony component or it is a muscular component? And accordingly, we can, if required, to support our working diagnosis or provisional diagnosis, a CBCT or MRI can be ordered. As we saw in our last lecture of Dr. Nair, basic OPG is not the right way to evaluate temporomandibular joint disorders. From that, we need to come down to a DC-TMD diagnosis, and depending upon your skill and your expertise, we need to decide that whether we can treat the patient or we need to refer this patient. So this is a simple flowchart of how I examine my patients. Now coming to the actual topic of my presentation, conservative treatment modalities. So all in all, to give a synonym or a mnemonics, this 5 P's which could be remembered is how we deal with the temporomandibular joint. First is physical self-regulation, pharmacology, physiotherapy, plates, where we use oral orthotics or splints, and psychological counseling. The 5th on the psychological counseling forms a very important role in patients who are suffering from chronic pain. Their behavioral modification in response to pain and biopsychosocial evaluation is very important. Gradually, these biopsychosocial component of chronic pain is taking up the need for clinician to identify and address it for patients who are in chronic pain. So moving ahead, physical self-regulation. So basically what physical self-regulation is, to identify patient via a detailed case history of any wrong habits, any parafunctions, any clenching, or any wrong postures or habits which patients may have developed with or due to TM joint pain, or that might have been precipitated. So what we see here basically is rest jaw position awareness. On 10 cases, roughly 6 to 7 patients report that their rest jaw position is clenched. For them, that is normal. So this needs to be brought to their attention that this is not normal. If during the rest jaw position, if you keep your jaw clenched, the muscles are continuously loaded, the joint is continuously loaded, which can be one of the precipitating factors for the problem they are facing. Tongue rest position is again equally important. Many a times I see patients keep tongue on their floor of the mouth, or if they have an open bite, in that open bite of area is where they lodge their tongue. So tongue position plays a very important role in the musculature and keeping the musculature in their optimal position. Posture. Many a days IT working professionals working on laptops and desktops for around 10 to 12 hours and throughout the day need posture correction, need posture advices where they need to correct their postures. Nasal breathing, mouth breathing, all these things need to be taken up, elicited during an history taking, preferably in your first visit, your first consultation visit, which generally lasts for around 1 to 1.5 hours, where we need to pick up these things, which wrong habits or parafunctions which patients have developed, and need to bring to their notice that these are not normal, these needs to be changed, and you need to make a conscious effort to change this wrong habit. Stress management is equally an important part. Proper sleep and sleep bruxism is again getting a huge momentum, a huge identification is required where patient is properly sleeping or not, as having a good sleep or not. Coming to a second management protocol is pharmacological management. We as dentists are very good in managing acute pain. A patient with pain of score 9 on 10 with acute pulpitis can be relieved immediately within 10 minutes with a good, efficient local anesthetic block. But when it comes to the management of chronic pain, our understanding and our management of chronic pain is lacking behind. So that is where we need to cope up and understand ourselves with the physiology of the pain. So yes, we are well versed with the medications that we use for manage pain, and NSAIDs, local anesthetic, local anti-inflammatories. The anti-inflammatories given for TMD pains required to be given for a slightly longer duration, and for the round-the-clock effect, for the sustained anti-inflammatory effect, if the suspect TM joint of inflammatory pain. Muscle relaxants help to that. Corticosteroids, again, we as oral surgeons use corticosteroids in surgicals to reduce inflammation. Again, this plays the same role in inflammatory TM joint disorders, where the corticosteroids, either oral or injected, helps to reduce the inflammation. Topical analgesics, injectable local anesthetics for trigger point injections or nerve blocks, Botox injections. Off-label medications are here, which is a new thing for and are used for chronic orofacial pain. Which, what does off-label medications mean? That medications which are not primarily used to manage pain but are used for some other disease or conditions in varying dosage and varying combinations. Antidepressants, anticonvulsants, and anxiolytics can be used effectively to manage chronic pain, especially for orofacial pain and chronic temporomandibular disorders. So yes, these are the classes of medications. These are the examples which we are well versed at. Ibuprofen, opioids we are not allowed to prescribe. Corticosteroids, prednisone, dexamethasone, injectable muscle relaxants, antidepressants, and anxiolytics. So these are few drugs, and what are they used for in TMDs? Coming to physiotherapy, physiotherapy is an added modality to be used to manage chronic pain, especially when it is with muscle related. Muscle pains are generally chronic. They take time to precipitate, and once they show, they take time to recover back. So yes, we can use manual therapy like joint mobilization and manipulation, trigger point release exercises or trigger point injections, intraoral massages for temporalis tendon or masseter muscle intraorally. Modalities of pain relief would be heat therapy, where we increase the blood flow to release stiff muscles and reduce the allogenic chemicals in the muscles. Cold therapy, which reduces the inflammation and is basically used in chronic acute cases where spasms and TMD flare-ups. Ultrasonic therapy and TENS are used, but they are not used to that extent in orofacial region because they have their side effects using in the temporalis, which may affect our retina if ultrasound is used near eyes. And TENS, if not used properly with adequate knowledge or by their experts, can have effects on vital nerves like carotid plexus, vagus nerve, and the facial nerve in the head and neck region. So yes, they are definitely effective, but they need to be used with caution in patients. Coming to our next modality are oral or occlusal appliances. The evolution of oral or occlusal appliances is drastically changing. Initially in 1960s, we used oral appliances as a mechanical way in a mechanical world to help the temporomandibular disorders. Their current role in relieving temporomandibular disorders is coming to a limited, where we restrict its parafunction and equilibrating the load onto the joint rather than many big claims which have been made. So yes, I stand to be corrected, but we have n number of oral appliances present in market, but most commonly used are flat plane appliance or stabilization appliance, anterior biplane appliance, and anterior repositioning appliance. So they are used in their specific conditions, specific when they are required, and their mechanism basically helps to break proprioception from the peripheral to the motor cortex. They help to reduce parafunctions. They help to break break wrong habits of clenching, parafunction, daytime clenching, and make patient aware. So yes, oral plates, occlusal appliance have their role, but their role is gradually reducing. Psychological counseling plays a very important role, especially in patients who are suffering from chronic pain. So the main aim over here in psychological counseling is to make patient aware of their pain, their condition, so that patient is in charge of their own complaints and therapy. Involve patient in the treatment, make patient understand what treatment modality will help to overcome what pathological which may be precipitating the cause. For example, splint. How would splint help? Splint will help to reduce their parafunction, will help to position their tongue properly on the palate, and will help to break daytime clenching habit. General information, misuse of oral masticatory system, posture education. So yes, making patient aware of the disease causing etiologies and the treatment done for that helps us to make patient aware, and this helps us to make patient in control of their complaint. And this is a very important upcoming modality for treatment. We cannot underestimate the role of stress, sleep, and emotions on chronic pain conditions. This diagram does not give justice to the cause or to the underlying factors which they may precipitate for chronic pain. Stress is a very huge factor. Improper sleep is again a very huge factor, which is out of the purview of this presentation. But yes, when managing chronic pain patients, the emotional background of the patient, how the pain is perceived by the patient, what is the pain threshold of the patient needs to be judged. The stress level of the pain, how much of the chronic pain is adding on to the stress, and sleep. So these three are intertwined with a chain, and we need to address these conditions when managing chronic pain situations. So now coming to case discussions, we will see few videos. So this is a video of patient who is presenting with which cannot bite with your posterior back teeth.
Close. 2 quick movements, open and close. With your back teeth. Yes. That's great. Yes. Open. Close. Open. It is closed on the left side. Yes. Open.
So here, if we see, when patient is just asked to open and close, patient is not able to close with his back teeth, which is habitual position, his habitual bite position. This patient is bringing his jaw forward. So most probably this patient had undergone probably bilateral lateral pterygoid muscle spasm, which has pushed the mandible anteriorly. And for patient to bite in his habitual occlusion is becoming difficult. So what we did here is, this is after 2 days of treatment. So when we ask patient to bite, open and close repeatedly, he can easily close from his back teeth, which is his normal habitual position. So what we did was we gave patient a simple anterior bite plane appliance and asked patient to go on soft diet and rest, no exercises, no mouth opening. And the anterior point was marked when we delivered the splint, and the posterior point was marked when patient came back. So this plate and anti-inflammatory and non-steroidal anti-inflammatory medications for 5 days course helped us to achieve reduced muscle spasm and achieve proper habitual occlusion for this patient. Coming to the myofascial pain with referral, if you remember those diagrams where the trigger points which we have identified referred pain for this patient onto the complete left side of face, left temporal region, left occipital region behind the ear. So on intraoral examination, we found that the occlusion or how patient teeth meet was not up to the mark. Only single point contact on this prosthetics which was done was seen over here. So what we did here is we gave patient a stabilization splint with equal contacts on all teeth with proper guidances. You can see a proper contacts on all functional teeth. After 3 to 4 months of splint wear, patient symptoms reduced drastically. And after 6 months follow, patient was advised to rehabilitate her dentition so that there is no need of the splint, and instead of splint, we inculcate those guidances and equal contacts on the dentition itself. Coming to chronic myofascial pain, if we see here how we manage this myofascial pain. So this is a simple spray and stray technique with ethyl chloride spray. The muscle is sprayed, which gets numb, and we are able to do complete range of motion of stretching. Here we are stretching her trapezius and posterior cervical muscles to achieve the range of movement. If you see the markings done over here, these are identified trigger point markings. Some are local and some are with referral patterns. So this is one of the modality which patient can be taught and they can do stretching exercises at home. Next, trigger point injections. So chronic pain patients suffering from 6-8 months with on and off pain, and when palpation, the patient elicits pain and referral type of source, we inject plain lidocaine 2% into the trigger point, which is palpated in the bulk of the muscle. And after 1 or 2 sittings, we have seen tremendous relief in the pain of which patient has the pain of the patient, which patient is suffering from. So now coming to the intracapsular disorders with disc displacement without reduction, again you see the dentation. So what I personally feel with over so many cases being treated is improper occlusion or improper load transferred from occlusion to the TM joint might be the precipitating cause rather than the occlusion of class 1, class 2, class 3 per se. So if you see here, the midline is shifted towards the left. The MRI confirmation showing disc placed anteriorly in the closed mouth position, disc displaced anteriorly on open mouth position with reduced range of movement of the condyle. Again, a simple stabilization splint with guidances. Here what we have done additionally is a pivot splint where we have given posterior stops on the bilaterally on the occlusion with proper specified height, and with that pivot splint patient needs to do a traction exercises on the chin, which would distract the joint, reduce the load on the joint. A point to highlight over here is this splint in nowhere recaptures the disc, but it definitely reduces the load on the tissue which is crushed between two bony components, which helps in healing of the joint, and patient tend to respond very well with the pain in the joint. So the pivot splint needs to be worn only during exercises, and rest of the time stabilization splint is required. You can see here change in deflection. The mouth opening was better, patient symptoms reduced, and patient was coping well. So coming now to bilateral temporal headaches. So again, a muscular case. Here, a geriatric patient in her late 60s with long-standing chronic bilateral temporal headaches. So when a geriatric patient comes with temporal bilateral headaches, a systemic condition which is known as giant cell arteritis or temporal arteritis should be ruled out prudently because it is a debilitating disease. We ruled out because the temporal artery bilateral was palpable with good pulse, and patients got immediate pain relief on 24 hours after anterior bite plane appliance, which was diagnostic confirmation with the muscle. So this is the intraoral photos. Patient in the late 60s. If you see this video, you will notice the patient's tongue position. Patient is positioning tongue in the anterior open bite, and when patient is opening, her habitual tongue position is on the floor of the oral cavity, which is again not a proper tongue resting position, which needs to be brought in patients aware. So if you see this OPG just as a screening purpose, a patient in her late 60s with all teeth intact with no filling and dentation is very rare to find. So we do not need to do anything on the teeth or on the joint per se. An anterior bite plane appliance, yes. Importance of face bow is what I would like to bring it with this picture is if you can notice the cant of the patient, maxillary cant of the patient, we cannot identify whether patient has a cant or not if we do not have this setup over here. So yes, we cannot neglect prosthodontic principles when we are giving a splint to the patient. Again, a common stabilization splint with no restrictions on the lateral movements and guidance is given, incorporated into the splint. Idiopathic condylar resorption. Yes, as I had discussed in my initial slides, a 28-year female presented to clinic with complaint of developing anterior open bite. So patient came with, doctor, I want to get orthodontic done. I want to close the gap which is developing in my front teeth. There is no pain whatsoever. Her problem was aesthetic, and her one very important complaint was that she cannot bite wrappers of chips and chocolate from her front teeth, which she used to do previously. She cannot bite the threads from her front teeth. Eating sandwiches from her front teeth was becoming difficult. So these are her intraoral photos. So if we observe carefully, you can see the canine has worn down completely on the right side, and on the left side we have a distal slope wear seen on the canine. So if this is since adolescence or the patient has been growing up with an anterior open bite, we would see a beautiful mamelons present on the teeth. Rather, we are seeing wear facets on the teeth, which are signs of function and wear, physiologic wear on the teeth. So that means that something is not right. 3 months, patient is complaining of developing open bite, but no pain, needs a radiologic evaluation. And on screening OPG, we saw that the head of the condyle is completely disappeared over here. On the right hand side, and left is following. You cannot see the anterior neck, the proper shape of the condyle over here. Coming to the 3D reconstructed image and open and close movements. So the complete head of the condyle is gone on right, and this is the open movement. You can see the range of the mandible going anteriorly beyond the eminence way almost to the zygomatic arch. The maxillary process of the zygomatic arch, and this is the left side which is following. So yes, this was an identical finding. So if we do not know the systemic diseases affecting TM joint, we would not be able to identify this. So this patient, since she was painless, her normal function was not affected. With the consult of oral maxillofacial surgeon and orthodontist, we decided to undergo wait and watch philosophy, because most of the cases, idiopathic condylar resorption has a self-limiting ability once the head of the condyle disappears. Once the resorption reaches the neck, the disease gets stabilized. So with the help and with patient's consent, we decided to have a wait and watch philosophy. Every 6 to 8 months, we would have scans repeatedly to see the disease progression. And we made again a stabilization splint over here with all the guidances. The splint will again help us to evaluate the progression of disease, because now the lower anterior teeth are in contact with the splint. If we get any gap opening over here, we know that the condyle is again resorbing and it needs attention. So concluding my slide here, take home points for my clinicians and my young clinicians of orofacial pain would be diagnosis, diagnosis, diagnosis. I cannot reiterate again and again. Please do not begin a case unless you have a provisional or working diagnosis with you. There are n number of systemic conditions that mimic TMD pain. We as dentists and orofacial pain become tunnel vision, seeing only TM joint, and we tend to neglect that it is a part of a body. So systemic conditions affect and mimic temporomandibular disorders exactly the same. Reactive arthritis, Lyme disease, Ehlers-Danlos syndrome, fibromyalgia, migraine, giant arthritis, etc. are very few diseases, to name a few. So the clinician should be well versed with the systemic conditions which affect temporomandibular joint. Temporomandibular joint and their management, to be successfully managed, we need to be a good diagnostician. We need to have good prosthodontic knowledge of how dentition affects the joint and how the joint would affect the dentition. Good surgical knowledge of anatomy for trigger point injections, arthrocentesis, and radiological evaluation. And lastly, we should be good in cognitive behavioral management and identifying psychological factors of patients behind chronic pain. Of all splints, fat plane appliance or stabilization appliance works for majority of the cases when given with proper guidances. The role of splint is considered as a habit breaker. It protects hard tissues, and the disruption in the proprioception sent from the periodontal ligaments and the muscles from periphery to the motor cortex of the trigeminal complex. Splints are basically very best modalities of treatment for myogenous and arthrogenous, because they are reversible, can be easily managed chair side, and help to prevent harmful effects on the dentition and our prosthodontics. So yes, here I end my slide. Thank you all very much for your patient listening. My contact details are over here. My Facebook page details, which Dr. Sonal mentioned, I keep on bombarding my cases and discussions, are over here. You can join over there. And yes, any questions or queries?
Yeah,
I
Dr.
would be more
Saurabh,
than happy to.
thank you for, I could not have asked for any, but other person who could have summarized this whole temporomandibular joint.
Dr. Sonal, I cannot hear you. Yeah, sorry.
Yeah.
Yeah.
So I could not have asked for any better person who could have summarized the whole conservative management for TMDs. And questions are there. Definitely they would be there. What were you expecting? They will not leave you like that, the audience. But what I would suggest is, can you please go into the chat box and answer those questions? And in case if there is, because I'm looking at them, and that's another half an hour discussion, I'm sure of that. So if you would be kind enough to wait and answer those questions in the chat box, that will be great. And
Yes, definitely.
yeah, and Dr. Saurabh has covered up the conservative management, but there are at times situations which require surgical interventions, and that's when his I always call him the better half, only because they work in conjunction. So I did mention that Dr. Saurabh's wife came for the present convocation, but he
Hello.
forgot the other better half, that is Tawfiq. So
Hello.
Dr. Tawfiq, yeah.
Can
Dr.
one question,
Abhay,
please?
Dr. Abhay, we are not taking any questions right now, so you can ask in the chat box. We are running a little late. So you can just ask in the chat box. He will answer you there. Definitely he will answer.
Yes, I'll reply.
Okay. And Dr. Tawfiq Bora is our next speaker, and other better half of Dr. Saurabh. So they work.
He's like my elder brother, go-to person, where there are some we as a clinician, I'll be very frank that you cannot treat 100% of the cases. I am sure those clinicians who are managing patients will agree. So Dr. Tawfiq is the one where my 10-15% of the cases are not responding. And yes, we together have worked together with so many cases, have surprised us that the clinical presentations are such, radiological presentations are such, and surgical views have surprised us. I'm sure Dr. Tawfiq will elaborate in his presentation.
Yeah. So, Dr. Saurav, please hold back and answer these questions. And if you permit, you can give your number also, so that inquisitive audience like Dr. Abhay, he's been the most active participant in our conference. So he can also ask you certain questions there itself.
Yes,
Okay,
yes,
thank you,
yes.
Dr.
Definitely.
It's always a pleasure listening to you.
Thank you, Dr. Sonal.
Let's welcome Dr. Taufik Vora. Dr. Taufik, can you just switch on your camera? Yeah, you're there. Okay, Dr. Taufik is actually basically he's an oral and maxillofacial surgeon. Then that didn't satisfy him, and then he went ahead and did some fellowships also. So his first fellowship was in cleft and craniofacial surgery from CCI, and then another fellowship in TMJ arthroscopy and total joint replacement surgery from TMJ mini and then TMJ mini surgery from University of Maryland. Doctor, you plan to stop, or the fellowships will keep on adding by the next year? In fact, that was the only question I asked him. Do I keep the same bio as last year, or have you progressed little ahead? Fellowship into multiplied by 3. Okay, he's also a certified practitioner of pain medicine affiliated with British Pain Society. He's currently practicing consultant at SJ Raheja Hospital, Fortis Associate Hospital in Mumbai. He heads the cleft unit at Raheja Hospital and does all level TMJ arthroscopy in his private practice. Dr. Taufik is among the first few maxillofacial surgeon in the country to complete prestigious TMJ mini surgery program in USA and perform all level of TMJ arthroscopy, incorporating laser via arthroscopy in management of TMJ. Whew. That's a long, long, long bio, doctor. And I congratulate you for having such multifaceted personality and with respect to your curricular activities also. So, Dr. Taufik, the stage is all yours. So, you may start sharing your screen.
Yes, ma'am. Thank you, Dr. Sonal, and you have been really kind for that intro. Dr. Saurabh, thank you for the wonderful presentation. So,
Yes, Dr. Taufik.
is my screen visible right now?
Yeah, the screen is visible and you can go on the presenters mode.
Yeah.
Yes, please go ahead, doctor.
So yeah, and at the onset of it, I would like to thank Dr. Nurul, Dr. Sonal, all the patrons of IOPCON 2024. I have been a participant in the previous NOPCON as well. And it's a pleasure being here. I thank the orofacial pain community to have invited me specifically to give a talk. Dr. Sonal was talking about broadening the horizon. And yeah, that is the current need. So I will try to remain extremely crisp about the talks. These are my associations. These are the organizations that I've been associated with. This is me receiving the fellowship. This is my team. Dr. Saurabh is a part of it. Nobody was more happy than me, I swear, when he received his fellowship. It adds a feather in my cap as well. So I will not go into other details. I will directly talk about biomechanics and adaptability. Biomechanics is application of the mechanical laws to the living structures, specifically to the locomotor system of the human body. So technically, biomechanics applies to us in all day-to-day scenarios. The way we look at it from a surgeon's perspective, we look at it from an orthopedic joint point of view. And for me, when a patient says that I have temporomandibular joint disorders, what we look at is intra-articular, extra-articular, and yes, we do look at the occlusion. Occlusion is never out of the window, because per se, if either one of this is not working properly, then the patient becomes symptomatic. Moving forwards, this is the Hilton's orthopedic law. So I have sat with a lot of orthopedic surgeons who perform small joint arthroscopies, and they have been kind enough to share that the nerves that innervate the joint also innervate the muscles that move the joint, as well as the overlying skin. So in crux, what they are trying to say is that when the joint is affected from inside, there is a guarding mechanism that comes up for the patient. So if you get a bump on your elbow, you will not open the elbow because of the guarding mechanism, because now it pains and the injury is to the joint. This slide is extremely important when you look at the physiology of damage that happens. So there is something what I would like to highlight over here is that always when you look from an orthopedic point of view, load is equal to adaptability of the joint. So what is functional remodeling? When the adaptive capacity of the joint is equal to the load coming on the joint and the discs are in place, there is no internal rearrangement, the patient is asymptomatic. As soon as the load on the joint is increased and the joint it exceeds the adaptive capacity of the joint, what takes place is dysfunctional remodeling. That is what Dr. Ajay Nayak also talked about, the gradations of the bones getting flat, bony erosions, beaking of the condyle. All this is dysfunctional remodeling because normally the patient is not aware about it and the patient is not going to stop with their daily function. So everything goes on. Like, as rightly as Dr. Ruchika Sood ma'am also commented that in India we have a chalta hai attitude. I would say we have an attitude where abhi to और चलेगा वाला attitude है कि अभी इतना बुरा नहीं हुआ है अभी और चलेगा. So that's where dysfunctional remodeling comes into place, and a lot of times we receive questions that what is the role of disc? Is the meniscus really important? Well, it's a multifaceted question, but yes, as a maxillofacial surgeon working with a keen interest in TMJ, I would say that this condyle relationship is important because synovial fluid is something which is very seldom talked about. Synovial fluid, as we all know, is the lubricant of the joint. There is something called as boundary lubrication, and then there is something called as weeping lubrication. This particular activity happens on loading and unloading. So now imagine a disc which is forward, it's non-reducing and it's folded. Basically, the radiologists, how they mentioned it's buckled over its own surface. What form of lubrication now this joint is going to develop? So there's going to be no exchange, no metabolic exchange. There is going to be very less amount of lubrication in the joint, which will eventually lead to formation of adhesions inside the joint and lead to a phenomena known as a stuck disc phenomena. So this is a slide which talks about synovitis. What is synovitis? The synovium is lining the joint. When the synovium is inflamed, it develops capillaries. It develops a synovial flow of its own, and that is called as synovitis, which it can also be called as adhesive capsulitis, or synovitis when left untreated can lead to synovial plicae. It develops a full-blown blood circulation of its own, and it develops into a form of cartilage that itself becomes a reason for biomechanical instability and causes mechanical interruption in the movement. I will skip these slides and will directly go to the surgical management of TMD. So, how do we manage surgically when the patient has been under all these investigations? Has been, and trust me, in our practice, we do not receive patients who have not been under any of these. It is very, very, very rare that we have received any patient who has not been under any form of treatment and is directly seeking for surgical references. And if at all such scenarios have arise, one or two, I myself have told them that I'm not the right person right now to consult. You may go through the normal protocol first. So coming to arthrosynthesis is a very efficient form of management. Typically, I have been told that my speaker previously yesterday talked about arthrosynthesis. So in essence, it involves two needles entering inside the joint to flush the joint. Basically, what does it flush out? It flushes out inflammatory mediators from the joint, and it can provide immediately. However, there are a few pros and there are a few cons to this thing. I have performed more than 500 or 1,000 arthrosynthesis. Arthrosynthesis per se also has a learning curve. Because yes, it is simple to put the first needle inside, but when you talk about putting in the second needle, that is something which is a little bit of it requires a little bit of experience, because at the end of the day, it's a blind procedure. So when you talk about the pros and cons, arthrosynthesis is an OPD procedure. Yes, it requires no downtime. It requires no special armamentarium and can be used efficiently for acute closed lock cases. What is acute closed lock case? So imagine a patient entering your office and saying that I was eating something or I yawned and there was a loud pop and now I cannot open my mouth. It's extremely painful. You as a clinician are going to prescribe an investigation. The patient says, I cannot perform the investigations as well. So in these scenarios, if you just flush the joint, this patient will have immediate relief and can go ahead, perform the investigations, and then come back to you in due time. Now, there has been a lot of debate over how much time does arthrosynthesis technically provide relief. In my practice, what I have seen is that a patient where arthrosynthesis performed more or less for 3 months remains asymptomatic. It's after that 3 months time when they will be having a few days good and bad, and then they are back in your office. The cons, as I said, yes, it's a blind procedure. There is limited capacity to adhesiolysis. Does not work in long-standing, severe non-reducing cases. I say this after I started doing arthroscopy. Why? Because arthrosynthesis per se is a procedure which relies on encephalation of the joint. What do I mean by encephalation of the joint is that the surgeon puts the first needle inside the joint and pushes fluid, technically RL, linger-acted solution. It pushes inside the joint and tries to encephalate the joint. So now I want the audience to imagine a bloated balloon. So this capacity of the joint to bloat is prima facie the premise because of which you achieve adhesiolysis. So this bloating can lead to breakage of adhesions inside the joint. But what happens most of the time is that when you do this, you don't apply enough of pressure. The surgeon does not apply enough of pressure sometimes. And sometimes there have been multiple jabs inside the joint. So imagine a balloon which is punctured 2 times. Now there is not enough pressure happening. No doubt there is flush happening inside the joint. However, there is not enough pressure generated inside the joint to achieve that form of adhesiolysis. Also, having said that, there are long refractory cases. I'll be demonstrating some of the adhesions to you. These adhesions are going nowhere with arthrosynthesis. Dr. Sonal, am I audible? My screen is stuck.
Yeah, you're audible and it's on orthosynthesis slide. So can you go back and then come log? Just go back, escape, and check if it is possible to share it.
I'm not able to escape as well.
Okay. Yeah.
Did it change?
It changed to TMJ arthroscopy 1.9 mm scope 30 degree.
Yeah.
Okay, perfect.
It's working. Yeah. So TMJ arthroscopy. TMJ arthroscopy, yes, is an advancement on arthrosynthesis. Arthrosynthesis was the TMJ arthroscopy, I believe, is the most advanced minimally invasive technique we have as of now in India. It requires a 1.9 mm scope, which can be available in 0 degree, 30 degrees, 70 degrees as well. However, what we prefer in our practice is a 30 degree scope. 1.9 mm is very small. It's a nanoscope. Yes, you do have a 1.3 mm scope available for silo-endoscopy. However, that is really small for the joint. And 2.7 is big for the joint. So 1.9 mm is the ideal scope. What we do in an arthroscopy is typically, as you can see on your screen, there is one camera that enters the joint from the per glenoid approach. The center point of the glenoid fossa is palpated by the surgeon. The surgeon enters via the center point of the glenoid fossa. The surgeon at this point of time is able to look at the entire joint. They can also introduce one more port inside from which they can use different instruments inside the joint. And they can also involve a third and a fourth port, where that's called as a level 3 arthroscopy, where effectively we can anchor the disc. We can engage the disc first with a 2O nylon PDS suture. We can engage the disc, we can pull the disc behind, and we are also in a position, if you are in a position to use lasers, you can use the anterior port and you can also perform a lateral pterygoid muscle myotomy. how does myotomy come into picture? So now we all know about lateral pterygoid muscle. Surgically speaking, when I see these cases, lateral pterygoid muscle has a very robust memory. So in chronic cases, how much ever you pull the disc, so now recapture of the disc, it is said, this term is used multiple times. Frankly speaking, when we go inside the joint and we try to pull the disc behind, as soon as you do slight movement, the disc pops back ahead. That's an indicator that the lateral pterygoid muscle pull is so robust that sometimes you need to release the muscle from the anterior part of the disc and pull the disc back, because now this disc anteriorly, the lateral pterygoid muscle will not let it come behind, and it will stay there. It will constantly act as a speed bump. The condyle is going to constantly jump over it, and it will lead to synovitis or arthritis. So not wasting much time, I would like to demonstrate. I'll be talking about it. This is how a surgeon takes entry into the first port. This is a fast forwarded video and also edited for the time constraints. That's how we perform arthrosynthesis. This is how, this is arthrosynthesis prima facie. If you just put an outflow port and that's the scope inside, you can look into the joint. This is your colleague helping you to put in a spinal needle, which again acts as an outflow. That what you see, what I'm putting inside the spinal needle is a 550 nanometer laser fiber. The laser used over here would be a Holmimiak laser. This is me inserting a second port inside the joint. Now, this particular case, there was a non-reducing disc. We had performed a laser myotomy. That's one more spinal needle trying to engage the disc from preauricular area in the manner you can see on your screen. The disc comes from the inferior joint space to the superior joint space through the disc. Over here, the surgeon would then pass a 2O PDS. That's me putting the fourth port inside. So you can appreciate all three ports inside the joint. And all three ports have to be in vision. You cannot, this is not happening blind. They are all the time in vision. That's something called as triangulation in the surgical world. You triangulate these instruments to be in vision. The surgeon would then pass a 2O PDS and would try to retrieve it using alligator graspers. So once you have taken hold of the 2O PDS, your colleague will withdraw the spinal needle out of the disc. And now you're free to pull the 2O PDS outside the joint, which would eventually help you to engage it with the disc. You engage the soft tissue component along with it. And now I will demonstrate how it anchors the disc in position. After this, we would do all set of movements inside the joint. We would try to crank open the joint and see whether it is staying in position or the suture does not give away. Both the things have to be seen. Once we are out, we take all our ports outside, and then we do engage this 2O PDS to the preauricular area of the disc, which is posteriorly through the soft tissue. You're trying to keep the knot of the 2O PDS inside the skin so that there is no cosmetic problem in the past, in the future. So now, since we have a basic evaluation of how arthroscopy is done, this is one case where you can see the disc is completely anterior, and we went ahead and the patient had a lot of inflammation inside the joint, severe mouth restriction, deviation, did not open beyond one finger. and we went ahead, we reduced the disc in position, but you can see the amount of inflammation inside the joint, all the red synovium, and this is a scenario of overgrowth of synovium, if you can appreciate. This is the retrodiscal part of the joint. You're looking at the right joint. The disc is facing forwards. That's how a 550 nm Holmemiag laser works. It works fantastically in such scenarios. So technically, what were we trying to achieve? We were trying to achieve, with giving steroid injections, we were trying to get rid of this form of arthritis inside the joint. This is something we can do under vision. We go ahead, we get rid of adhesions with the help of lasers, and also we do an all-round ablation of the retrodiscal tissue. It achieves two things. What it does is it relieves the patient of the pain instantaneously. However, this ablation, what I'm doing, is going to eventually lead to scarring. So after this, if you go and you do a proper load management for this patient will have a good stable joint, and will be able to do all the normal activities as they were doing before. Wow.
I think you've logged out of your presentation, Doctor.
Is this, yeah?
It's visible.
I'm sorry for the technical glitches happening. I don't know why.
Happens.
So this is one more joint. I'm sure this is crystal clear. We got a very good visual at this. Look at the amount of synovial perforation happening over there. This is all hyperperfusion of the joint. There are specific capillaries that can be seen over here. We passed in a laser. This is the reduced thing. So earlier this was covering the joint head. Once it is reduced, this is what you are left with. And the lasers work wonderfully in these scenarios. It acts as an eraser inside the joint, just gets rid of everything at one go. Why do we use Holmemiag lasers? We use Holmemiag lasers. So I received this question that why don't we use any other laser? Holmemiag laser and thulium is the only laser which works in a water-filled scenario. And this, mind you, is constantly under an RL insufflation. So RL is constantly getting flushed inside the joint, and we are working with the laser with the water environment inside. So that's why Holmemiag. There are coblators available from the surgical aspect that we can be used, but coblator uses if you're using a coblator, you need to use a normal saline as water environment, but RL is most physiologically similar to the synovial fluid and the joint components. That's why we stick to RL. So moving forwards, this is one case. This is a case of a doctor himself. He was a laparoscopic surgeon in Delhi. He has tried everything under the sun, from splints to medicines to arthrosynthesis, everything. This is chondromalacia grade 3. The entire joint is filled with synovium, which has overgrown to that extent that this patient had pain, no doubt. But the main complaint was stuffiness of the ear. So when it could not come forward, the patient started having blockage in the ear. However, when we went inside, this was the scenario. It was extremely difficult for me to even gain an entry inside the joint. This is how it looked. However, in this scenario, when I entered the joint, I found that a shaver, at that given point of time, I did not have a shaver with me. So we used a laser and individually ablated everything, and it took me a lifetime to achieve that. However, the doctor responded well to the procedure, but yet I feel that a shaver would have worked wonderfully in such cases. This is just to show that, and the MRI is inconclusive. I mean, the MRI is not talking about it. It was talking about a fusion, but frankly speaking, this is what we saw when we entered inside the joint, and it become completely red and filled with cartilage. In this same patient, this I wanted to show, this is an adhesion. It's going across the joint. So if you can appreciate, it's right from medial lateral. So now any form of arthrosynthesis you perform, you're not getting rid of such robust adhesions inside the joint. This would require somebody to intervene and break the adhesion. We use a laser to rip it off. And so what does arthroscopy do? Arthroscopy will allow the surgeon to flush, or obviously flush the inflammatory mediators. It will allow the surgeon to reduce the disc under vision. It will also enable the surgeon to perform Botox injections in the lateral pterygoid muscle if required, in case of an hyperactive lateral pterygoid, which obviously due investigations will tell us. It will allow you to perform adhesiolysis. It will allow you to perform a myotomy. It will also allow the surgeon to pass a disc and anchor the disc in position, which was the reason prima facie why other procedures were not found to be very conclusive, or if there were procedures, it was supposed to be very aggressive. Now, yes, me being a surgeon coming from a surgical background, for a 2 mm or a 5 mm disc displacement, opening up the entire joint, yes, it did sound very aggressive. But with the advent of arthroscopy, it kind of bridges the gap between just performing a conservative management and getting the disc back in position without opening up the joint, or without technically violating the entire anatomy around the joint as well. So it's a very minimally invasive procedure. It deals with the points it can deal. However, it cannot deal with a lot of other things for which open joint surgery is indicated. But when it comes to internal rearrangement, arthroscopy has proven to be a game-changing thing. Because yes, a efficient disc-condyle relationship is and will prove important for all other faculties working in this area. Because what happens is, if the disc is not put back in position, or not relatively, got in the functional aspect, there's no harm. There are a lot of patients who have a disc displacement yet are doing very well in their life. The point is not that. The point is staying with a non-reducing disc, a non-functional disc. Now, this non-functional disc is a problem, because what it does is so if you are managing the patient with medications, if you're managing the patient with splint, both of these things, when they are stopped, because the disc is non-functional, now the patient will again come back to your clinic. So it has to be seen from all angles. If you're managing the patient with XYZ protocol, if this is left, it will take down your treatment protocol, your treatment effort with it. Moving forwards to an open joint surgery, this is a case which is very interesting. Now, why did I and Dr. Saurabh, we were on this case together. This patient has, again, the patient has tried everything under the sun. The patient has been under 2 sessions of arthrosynthesis. This patient, when I received the MRI, obviously the MRI was saying that this is effusion. And I myself felt that it is effusion, but on giving it a real thought, I said that this is too organized a form of effusion. How can it be like this? I also called up the previous maxillofacial. It was referred to me by my maxillofacial colleague. So I called up the maxillofacial colleague, and I asked him that, did you inject Kinacort, steroid, inside the joint recently before the patient did an MRI? Because that also can present somewhat like this, because that's a hazy solution. The surgeon said that, no, I've done nothing like that. And then I had a word with the radiologist, and they said that, yes, it is a little too much. But yeah, at the MRI, it looks like a effusion. Now, when I saw the patient clinically, she had a pinpoint swelling at the TMJs, and as if something is jutting out from the joint. Again, it was a red flag for me. I did not find it absolutely normal. I have seen my share of effusions inside the joint, but this was not something which just looked right. With my previous experience of dealing with the respected doctor's case in Condro, Malaysia, this time I took a gut call, and I said that I will not be going ahead with an arthroscopy, but will be performing an open joint procedure for you, because I don't think this is absolutely effusion. This is the right TMJ of the same patient. This is the CT images of the left and right TMJ. So there was nothing more to this. However, when I opened the joint was completely filled with cartilage. So this was, and we obviously sent it for histopathology. Patient had tremendous pain pre-surgery, a mouth opening less than 1 finger, something jutting out from the joint, as I said. And when we opened up the joint, you can see it was, we had to literally scrape out the cartilage from the joint, and it was completely filled. Good thing was that the disc was intact. The anterior compartment and the posterior compartment, the entire wall was having, so technically synovitis, which eventually misdiagnosed, again went into further form of pathology, and the entire cartilaginous wall started developing inside the joint, which represented like this in small pieces of cartilage, completely organized inside the joint in the posterior space and the anterior space. We went ahead, we removed everything. Now imagine me going inside with an arthroscope for this joint. It would be a great sight for me, but I would not be able to do justice to the case because removing one by one would take me a lifetime. So it was a good call. We opened up the joint. We took out everything what needed to be done. We flushed the joint with a lot of copious RL irrigation. After that, we irrigated vancomycin 500 mg, and then we achieved closure. The patient now has good amount of mouth opening, at least 3 fingers. So this is something which is new. I mean, we do not see this day in, day out. So it was a very interesting case. Coming back to the normal genre of work we do, open joint disc repositioning sometimes where there is a tear or something, we can deal with it in a open joint manner. We are in position to put 1.3 mm screws inside the joint, some known as Mitek anchors. They have slots for them to pass a stitch through it. So we engage it in the condyle and we can engage the disc around it. And that is pure, it's a pretty sure shot procedure. It holds it in position. That's how we reposition the disc and we tie it in an open joint setting. Total joint replacement is another surgical modality mainly considered in TMJ ankylosis, avascular necrosis, resections, tumors, osteomyelitis, juvenile idiopathic arthritis. Severe cases of juvenile idiopathic arthritis, I do not think JIA detected at an initial stage would require an open joint surgery, at least not after arthroscopy. That's how a joint is replaced. This is an AO animated image. We replaced the ramal component as well as the glenoid fossa for this patient. This was typically a patient which had a bony ankylosis, refractory to treatment, dealt with an open joint surgery. A discectomy was done. They removed the disc out and they tried to rotate the temporalis muscle, but somehow the temporalis did not work well and there was complete bony union. Dr. Ajay Naik showed a case where there was loss of bony continuity. Even those cases, when left refractory, will lead to ankylosis scenario. We replaced the disc, the joint of this patient. And that's how the ramal component and the glenoid fossa seats inside. We take 2 incisions. We take a preauricular incision as well as a submandibular incision, and we replace the ramal component as well as the glenoid fossa component for this patient. This is one more patient we had. This was patient having an AHI index of obstructive sleep apnea patient with a Pierre-Robin sequence. He was operated earlier by a surgeon. They did a rib graft over here. The patient was tracheostomized for 30 years. He came to me in his 50s and is on CPAP. We had planned, and we have already executed. The patient is not allowed given consent to share clinical photographs. So what we did is we did a bilateral TJR. We got the entire mandibular segment ahead. He had an AHI of 70+. So yeah, and concomitant orthognathic was planned for this patient, and the patient is doing well now. These are the pearls. Mostly, what is necessary is when it comes to TMJ, you need to look at it at a whole. The joint needs to be stable. If the joint is stable, everything else, the muscular component and the occlusion would fall in place eventually. Dysfunction and morphology is more important than disc position per se. And since the advent of minimally invasive methods, I can vouch and say for it that if they are dealt with at an early stage rather than it being the end stage, if you feel that, okay, this patient is refractory and now is not responding, at that given point of time, if somebody enters in and deals with the internal rearrangement scenario, I think we get better outcomes out of this patient. We get better compliance, and the treatment time frame is shortened. It can always help the patient to bounce back a little earlier. Even in scenarios of chronic musculoskeletal pain, sometimes which are involving interjoint components, it will prove important. Thank you. And these are the three things I always do. I anticipate, I seldom improvise. I always stick to the plan. And I personally believe that slow is smooth and smooth is eventually fast.
Yeah.
Thank you for your patient listening. Thank you, Dr. Sonal, and over to
Wonderful,
you.
wonderful case presentations, Dr. Tawfiq. And
Thank you.
though I'm not a surgeon, and this was such fascinating thing that I might think about dwelling my hands into that section also now. So beautifully managed cases and lovely presentation, I would say. And awesome is the word for it. Like beautiful.
I would like to say that all these cases, most of them pre-operatively and post-operatively, go to Dr. Saurabh. He
I
does
called him your partner
maximum.
already. I have
Yeah,
already
he does
called him your
maximum
partner.
amount of management. Once I go and I do my thing and come, and then he's the guy who is managing stuff after that.
Yes, yes.
Uh,
I have already named him partner in crime with you, so I can understand. I can understand the Jugalbandi. I had named your session also Jugalbandi session, but
yeah.
here the Jugalbandi didn't happen. It happened in concurrence with both the worlds, like the surgical world as well as the non-surgical world.
So,
So,
Yeah.
Dr.
like,
Sonal, to
yes.
just 2 minutes, having worked with Dr. Taufik, it needs a lion's heart to put hand in such cases where many surgeons have refuted back. And now, almost working with him since 2 years, I can vouch for the cases he does and how what goes into the pre-planning of cases, what he do. And yes, that's what I want to tell about him. Yeah.
Thank you, Dr. Saurabh. You are very kind.
Like, maybe
You will receive the due check.
oh my goodness. Oh, okay, okay. By
Hello,
this,
sir.
this must be the
I
third
have a
time
question.
I'm listening to Dr. Taufik, and I see year and year after he is presenting beautifully surgically managed cases, like where we really would not have the heart even to delve into those cases, and he's managed them very well. So kudos to you, doctor, and congratulations on such a wonderful practice and such a wonderful service to humankind. So
Thank
thank
you.
you
Thank you.
so much. And the purpose of conference is already getting its shape, that the way we want to care for patients, and that is already shown by the orofacial pain specialists who are on our team. So thank you so much. And with
Thank you.
that,
Hello, ma'am.
yeah.
I
Somebody's.
have a question.
Yeah,
Sorry to
no, so
interrupt.
we are not taking in any questions right now. So you can
Two questions.
put up the questions in chat box, and Dr. Taufik, I'm sure, will wait and answer all those questions. And Dr. Saurav also is still here. So can you just put in your questions on the chat box, Doctor? Dr. Syed? Yeah.
Yes,
We'll
ma'am.
call it.
I'll put my questions.
Yes,
So, if my
everybody.
question is to Dr. Tafir, sir, I'll put my questions on chat
Yes,
box.
please do that. So everybody, because of the time frame, I would want everybody to put their questions in the chat box, and the speakers are here itself. They are not running away, so they are supposed to answer these questions. I know that they will answer, and I'm sure they will connect with you all later on also. So please type in your question in the chat box. With that, I would like to call in our next speaker, that is Dr. Anu Vijan. Anu, are you there, dear?
Yes, Dr. Sonal, I'm here.
Yes. So Dr. Anu is BDS from Government Dental College, Calicut. She's completed in 2009, and MDS in OMR from RGUHS in 2014. Awarded the first rank and gold medal in the during her MDS section, and began academic career post MDS. Currently serving as professor Mar Basilios Dental College, Kerala, and she has completed a mastership in orofacial pain and TMD from Roseman University under Dr. Davis's guidance and delivered lectures and on dental sleep medicine to dental and ENTs professionals. She's the chief editor of Malanadu Dental Journal and reviewer of the Kerala State Dental Journal and Journal and Medical Sciences published in leading journal that publishes leading journals for all around the country. So, Dr. Anu, where's your camera? Just switch on your camera, dear. I would like to see you first.
Yeah. Yes.
Yeah. So, yeah. Your slides are also visible. So, can you start your presentation there? And welcome
Yeah,
to
sure.
International Orofacial Pain Congress 2024. And Anu is one of the speaker who was diligently behind me that, okay, no, you have to call me in. And she literally, when she spoke about her presentation, I said, no, you need to be a part of it because Dr. Anu is going to be talking about TENS, an adjunct therapy in orofacial pain management. So here we are talking about the management part of it, and TENS plays an important role, though an adjunct role, but it plays a very important role. So Dr. Anu, the stage is all set for you. Your slides are visible. Go ahead with your presentation, dear.
Okay. Thank you, ma'am. So good afternoon, all. Warm greetings from me and my team in Ma Basilius Dental College. It's an institution where I'm attached as a professor in the Department of Oral Medicine and Radiology. It's in Kerala. It's in a small town called Kothamangalam, which is a gateway to Munnar. I hope everyone among you have heard of the tourist destination in Munnar. So if you have a chance to visit Munnar, do come and visit us in Ma Basilius Dental College. So it's great to see you all on the third day of this international conference and to learn about orofacial pain. And as you all know, it's a new and the 12th branch in dentistry. I'm so glad and I appreciate Dr. Sonal, Dr. Noorul, and the whole team in the MidSkill for organizing such an enlightening session and an international conference. And thank you for making me a part of this. Even though I couldn't attend all the lectures which happened over the past days, I understand that all the delegates have been taken through the basics of pain and various modalities of management. So let's build on what we have learned so far and dive into TENS therapy, its practical application in orofacial pain. So today I'm here with my topic of presentation, TENS and adjunctive therapy in orofacial pain. So what is TENS? TENS, as you all know, it is an acronym of the word transcutaneous electrical nerve stimulation. So it's a non-pharmacological method for pain control wherein a small machine which we can can be used as a portable one also or in clinics also which produces electrical current for alleviation of the pain, and the pain is delivered with help of certain self-adhesive electrode pads which we apply on the surface of skin. So before going into TENS, let me show you there are several modalities of pain management by stimulation of the nerve. So the first one is by stimulation of the large diameter fibers of the pain transmission. So those are the ones like TENS management, which I will be talking in detail. Then the commonly used modality of pain management, that is the massage therapy, which we do commonly when we get a cut or when we get a painful injury. What we do is immediately we massage the area, right? Or we take a balm to apply over the area and we gently massage over there. So what is happening at that time? We are stimulating the large fibers, which helps in alleviation of the pain. Now, the second modality of pain relief by nerve stimulation is by decreasing the pain fiber transmission velocity. Means the conduction of the pain is being reduced, and this is being delivered with help of cryotherapy and the ultrasonography, which already Dr. Saurabh had spoken about. Now, the next method is by stimulating the small diameter afferent fibers and the descending pain control mechanism. I hope the descending and the ascending pain systems has been covered in the past sessions. So the descending modality is the one which helps to modulate the sensation of the pain which a person perceives. So this modality is being delivered through acupressure, the deep massage, and the TENS system. And the last modality of pain management by nerve stimulation is to stimulate the release of endogenous opioids by prolonged stimulation of the nerves. As we all know, opioids are pain relieving medications which are there inside the human body, naturally produced. Those are called the endogenous opioids. And yes, TENS helps to release the pain by working on this mechanism also. So going to a brief history about the TENS, electricity has been used for alleviation of pain since the era of ancient Greeks, Romans, and Egyptians who used the live electric ray fish for management of pain. And it was in 18th century, Sir John Wesley, he introduced the relief of pain with electricity for management of sciatica, headaches, kidney stones, all those things. And in 19th century, Dr. Francis introduced the management of pain in dentistry, and handpieces providing electric current via burr cavity preparation was introduced in the 20th century. With more and more inventions, the modern concept of pain therapy with the TENS was proposed by an American neurosurgeon, Dr. C. Norman Shaley, and in 1972, FDA approved the TENS as a Class II medical device, like our blood pressure monitoring devices, glucometers. This is a commonly used machine which is easily available for the patients, also for the management of pain at their home. So, how is this TENS acting? As I told earlier, TENS acts by nerve stimulation based on two theories. One is the gate control theory, and the other one is the endogenous opioid theory. So, gate control theory, just to say a brief about it as a basic, the gate control theory is the one which is proposed by Sir Milsack and Wall. It says that in the spinal cord, the dorsal horn cell, the substantia gelatinosa, is a gate controlling system which controls whether the person has to perceive the pain or not to perceive the pain. So what happens in a healthy individual is that whenever there is a pain, when the small diameter C fibers are getting stimulated, there is a transmission of pain through the spinal cord to the brain. So the individual will have the pain. But here in TENS, we are stimulating the large diameter fibers so that the fibers will inhibit the action of the C fibers. That is, it will stimulate the inhibitory interneurons, and that will close the gate, and thus the patient is not perceiving the pain. So that is how TENS is acting with help of the gate control theory. Now, the second theory based on which the TENS is acting is the endogenous opioid theory. As I told earlier, we have the opioids which are endogenously produced in the body, like the dynorphins, enkephalins, and the morphins. So we have several receptors like delta receptors, kappa receptors, mu receptors, which are there in the central nervous system. To be specific, as I have shown in this picture, we have the PAG, that's the periaqueductal gray. We have the RVM, rostroventral medulla. These are the structures which is there in the midbrain, which is there in the medulla oblongata, where these receptors are present. And what happens is that this is like a streamlined pathway. So when we activate the TENS will stimulate the production of this endogenous opioids, and this will go and attach to the receptors in this PAG, RVM, that will stimulate the release of these system, the PAG RVM system, and they will go and inhibit the gate. Which is the gate? That is the dorsal horn of the substantia gelatinosa in the spinal cord. So again, by the release of this endogenous opioids, by stimulation of the TENS, there is inhibition of the pain transmission. So this activation of the mu receptors or the kappa receptors is based on the frequency of the TENS which we provide. So when we are providing a high frequency TENS therapy, that will activate the mu opioid receptors. And when we are stimulating the low frequency TENS, they will stimulate the delta opioid receptors. So indirectly, whichever receptor is getting stimulated, the net effect is hypoalgesia or decreased pain sensation for the patient. And there are several other theories also proposed, like in the TENS, will help for the local peripheral or autonomic effects. It helps to modify the flow of the blood in the body, that is in the muscles. It will increase the blood flow. So what happens when the blood flow is increased? When the blood flow is increased, the toxic metabolic waste which is getting accumulated is washed away. And these algogenic substances, when they are removed from the body, that will increase the comfort level of the patient or decrease the pain for the patient. And also studies have proved that when we are delivering TENS in a high frequency mode, it decreases the substance P. Again, substance P is an ergogenic substance which induces pain in the human body. So as the TENS decreases the substance P in the dorsal root ganglion, it decreases the pain perception for the person. So these are the few theories based on which the TENS is acting. So this is the basic TENS machine which is available. These are the basic components of the TENS machine. So this one is a pocket type of machine which the person or the patient can carry with him. It's a portable one. As you can see, it is very small. And it comes as it has an electric outlet, a power plug cord, or it has a battery which has been put into as a power supply. And this D is showing the lead wires with which the electrode pads, that's a E, is connected to the electrical unit. That's a TENS machine unit. So TENS is a electrical pulse generator, which is available in the two clinical modes. So this one is the pocket mode, which is connected, which is using the battery as a power source. And the next picture, this one shows the this is the one which is used in the clinics. So this is the one which we have in our clinic. So here again, you can see there is the lead wires. You can see there is the this is the adhesive pads. This is the metallic stimulators. You have the conductive gel, and this is the cover of that whole machine. So on the machine per se, when we see, you have several buttons which helps to adjust the frequency of the current which is delivered. We can adjust the current to be a low frequency one or a high frequency one. We say a high frequency when we are delivering a current of more than 50 hertz, and that is operating via the gate control theory. So it produces a short-term analgesia. And when we are adjusting the current in a low frequency, that is in less than 10 hertz, then we are operating via the endogenous opioid mechanism, and that provides a long-term response to the patient. And again, you can see a few other buttons. That is the one which is adjusting the amplitude of current. So in this machine, you can see one red button, then there is a black one, again red, again black. So these are the outlets where you are going to connect the lead wires, and a single channel comprises a red outlet and a black outlet. So if you connect both the lead wires together, that will complete the circuit of that single channel. And in this machine, there is another part, that is the muscle stimulator part, which is used for patients who have spasm of the muscles. So this picture is showing the modality or the how much intensity we are, or how frequently we can deliver. So we can deliver the pulses of the current in a burst pattern, that is the same frequency of pulse is being given with a break-free period, or we can deliver in a continuous pattern. So the most commonly delivered modality for the management of myofascial pain is a continuous pattern. And otherwise, if you want to produce a brief period of muscle twitching, then we provide for a burst pattern. So there are three types of TENS modalities delivered to the patient. So the first one is the conventional TENS, wherein the International Association of Study of Pain defines this as a high frequency delivery of the electric current with a low intensity. So this high frequency current, what it does is it will activate the large diameter fiber. So as I told, this will work via the gate control theory. So in these situations, we can instruct the patient to increase the amplitude of the TENS, the current, until a strong, comfortable, non-painful analgesia is being experienced beneath the electrodes. So we don't prefer a painful paresthesia for the patient. We ask the patient to adjust the amplitude. So we adjust the amplitude and ask the patient verbally how you are feeling. Is it a tolerable kind of sensation you are perceiving? Till the level of tolerance which is being comfortable to the patient, we increase the amplitude of the current. So this conventional type of modality of the TENS can be used in situations whenever the patient is having pain, because it produces a rapid onset and it waves off also rapidly. The next modality of delivery is the acupressure-like TENS, which is called as L-TENS. So here IASP defines it as a form of hyperstimulation, which is achieved using current of low frequency, less than 10, that is commonly 2 to 4 hertz, and a higher intensity of current. So previously it was a high frequency and low intensity current, whereas here it is a low frequency current with a higher intensity. So here we are stimulating the small diameter fibers. So this L-TENS was developed to harness the mechanism of action of both the TENS and acupuncture. So the segmental and extrasegmental analgesia will be achieved for the patient. So it is used to treat patients who are not very easily responding to the conventional TENS modality. So here the patient is advised to be careful to administer this with less frequency as compared to the conventional TENS. So as I told, the conventional TENS, the patients can do it maximum 4 to 5 times a day, or as per the pain is there for the patient. But this acupuncture like TENS, we advise only a period of 5 to 15 minutes for approximately 3 times a day. Now the third modality of TENS which is available is the intense TENS, which is not very frequently used by us for the myofascial pain. It's a counter-irritant kind of management where we deliver a high frequency and a high intensity current. So it is very painful but tolerable. So it is used for patients only for very few minutes. So the advantage of this is that it has a delayed offset. It remains for a little more longer period of time. So to compare all these things, as you can see, as I told, conventional one uses the high frequency and the low intensity. The acupressure L-TENS uses a low frequency and the high intensity. And the intense ones uses a high intensity and the high frequency. So since the intense ones creates a more painful feeling for the patient, it is used only for few minutes. The conventional ones can be used as and when required for the patient. And the acupuncture like TENS is used for 5 to 15 or 20 minutes, approximately around 3 times a day. So the experience by the patient using this is like the conventional TENS produces strong, non-painful TENS with minimal muscle activity for the patient, whereas the L-TENS, the acupuncture-like TENS, produces strong, comfortable muscle twitching for the patient. So it is not very commonly used one. And the intense one produces a uncomfortable pain, but still the patient have pain relief. So this is I have added a video presentation of TENS therapy, which is given in our department for the patients. So this is for the patient who she was the intern in our college itself. She was diagnosed with fibromyalgia with generalized aching pains over the body, and she was complaining of pain after chewing in the masseter region. So we apply the TENS in the bilateral masseter area. And you can see this is my postgraduate student. She's adjusting the amplitude of the current as per the tolerability of the patient. And this is a second patient. Here, this patient is being delivered again a TENS modality of management of stimulation of the muscle. So in this patient, she was having a myofascial pain with no referrals. It was a localized myofascial pain in the area of a masseter and sternocleidomastoid muscle. So we are applying the electrode pad over the masseter region and the SCM region. So again, we have to be careful in these situations not to apply very close to the eye of the patient. It is not very preferred to be near the eye of the patient. So very carefully, we have to keep away from the eye region over to the bulk of the muscle of the masseter and above over the bulk of the SCM, not very anteriorly, have to be on the surface of the SCM so that the bulkiness of the muscle prevents the travel of the electric stimulation towards the underlying vessels. So again, when we are applying these kind of electrodes to the patient's face or the skin, we have to be very particular in seeing that the skin is intact, healthy. It's not having any sensitivity. And we have to sterilize the area before application of the electrode pads. And we have to keep it in the area of the dermatome where the patient is feeling the pain. So in case if the patient has pain in a particular area and you cannot keep the pad in that area, you can select the peripheral or the adjacent area where there is no hypersensitivity of the skin, but at the same time, the dermatome transmits electrical signals to the nerve in that area. So the key determinant for the success of the stents management is the pulse amplitude and the frequency of the pulse we delivered. So as I told, there are different modalities, the conventional, the acupuncture and the intense type. So most commonly what we preferably do for the management of myofascial pain is the conventional TENS therapy, and we have to adjust the amplitude of the current which we are giving. So always keep the frequency at the higher level and adjust the amplitude so that the patient has a strong, comfortable, non-painful anesthesia beneath the electrodes. So we can encourage the patient, ask them to be free and speak to us that if it's not feeling comfortable for them or he's having some kind of an paresthetic or tingling kind of sensations, we can reduce the amplitude of the current which is being delivered to the patient. So coming to the clinical indications where we can deliver this TENS therapy is that we can give it in both acute and chronic cases. So we have the chronic cases, the myofascial pain, we can give in the osteoarthritis, rheumatoid arthritis, and the back pain, especially in the neck and the low back pain regions. In the neuropathic pains for the management of trigeminal neuralgia, post-herpetic neuralgias, in the localized myofascial pains, myalgias, and post-excessive soreness. Then in patients with inflammatory pains and chronic wound pains, we can give, but be careful not to apply directly over the wound region. And also in cancer-related pains, it has been proven scientifically for the management of pain relief. So the indications, the precautions which have to be taken before we administer the stents therapy is that it should not be administered, as I told, over the anterior neck region because of the direct vascular supply in that region. So it will be in direct contact with the vessels and the nerves, and also near to the eyes, as it can coagulate or it can reach the retina or the eye region. And it should not be administered close to any transdermal drug delivery systems which is already kept over the patient's skin. It should not be given or used by the patient while they are driving. And it is preferably if the patient is using the TENS before sleep time, the machine should have a timer so that the machine switched off by itself after a particular period of time which the patient has set. And the studies have proven that caffeine inhibits the effect of the TENS. So we can instruct the patient, if you are planning to advise a home care therapy with the TENS, not to have coffee intake before the application of TENS, because the efficacy of the TENS will be reduced when the caffeine is taken, because the adenosine will be inhibited. So with these precautions, the contraindications which we have to take into considerations are, it's not to be used in patients who are apprehensive, the patients who have communication gap or mental disabilities, patients who are using cardiac pacemakers. It is relatively contraindicated. It is completely contraindicated in patients who are taking cardiac pacemakers because this electrical impulses can interfere with the electrical impulses which is being produced by the pacemakers, unless and until the pacemakers one which is having a fixed output. So in cerebrovascular diseases, in patients having aneurysms, post-stroke or transient ischemic diseases, it will, as I told, it will stimulate the blood flow, so it is contraindicated. In epileptic patients, it can increase or induce the seizure activity. In pregnant patients, we don't have FDA approval to use the TENS therapy, but the Chartered Society of Physiotherapy suggests that TENS can be used in pregnancy and in epilepsy, provided the electrodes are placed well away from the abdomen, sacrum and the neck region respectively. But I don't prefer using in the pregnant patients because relatively not safe. And in undiagnosed pain, we don't know, we have no clue what pain the patient has. Don't go and jump into this adjunctive therapy of modality. And it's not effective in patients with temporomandibular joint diseases, which is due to diseases pertaining or per se arising from the disc derangements, metabolic diseases, or the trauma. So basically, it helps in management of pain arising from the muscle and the related structures. So the advantages of using the stents is that it's a non-invasive procedure, relatively safe for the patient, and it doesn't have any side effects of the pharmacological therapeutics which we are administering to the patient. Relatively fast in action, reducing the pain, and there is no post-application effect on the nerves. Patients can self-administer and titrate the dose according to the pain intensity and frequency. It is relatively inexpensive as it's a one-time investment. So it comes to nearly, you can see in the Amazon, there are portable TENS machines available from even 1,500 to 2,000 rupees. So it is relatively advantageous for the patients who are in real pain, real chronic pains. You can help the patient. But the disadvantage of this machine is that it is creating a transient tingling sensation and transient paresthesia. So you have to inform the patient. So what we do in our department is that we already take a informed written consent from the patient that I have been informed about the disadvantages, the transient effects which can happen after keeping the tense electrodes over the skin. So it can induce transient tingling sensation or a transient paresthesia. Again, it's transient, it's not a permanent damage to the person. And it's only used as an adjunctive therapy. It's not a mainstay management for control of pain in the patients. Again, as I told, you can do it as a combination therapy, which helps the patient. And high frequency will be required in patients who have morphine intolerance. So it is not an indicated one for patients who already is taking morphine in high doses. So that is in the case of malignancies. And also in combination therapy, it helps the patient in non-responsive individuals. So with this, I would like to conclude my presentation with a takeaway message that TENS is a linchpin in various clinical domains and helps in alleviation of pain. But before embarking on the management with the TENS, you should have a good clinical knowledge. You should take a formal pain assessment and come to a conclusive diagnosis. So clear and understandable instructions should be given to the patient for the management of the pain. And it acts as a safe and adjunctive management for myofascial pain, TMDs, osteoarthritis, rheumatoid arthritis, trigeminal neuralgias, and post-herpetic neuralgias, these are the patients who come to us with a chronic pain in our clinics, right? And thus, this TENS acts as an increased efficacy when used in combination therapy with other modalities. So that's it with my presentation on TENS as an adjunctive therapy in management. I think all of you are in the situations with all your neurons on fire, lit by the wealth of knowledge on orofacial pain over the past 3 days. I wish you all success in applying these insights to improve the patient care in your practice. Thank you for your patient listening. Thank you.
Thank you, Dr. Anu, and you rightly put the last video, the GIF, the image what you put actually sums up the brains right now. And
Yeah.
thank you, Dr. Anu, and it was really insightful because TENS therapy, not everybody is equipped with the device firstly, and secondly, at an institutional level, it is possible. But I have seen many clinicians now adopting to this therapy as an adjunct therapy, and I'm sure as in how when the orofacial pain practice progresses, we will have more and more cases to discuss regarding how they have been benefited with this therapy.
Yeah,
So
yes.
so we need more and more clinical I mean the factual cases that we have seen, because there are so many adjuncts that go along with it. So TENS is one of the adjunct that way, but
Yeah,
very
it's just an adjunctive therapy.
yeah, very well put up, and I'm sure the audience has gained a lot of different insight on management of TMD from you. And more importantly, you mentioned that it is mostly for a muscular issue, not when the issue has to be, the diagnosis has to be very correctly placed in, and then only the therapy has to be applied. There are certain questions for you on the chat box, so please stay back and answer those questions. And I would like to invite you to wait and listen to this next speaker also, Dr. Jamin Patel. And
Thank you.
thanks for coming to International Orofacial Pain Congress. Thanks for being a part of it. Yeah, and with that note, I would like to invite our next speaker, Dr. Jamin Patel.
Hello, Sonal and everyone.
Oh, yes.
Good afternoon.
Good afternoon, Jamin. Okay, and with where should I start? Why I call him Jamin is because Jamin is my partner in crime when it comes to solving orofacial pain cases or completing the orofacial pain syllabus itself. So Adha Tukar, Adha Maker. This is that 3 a.m. friend of mine who always helps me in any situation, personal or professional. So, Dr. Jaimin Patel is the Director and Chief Implantologist at 32 Pearls Multi-Specialty Dental Clinic. He has chains of clinic in Ahmedabad, and I'm sure he will have many more chains because that's what is his vision. So, in future, every corner, I bless him that, in future, every section of Ahmedabad should have a name, Jaimin Patel's clinic there, Dr. 32 Pearls. So, all
Thank you
the
so
best
much.
for that, and that's our next motive. And he's completed his fellowship in dental sleep medicine from Rosemary University, like me. He was my fellow partner that while completing the fellowship. and he's also a fellow in ICOI. He's actually basically a implant person. Jamin, he can answer anything in implantology. I always go to him. What should I do? Should I place this implant? And he just needs a radiograph and he will guide you without even batting an eye. So that is Dr. Jamin Patel for you. He's actually a mentor, key opinion leader, and an enthusiastic for cyclist also, I would say. He owns a nature-driven lifestyle wherein he lives between weekends and he waits for those weekends wherein he can roam around on his cycle, and he lives in a very beautiful society, I would say, where I can see peacocks and all kind of birds flying around. So Dr. Jamin is going to be talking something related to a very different field, or Dr. Nivi has already shown light on the topic, that is sleep medicine. So he's going to be talking about scope of dentist in sleep medicine. Why we have included sleep medicine in this orofacial pain practice lectures. So Dr. Jamin, the stage is all yours, and I can see your slides. And please go ahead, Doctor.
Thank you. Thank you, Sonal, for a wonderful introduction. And for the audience, Sonal is a very good friend of mine, and along with many other friends, we were there together enjoying. So I know that we are running a little late in the schedule, so I will also try to cover up the clock and moving further. So, as Sonal has given introduction, I am practicing in Ahmedabad, Gujarat, and I am having 4 practices right now. And my current focus is on implants and veneers, and now the orofacial pain and sleep medicine portion. So, I've been given topic of speaking on scope of dentist. What is the scope of dentist, right? We all know that the scope of dentist in a current scenario is a little bit, people are not so happy everywhere, particularly the young dentists and the practitioners. But I would say everywhere there are huge scopes involved. When it comes to sleep medicine, once I have entered into this field, post-COVID area, which you can say, and definitely it is very, very interesting, and it's a different ball game, right? So what we can go further, I would try my best to give you the insights. You can meet my mentors. On left is Dr. Davis Thomas. We are always grateful to him and my team, my gang, I would say. And many of these gang are already speakers in this lovely symposium. So you would love to hear them all. As far as Dr. Thomas is concerned, after my fellowship, I have done 2 international publications with him. I would discuss during the presentation. After those 2 publications, I had an opportunity to write a chapter on in his book on dental clinics of North America, which he recently published. So I was a part of that thing. So I was privileged in that way. So moving further with the topic. So what is the scope of dentist in sleep medicine? We all do the treatments and whatever pain and non-pain and replacements and everywhere. But when it comes to sleep medicine, there are multiple ways a dentist is involved. But there are 3 things where a dentist is more important, or we have a scope in our regular general practice. As Sonal told, I am a general practitioner, I'm a hardcore practitioner, and whatever I learn or whatever I apply, I always see in context of the practice. So I will also speak in that context only today also. So when it comes to sleep medicine, I would say these 3 things are majoritarily involved in general practice. One is sleep breathing disorders, another is sleep bruxism and movement disorders, and the third is sleep and orofacial pain. So sleep is involved in these 3 verticals differently, where we as a dentist have a big role to play. So let's go in depth one by one. And before that, you need to understand the sleep. Very commonly and jokingly, we say that we don't want to understand anything, we sleep. Now, there's lot more to know about the sleep. Many of you must be knowing, those who are not into this sleep medicine or into the science of sleep. Just a quick reminder before we move ahead, that sleep is divided into 2 types, a non-REM and REM. REM is a rapid eye movement, the rapid eyeball movement, and one is the non-rapid eye movement stage of the sleep. Now the step, if you see this graph from left to right, you can say in the wake stage, when you are awake, you are trying to sleep, you will be in the light sleep stage, then you go into deep sleep stage, again you come back into light sleep stage, again you will convert into a REM stage, that is the paradoxical sleep. And these whole stages, 1, 2, 3, 4, 5, REM, these all are usually from 7 to 110 minutes. It's a 7 to 110 minute cycle, more or less average you can say it's 80 to 90 minute cycle, so around a 1.5 hour cycle, and usually it gets repeated 3 to 5 times in a one night or in your sleep time. So you will have a cycle after cycle after cycle, and this is a sleep cycle, you can say. But where with dentists are involved more, that this you can see the stage 2 and the REM sleep, where the things which are happening and which are in our purview are more importantly happen around this stage 2. So let's move further into these three verticals I have shown, which I'm going to discuss. First, I'm going to discuss is the sleep breathing disorders. So breathing disorders, when it comes, it's a purview of the respiratory medicine or the chest physicians. Yes, we have to work in context with them, in coordination with them sometimes. So when it comes to classification of sleep disorders or breathing disorders, then this international classification of sleep disorders, that is ICD, that is in 2014, which has identified obstructive sleep apnea as a specific disease. So we need to know what exactly is obstructive sleep apnea. Before that, you need to understand what is sleep apnea. Sleep apnea is wherever your sleep is getting disturbed. In general, very vague explanation, I would say. It is divided into two parts. One is an obstructive sleep apnea, another is a central sleep apnea, and third, it may be a mixed variety. The obstructive sleep apnea or OSA, it is a repetitive, complete or partial collapse of upper airway. Upper airway means which is above the epiglottis in usual sense. So in that area, if there is a repetitive or partial collapse of the airway, so air is not going inside, some obstruction is there, then it is called obstructive sleep apnea. And in central sleep apnea, usually you can see the diagram on the right, where there is a problem with the efforts made by the brain to sleep. So that is a central sleep apnea. So what is more important for a dentist is an obstructive sleep apnea. So when we go into obstructive sleep apnea, you need to know what exactly happens. Consider this person is in a sleeping position and there's an airway there. There are multiple reasons of airway obstruction. It can be fat deposition, it can be tongue fall, it can be small bony case. You can see what happens when patient or when any person breathes, the airway sometimes gets blocked, maybe because of tonsils or any mechanical obstructions. But because of that, what happens when they sleep in a supine position, in that supine position they get the airway obstructed. Now when these people come to our clinic, how you diagnose that these are your patients? Sometimes if they know that you are expert in this field or you are doing some work in this field, they may ask for your opinion that I am having these things, can you please help me? Or sometimes when you are having your regular OPD and you are examining for other things, or you identify the person by just looking at it and you will do more inquiries, you will come into more having more information for that person. So the common things which people notice first is the snoring. And unfortunately, patient himself or herself, usually I have seen in my practice, they are least concerned about their snoring. Because in our society, particularly Indian society, snoring is considered as a sign of a deep sleep, which is absolutely wrong. Sometimes the bed partners complain about snoring. As we have learned, Dr. T has told us that snoring has been documented as the third most common reason for divorce in United States. Fortunately, in India, people are more tolerant. Husbands and wives are tolerating each other very well for years, and these things doesn't happen. But it affects a lot with their family life, social life, and their personal health. How I would say further. The snoring is one of the first sign you can look for. Other is the witnessed apneas, means the gasping which happens when they sleep if you have seen someone in your family who is snoring while sleeping, you can see they are gasping. They are just giving the short jerks after a few seconds. What are those jerks or the gaspings? They are actually the micro arousals, which happens and they break the sleep cycles. So somebody has witnessed it, right? Then comes excessive daytime sleepiness. People think that when I'm watching TV, when I'm sitting, people are sitting in their in your waiting rooms and they keep on dozing. Sometimes they feel dozing during driving, which becomes risky. So these are all signs of daytime sleepiness. There is a scale there, which is Epworth sleepiness scale, which we follow in our clinic, that measures how much intensity is there about the daytime sleepiness. Then comes many other nocturnal symptoms. There may be other things like limb movements, or they may be bruxism, they may be talking, there may be movements or other movement disorders which are concomitant with the snoring. Most common finding amongst majority of the obstructive sleep apnea patients would be the obesity. So they are more prone to develop obesity. And these obesity can be from beginning or it can be in women. It is a post or perimenopausal. When it becomes a central obesity, which is happening after menopause age, then they are more prone to develop obstructive sleep apnea. Body mass index, the short stature, thick neck people, wide neck people, when the neck diameter, you can see in the diagram in our patients, we always measure the circumference of the neck. So if it is more than 16 inches, then that's an important finding, right? Then craniofacial and oropharyngeal anatomy is what the X-rays sometimes suggest. You can move ahead with the investigations case to case. There may be associated comorbidities. Why they are important? Because obstructive sleep apnea is a life-threatening disease. Yes, it is a life-threatening disease because it can develop either heart diseases or cerebrovascular diseases or metabolic diseases. So you have to ask for any associated comorbidities, whether they are there, because sometimes they don't have any reason for developing those comorbidities, but it can be the OSA can be a biggest reason you can identify. Now, within your examinations, these things comes into picture, which is called a modified Mallampati classification, where you have to see how much is the posterior part of oropharynx is visible, the uvula, the posterior wall of pharynx, the fauces pillars, base of the tongue, how much is visible. That is the grade 1, 2, 3, 4, you have to note down. Now, for OSA to diagnose polysomnography, or commonly called a sleep study, right, which is the gold standard investigation. Usually it is done in the hospitals overnight and the technician do the manual tracking and making all these markings noted. The common things nowadays developing is the portable polysomnography machines where the technician comes to the patient's house and they put the machines at the night time, at the sleeping time, and on the morning they collect the uh, machine and they will evaluate later on. Within 1-2 days, they will give you the reports. So that way also you can go. And there are many things, many channels involved, sometimes 20 channels, 40 channels, different machines, different grades of hospitals, they have it. But this is an important investigation. What it actually gives is the apnea hypopnea index. Apnea is a complete cessation of airway. Hypopnea is a partial cessation of airway. That means the total events of apnea plus hypopnea per hour. That is called AHI index. How many times in an hour person has the airway obstructions? That is called AHI. That is the most important marker, and you can see on the bottom right, it is divided into three: mild, moderate, and severe. If AHI is 5 to 14, it is considered mild OSA. If it is 15 to 30, moderate. If it is more than 30, severe OSA. If it is less than 5, considered normal. And there are many other markings which are to be evaluated through polysomnography. When it comes to management of OSA, where we stand, right? So along with the respiratory physician, our role comes. But commonly, doctors or respiratory physicians prescribe one thing which is called a CPAP machine, which is a forced airway or oxygen pushing inside the lungs. But the reality is it's a big problem with the compliance. And the people who are using CPAP, you can ask them, they don't tolerate and the compliance rate is very low. So what is the next thing available is the oral appliances, where our role comes, where our scope comes. So what type of oral appliances we can give? If you Google oral appliances for OSA, this image will come. I have just taken a screenshot so that you will have idea that how confusing it is. It can be different, but you can design them according to your wish and your requirements. It's a method of retention, flexibility of material, adjustability, whether it is vertically open or not. There is a freedom of jaw movement there or not. Either you make it in-house or make it laboratory wise. So there are different ranges available. You have to go in depth to select the type of appliance. Ultimately, what it does, it is it should advance the mandible, it should open the airway. What the study says, that the adjustment mechanism that stabilize the lower jaw, firmly the upper jaw, and the elastic band should be there. And increased mouth opening will counteract the stability of the upper airway. So ultimately, the mouth opening increases, the vertical dimension increases, and the upper airway increases. So that's how this study is shown. There are a few photographs from my patients where I have given the mandibular advancement devices, right, where the jaw gets forwarded, and along with the jaw, the tongue and other musculatures gets advancements when patient sleeps in a supine position. And then what happens? The airway opens and there will be relief. I have few cases where I have done the polysomnography after giving these appliance also, and believe me, it is working good. You can rely on that, right? But what is the evidence? The evidence is suggested by American Academy of Sleep Medicine and American Academy of Dental Sleep Medicine guidelines. They have suggested that these appliances are good, moderate, mild, and severe. Where to apply, I will discuss more in detail, right? But there are evidence-based practice which is you can incorporate in your menu. There are a lot of literature you will find. The oral appliances are found more effective in moderate or severe OSA patients who cannot tolerate CPAP, because worldwide it is a problem that CPAP tolerance is a big issue. There are many other things that increase in parietoglossus activity may promote upper airway enlargement in posterior soft palate region. So ultimately, the oropharynx is the area where you need a space. The forward pulling of the tongue together with the mandible during mandibular advancements includes enlargement of the oropharynx. Ultimately, we want that thing. Reduction of oxyhemoglobin desaturation index during sleep with mandibular advancement device. So you will have endless literature available on PubMed. You will go. So many articles you will find when you go. But the inference is when it comes to mandibular advancement device. That mandibular advancement device is the first line of treatment in mild to moderate OSA. So in mild to moderate OSA, you can avoid CPAP. Another inference, patients should be given mandibular advancement devices for trial before attempting surgeries. So a lot of ENT surgeons are doing those triple P, U triple P surgeries and a lot of other surgeries are there. But patients should be given a non-surgical trial. MAD is better tolerated than CPAP, no doubt about it. And hybrid therapy is better in severe OSA rather than only CPAP. So in severe OSA cases where AHI is more than 30, only mandibular advancement device is not going to help. It should be incorporated with the CPAP. So CPAP is the first line of treatment for at least severe OSA. After the sleep breathing disorder, the second vertical is bruxism and movement disorders. Now, this part, bruxism, is something which I have seen the general dentist have maximum myths about this phenomenon. And thanks to our college educations where we have been fed with those informations, where we have accepted that this is the truth about bruxism. But when we went into detail, these are the two articles where I was involved, fortunately, with Dr. T, where we have done two review articles in this year only, and both were with sleep bruxism. So we have gone into a lot of depth of it. So what we have found, so I will give you the inference of all our research from these two review articles. The last one was in JADA, and before that was the Frontier of Oral Maxillofacial Medicine, right? Few things. Before that, I would give you this is the diagram. This is my original country work or my contribution to these our publication articles, where I have drawn this original article, and we found that it is connected from the brain, that the cortex is driving the sleep bruxism pattern, not anything else. So this is the diagram and all the chemical mediators and neurotransmitters which are involved in all the normal movements and sleep bruxism. This is another diagram from the JARA article where my contribution of this original work was there, where you can see if you can see my arrow, the red arrow is there. That's the proposed central pattern generator of sleep bruxism. That is in the brainstem area. There is a central pattern generator which can induce the sleep bruxism. That's what we have proposed, right? And more work is needed on this thing to prove that yes, it is there in the brainstem. But for a general practitioner, for a dentist, what is to be seen? These things to be understood. Number one, sleep bruxism is not a habit. Many times we say, आपको दांत घिसने की habit है. Sometimes we ask to the patient, it is not a habit. Second, it is a movement disorder. It's a type of movement disorder. Then daytime bruxism is different than sleep bruxism. So daytime bruxism can be a habit, but sleep bruxism is totally managed by the cerebral cortex. Then there is no significant correlation found with sleep bruxism, like malocclusion है इसलिए आपको sleep bruxism है, TMDs है तो sleep bruxism है. If you are in stress, you will brush your teeth. If you have worms in your stomach, you will have bruxism. No, there is no statistical significance found anywhere in the world in these many years. So sleep bruxism, ultimately, it is only and only derived, or it is managed by brainstem, or you can say the brain at least. Then when sleep bruxism is come clinical side, it can be static, where only the bracing happens. Only the mandible gets stuck with maxilla, no movement. That is a static sleep bruxism. Another, it can be static with dynamic, means mandible is moving around and there may be sound there. Somebody has noticed, somebody may not notice. There can be mixed pattern also. There is a strong genetic component involved. Means if father is bruxing or mother is bruxing, then the children bruxing chances are more. We have seen a lot of pediatric patients coming and the parents complaining that my child is bruxing the teeth, and we have given night guards to them also. Of course, you need to change periodically as their jaw growth happens. Why it is important to us? Because if we don't diagnose this thing, then it will damage the enamel, it will damage our restorations, fillings will come out, crowns will come out, implants will get mobile, crowns will be, there will be having a lot of screw loosening frequent. There are many other considerations. So sleep bruxism is involved where, what is our role? First is the diagnosis. It should not be missed at all, right? It has to be diagnosed because it is going to affect our restorations. We have to aware people that you have this thing. You may not be knowing, but you have this thing and you should prevent further damage. Right now, there is no remedy involved. How to stop sleep bruxism? We can only do things like preventing the further damage of enamel and our restorations by giving a night guard. That's our role in sleep bruxism. But by identifying this condition, you can save a lot of investment what patient has put in the dental treatment and the enamel itself. Right. Moving further, as the time is pressing, moving further is the sleep and orofacial pain. The third vertical, where the dentists are involved more. Every third patient comes is a pain somewhere where you will feel that there may be some second or third diagnosis possible. And many times, every fifth or sixth patients, you will see that it is a myofascial pain or somewhere patient complains around the TMJs. And nowadays, these type of patients are increasing a lot in a high-fi society, or you can say fast-moving world, stress-giving world. These pain patients are coming a lot, right? So why it is important to us, and where sleep is involved, right? You need to understand that pain and sleep are interconnected. That means if pain is there, there will be sleep decreased. If decreased sleep is there, pain will increase. If pain and decreased sleep are there, then there will be increased pain and decreased sleep. And decreased sleep and pain will run together. So whenever patient comes with pain, then you have to ask about the sleep history, whether they sleep well, whether there is any fragmentation in the sleep, whether they are night workers. If they are night workers or the night duty people are there, then their sleep is definitely disturbed, because there is always a daytime sleep cannot be managed, that sound sleep with the whole world moving around. So if that sleep is not good, if they wake up tired, if they have a lot of time latency in sleep, starting the sleep, then definitely the pain is not going to go. So you have to tell them that we want to reduce the pain, but concomitantly sleep has to be improved, or the sleep hygiene at least has to be improved. So we need to go that way. So whenever you have a sleep and myofascial pain comes, it may be TMD pain, or it may be only involving not joint but the muscles, or anywhere pain, whether it's a dental pain, anything, right? But particularly when you have to ask the sleep history. Once you ask the sleep history, they may be surprised why you are asking, but it is your role to tell them that there is a strong correlation. You have to educate them. These way it is correlated, and they will understand. Yes, I have not slept well for last 3 days, and now my pain has started. My neck is aching a lot. The back of the neck is aching a lot since 3 days. Then they will understand that yeah, this doctor is good, and you can help them better. Then there is a role of medications. NSAIDs comes. The pens you can see. The last presenter has presented beautifully. There are a lot of physical other therapies. There is exercise involved. There's a lot of potential in cognitive behavior therapy. What is cognitive behavior therapy? I'm not going to speak a word because I'm waiting eagerly for next two speakers, which are very good friend of mine and they're masters. Don't forget to attend those two presentations, and following after that, Dr. Sonia also. So our role is in these things to identify, educate, and explain them how we can do. So to conclude, the scope of sleep medicine in dentistry, it's huge. Why it is huge? Because you can start new procedures. I've just given you some insights, but it is going to, if you are having some knowledge about sleep medicine, it is going to help in your own general dentistry a lot. It will help you in managing the pain of your patients a lot, and it is going to help you in saving your own restorations from breakage and loosening and failures. So with that, I'm ending my presentation. This is my QR code of Insta. If someone wants to connect with me, you can connect with me to Insta. This is my team, and with their family members, we do annual functions every year where all our centers are doing dance performances, and there is a competition going on among the centers, and all their family members comes to watch. Usually we do it during Navratri days. So whenever you have the chance to visit Ahmedabad, then during Navratri in particular, then do visit us and be our guest during our annual functions. Thank you very much.
Thank you, Dr. Jamin, and lovely presentation. And I'm sure everybody has taken home what they are supposed to be diagnosing as a clinician first, the first line of treatment, or forget about the treatment plan. At least they can start diagnosing and understanding the whole scope of dentistry in sleep medicine. Thank you so much, doctor, and pleasure to have you here. And there are questions for you in chat box. Please do answer them. With that, I would like to call in our next speaker, another friend of mine, Dr. Karthik, on stage. Dr. Karthik and Dr. Shashi Raman.
Hi, Sonal.
Hello.
Hi, Jamin. As usual, you perform like the Australians in Adelaide. Sorry, in Perth.
Okay.
To see you both together.
I said when I was saying that the audience are here in for treat. So today we have a husband-wife duo who are going to be presenting together. It is very uncommon, mind you, when we say that a couple, husband-wife duo married for more than 20 years are presenting in one session, and that too in concurrence. So imagine how much of effort that must have been on our part also to get them together. And they are going to be talking about some topic which is going to change your practice and change you as a person also. So Dr. Karthik Raman is bachelor and masters from Government Dental College and Hospital Aurangabad, and he's actually he's an endodontist basically, and also a fellowship friend of mine from fellowship group from Roseman University under Dr. Davis Thomas's guidance. And he is associate fellow of World Clinical Laser Institute in USA, PG diplomate in CBT, that is his topic for the day, diploma in modern applied psychology, writer, and he has written a chapter in dental clinics of North America on psychological aspect determining the prognosis of dental treatment. PG diploma in aesthetic dentistry from Britain Academy of Restorative Dentistry, UK, and key opinion leader speaker for culture and Germany, and fitness enthusiast. As you all can see, looking at them, they are definitely fitness enthusiast. And his area of interest is definitely TMD, CBT, endodontics, laser, and being a good person and a friend in need. Okay, and Dr.
Thank you so
Shashi
much.
Raman, his better half, who is going to be this is going to be a combined session. So Dr. Shashi Raman, she's completed her BDS from Government Dental College and Hospital, Sambhajinagar, Aurangabad. She's into private practice at Raman Dental Clinic, Aurangabad, since past 20 years. Stalwart of smile designing and aesthetic dentistry and direct composite resins. She's has keen interest in regression therapy, family constellation, and hypnotherapy. Student of esteemed regression therapist Dr. Hans Tanden. Pardon me if I'm wrong in the pronouncing it. Of the Tasso Institute, Netherlands. And along with that, she is a diligent wife to Dr. Karthik Raman, and I've seen them grow together. Welcome. The stage is all yours, Dr. Karthik and Dr. Sashi. You are going to be talking about CBT and regression therapy in orofacial pain. That is the need of hour. Forget about orofacial pains, cognitive behavioral therapy. I myself, I practice that. It is a need of hour for us as individuals. Any working individual, be it kids also, they need to know certain amount of cognitive behavioral therapy. That is a need of hour because of the stressful situation around us. And when stress and pain come in concomitant, and that combination is worst for our patients. So here, let's debunk cognitive behavioral therapy and their uses. Dr. Karthik, can you share your screen, sir?
Yeah, immediately.
Thank you for the introduction, Sonal.
Yeah, you're always welcome, dear. Yeah, your screen is visible. Go ahead, doctor.
Yeah, so first of all, my acknowledgements and appreciation to Sonal and the entire team. Can you hear me clearly, Sonal?
Absolutely, crystal clear.
Yeah. So my appreciation and acknowledgement to you for conducting these sessions so beautifully and for this amazing conference. And you thought us worthy, both Shashi and me, to lecture along with stalwarts. And the brightest student of our batch was lecturing prior to us, Dr. Jaimin. Yeah, it's such a privilege to be lecturing after him, because he has a habit of always creating a background for the other speaker to come up and create something. So he spoke about cognitive behavioral therapy, and Dr. Saurav also spoke about cognitive behavioral therapy by talking about the biopsychosocial model. So I'm not going to talk a lot about that because I'm not an expert with that. I'm an expert with CBT, not expert, but an evolving student with CBT. And I first of all express both our heartfelt gratitude to our teacher, mentor, friend, philosopher, guide, Dr. Davis Thomas. It was such a privilege to write an article, a chapter with him on, in his edited journal in the dental clinics of North America. And, it's a privilege to do that fellowship. And I urge each and every one of you who are budding dentists to go into this fellowship. It will change you as a human being. It converted me from a dentist who was only, focused on root canal on root canals and endodontics and restorative dentistry, into being an oral physician and changing my approach. And one of the greatest things that happened to me is it helped me to study and look at that. If these are so many number of zeros in front of that one, these are the number of patients in the US suffering from severe orofacial pain. And this word suffering is not connoted by me, or I have written this. So this is from a referenced PubMed journal. And these are the patients in the US, and you can't imagine the amount of orofacial pain or chronic pain patients have to bear with throughout the world. And if you see the way things have evolved, despite our understanding and our evolution in the field of treating orofacial pain, be it innovative pharmaceutical agents, or for that matter implantable drug delivery devices, or for that matter occlusal therapy, splints therapy, anesthesia. We have seen surgery and so many methodologies of treating in these past 2.5 days, plethora of them. But the thing to ask and inquire is what is the amount of gratification, or for that matter, are these patients able to achieve 100% cure? No. And that gave me an opportunity to study orofacial pain and study CBT along with it, because chronic pain by itself is a disorder. It's long-standing and it has a tremendous emotional, physical, and psychological toll on the patient. Not only the patients, but the environment in which the patient, is studying or working, or for that matter, living in. So like I have written, medications give 30 to 40% relief. Spinal cord stimulators give approximately 65% relief. But still, the relief is incomplete, because at an emotional or physical level, still the pain hasn't gone complete. There is a residual pain that remains. And it creates a burden, an emotional or functioning, a burden, a functioning burden, emotional burden on the patient. And there is a need, or I saw a need, where there's a need for a radical and a collaborative approach. Cognitive behavioral therapy, I feel, is an alternative modality of therapy which encompasses not only psychological counseling, or for that matter, motivating the patient falsely, but it involves changing the thought and the thought, not only the thought process, but what comes out of your mouth as a human being. So we've been talking about, that our word creates the world. This we have been learning since a childhood. My grandmom used to say in Hindi, in Hindi language, संभाल के बोलो, ध्यान से बोलो, जो तुम बोलोगे वो सत्य हो जाएगा, सच हो जाएगा. So your word creates the world around you. And the cognitive behavioral therapy somehow gave me the access to neuro-linguistic programming, to study human behavior, wherein when I studied modern applied psychology, I got to understand, why does this particular patient have orofacial pain? Why aren't my other patients having similar or worse circumstances going through the same? Because the development is different, because the environment is different, because what the patient speaks, thinks, acts is very different. What is cognition? Let's look at basic terminology. Mental action of acquiring knowledge and understanding. But this, in cognition, it happens through experience and the 5 senses. Cognitive behavioral therapy is a type of psychotherapy in which negative patterns of thought about myself, my environment, people I live in, are challenged by the CBT specialist in order to alter unwanted behavior patterns. Because we have observed that whenever there is an episode of orofacial pain, there are behavior patterns associated with this. It's like a vicious cycle. I'll speak on it as I go ahead. So the CBT approach integrates psychosocial aspects, behavioral factors, along with physical or somatic ones. It emphasizes prior learning history. That is, your childhood is a very important part of treating the patient. What the patient went through in his or her childhood, the mood swings, the beliefs, the appraisals. What is the context behind, or the contextual factors which create this pain, or the experience of pain for these patients? It's a very accepted psychological conceptualization of pain according to Guzman. And also CBT is extraordinary because it is applicable throughout all age groups. Effective also, like in Turner study, or for that matter, Wilder study, or Thron, or for that matter, Berandi, fibromyalgia, headaches, neuropathic pain, TMD. It has been shown to be effective as a conjunct therapy in almost all the cases of orofacial pain that we come across. Let's look at a classification of CBT. So there's a first wave CBT, which was based on the behavior therapy as taught to us by the legend himself, Sigmund Freud. Then there is a second wave CBT, which involves the original cognitive therapy, or by Aaron Beck, the REBT and the CBT. The third wave CBT, notice that the first and second wave of CBT had its own restrictions. The third wave of CBT has evolved just a few years ago, where it has become more, accepting of so many other alternative modalities of healing, including meditation, or including mindfulness-based cognitive therapy, or for that matter, behavioral activation. And like we spoke about TENS, or for that matter, we spoke about physiotherapy, exercise induced analgesia. So many of these things have come together to create third wave CBT. Look at a small introduction on CBT. It's not a replacement to conventional therapy. It helps patients to live a more effective and satisfying life despite having all the problems associated with orofacial pain. It reduces the dependence on medication. And I think that's the best part of CBT, where Dr. Thomas always tells me that we are treating orofacial pain, TMD, and other chronic pains being very pill happy. And slowly cognitive behavioral therapy is helping us give up that old habit or old paradigm of ours of treating patient. And it helps the patient to return to their employment or daily activities pretty quickly, and also helps to reduce the suffering of the patient. So what is the basis and foundation of the cognitive behavioral therapy? So it's a cycle. So what we feel affects how we think and how we act. Our thoughts and behaviors are affected by our emotions. Same way, what we think affects how we feel and act. And the third, what we do affects how we think and feel. So it's a vicious cycle. So your emotions create thoughts, thoughts create behaviors. So same as how the behavior again starts creating the same emotional and the thought cycle. This is the basis and the foundation of the CBT. What is the philosophy? The philosophy of cognitive behavioral therapy is based on three main principles: the cognitive triad, or the automatic negative thought. I will talk about it in detail in the coming slide. Negative self schemas, that is, we have observed in our humble experience of 7 to 8 years, Shashi and I, that most of these patients whom we are treating for chronic orofacial pain have some or the other episodes of abuse, or death, or bullying, or for that matter some physical, mental, or social abuse in some or the other forms in their childhood. And so it is acting as a predisposing factor. Third thing is cognitive distortions or errors in logic, sort of abstractions or overgeneralizations or catastrophizing things, always thinking in the negative. We have observed people in our life whom we feel we should be, we should stay away from because they are very negative people. They are not to be blamed. There are some people who they seem very arrogant or very, abusive in their language. It's not their fault. Hurt people. This is what I had just heard. But when I studied them, I could have empathy while treating my patients. Let's look at this cognitive triad. What does this cognitive triad basically say? It's the fundamental concept in cognitive behavioral therapy as proposed by Aaron Beck. What he said that we have three negative thought patterns. We are negative about ourselves, we are negative about the world out there, and we are negative and resigned about the future. Iska kuch nahi ho sakta. Mera kuch nahi ho sakta. Please pardon me, on a international platform, I'm using Hindi words because this is what comes out of the patient's mouth when they speak to me. It's not going to go away. This is going to remain as it is. People around me are never going to change. Addressing and challenging these distorted cognitions or thought patterns is a central focus of cognitive behavioral therapy. Mind you, these patients have to be given time to listen to all these, because there is, black and white thinking. So these patients don't have a gray area. They're not very adjusting. There's always overgeneralization or self-criticism, criticism to the other, about the other person, lot of despair, giving up very quickly. These are all patterns which we have to understand. Once we study CBT more, we will be able to understand them better. Look at this beautiful slide. It shows us the impact of childhood trauma. We have observed in our humble practice that all these patients who come to us for chronic orofacial pain treatment have gone through some or the other issues in their childhood, and what they are manifesting is just the tip of the iceberg. Dr. Shashi, my wife, is going to talk about something very deeper and very more spiritual, or maybe more, psychological in nature, which everybody, one of us, can connect in some way or the other. I have observed in my humble practice that patients who have severe orofacial pain have difficulty in problem solving. They have delays in their language, delays in controlling, the difficulty in controlling their emotions, generally land up with emotional or relationship problems, difficulty in forming relationship with peers, lot of self-criticism, perfectionist, very easily depressed, very easily anxious, very low self-esteem, and sometimes bordering on suicidal tendency also. Some of them are extremely brilliant, others are have very poor academic achievement, and have issues with even concentrating when I'm on a phone call or a Zoom call with them. This is all that I have been observing, and that is an impact of some or the other childhood trauma. Dr. Shashi will speak a little more about that. So how does it show up in their life? So we have observed that these patients are very harsh on themselves. They have people pleasing tendency. They always want to be very nice to people, and when people are not nice to them, then they say, oh yeah, I know people are like this, people will never change, they are bad. There are a lot of skewed thinking patterns about life in general and people in general. They have difficulty trusting others, very critical about self and others, and they believe that actually they are broken inside, lacking some sense of identity of self. And these patterns keep showing up in their lives, not only with regards to their academics, but with regards to their relationship, with regards to their health. They are consistent for some time, then they just break away. They are unable to come back to just harmonizing or bringing their life in equilibrium. So the third part which I spoke about, I'll just go back to my previous slide so that you get a gist of, or you can just connect. So we talked about the cognitive triad, or the automatic negative thoughts. We talked about the negative self schemas, that is some childhood trauma to the children, to these patients in their childhood. The third is the cognitive distortions, or the errors in logic, which Dr. Ellis has very easily written in the form of 13 self-defeating laws. If you wish, you can take a screenshot also. That's really not a problem, or a photograph. There is a lot, if you read or go through these articles, go through these sentences, you will see a lot of must word inside. I must do well. I must get the approval of others. When things are tough, I am under pressure, I must be sad. My past is the most important part of my life. Everybody and everything should be better than they are. So my life is not worth living. I must be a high achiever. Nobody should ever behave rudely with me. Other people must treat me kindly. Or they should treat me the way I want them to treat me. I deserve to be happy by doing as little as possible and just by enjoying myself. Some or the other of these self-defeating laws is the undercurrent in all these patients' lives. This is what we have observed. Now, coming to how to implement, or how do I implement this in my clinical practice. So once I see the patient of orofacial pain, first of all, as suggested by my mentor, Dr. Thomas, in the way all the students of, the fellowship or the mastership approach their patients, we first do a thorough workup with them. And once we see that, oh, these medicines are not working, or alternative modalities like physiotherapy, TENS is not working, then we shift over to cognitive behavior therapy. And the first part of the cognitive behavioral therapy is the initial assessment. And I will come in detail about that. Then comes the phase of reconceptualization. So changing the perspective, changing the thought process, changing the cognition, changing the way they interpret situation. Third is acquisition of skills. So over a period of few months, these cycles, or these one-to-one talks with them, habit breaking or habit changing phase is called acquisition of skills. Then comes the generalization word, where the phase where all these three prior phases are brought together, and we keep on reinforcing them. And then last comes the booster sessions, or the follow-up sessions. So what do we do? So the step-by-step implementation. So know the patient and their environment. So when we do the initial assessment, it is very critical for us to know what we are dealing with, whom we are dealing with, what is their expectation, what is their level of stress. Also, it is critical that we, put up what would be the goals of the therapy, what do they expect, and what is possible from us. What are their expectations, perceptions? There's a need for us to get information about their workplace, people that they love, people that they don't like, what are their maladaptive behaviors, And this helps us to start the second phase of the therapy called the reconceptualization. But before that, what is important is how do we come to that? We come to that by speaking to them, having few sessions. It takes around 3 to 4 sessions to understand what are they actually stressed about and how do they compensate for it, for that stress. So you can see in this slide. And we also discuss with them pitfalls in the workplace. So in conjunction with whatever we saw in the cognitive triad, as well as in the at least 13 self-defeating principles. So patients generally land either with the ambition trap that they have to do well and they have to excel and they have to be up there at the top of the pyramid. Then there's a should trap, where they hide their personal life. They don't want to talk about what is going on with them or families. And these generally amazing achievers are excelling in their professional work, but they are not doing great with regards to their relationships or their health. We need to know what is going on. Then the overwork trap. How do you compensate? So if you are one area of your life, for example, your relationship with your spouse or your partner isn't working, you compensate by overworking. But more work reduces the efficiency as well as the emotional quotient. And the imposing or impressing the boss trap. So there are many aspects which I can't go into the detail right now, but we are just having an overview how we work with the patient. Reconceptualization. So patient generally has a tendency to overgeneralize things. Just a second, let's go to the timeline 4-9. Okay. So what does this chronic orofacial pain patient do? Patient generally tends to catastrophize things. It's never going to work out. I'm always going to have this problem. This problem is never going to be solved. And even before the doctor speaks, they have already jumped to a conclusion. I have seen them doing a lot of mind reading what I am going to speak, or for that matter, they have a habit of mind reading the person they are interacting with. And very commonly this happens with people that they love and people that they are interacting with the environment. So they have negative predictions about people, selective attention span, and most critical is catastrophizing. Why does this happen? Now the funda is here. Human beings generally tend to create an interpretation or story about actually what has happened. If I ask any of you, for example, tomorrow morning when you open your door and once you open that door, a police inspector is standing in front of you. If I ask you what thoughts are going to come up in your head, definitely they will be negative thoughts. So out of all the 10,000 thoughts that I have every day, 8,000 of them are going to be negative. Why? Is it my personal problem? No, it's a part of my design. It's called automatic negative thoughts. And these automatic negative thoughts, I don't say help me, but they are instrumental in me creating an interpretation or story about actually what has happened. So the first thing that comes to my mind if I'm going to see a police inspector tomorrow outside my door is, my God, what have I done? Whereas the same police inspector or some other police inspector is seen by a person in whose family there are IAS officers and IPS officers and full of policemen, they will have a different interpretation. So your environment, your belief, your concepts, your thoughts, and the environment in which you have grown up. So these also create or have an influence on your interpretation of situation. This is why these create a very terrific impact on how the patient is going to interpret orofacial pain also, or how the patient is going to deal with them. Third phase of the CBT is acquisition of skills. So here we teach them, some part of neuro-linguistic programming, wherein we ask them how do they construct or construe, when they go through the phase of pain, and then how we can help them, create new words or words which are less, demeaning or less, with less force to describe a situation. Oh, it was excruciating versus, yeah, the pain was intense and it stopped after some time. So something like this. So we train them to do this. Then we train them to do attention diversion by going up for exercises, or for that matter, meditation, box breathing or abdominal breathing or pranayama, yoga, physiotherapy. So this is a phase where we are consolidating the other and taking support of the other branches of medicine also for dealing with the orofacial pain episodes. So we also teach them to react to respond to a situation versus reaction. So reaction is like an immediate and emotional reply. Response is a evaluated, reply, and it's a slowed down reply. Response helps you to maintain self-control, whereas reaction doesn't. So this is through a principle called pause, breathe, and respond, which also is is also taught in many universities as the pause phenomenon also. So pay attention to your body, thoughts, moods, feelings, assess what is activating or, angering me or, making me react, understand the root of your feelings, set boundaries, separate from those people, don't interact with them, and empathize with, yourself and the people who are supporting you. So this is the pause therapy. Then there is something called a behavioral activation, where we ask them to engage in very constructive activities like running and other forms of exercise. And like the previous to Dr. Jaimin, Dr. Anu was talking about TENS and the way endorphins are released. So exercise-induced analgesia is a very important part of behavioral activation, where we use third wave CBT to bring down the patient's pain by engaging them in creative activities. It also involves use and support of mindfulness-based cognitive therapy, also very similar to the Vipassana type of meditation that is taught to us in India for past thousands of years. The fourth phase is consolidation of skills, where when we start, periodically assessing, how patients are doing, what has been the impact of all these sessions on the patient, making them aware of, elevating or exacerbating factors, looking at, reinforcing or enhancing self-efficiency, how to deal with that particular situation, and interviewing their environment, people in their environment. It may be a partner, a family member, or their people in the workplace whom they are very close to. So role play, and even we giving them or checking their pain diary, or giving them homework, and looking at how far we have come and how far we need to go with regards to therapy. This is the consolidation phase. Maintenance and relapse prevention. Here we anticipate high risk situations and how to deal with setbacks and lapses, and these involve sessions with the psychologists also many a times, wherein we help them encourage self reinforcement and adherence to certain home practices which we have recommended to these patients. Booster sessions and follow-ups are an integral part, wherein we keep meeting these patients every month and keep discussing what worked and what did not work in this particular month. So this is a monthly follow-up session. In spite of doing all this, and in spite of instilling, changing behavior, thought patterns, or changes in their routine, introducing exercise, or for that matter, recreational activities, there are limitations to cognitive behavioral therapy. That is, most studies are required as far as chronic pain is concerned, and we are still with regards to mental disorders. CBT has shown some fabulous result, but more studies. I'm writing an article, a review article, and working on it with Dr. Thomas and Dr. Maithili on CBT, and I realized that so much more work needs to be done with regards to orofacial pain patients, and how they are responding to CBT, rather than just jumping into and starting CBT for a patient. So one of the things that I always recommend to all the newcomers and doctors who are dealing with chronic orofacial pain is, please read and study the cognitive behavioral therapy, study pain psychology overall, and be open to collaborating and being open to these alternative modalities of therapy also. So in some patients of ours, where I see even the CBT not working, where that is wherein Dr. Shashi steps in and supports us with creating and supporting the patients with regression therapy. So I'm just going to hand over the podium to Dr. Shashi, and she'll take it from here.
Yeah, welcome, Dr. Shashi.
Thank you, Sonal. Can you hear me? My
Yes.
voice is
Yeah.
a
Your
little
voice,
lower than Karthik.
No, it's all cleared. Go ahead.
All right. So I'm really thankful, Sonal, that you're bringing me in. And not many people know about regression therapy or, this alternative modality, though it is more than 100 years old. And apart from being a dentist, I'm interested in healing, alternative methods of healing. So I'm a trained regression therapist. I am a hypnotherapist. And when I say hypnotherapy, I see a certain strain on almost everybody's face who don't know this. And they think that it is hypnosis. So I want to first start with that hypnosis and hypnotherapy are quite different. Regression therapy that I practice is a type of psychotherapy. I don't practice hypnosis. I practice hypnotherapy or regression therapy. What is it? It's a type of psychotherapy that guides people to remember past events and traumas that Karthik spoke about. What is an inner child? An inner child can be a small child. An inner child can also be a personality which is last year. So if I'm 40 years old, a 39-year-old Shashi who underwent a trauma, maybe an accident, maybe a loss of a parent, can be an inner child. And so this is the person, Milton Erickson, who started with these alternative healing modalities. So what is it based on? As you can see in the slide, this is the conscious mind. And even Einstein spoke about it, that the conscious mind is, we are using hardly 5% of our mind. Most of our mind is our subconscious mind. It's like a computer. So not all programs are open on your computer screen at all time. It's one program which you're working on, or maybe two programs, but the rest of the programs are in the background. So the subconscious mind is in the background. The mind is absorbing so much in day to day, and all of it is suppressed or repressed or stored in the background. And we need only 5% of our mind to work for our daily day-to-day activities, like, maybe working in our practice, dealing with our children, or remembering something, or going through our exercise. But the subconscious mind stores so much, and we don't have major opportunities for that to come out. But the subconscious mind is like the mastermind who's driving your emotions, who's driving your actions that you take in daily life to deal with everything, or what comes out of your mind, like Karthik said. So we have emotions. We are not robots. Our mind is not a purely mechanical one. As human beings, we also have a lot of emotions attached. And this is a slide which shows that pain is a way in which the body stores emotions. And there are, of course, it's a detailed science. Each part of the body represents something, like the head or the orofacial region represents your control. It is the mastermind. So a lot of these orofacial pain patients will have some kind of control issues. Either they are controlling themselves physically, mentally, emotionally, something about control. There are other areas, and there's a lot about this on internet. How do we approach when a case comes to us? Is we say, yes, the patient is dealing with real pain. So we acknowledge and accept the presence. This is very critical because many of these patients come with when the doctor has told them that it's all mental. No, it's not mental. It is started exhibiting at a physical level, whether it is orofacial pain, TMJ pain, whether it is neck pain, migraine, body pain, anything. So acknowledging deeply that it is present, the patient is right, and experiencing that, and not negating, like 5% of that may be mental, but when the patient is talking to you and understanding what you're talking, then most of the time it is not mental. So acknowledging and accepting its presence. A therapist who's practicing hypnotherapy, regression therapy needs to be somebody whom people can rely on, can trust with very intimate information, can so a kind of behavior, a kind of speaking skill, a kind of training where the patient can experience your compassion, experience your care, and can trust you and come out with information, wherein you train them to gain a deeper understanding of what happened and where the pain started, how it started, what was the environment in which it started. So I said, I spoke about hypnosis and I spoke about hypnotherapy. What is the difference basically? So I would like to take the example of the slide that Dr. Jamin had shared on sleep, like the stages of sleep. So while we are awake, it's the beta waves in which the mind is. We, through our training and practice, we try to take the patient in alpha wave state, which is not deep sleep. So when a person goes to deep sleep, this is hypnosis. And there are, like, we have quack dentists. We also have people who can take you into hypnosis and take benefit, or, all those things that the papers are full of. But we are trained regression therapists where we only reach the alpha wave state, and it is purely for therapy purpose. In this state of sleep, where the patient is sitting with the closed eyes, we slowly take the patient to the originating incident. So for example, it's pain. What is the patient experiencing emotionally? What is the patient experiencing physically? And go to the moment when this pain started and explore that environment. How is the environment? Is it daytime? Is it nighttime? Who all are there? What are they saying? How is the pain starting? And systematically, then we sort of start elaborating on that situation, and slowly all the beliefs that the patient has started forming there, systematically deal with that. How is it different from cognitive behavioral therapy? Cognitive behavioral therapy is dealing with the conscious mind. Hypnotherapy or regression therapy is dealing with the subconscious mind, the 80-90% of the mind, the additional information that the brain has stored, which the patient may not know or hasn't even registered consciously, can come out from the subconscious. I would like to give examples of 3 cases where I've been benefited immensely in my dental practice. The first is a case of a lady who would not allow me to touch her teeth. The moment I start the drill, she would hold my hand rigidly and not allow my handpiece to be carried to her mouth. So, and she needed to do a class 2 cavity restoration on her 4-6, lower right 6, and she would not allow that. Twice, thrice, I tried doing that, and she was in severe pain. So slowly I introduced myself that I also know regression therapy, hypnotherapy. Would you want to try this? She was ready. So in the session, close your eyes, just relax, systematic relaxation, and giving positive affirmations that this process is to support you, to help you. The noise of the handpiece will be felt at a much lower level, and you are in control. You can stop the process whenever you want to. 45 minutes of doing the class 2 cavity restoration. She was not holding my hand. I was able to do her restoration. And later on, 6 months later, she had a few implants to be done. She had a few root canals to be done. The patient has completed all treatment and is happy. During further sessions, we found out that a few years back, 2 to 3 years back, she had a tragic loss of a very young teenage son. And that was the initial moment when all her hypersensitivity to pain and noise started. The second case is a very close friend, needs to do a root canal on 4-5, but is extremely scared, doesn't want to sit in the dental chair. So we tried a regression therapy for her. I was non-believer before that of past lives. I'm a past life therapist, but what came out was a life where she died in a tragic truck accident and there was a lot of blood splatter. So she's scared of blood. So we healed that life and she did her root canal. She comes every 6 months for a regular dental cleaning, all her restorations, everything. She sends her son. The third is a case of migraine and headache, severe headache, which occurs around weekends. We go through regression therapy and hypnotherapy and find out how did it start. So she is 2 years old or 3 years old, and every weekend her father washes her hair and dries her hair. So when father washes her hair, there is too much of heavy scrubbing. He applies the shampoo with a lot of scrubbing and force. And when he wipes her hair with the towel, he is forcing her head here and there. And it's as if she's losing consciousness from the head. And that memory has stayed in the head and now occurs or recurs around the weekends as headaches. And immediately post this, her headaches disappear. So this is quite a short time to speak about everything about regression therapy or past life therapy or hypnotherapy in this session. But I've given my number. Any of you who's interested in finding out more about it can speak to me. And I encourage you to incorporate associating with past life therapists, regression therapists to support these kind of patients where medicine is not helping or other modalities are not helping and still a part of the pain is remnant. This support is available. So I invite you to be open to this modality as well. And immensely thank you for this platform, Sunil. And to Davis Thomas, sir, I can see you on screen, sir.
Thank you, Dr. Shashi and Dr. Karthik. And as usual, you all have taken us to a very different land altogether. And this kind of therapy is a need of our, and not only about, it's not only about orofacial pain practice. That's what I was telling you. It's about, this therapy can be utilized for well-being for each and every person also in your family. So, and we have Dr. Davis Thomas also with us. Dr. T, can you come, can you just say a few words? I know you have attended only last section of
Yeah. Good
Yeah.
afternoon, all. Well,
Hello, sir. How are
Karthik,
you,
hello,
sir?
and Shashi, hello. They
Hi,
had,
sir. Good afternoon.
hi, good. How are you doing? So I listened to the last, I think, like part of Karthik's and Shashi's. They were on our program, on the 100-hour program, and they were doing one on-site with one of my students, and it was fantastic. I would strongly recommend. I think you guys are in Gujarat, right? Aren't you? Where are you located? Your practice?
Aurangabad.
Karthik, where's your practice? Aurangabad. Okay.
Aurangabad, yes.
So it would be a trip. Yes. So I will have you again. June we'll have the 100 hours. I want you to talk when the pioneers of the field are attending. So they will be there, and we will have the flyer and everything. I'll confirm you by probably March. I'm on a cruise ship right now, so
Yes, sir. We are aware.
that's
Yes.
why my voice might go down a little bit. It's about to go to port, I think, in the next couple of hours. So fantastic presentation from both of you. I really admire your work.
Yeah.
And of course, you'll be part of our courses too. And this program has taken it to another level. Oh, Jamin also. You know, two-thirds
Sonia
of
is going
this
to be
faculty is
presenting
my
next.
students.
Dr. Sonia
Unbelievable.
is going
Okay,
to present next.
Next is Sonia, sir.
super.
Next is
So,
Sonia. Okay.
all right. So I'm going to now
Ni-
say and good morning, good afternoon to everybody. Thank you.
Dr.
Great
Sonia, are you
presentation.
there? Yeah, Dr. Sonia is there, sir.
Tony is a little follower of mine. She's so good. She, puts courtesies for me every time on Facebook. And right now we're going to travel back to Florida. It's been 7 days on this ship, 7 nights. So I was telling him the first day, If I can do it, you can do it too. I'm going to bring one of these people to Mumbai because there's a big Mumbai and Singapore and stuff like that. Let's see if that will happen. All right, I'll mute. So Sonia,
Thank
I
you,
think Sonal will introduce you. Thank you.
Yes, let's welcome our next speaker, Dr. Sonia Bhatt. She's BDS, MDS in prosthodontics, fellow in orofacial pain and sleep medicine from the same and she's a Dr. T student, Roseman University, Smiles, USA, and a certificate course by Jeffrey Okeson on treatment of TMJ disorders and muscle pain. Certified cognitive behavioral therapist, practitioner across practitioner course from UK, and multiple national and international awards. And currently, she's practicing privately in just a second. Okay, she has a private practice in UAE, and she's invited as speaker and mentor in various Indian and international forums. And welcome, Dr. Sonia. I'm sure you have been waiting for a long time. I know that, and she is the person who runs on the clock. Or every time it's Sonia is like, give me 10 minutes, give me 10 minutes. It's always the same with her. So welcome, Dr. Sonia. And can you start sharing your screen, dear?
Yeah, sure,
She's
sure.
going to be
Sure.
talking about
I'll be
non-chronic pain and case integrated. So that's a very interesting topic. Yeah, you can share your screen, doctor.
talking about non-odontogenic. Yeah.
Yeah. So
Okay.
start sharing your screen, dear.
So I'll share my screen.
Yes.
Yeah, just a minute. Yeah. Can you guys see it?
Yes. Please go ahead.
Yes. 1 second. Presenters mode. Just 1 minute. Just 1 minute. I'll go into the presenters mode. All right. Yeah, I think now am I audible and am I clear?
Yes, yes, yes. Please go ahead.
Yeah, okay. First of all, I think thank you to Sonal and her team is due. Having 3 consecutive days of so many topics dedicated to orofacial pain, running such a show is not easy. That's for sure. And so many speakers are there, and there were paper presentation on day 1, and that's fantastic. So I know so many of the speakers. Dr. T, my teacher, is here. I couldn't have asked for more today. I'm glad I'm on the last day, and it's almost the rare end of the program, because I think my presentation somewhere would sum up the key idea behind this IOPCON, that each one of us, whether we are specialists or not, we need to start looking at our cases in a different light. Now, for those of you who don't know me, I practice in Al Ain, Abu Dhabi. This is the place where every single day go for my morning walk. I'm a big proponent of natural sunlight and vitamin D. What orofacial pain study does to you is it changes you as a person, not just as a clinician. It changes you as a person. And I practice, luckily, in a multi-specialty clinic. So that's my orthodontist and maxillofacial surgeon there. I practice prosthodontics and, of course, orofacial pain. And it's good because I practice only what I'm good at. And I always call in for a second opinion my other fellow practitioners. Across the platforms that I've spoken to, whether it's in India or whether it's here, to dentists, to students, postgraduates, practitioners, everyone, the focus has been always one thing, that we all need to have a baseline idea about orofacial pain. We may not want to practice full-time orofacial pain, but we must have an idea. And why is that? Because over a period of time, we all develop a tunnel vision. And what's that tunnel vision? We see the tooth, the whole tooth, and nothing but the tooth. And it's so true. It's so true. Because over years of our practice, 9 out of 10 cases are all pulpal pain case, periodontal case, and the case where we actually see a pathology out there when we retract the patient's cheek. But there's always this one case which walks in, which confounds you. You don't know whether this pain is from pulpal origin, periodontal origin, or none of these. This is not the time to pick up your erotor and treat the case. This is the time to step back. I remember one of Dr. Okeson's lecture. He said that when you see a patient whose signs and symptoms do not go with your training. The question to ask yourself is not how do you treat this case, but can you treat this case? And that is very important because we are all not masters of all trades. So that would be the time to take a step back, rethink, call for a second opinion before you do any irreversible treatment. Patients are always our best teachers. I remember Dr. T, when we used to have our clinical cases, he would keep listening to the patient and then he would give a diagnosis and we would wonder how is he able to do that? Well, he has seen how many years of practice and how many patients, how much teaching and articles. And the one thing that you learn is no patient follows the textbook. I can't say I have 20, 25 years of orofacial pain practice, but the number of cases that I've seen, I can tell you one thing for sure, that they don't follow the textbook. You don't really get to see the typical textbook cases out there on your chair. They come with so many signs and symptoms. They tell you all your history, past, present, everything they tell you. It's quite confusing in the starting, but you can learn to master the art over the period. Case in point, this case, which came earlier on, a complete case of misdiagnosis and incorrect treatment. Now, the patient has been having gingival orovestibular pain right from childhood. He had been treated by multiple dentists. One fine day, a dentist decided to do multiple RCTs, and then he goes ahead and gets a bridge done. Mind you, none of this really takes care of the pain complaint that he came with. At present, the patient carries all the time in his backpack certain small bottles like this. This is basically a pain balm oil, Chinese medication that I think some of you are familiar with. He carries lime, we call it chuna in Hindi. He carries tobacco, he carries pepper, which he crushes and he applies. That's counter-irritant. That's your gate control theory, isn't it? Now the patient is desperate for relief. So these are not the cases that we can treat. These are not the cases to do root canal treatment for. So hopefully my presentation today would bring into light these kind of cases. Why the problem in diagnosing these cases? Because your orofacial region is a packed house. You have sinus, you have your lymph nodes, you have your salivary glands, you have a trigeminal nerve, which is really, really complex. You have a temporomandibular joint, which is so unique. You're so close to your intracranial structures. Now, all these do tend to refer pain to each other. Plus, the pain of pulpitis, the pain of a fractured root, a large composite sitting very close to your dental pulp horn, all these tend to confuse the picture. And as I mentioned earlier, since we have a tunnel vision, we tend to look only at the tooth. So you are in trouble if the patient is actually having an orofacial pain and the patient actually has a large composite restoration right next to the tooth, because your thinking will always lead you to the tooth. If there is one slide that I want all of you to go back to, is this, that the pains that are felt in the tooth do not always originate from dental structure. So it's important to distinguish between site and the source of pain. Now, I know multiple speakers have spoken about it since yesterday and therefore, site is basically where you feel the pain, okay? For the students out there who are listening, if the patient points to one particular tooth or region and he says, I'm feeling the pain here. So that is your site of pain. The source needn't be the same. That means the region from which the actually pathology is existing is the source, and the site and source may not be the same. Now, all these pains that we are talking about, they come under something known as heterotropic pain. That means site and source are different. They're basically of three different types. So you have your central pain, wherein there is an intracranial space occupying lesion, or probably patient has had a cerebrovascular accident. There is a trauma to a region, or there's a lesion which is applying pressure to a certain area within the intracranial region. And somatotropically, that region in the body or the head and neck tends to have painful experience. The other one is your projected pain. That means somewhere along the pathway of the nerve, there has been an irritation, there has been some sort of a trauma which is causing the pain. Now, we are all familiar with trigeminal neuralgia. That comes under the projected pain. And the last, which we see more often in our clinical practice, is your referred pain. That means pain or the source of pain lies in one structure and the site of pain is another structure. And they both may or may not have the same nerve supply. Now, before I get into the referred pain and the whole family of it, it's important for us to understand that there's something called as passing of information. I know somebody has done a good job of explaining this, but here I just needed to highlight a little thing. We all have in school days attended relay races, or we have been forced to participate in one of them. What does the athlete do? He passes the baton from one person to the next person, so on and so forth. Passing of neural information is something like that. There's no one single nerve which is taking it all the way from the periphery to the cerebral cortex. So you have something called as a first order neuron, and then that takes the information all the way into the spinal cord. From there, a second order neuron, and so on and so forth. The information finally reaches the cerebral cortex, where it deciphers it as pain. Now remember, more than 90% of this peripheral information does not even reach cerebral cortex. Sometimes two first order neurons, so in this case, probably in the second picture you can see there's a temporomandibular joint and there's a epitrapezius. Sometimes two first order neurons tend to converge the information on the same second order neuron, and the information finally reaches cortex, and the brain, as smart as it is, cannot decipher from where is the information coming. There are a lot of theories regarding the referred pain. This is one theory probably which is, for now, to understand the basics, I suppose this theory is good enough for all of us. Under heterotropic pain, you'll find so many of these cases which will walk into your plane. Let me just go through each one of them. One of the most common cases of orofacial pain that you will see would be your myofascial pain, or what is called as a trigger point myalgia. That means within the muscle unit, whenever a muscle contracts, then all its units contract and all its units relax. But sometimes, some of them, there'll be localized areas of hypersensitivity. They're called as the trigger point. Now, what is classic about this trigger point is they have a very, very specific pattern of referral. The patient may have localized tenderness at the area of trigger point, but they also tend to refer pain to other regions. For example, if masseter muscle is involved and there is a myofascial pain involving the masseter, the patient, depending on the location of the trigger point, might complain of pain in the maxillary posterior, mandibular posterior, a barrage of symptoms. In fact, they can complain of any of these symptoms, toothache, otalgia, preauricular pain, any of them. But one must have the diligence to separate the site from the source. Similarly, temporalis, anterior temporalis tends to refer pain to the maxillary anteriors, middle temporalis to the premolar regions, and the posterior temporalis to the posterior teeth in the maxillary region. Now, these patients will not say that I've got pain in the temporal region. They are the ones who will complain of toothache. There are some patients who have absolutely no headache, but only toothache, and only a good examination will help you differentiate whether the site and source are same or different. Now, let me just look at one of the cases. Now, here's a 46-year-old gentleman. He is complaining of pain in the maxillary left posterior teeth. He's been having on and off since almost 1.5 years. This pain, in the past, he has got extraction done to retrieve this pain. Subsequently, he got implant replacement done, and the pain has again come back. You must understand that this is a mirror image. So these are the two teeth that we can see over here. We have taken a good case history. He has a continuous pain. It increases in the evening, talking for long hours on phone, sitting on computer the whole day. By the end of the day, he wants to be socially shut off. In fact, he was referred to me by his wife and not by him because she said he's absolutely refusing to step out of the house even in the evening because the pain has overtaken our lives. You can see on VS scale it is between 8 and 9, and those are the regions that he's constantly complaining of pain. His sleep as such is not disturbed by this pain, but when he wakes up in the morning, he has pain. And the pain starts in the left temporal region, goes to the jaw and all the way to the teeth. And to overcome, there's a compensatory mechanism. He tends to bite. He tends to bite hard and he's developed clenching and grinding as well. So you can see in the examination the values for the pain in the muscles. So his temporalis is involved, his deep masseter is involved, and all of them are referring pain to the tooth. So the palpation of the right trapezius provokes the pain to the right temple, which is the patient's familiar pain, and the palpation of the left middle temporalis provokes the pain to the premolar region. So what's the take-home message for these cases? As you can see, these are your myofascial typical cases of referral. The trapezius, which will have a typical question mark pattern of referral, and then this is your temporalis. So when we are looking at a patient where we do not find an actual tooth pathology, you got to step back and think. Understand the referral pattern of the common muscles which refer to the head and neck region. Take a very, very good history. Try and see if you can elicit the same pain that the patient is complaining of chair side. And finally, try and do a diagnostic test. Because if the pain is originating from the tooth, your infiltration or your block will block out the pain completely. But if the pain is originating from some other structure, only when you block that structure will the pain go away. Now, the next classic area that we tend to have patients with is the neuropathic pain. I know yesterday, I think Dr. Maitley had a good lecture on neuropathic pain, because these are the cases which will come to your clinic. Classically, you will see two care categories. One is your classic trigeminal neuralgia. We read about it all the time, isn't it? Your paroxysmal pain episodes. There will be a refractory period. Patient complains of shock-like pain, and there's a trigger zone. The other category, which is trigeminal neuropathic pain. Unfortunately, in my experience, whenever I have referred patient for neuropathic pain, almost all of them by the medical fraternity have been given a diagnosis of trigeminal neuralgia. And all of them are put on OxCarb. One must understand that all neuropathic pain in head and neck are not trigeminal neuralgia. You have other care conditions like post-traumatic trigeminal neuropathy, your PTTN, herpetic neuralgia, and of course there are these persistent dentoalveolar pain cases, which we were calling, I think, atypical odontalgia earlier. Their presentation is different from that of a classic trigeminal neuralgia case. Now, case in point is this 43-year-old male patient. Somewhere in February 2021, while having his food, he develops this painful episode. It's a shock-like pain. He keeps having them on and off. He's not finding any relief. He flies to his home country, and there he's prescribed NSAIDs. Now, throughout my slides, I will be highlighting some of the text for everyone to understand that this is what 9 out of 10 dentists would do. So he's prescribed NSAIDs, he finds no relief, he flies back, he has to join back work. Again, he sees the dentist here. Here he's given a desensitizing toothpaste and a mouthwash. It doesn't work. And in the last 1.5 months, the pain has become intolerable. His pain is really high. He's not able to chew, he's not able to enjoy his food. Anything which has a little bit taste, it triggers pain. Washing of the face, brushing of the teeth, everything triggers pain for him. Now, this is the OPG of the same patient. I think you will agree to me when I say that there doesn't seem to be much of any alveolar bone changes or any periapical pathology that you can see. Examination of the patient as well. When we did, I tried. That's how we have been trained by Dr. T. We try and see if on chair side we can get the patient to have similar pain, right? Now, on a VA scale, a neuropathic pain patient will always point to a 9 or a 10. And so did this patient. Let me just play a brief video of the same patient. You will notice that he has 3 episodes. That's one, that's second, and that's third. This is just by him rinsing the mouth. Can you imagine how painful it must be for the patient that even merely rinsing of the mouth is initiating an attack? Now, this patient, yeah. For this patient, of course, a clear examination was done, a good case history was taken, and upon examination with light touch in the region of the edentulous area, I could elicit the pain. There was on the timer, I calculated there was a 31 seconds of refractory period. We tried chair side, I tried with sugar solution, with cold testing, everything was tried. Now I know QSU is probably not possible for everybody, but whatever instruments you have within your clinical practice, you should be able to do that. Do a testing of a larger region rather than just the tooth. And of course, when the block was given, the pain had temporarily stopped. So the diagnosis was that of a trigeminal neuralgia of the mandibular division. There is another case that I would point out, which came to me with the diagnosis of trigeminal neuralgia. And of course, the medication which was prescribed was not working for the patient. Now, there's a 28-year-old gentleman who had pain in tooth number 19. That would be your lower left first molar. Now, tooth was extracted, and this has happened about 4 months. Prior to that, the pain does not go away. He goes back to the same dentist, and now, though the adjacent tooth does not really have an issue, the second molar also is extracted because the pain is not going. At the time that the patient approached me, he's having continuous throbbing pain on the entire left side, and the whole left side of his face becomes hot and red. There's pain in the temporal region, and the aggravating factors of food, cold water, and sleep is completely disturbed. This is again the OPG of the patient. As you can see, extractions have been done, but there are not much findings as such in the radiographs. The temporomandibular joint is having absolutely no positive findings. All the muscles have no positive findings. His temporalis is tender. All the 3, anterior, middle, and posterior, 3 on 3, they are tender. And V1, V2, V3, all the divisions were tested. Intraorally, again, I tested it for light touch. Intraorally, I could elicit the patient's pain. So the minute light touch was there was an episode of this familiar pain with hotness on his entire left side. You can actually see the temperature was measured on the left side of 37.8 and on the right side, 36.2. So there was actually more than a degree difference between just the right and left side of the patient's face. Again, a 9 on 10 on a VS scale. And this is a brief video. So here I'm asking the patient if he having pain, and instrument is being touched and just light touch is being performed. And he is describing the areas where he says yes and no regarding the same pain. So at the end of it, there's a very, very small region. Physically, you can see nothing wrong in that area. It's well healed. There's just about 3 to 4 mm area where the patient is complaining of pain. That's all. So physically, you'll see nothing wrong. So these are the cases, probably we'll say they're psychogenic cases because we are not trained well enough. The case happened to be that of a post-traumatic trigeminal neuropathy with autonomic features. What is the take-home message? Most of these neuropathic pain patients, the pain is similar to that what you would experience with a shock-like pain when I drink cold water or sweet. That's your patients who are complaining of pulpal pain or dentinal hypersensitivity. Think twice before you do a root canal treatment. Take a very good history. Ask, and when you're examining, don't just look at the tooth, look at the larger region involved in that, because there are trigger zones involved whenever it is a neuropathic pain case. And always take a second opinion before you progress with the case. The next category is that of neurovascular pain. Now, this is probably one pain that across the globe, I think all of us have experienced, whether we are doctors or not, because headache is a very, very common entity. And not many people are aware that headaches show up in the orofacial region as well. So out of all the headaches, migraine and TACs have been shown, and there have been a lot of studies, there have been a lot of case reports reported for the same region. And there is so many studies. I'm just put up 2 of these where there was this case series published wherein 11 patients with lower half migraine cases were reported, that almost 40, I'm thinking 45% of them, they have undergone some sort of a intervention, endodontic treatment or extraction. And the diagnosis was delayed as much as 525 months for some of these patients. Almost 36% of these cases have had a tooth extracted in an attempt to relieve the pain. And this is a neurovascular pain case. This is not a case of tooth pain. But I would not blame the dentist. If you are not trained to see them, if you have never been aware that there can be an episode of a neurovascular pain in the lower half of the jaw, you will never know it. Of course, we all have read books by Benulgil and Yash Sharaf, and there's so many articles, and he was in fact instrumental in expanding the current International Headache Society classification for headaches. There are such beautiful articles out there. You have to read them. There's this one case I thought 3 times before I should put it up or not. But then this is the platform where we teach, where we learn. And here's a case. This patient comes with a pain in the lower right third molar. There's a typical case. There's pain on percussion. She has, when we take IOPA, there's superior apical lesion. When we give a block, inferior alveolar block, the pain stops. An extraction is done, and it's quite normal. Patient goes back home. After about 5 days, the patient calls and says, I'm having pain again. It's the same kind of pain. It's throbbing. I cannot sleep. Now, patient happens to be a medical specialist, internal medicine specialist herself. So she's tried everything. She's taken paracetamol, brufen. I think she had access to opioid medicine as well. She's taken that. She's gone to a local dentist. She has not found relief. So she drives all the way 2 hours back to our clinic. The dentist who did the extraction did the diligence of checking the region. The area is healing beautifully. Okay, this is your post-op OPG. I don't know if you can appreciate this extraction site. The pulp testing has been done for opposing teeth, for the adjacent teeth, because we do know that refer pain happens from there. But all of it is negative. Now, this patient is complaining of throbbing pain. He has got, the pain is continuous. There's photophobia, there's phonophobia. Okay, now this is a picture that I've taken from one of Benoliel's articles, wherein he speaks that there should be at least 5 attacks fulfilling at least a few of these criteria. If you have to categorize it as NVOP, that is your vascular orofacial pain cases. And this patient had severe unilateral throbbing pain. She had photophobia. She had phonophobia. Now, she is not your typical migraine patient, which is less than 16-year-old. Generally, we see them at the time of menarche. She is above 40. Now, all of them were coming as checkpoints. So for this patient, I told, I think you need to sleep. We gave her inferior alveolar block. The pain had come down, but not completely gone. I said, go home, close the windows, close the curtains, switch off your mobile, just go and sleep. That's all. I didn't tell her anything, because if there's a typical migraine attack, you need to do that. She refused to take any more medicine. And she went back. She had a good deep sleep. And then she calls me in the evening saying that, Doc, I don't know what you did, but the pain is gone. Pain is completely gone. I was still not sure. Now, she's a medical colleague. I said, I do think it is a big case of mid-phase migraine. I am not sure yet, but you need to see somebody who sees into migraine cases. And if you do have a next attack, a similar attack, you need to probably take a trip down because it will be an acute attack. But you need to consult a medical practitioner who looks into migraine cases. That's why I had my doubt in sharing this case. But in my opinion, this was a case of a neurovascular pain. It is known that NVOP attacks get triggered by dental treatment, root canal treatment, and extraction. In this case, extraction was done. The other entity that we all need to know is the cardiac pain. Now, ischemic attack are known to refer pain. And this is a poster, typical poster you will see of the region where a cardiac pain can get referred. Look at the region number 3. That's your jaw pain. So cardiac pain can get referred to this entire region from the jaw area, neck, upper chest, and hand. Some of these patients come with complaint of only jaw pain. With the current trend going on, where every patient is a temporomandibular disorder patient and every patient is given an occlusal splint, what a huge disservice you're doing to a cardiac patient being given an occlusal splint. So again, there are a lot of case reports of cardiac cases which have been wrongly identified either as a temporomandibular disorder case or a root canal treatment has been done. But obviously, finally, it is not so. If a patient complains of jaw pain, don't rush to just go and give occlusal splint. Do your thorough case history taking. Ask the patient when does the pain increase, your aggravating factor, your relieving factor. Does exercise increase the pain? Well, doc, I don't exercise. Fine. When you walk up the stairs, when you go to your office, when you walk for 5 minutes, do you get tired? Is there a history of cardiac issues in the family? Now, that's why history taking is the most important part when it comes to looking into the orofacial pain cases. And of course, if it is of cardiac origin, your inferior alveolar block is not going to relieve the pain, isn't it? Referred pain from the maxillary sinus is probably one referred pain that most of us dentists do know about it, isn't it? Now we know that the maxillary sinus and the maxillary premolar and molar are very closely associated. So if you have an acute sinusitis attack or there is a growth within the sinus, they can apply pressure. The funny thing is these patients, they come with pain, toothache as their complaint. So when you percuss this tooth, there will be pain. When you do your heat and cold test, there will be pain. So a dentist is likely to get confused. But if you take a good history, you will know. Now, I work in UAE where air conditioner is there in every single house. Even our bus stands have air conditioner. But how often are these conditioner filters changed? So dust allergy is very, very common here. So to think of maxillary sinusitis as a differential diagnosis comes quite naturally to the most of the dentists here. So here is the OPG. I'm not sure how clear it can be. There is an antral growth here. So this would apply pressure on the adjacent teeth. Then if OPG is all that you have, then you can make out the haziness between the right and left. You compare the sinus, you can make out the haziness because of the fluid presence secondary to the inflammation within the sinus. So when you have these cases, you have to ask regarding the ENT history. Do you have allergies? Have you recently had any infection, viral infection? You have to ask when they bend their head down, do you get pain? You can actually check test the chair side. So when you have a maxillary posterior region as a region for complaint, and you do not find any obvious findings, now that is the time you need to think that probably it could be a maxillary sinusitis oriented pain. The next category that we are talking about is your neoplasia and toothache. Now, jaws, especially mandibular region, has been known to be the site for secondaries. Of course, if it is a primary squamous cell carcinoma, it will show up in the face intraorally as probably a mucosal lesion or an ulcer, indurated ulcer. Nasopharyngeal cancers can be very, very confusing because they can cause pain in the jaw, they can cause deviation of the mouth opening. So all your classic symptoms of a temporomandibular disorders might be present. That's why I said all cases are not TMD. Then, of course, we have known of cases of breast cancers which are showing up as secondaries in the jaw. Now, here's a case. Though it is not a neoplasia case, I still wanted to share it with you. Now, there's this person who came, who was referred for endodontic treatment. You can see the molar. Again, there's a large filling. IOP is again any sort of two-dimensional image. I think Dr. Ajay mentioned it today. IOP, OPG, they can be quite misleading. There is a periapical lesion in his IOP, but of course you can't see the boundaries. If you cannot see the entire lesion in any radiograph, you got to stop and think of a next radiograph or the next entity which can give you more details. The patient's OPG was taken where the lesion was looking much bigger, and unfortunately, I don't have the OPG, but I do have the CBCT image. For those of you who are not familiar with seeing a CBCT, now this is the entire mandibular arch. You can see a green line here, right? So these are basically your sections, and as the line moves backward, you get to see the sections of the patient's jaw posteriorly from premolar all the way till the ramus. Let me just play this to you. Yeah, and lower on, in the lower side, you can see what's happening. So you see a radiolucency, which is occupying now the entire distal half of the patient's body of the mandible. So what just appeared like a small periapical radiolucency, for which probably an endodontic treatment would have been initiated, luckily was caught in the CBCT. So the patient opted to go back to the home country and get the treatment done. A corticotomy was done, and the path report showed it to be inflammation of the osseous structure, which was concurrent with finding of osteomyelitis. So this is what this whole presentation is about. It's about seeing the larger picture and not just the small view that we most of the time tend to have. The last but not the least is the psychogenic toothache category. We have come to a time where if any of us do have any psychiatric, I wouldn't say condition, but issues, it is not considered a taboo. I had patients, and because I have done CBT training as well, there are times that I can identify these cases. There are times our talking helps with these cases. Now, your patients who are having psychogenic oriented toothache do not give you specific symptoms. They give very vague symptoms. Their symptoms change from time to time. It could be bilateral, it could be unilateral, and it is known among the somatoform disorder. Having said this, I will be cautious because it's a very, very, very small percentage of cases which have this psychogenic. So if you cannot identify a particular issue chair-side, please do not do the disservice of calling them psychiatric cases, because I've had colleagues who have called me and said, I'm going to send you a case. I think it's psychiatric, but you handle it somehow. That's so common for me to hear this. Having said that, a small percentage do have a psychiatric component. Now, there is this case, patient had pain in the upper right premolar region. She says her second premolar was extracted because of the same reason. The pain did not go away. Root canal treatment was done for the premolar. The pain did not go away. A re-root canal treatment was done. And finally, out of frustration, the tooth has been just ground out of contact. I know Dr. T used to talk about these cases, but when I started seeing these cases, I realized that how common it is. Now, I realized that this patient has probably a myofascial pain component. I did examine her and I told her I want to give you a diagnostic block. And she stopped me there. She said, Doc, you can do whatever you want, but you are not going to touch me, or you're not going to inject me with anything. She just absolutely refused that I should touch her. When patients say something like that, you got to take a step back. I did get to speak to the family. The patient is under psychiatric care. She's under psychotropic drugs. She has been diagnosed for a somatoform disorder. So every once in a while, such a patient will come. That's where your case history is important, and you should not put your hand in these cases. Again, there's another category called occlusive dysesthesia. Again, I remember Sir used to say, you get married to this patient. It's so true. I've had only one such case, and I don't think I'll ever forget that case in my entire life. We have to do our diligence before we put our hand in the patient's mouth or before we do any irreversible treatment. History is the key, period. you have to ask why, what what aggravates the pain, what relieves the pain, what's the quality of the pain, does it go away, what time of the day, does it disturb your sleep? You have to ask a good case history before you actually even pick up your mouth mirror and probe and examine the patient. And I think it's time for us dentists as a profession to just step back and not just look at the tooth. We are day in and day out looking only at the oral cavity. And as we become specialists, we become even more myopic in our view. So it is important for us to look at the entire head, the teeth, the muscles, and all of the structure to go and get our final diagnosis. I hope I have been able to shed some light and share some of my little experience that I have in the past few years with the orofacial pain cases. Thank you. Thank you so much.
It's always nice to listen to you. Yeah, Dr. T is also here, so let him speak about you first. And Dr. T?
Yeah, Tony, nicely presented. Very proud of you and my other mentees who have been in this program so far. You guys have demonstrated a much higher level of understanding in general. You're talking about psychogenic pain right now. I just presented occlusal dysesthesia to around 30 physicians yesterday. And my core lecturer is a chief of psychiatry at a large hospital in the US. It's very well known, Dr. Betnitsky. So they were stunned at what a dentist or official pain specialist would know. And I showed them cases of occlusal dysesthesia. And I asked him, so we're going to publish. I asked him, so he's going to talk a little bit about our next program. He's going to talk about body dysmorphic phenomena plus somatoform disorders. And when you extrapolate that type of information to, let's say, US, where many of them go through unnecessary surgeries again and again and again, those are the somatoform and body dysmorphic phenomena that we're talking about. And you're right. You quoted me, and I'm right too. We get married to these cases, and that's occlusal dysesthesia. So now I'm going to mention it again, and I mentioned again in yesterday's one too. We're going to start our third mastership program. I invite you to join. That is another 150 hours, and Sonal and our batchmates, I'm going to inspire them to join that. It will be June 2025. We're going to start a huge program, our third mastership. There is no such program in the world that I can tell you. But thank you. Amazing presentation. Nicely dissected, very composed and hopefully compassionate. And thank you for the same. Donald, you should mute everybody.
Yeah. I don't know. I'm not getting the mute button only for this. Yeah, they are muted. Yeah, with that note, thank you, Dr. T, for this encouragement every time. And with that note, I will like to call in our next speaker. We are running a little late. Sorry, Dr. Gupta. Dr. Shifali Gupta, are you there? Yeah, can you switch on your camera, madam?
I have.
Yeah, please. Dr. Sonia, can you stop sharing your screen, please, dear? Dr. Shifali Gupta, welcome to International Orofacial Pain Congress 2024. Dr. Shifali Gupta is not a dentist, let me tell you all. She's a pathologist by profession, but she manages her lifestyle medicine. She calls herself a lifestyle medicine physician, and she practices with evidence-based lifestyle intervention, focusing on the prevention and management of chronic diseases. Her meditation practice, and she's a meditation practitioner and a teacher incorporating mindfulness techniques in pain management or patient management. So welcome, Dr. Shifali, and can you start sharing your screen, dear? I hope you're enjoying the dental fraternity program also.
Absolutely.
Yeah, we would love to see the other side of the story now. Yeah, your screen is visible and I can hear you. So can you, before that, Dr. Sonia, can you just check the chat box for any questions for you? Yeah, welcome, Dr. Shefali. The stage is all set for you.
Yeah. Thank you so much, Dr. Sona, for inviting me at this wonderful conference. I'm totally enjoying the talks that we are having. My topic for today is integrating lifestyle medicine for comprehensive orofacial pain management. The outline of the talk would include an introduction, the 6 pillars of lifestyle medicine, lifestyle management for orofacial musculoskeletal pains, for migraine and neurovascular pains, burning mouth syndrome, and trigeminal neuropathies, and some key takeaways. Orofacial pain, as we just heard, encompasses various chronic conditions that impact the quality of life, and medications provide limited relief, emphasizing a need for comprehensive management strategies. And if you were to classify them, as we saw, they can be musculoskeletal in origin, for example, including TMJ disorders, neurovascular in origin, also including migraine, and neuropathic pains. So what is lifestyle medicine and where does it come into picture? Because there can be so many causes, factors that influence this chronic orofacial pains. Lifestyle medicine is a recent emerging branch of allopathic mainstream medicine that focuses on using evidence-based lifestyle interventions to prevent, treat, and manage chronic disease. This is evidence-based, and there is evidence that more than 85% of these chronic diseases actually can get treated and even reversed in some cases by just lifestyle management. The 6 pillars of lifestyle medicine include nutrition, diet, which could, we'll see all these pillars in details, physical activity or posture management, sleep health, sleep hygiene, stress management, which is very, very important, positive social relationships, and avoidance of risky substances. So it is said that one or more of these pillars are usually involved in chronic diseases. And when we identify and manage that, we actually see a very good response in the patient. There are numerous publications as well that support lifestyle interventions, and some of these are very recent, have been mentioned here. The first pillar of lifestyle medicine includes nutrition. Nutrition, as we now know today, is very closely related, is a very important pillar, and gut-brain axis is a very integral part of how things get managed by nutrition. We have 10 to 30 trillion bacteria within microbiota in the gut, and these are responsible for releasing serotonin, the happy hormones, for immunity, and therefore an anti-inflammatory diet, or diet which helps the good bacteria, the prebiotics and the probiotics that we may take, would influence the way the disease or the orofacial pains are experienced. So whenever there is an alteration in the gut microbiota, we may experience anxiety and depression, and that is why we very often see these symptoms which are associated when the diet is not right. The nutritional powerhouses for orofacial pain would include whole food, plant-based diet. This would include food which is predominantly rich in omega-3 fatty acids, so walnuts, flax seeds, chia seeds, antioxidant-rich foods, so colorful foods which are rich in carotenoids and flavonoids, spinach, blueberries, turmeric, colorful foods, magnesium-rich foods. Now, magnesium has been known to reduce migraine frequency, and nuts, seeds, and green leafy vegetables are very rich in magnesium. There are obviously so many triggers that we've been discussing over the last 2 days that may trigger the orofacial pain. If we can manage the 3 whites, the gluten, the fine refined wheat, maida, and those that are the cookies and the cakes, the biscuits, the pastas, the noodles that are made from it, excessive caffeine, ultra processed foods So these would include, these are very rich in sugar, in salt, in saturated fats, and very calorie dense, and therefore they cannot be a part of routine diet. And when they are, they often may trigger orofacial pain. I mean, if we take the right history. So history, like this, like Dr. Sonia mentioned, is of paramount importance. And history to be taken for all the 6 pillars, whether it is diet, whether it is exercise, would truly help the patient in a huge way and would help you in the management. Tough and chewy foods would need to be seen in case of, in case of TMJs and disorders where orofacial pain disorders. There is something called a FODMAP diet. So there is fibromyalgia, which is a systemic condition, may have an orofacial pain component. And in these, when we take a low FODMAP diet for 8 weeks, it has been shown in publications that there is a very definite decrease in the VAS pain. That is, the visual analog score of pain is shown to be significantly decreased. The FODMAP sugars include fermentable sugars, the oligosaccharides, the disaccharides, the D for the disaccharides. So disaccharides would include the milk and dairy products. The oligosaccharides would include wheat, gluten basically, and many others. So onion, garlic, etc. can be very high in oligosaccharides. And for those who are very hypersensitive to pain, a low FODMAP diet has been shown to have significant help. Monosaccharides, so and polyol sweeteners, which are artificial sweeteners. So this Yeah, so the low FODMAP sample meal plan typically would include a diet which would be high, would be rich in green leafy vegetables, so green juice in the morning, nuts, seeds, and a lot of proteins, which would include sprouts, etc. And they have to be as raw and close to nature as possible. The second pillar is stress management. We know today, in the hectic world of today, everything, almost every stimulus seems to be a trigger to us, and which releases very high cholesterol levels. Any negative thought, that the stressful thought, would result in stimulating our HPA axis, the hypothalamic pituitary adrenal axis, and therefore the pituitary would release the ACTH, which goes down, and releasing the cortisol hormones, increasing the levels. This creates an imbalance of the neurotransmitters, the cocktail of neurotransmitters that are present in the blood, and creates a feeling of either anxiety or depression, and have to be managed. Mindfulness and meditation techniques do just that. They bring the neurotransmitters back to balance. Very interestingly, I mean, when I heard it for the first time, I wasn't sure if I believed it. There is a hormone called anandamide. Anandamide, this is the chemical structure I had shared with it, and this is known to increase in meditation. So mindfulness activities wherein you're neither thinking about the past or the future, when you're centered in the present. So there are different types of meditation and gratitude practices. They are known to decrease pain, improve sleep quality, and enhance physical functioning. They decrease stress, anxiety, and depressive symptoms. This is a brain scan that we see when, as a normal, in normal person, we see that the theta waves, brain waves, which are red in color, are very low. Theta waves are seen in very deep sleep. After 15 minutes of meditation, we see that there is an increase in theta waves, and there is a harmonizing and balancing between the two cerebral hemispheres, which increases our improves our communication of thoughts and information across the cerebral lobes, and improves performance, functioning, and mental and emotional health. So brain coherence is a very important finding that we see in meditators. CBT is another approach that a psychologist would take, and ACT. ACT is acceptance and acceptance therapy, acceptance and commitment therapy, again, which is catching up recently, wherein wherein the maladaptive thoughts are worked upon and it's brought into awareness, and the emotions and behaviors, and they're turned towards they're taught how to manage them rightly. The third pillar of lifestyle medicine would include posture and regular physical activity. As we all know, that regular physical activity actually reduces stress, releases endorphins, improves our sense of well-being. So in patients of orofacial pain, it can be of huge help. I mean, as we would see a little later, there are different, and even the presence of sun can be very rejuvenating and is known to increase energy levels. There are 4 different types of exercises if we were to look at it: endurance, strength, balance, and flexibility, which is the yoga exercise, which we saw a little in detail yesterday by Dr. Ramya. Addressing the upper body postures helps improve the jaw biomechanics and the range of movement. Muscle tension, which is seen in TMJs, gets transmitted to up to the shoulders, upper back, and the lower back, would find great relief if we were to do yoga, Tai Chi, and Qigong. Tai Chi and Qigong, they're both Chinese forms of exercises, and there have been some studies which have been done on them. They somewhere combine breathing, and they're very slow movement, and so they're almost meditative. And there have been studies again which show that 1 hour twice weekly of Tai Chi for 3 to 6 months has been shown to be moderately effective in improving the quality of life in patients with chronic pain. Similarly, Qigong is meditative, and it improves energy and decreases fatigue. Breathing exercises and pranayam, as we would call it in India, are known to improves our oxygen supply. It stimulates our parasympathetic system, and therefore relaxes us so completely, enhances our lung capacity. The CO2, the carbon dioxide, gets flushed out, and which actually pushes our blood towards the alkaline pH, and which is what actually inhibits the chronic inflammation which is happening. So it is very helpful to do this along with an anti-inflammatory diet. There are other modalities also. EFT, for example, there are lots of studies that have been done on EFT. Is an interesting concept and very easy. It is just about tapping your acupressure points. So there are identified some 10 acupressure points. And when you tap them, and along with that, you speak your problem out. So there is a way you do it, and there is a course, there are certified EFT trainers. And when you do them, so it combines both psychology and acupressure, and can be done anywhere, and just 5 to 10 minutes of EFT can be extremely relieving in cases of orofacial pain. Now, this is a case study of a 42-year-old busy professional who had symptoms of dull, throbbing pain in her jaw and temples, and there were symptoms of anxiety and insomnia. And just managing her diet along with mindfulness and yoga and managing her sleep, there was such an improved quality of life. They're amazing. Lifestyle medicine can really surprise you with a lot of results, and I've seen some very interesting cases which have actually surprised me with their reversal. Adequate sleep is a 4th pillar of lifestyle medicine, and actually sleep results, there is melatonin release when we sleep, and this is what flushes out the free radicals and the toxins that get generated during the day. So it's very, very important. And when there is a lack of sleep, there is There are, increased response to their trigger points created. There's tiredness, there is irritability, and there is precipitation of a lot of these psychogenic illnesses. Holistic treatment for orofacial musculoskeletal pain would, for example, TMJ disorders would include exercises like controlled jaw opening, which would mean just placing our tongue lightly onto the roof of our mouth and opening and closing our mouth just slowly a few times can be very helpful. Isometric exercises about pushing, against the hand, providing resistance. Myofascial release of trigger points, as Dr. Sonia was mentioning, just circling, just releasing that, giving a constant pressure at those trigger points that we identify. Self massage of these of the cheek muscle close to the TMJ joints in a circular form for a few minutes can be very therapeutic and relieving. Stretching this masseter muscles, that is just pulling the jaw forward and downwards slowly, can help. Neck and postural exercises, which would include chin tucks, which means just straightening the back and then pulling it, taking their chin closer to your neck. Shoulder rolls, all these can be very relaxing, can just release the tightening that is there in the muscles there and can be of a great help. Shoulder rolls both can be a huge help. Stress and tension management, so progressive muscular relaxation, or yog nidra as we call it in the ancient Indian science, can be very, very helpful. Meditation and mindfulness exercises. Supplements like magnesium, which helps migraine, which is known to help migraine, riboflavin, and coenzyme Q10s help in these pains. Dietary and dietary modifications, as we saw, have already seen, can be helpful. Soft diet and hydration can also be very important. If you were to look at lifestyle management in case of VMS and trigeminal neuropathies, again, an anti-inflammatory diet. And what would be the exercises? So we'll just discuss them. Music can be a huge, reliever. Supplements, vitamin B complex, zinc, and alpha lipoic acid have been known to help in these cases. Jaw stretching, which includes relaxing the jaw and letting it loose and opening the mouth as comfortably as possible and holding it for 5 seconds. Very simple exercises can be a huge relief, have been known to decrease the burning sensation that we feel. So a tongue rest position, wherein we rest the tongue rightly on the roof of the mouth, just behind the front teeth, and keeping it there for some time, for about 20 seconds, tongue stretched, pulling the tongue out, moving it from side to side, up and down, and holding it in each of these positions for 5 seconds, repeating it for 10 times, twice daily. A cheek massage can be, again, very helpful. Treatment of holistic management of migraine and other neurofacial or neurovascular orofacial pain disorders would include stress management and relaxation techniques. It is very, for example, Dr. Sonia just mentioned about stress management technique. I'm just sorry. So stress management and relaxation. She mentioned about her colleague, going to sleep for half an hour and feel for some time and feeling so relieved with their symptoms. And that's exactly what stress management and relaxation techniques do. We saw how the brain waves completely change with it. Mindfulness meditation, progressive muscular relaxation, and biofeedback therapy. Obstructive, what is the holistic management in obstructive sleep apnea? We've seen these since morning, weight loss, and so I wouldn't get into them at all. Sleep position and nasal passages. So we do know that lifestyle medicine can be an important component in obstructive sleep apnea. Sorry. if we were to look at what are the AI, what are the recent developments, or where is the future taking us in orofacial pain management? There are wearable devices that are coming in that could be these wearables can actually be worn, and they can help monitor our muscular activity, our jaw movement, and stress levels. And they can provide feedback for managing bruxism, tension, or muscle overactivity. There are chat boxes which could come in the near future, which could offer on-demand advice for managing symptoms. There could be a psychiatric help that can be there, monitoring patient adherence to exercise and treatment can be a huge help. So just to conclude, the practical implementations for clinicians include assessing lifestyle factors during consultations, educating. So this is very, very important, assessing or history taking, as Dr. Sonia again had emphasized so completely upon. It is very important, educating the patients on holistic approaches, collaborating with nutritionists, physiotherapists, and psychologists, and using digital tools for mindfulness and tracking purposes. The key takeaways include that orofacial pain is multifactorial, and lifestyle medicine actually addresses the root causes and therefore has some very interesting results, outcomes. Integrative approaches today enhance conventional treatments, and collaboration is the key for success. So let's all redefine pain management by embracing holistic care. Thank you so much. Thank you for this.
Thank you, Dr. Shefali. And it was really a wonderful lecture. And I must compliment you for one thing. Your presentation brought about a calmness in me also. So if something I have to learn from you is the way you calmly presented. So that would be the take-home message also, that stay calm at every situation possible. Thank you so much, Doctor. And Dr. Davis Thomas is here. I'm sure he has some remarks for you, or maybe something he would like to add up. Dr. Thomas?
Hi, Shefali, how are you? I'm
Oh,
sorry, I was listening to you, but we are back on the port, as you can see behind me. That's the Fort Lauderdale port. So we are back here. I'll go off the radar for a little bit and I'll try to join. Great presentation. Just one question for you. You're a pathologist?
Yes.
How did you end up with this as a topic? What was your inspiration to sort of parallel line into
lifestyle medicine?
alternative
I think it was somewhere
medicine?
during the pandemic, sir, that I got interested in. I mean, I always believed in this holistic management and was waiting for something in allopathic medicine to come up with a branch of science which would address this aspect. And as soon as I discovered, I actually authored a book, Mind Sutra, as well, sometime during that time, which transforming woe to wow, which used mental techniques to and working on them. So that was we could collaborate. We worked with telomere research and connecting and latest psychology in that book. And so when I came across lifestyle medicine, my first thought was that I am not missing my chance of doing this. So lifestyle medicine, and
you remind me of myself. Yeah, go ahead. I'm sorry. Go ahead. Go ahead.
Sir. So whenever I get an opportunity to connect, so I'm still a pathologist, but I've got an honorary consultant post. And whenever I get a chance to practice this, it is amazing, sir, the results that we get. Recently, there was just one sentence. So we saw a patient of diabetes. I mean, I was just working on his diet and exercise, whatever. And he comes back and he says, after some time, after a month, that I had anosmia. He's 50 today. And I had anosmia since I left. He's in Amsterdam. I had anosmia since I had left India at the age of 22. And while taking this diet, I have 60% of it has reversed, which was a huge surprise for me. And later I learned that anosmia is actually related to stress. So, I mean, there is just one treatment. The symptoms can be different. The diseases can be different. But when you come to that ease, when you get it right, so many things fall in place.
So quick thing about anosmia, we published a full review can you hear me?
Yes.
Yes,
I'm not sure if you can hear me.
Yes,
Yes,
Dr.
we can.
Yeah, regarding anosmia, we published a paper, full review in Journal of American Associations in the context of COVID. I would love to talk to you later, but on that diet, maybe there is a research that is worth looking into anosmia. We published the paper. Have a look at the paper, 2022 JADA, JAD, Journal of American Association, full review. Sonal, you can send the paper to her, PDF to her, and I'll make it available. Thank you. I know the next presenter is waiting. I'll go off the radar. I have to take one of those transports to the airport, and then I'll try to join again. But if I don't, great presentation, Shefali. Great job. We'll talk soon. Thank you. Sonal, amazing job so far. Okay, so continue the thing. I won't bother you for much. I'm going to
Next,
go off
we
the
have
radar
a
for a moment. Thank you.
physiotherapist, Dr. T. She's going. Next, we have a physiotherapist, and
I'll listen to her. Okay.
yeah,
Kruti. Okay.
yeah, Dr. Kruti Khemani, can you come on screen, doctor? Can you
Yes,
switch?
I am. Can you hear me?
Yes. Dr. Kruti is a principal physiotherapist and founder of Continuum Physiotherapy and Rehab LLP in Mumbai. And she completed her bachelor's degree in physiotherapy from Pune in 2004. And thereafter, she has completed her master's degree in sports physiotherapy from University of Sydney, Australia in 2007. Having worked for about 3 years in Mumbai, her hunger for mastership in mastering the art of sports physiotherapy made her go abroad. But I'm glad that you're back in India now and practicing in India, Mumbai. And Mumbai Shi Mulgi. Good.
Absolutely.
So, yeah, so that's what we call for a Mumbai girl, doctor. So
You can't take Mumbai out of Mumbai.
yeah, you cannot take Mumbai out of Mumbaikar. So I'm glad that you are back to Mumbai and the stage is all set for you. Welcome to a dental forum, and I'm happy that Dr. Varun Kunte suggested your name. And he was like, she is the go-to person for temporomandibular joint disorder physiotherapy. So stage is all set for you, doctor.
I'm very humbled, and I'm really, I'm finally seeing that in India, that the entire medical fraternity is all coming together to treat various things. Like I've spoken on a ophthal stage, I'm speaking on a dental stage. I mean, of course, orthopedics is our, long lost love or love-hate relationship, I should say. And of course, as physios, we're still evolving. We're still behind the rest of the world. Having worked in Australia for 12 years, I can still tell you that's where my TMJ knowledge came from. Sadly, I didn't have any TMJ mentorship in India. We hope to become one soon. But yeah, I won't take too much time. And I think I'm not going to touch on some of my slides, which I realize a lot of other speakers might have spoken about. But the role of physio is very new in TMJ management, but it's one of those that is a very quick hey doc, can you do this for my patient, finish it, and then come back to me. So we have dentists that like Varun and a few others that we work with, and they just call when the patient is with them and say, we have them for an hour, can you just see them quickly, see what you can do so that I can do my, maybe measuring or fitting of the splint or designing of the splint or planning the next stage. So we see them on a very quick notice. And I think that is something that I realized. Till now, I used to think physio is not an emergency care service, but in TMJ cases, it certainly is. So can you see my screen?
Yes, doctor.
Great. So as I mentioned, why? We're looking at underlying musculoskeletal and neuromuscular issues. Musculoskeletal issues for me, I've always treated the body as a whole. So even if I'm looking at people's back, I will still ask them about their TMJ, dental history or headache history. If I'm looking at people's neck, of course, it's so close to what the dentists work on. So we will ask them those questions. So reduction in pain is one of our main goals with physio, and of course referred pain, but also finding out the root cause, if I may say that, because sometimes TMJ might not be primary, as we all know. So if it is secondary to some other issues like neck and shoulder, that's part of our role as well. And hence, once we reduce the pain, we find out the root cause, restoring jaw function with exercises, with manual therapy, as you can see what I'm doing, and hence, of course, improving quality of life. So the pain management is something that obviously is a big part of physio, the role of physiotherapists. And again, without dwelling too much into all of this, because you guys have spoken about it, we always ask these questions, and I'm not reading them all out again. But, the screening for us is equally as important. Even though you have screened them and sent them to us, we will still ask a lot more questions in addition to what has been asked by the dentist, because apart from all of this and a lot of lifestyle-based things that Shefali already spoke about, like OSA and things like that, and stress, we want to ask about their sporting history. We want to ask about their history of any fractures, any major ligament issues. And I haven't put a slide here because there's not research done on it. We're doing in-house research on this, but there is a new linkage that we are finding between people with hypermobility and TMJ issues. And I don't know if I've missed any speaker who's spoken about hypermobility in the last 2 days, but if people have heard about Ehlers-Danlos syndrome. So in Australia, there's a lot of research going on this syndrome, and they are obviously finding a lot of connection between this connective tissue disorder and TMJ problems in the latter part of life. Sadly, we're seeing a lot of TMJ cases in kids as well. So don't know where we're heading. I'm not going to go into the anatomy part. So this is more important, I guess, and more relevant. So TMJ and cervical spine dysfunction, as we know, not just from an innervation perspective, because they share a lot of the nerve supply, but of course, the restriction in cervical spine range, restriction in any kind of cervical spine functioning is directly related to the TMJ. Stress posture causing mandibular condyle pushing back against because of the clenching. Obviously, that would lead to the disc getting compressed and damaged and pain, inflammation, and so on. So for us, what's important in the history and our assessment is to know if that stress has led to postural changes, so we can reverse that postural change. Headaches, again, another big question that we ask. Between that cervical spine, the nervous supply, all of that, if the headache, once we know where the headache's coming from, if we can fix the headache, again, we can help the TMJ and vice versa. So there is so much hodgepodge of, sources of these symptoms that we can't miss out. So I always say to the patient, there's always one driver and the rest are all passengers. So in every case, the dentist will find the driver, and we will become the people fixing the passengers. But there might be some cases where we might find the driver and say, you know what, their hypermobility is the crux of the issue. And hence they are, trying to find more stability at some point, and hence they're clenching, and hence they've landed up damaging the disc in the TMJ. So again, there's a driver and then there's passengers. Of course, the driver needs fixing first, and then of course all the passengers need fixing as well. So for us, it's very important as physios as well to pick up the phone and discuss with the dentist to say, listen, out of all the things I've seen in your patient, I have a feeling that the actual root cause is this. So, a healthy discussion like that creates miracles when it comes to results. Relationship between, there is obviously studies, multiple studies, but I found this one really good because it clearly demonstrates that it's not necessarily that people need to have spinal pain where you can say, okay, hence it's connected to your TMJ. There were people without spinal pain, which were also showing signs of jaw, face pain, and headaches. So the study really confirmed what we had originally thought of. Chronic pain, we all know what chronic pain is, but in the science of chronic pain, as we all know, there is no cure, it's only management. So firstly, it's really diagnostically important to know what, again, is the root cause. So there are so many conditions, like, again, Shefali already mentioned most of these, which unless we fix those through lifestyle-based changes, we're not moving TMJ pain anywhere ahead. So in the realm of chronic pain, I would say Shefali's role, or people like Shefali's role, would come higher. And then, the role of the dentist, and then the role of the physio, and then maybe somewhere the nutritionist, and somewhere the exercise physiologist. So we're all going to be a part of the party, but there's always going to be one host. So, in brief, when I see a patient, what am I looking at really is I'm observing their facial symmetry. I'm looking at not just the face, but face, neck, mid-back, lumbar spine, hip, pelvis, lumbopelvic stability, and flat feet. So I'm looking pretty much top to bottom. And then locally, I'm looking at swelling, occlusion, clenching. I want to see range of motion compared to right and left TMJ. Spinal ranges give me a lot of information because a lot of range of motion restriction through the spine is going to give you, if you know what fascia obviously is, fascial tightness, which unfortunately tugs onto both the TMJs. So if I'm fascially tight and my neural tension tests are positive in my assessment, that's going to tell me unless I fix that lower back problem, I'm not going to be able to fix the TMJ. In my palpation, I'm obviously looking at local areas of tenderness and sensitivity and distribution of symptoms. Where else can I find? In our case, maximum amount of tenderness, problem, palpation, stiffness, restriction and range is in the neck and the cervical spine. So anterior and posterior cervical spine is what you'll see us work on with our hands maximum number of times. Our muscular assessment and cervical spine screening has a lot of special tests that we do, which involves facetal testing, ligamentous testing, and muscular testing, and of course the psychosocial contributor. So that comes in, and I think we're all from the same school of thought. Even just listening to the last 3 speakers, I've realized we're all very big on history. So that's fabulous. Again, we all know these associated symptoms. I don't want to harp on those. Important factors we consider also, because we now know about TMJ a lot more than we ever did, is that innervation, and if there is any issues coming up through the trigeminal nerve, the kinematics of the joint, which is again, though they're 2 separate joints, unfortunately, they are expected to work as one unit, which is very difficult. So when we look at them as a unit, we are looking at them as a unit in unison with the cervical spine and with the entire chain up and down. Other disorders in the disc will obviously be if they are the primary, if spinal disc issues are the primary issue, then the TMJ can be the secondary issue. So unless I decompress and stabilize that upper cervical spine, headaches going nowhere, TMJ pains going nowhere. Mandibular position, obviously we look at because we manually do some gentle mobilization work to reduce pain and realign it, just like we do for the rest of the body. We don't click TMJs. I'm sorry if anybody here is a fan of chiropractic treatment. I'm not a fan of chiropractic treatment done on TMJ. It's too sensitive an area. It's heavily innervated. You cannot click these joints. You're going to destabilize them further. So when we're trying to really achieve stability there, the chiropractic treatment is going to destabilize it. And I've had enough cases I've seen even in Australia where, they walk out feeling great and within an hour get a call saying, I'm nauseous, I've got a headache, I feel dizzy. And I'm like, okay, well, let's go to the ER. So please, refrain if your patients want to go see a chiropractor unless you've absolutely ruled out everything else. And of course, working on dynamic joint stability, which is balancing all the forces of different muscles. So we work on downtoning muscles that have been tight and protective in nature, releasing those, and then increasing the tone and strength in the muscles that have just been lazy for a while, and then starting to work now very slowly and steadily. Some to name would be deep neck flexors, your mid-scap muscles, because these are your stability muscles. These are the muscles which give that solid groundwork for the TMJ to feel like it has some support. What do we typically include in rehab, apart from the evaluation and treatment of manual therapy done in muscle spasm relief, is mobilization, like I mentioned, of the mandible. We do a lot of mobilization work of the upper cervical spine to decompress that C0, C1, C2 level so that the headache quickly goes, the jaw pain quickly goes. We do a lot of facetal mobs as well. Soft tissue release of the accessories of the neck, which we obviously look at the anterior aspect, so your SCMs, your scalenes, and of course a lot of exercises. So our job is to prescribe and design a very good customized exercise program for patients that are coming to us with chronic TMJ pain, in conjunction with the dentist, to say, look, how much work do you think this patient can tolerate? And if we found that they have a lot of psychosocial issues or psychosomatic issues, we want to make sure that we are pacing this program out and really hand-holding them through the process whilst the dentist is doing their work and whilst the psychologist is doing their work. And I think talking to each of these participants is so important to us. So communicating with other healthcare practitioners is absolutely a game changer. Again, how do we release the pain? I'm repeating probably myself, but a little bit of soft tissue release, identifying that contributing factor, and then preventing it, proprioceptive and stability exercises. So, you know, the role of a physio really, just if I was to just give it a quick summary, is not just treating the root cause, not just doing manual therapy to relieve pain and increase mobility of the area. But I think if you ask me, the final sealing of this deal is done via exercises. So for us, you know, use us to really help us teach your patients good exercises for their problem, for their root cause, not just for pain relief. Don't use us for pain relief. You've got enough pharmaceuticals for that. This is just an example of how this patient came to us through another dentist, and he's a dentist himself, and he realized how important it was for him to not live with this headache, and then just a couple of few sessions and he felt much better. But, you know, again, I'm not going to harp on this too much, but just to touch upon it is, you know, confirming that the TMJ issue and the orofacial pain is coexisting with other musculoskeletal issues first, and restoring the motor function, relieving the pain, and then doing the tailor-made exercises. I mean, these are my three top tips or steps that I would take if I was to see one of your patients. And that's pretty much what I wanted to contribute today. I know I've rushed through it, but I'm also wary of time.
No, Dr. Kruti, that was actually quite a good summary because we as dentists, we are trained to prescribe certain amount of medicines or maybe the exercises also. And I at my clinic also do that. But getting it done from a specialist like you will definitely make a difference in patient's life, because you all know the pressure, pain points, everything, like those things we are not trained for. So maybe in near future, you all can train us also. So that can also help. And
It's like, sorry, I'm cutting, but it's like how we tell the orthos, you know, your job is to do your surgery. Don't break your heads on designing your exercises. You know, leave that work to us. And the same way, I think there's a lot of minuscule work that we might do, which I think you don't want to be spending your energy on. So just send them off to the physio, trained up physio again, to say, you know, work on these people for A, B, and C. And I think that initial call for discussion is so important, because if that physio is trained up in TMJ, they will know exactly what you're talking about and what is it that you want us to achieve. And then off you are on your path again to do whatever dental work that you want to do. So I think, like I said, use us wisely, use us in the right manner and the right time, and the results are beautiful.
Dr. Thomas, whom you met just some time back, in his program also, he conducts a fellowship program, mentorship program. There also he keeps on mentioning about fibromyalgia and how the physiotherapy has been actively been a part of the therapeutics also. But then still at the end of the day, I'm happy that you were a part of this session, because this has given us a streamlined pathway, like, you know, what to do. At times, and I believe in referral practice a lot, because not everybody can do the job well. I mean, it is designed for some other person, just refer the case. So now I know that in Mumbai, you are there for me, so I will refer my cases to you.
Thank you.
Only one thing I would like to know, I know you're short in time, like, you know,
No problem.
But at suppose you said cryo practitioners and all that, I understand that. But are there any home care regime what we can tell patients to do? Like, instead of coming into the office and all, we are trained for certain amount of exercises and schedulers we plan for the patients. But is there any quick, not a quick fix, but some exercises which we may be prescribing the same, but if you can just throw light for home care regime for the patients, like, you know, that will be better.
Yeah, I mean, I guess if you already are doing that, I'm not sure, because I haven't spoken to you as in one-on-one. But when we do manual therapy, we are releasing the masseters, we are releasing some of the pterygoids and the temporalis and all of those. Once we've released it, of course, it's not going to stay loose for more than 24 to 48 hours. It's going to go straight back into getting tight, because that's the pattern it's got into. So to maintain that, we teach them how to self-release as well. And ice it and self-release, that's one part. That's for both pain as well as downtoning of the muscles. And so that they don't get tight again, we are going to work on, like I mentioned, the foundational strength and the stability exercises of the cervical spine. So we train them to, use their deep neck flexors, the long deep neck flexors. We train them to release their suboccipital muscles and work on stretching those, because that's going to tug as well. And we also work on their rotator cuff and their mid-scapular muscles, because that's like the basement, that's like the ground floor and the foundation. So if their rotator cuff is going to be really weak, even if they're going to drive or cook for 20 minutes, that's going to tighten those muscles up right after getting released. So strengthening rotator cuff, which is shoulder, and mid back, which is mid scapular muscles, is extremely important, so that the neck and TMJ feel like, okay, we have a strong base, so we don't need to do some work. So anybody who's using their arms to do something, be it driving, cooking, pushing, pulling, lifting, a new mom lifting their child, all of this we are going to ask in the history, so that we make sure that we're giving them that good, strong foundation. So a lot of the exercises for us, at least, are, apart from, of course, the usual TMJ stability work, which is for the mouth openers, the closers, the deviators. Apart from doing isometric ones for those, releasing those, we will add cervical spine, anterior cervical spine stability, and shoulder work as well.
Oh, great, great, great. And there's a question from the audience, that is, what's your take on laser physiotherapy, doctor?
So I've used laser back in Australia. I have one in the clinic as well. I'm only a fan of the laser when there is chronic inflammatory reactions happening constantly. So if the oral anti-inflammatories, icing, and all of that's not working, I might use it, but I'm very low on modalities, because over the 21 years of practice, I've realized that modalities are going to be a very short-term fix to a lot of people's pain. They might reduce the pain and inflammation. It's not regenerative as it claims to be. So if I'm not regenerating anything, I'm just reducing pain and inflammation. And for any modality, you have to call the patient at least 3 to 5 sessions in the clinic. Why am I wasting their time and money? I rather than they'd go down the path of something like, if they have worn out their cartilage, go down the PRP path if that's the case. But because laser is not regenerative, it's only for pain, inflammation, and vasodilatation, if you ask.
Yes, yes, yes. And so with that, I would really like to thank you for being a part of the, and for your patience also. I understand that you have to be somewhere else. And
Sorry.
on
Yeah.
a Sunday evening, I'm pushing you to stay and talk to us, because this part of it, the physiotherapy part of it, we all were eager to know what to
Right.
do and what not to do. Now, one thing we know that yes, we have a referral person to go to. So if
Yeah. And
you share your slide for your clinic address, so that everybody can note it down.
sure, I just have the number.
Yeah.
We have about 4 branches. So, in Mumbai, it's the main one is Khar, and the other one's Pedder Road. But yeah, just this number will give you all the information, if that helps.
Okay. And can you, is there any way or means of doing home physiotherapy or clinic consultations from your side? Like, if we want to call you for a clinic consultation or maybe home
Yeah.
therapy.
So we're a team now with TMJ. We're a team of 3 physios. We're technically a team of 21, but only 3 of us do TMJ work because we're trained for it. And like I said, I'm very strict. I'm not going to allow any other physio in the clinic to touch TMJ unless they've done the course or trained for it. So yeah, between the 3 of us, we can definitely do clinic visits.
That would be really great, and it would be a great service, because at times our patients are not able to travel
Yeah.
that. So if that
The only issue sometimes happens is that we need the bed to treat them, like the bed that goes flat. So I don't know if all clinics will have that, but we need the treatment bed for that. That's the reason.
Oh,
Because they have to go prone as well.
Great, great. Thank you,
So
Dr.
that's it.
And
No worries.
it was really,
Thank you for having me.
it was really awesome having you here. And
I'm
with
glad.
that note, we will welcome the next speaker. But before that, I have an announcement for you all. And Dr. Zakriti, you can stop sharing your screen.
Sure. Thank you.
For your patience that you waited for us to finish our earlier sessions. Thank you so much.
Thank you. Thank you so much. Thank you.
Vijay is with us now.
Yes. There's an announcement for all the participants. If you all want a goodie bag, I know you all patiently waited. So the number was already shared. But if you want, just get back to me. I have something very nice for you all, which you can use it. And that will be a guide for you all, whatever you have listened for these all 3 days. That will be a guide for you all to carry forward to. So looking forward to connecting with you guys in future also. And we have our next speaker, that is Dr. Vijay. Okay. Is he there? Can you switch on your camera, Doctor? Dr. Vijay? Dr. Vijay, can you switch on your camera first so that we can see you first? Yeah, you can share the screen then, otherwise, no issues, Doctor. Dr. Vijay worked as consultant in anesthetic and pain medicine at Bradford University Teaching Hospital, Yorkshire Clinic Hospital, Bradford in UK. After completing MBBS and DA in India, he traveled to UK to practice for nearly 15 years. During this time, he completed his pain fellowship and specialized in sleep medicine. He achieved a CCT in anesthesiology with special interest in pain management from Cambridge. In pursuit of academics and to achieve clinical excellence, he undertook a fellowship in neuromodulation and advanced pain research fellowship from the Guy's and St. Thomas Hospital, London. During this time, he published the occipital nerve stimulation for chronic refractory pain and participated in the landmark new technology for frequency SENZA, SENZA trial. And he contributed to many books, chapters, papers in academic journals, poster presentation and lecture in both national and international scientific forums. Hello, Dr. Vijay. It's an honor having you here. Can you unmute yourself, Doctor?
Yeah.
Yeah. Hello, Dr. Vijay.
Hi, can you hear me?
Yes, we can hear you, sir.
Yeah.
And, it's an honor having you here. And have you been attending our lectures, Doctor? The dental fraternity lectures. Have you been attending this 3-day conference? Were you
Sorry,
part?
actually, I've been working all day. Today, I'm working as well. Sorry, I could not attend that, but I opened it earlier and then I've seen, but most of it was dental part, so
Yeah,
I could not enter that.
but I nudged you that you please go through the YouTube channel, which is the National Health Academy channel, and IOPCON 2024. The link is already on there. The live streaming is there. Be a part of our dental fraternity, and I'm sure in future it will be a great collaboration, Doctor.
Yeah, thank you very much, ma'am. Thank you.
Okay.
Thanks for your time.
The stage is all set for you. Please go ahead, sir.
Okay, so thanks a lot for all the delegates who are actually sitting here on a Sunday. Yeah, as ma'am has said, I am a full-time pain practitioner working at Hyderabad now. I'm running this Indo-British Advanced Pain Clinic, and my interest in pain medicine will go into orofacial pain, where I've done a module in orofacial pain at Guy's and St. Thomas's, London. So yeah. And then my research also goes into the facial pain and headaches, which is occipital neuralgia. So this is my fellowship topic as well, which is very dear to me, neuromodulation for facial pain. It is one of the fastest growing field in the neural technologies and one of the biggest in the medical fraternity as well. So basically, what is neuromodulation? If you look at it, we all will be using some kind of pressure devices, chemical devices, like applying some balms on your face, and you will be applying some band on your head to treat your headache. That we all know, our parents always does it. But then if you make it into a technology, which is neuromodulation, where there is, the definition will be therapeutic alternation of your neural activity by delivering some electrical or chemical stimuli to target your neural sites. So that is what a neuromodulation is. So essentially, you alter the irregular activity of the brain by stimulating the brain's tissues by using or injecting some drugs, electrical, magnetic, optical or acoustic energy, any form of physical energy that we have. By using that, if you are altering the activity, thereby stabilizing your brain systems. So that is when you can actually cause neuromodulation. Modulation means changing the pattern, how it is working. So this is exactly what neuromodulation is. And over the years, there is a wave of neuromodulation which is coming. Basically, with the electrical neuromodulation, which occupies a bulk of this, you have a first wave of neuromodulation, which started in the 80s actually, where the dorsal column of your spine is stimulated, particularly in patients with failed back surgery or some type of complex regional pain syndromes. For example, your hand will start to get very painful, neuropathic pain, extremely painful that the patient wants to get commit a suicide. So that is exactly what we are talking about, complex regional pain syndrome or CRPS. So that is when you stimulate your spine, the dorsal columns, which are your touch and pressure nerve fibers. So when you stimulate those, you can actually stop the conduction into the pain fibers. So this is what we call as a gate control theory. In the gate control theory, for example, if you are applying pressure on your forehead, your actual headache will be reduced. So the pain is reduced by applying pressure. These are two different varieties of the sensations that you have. So that is the principle where they used to actually control pain. So this is the first way where they were using it in failed back surgery. Nothing else can be done. When you stimulate with an electricity on the dorsal column, which is the touch and pressure on your spine, then you achieve some pain relief. But then subsequently, various peripheral nerves could be stimulated in the same way. This is the second wave where we were using it for pelvic pain. It is called as the sacral nerve stimulators, where someone who cannot control their bladder sensations and passing urine or the bowel. So when they are unable to do that, you can actually stimulate these nerves and then you can control those, the bowel and bladder movements. So this is the second wave. This was also used for diabetic neuropathies, post-herpetic neuralgias, various things. And then you have the third wave, where not just a simple electrical pulse like a TENS machine, but then various varieties of stimuli are utilized. For example, repeated stimulation, rapid stimulation, various burst stimulations, various varieties of electrical stimuli are utilized to achieve better pain relief for the patients. So these are various things. So the first wave, second wave, and the third wave of neuromodulation we're talking about for various indications we'll go through now. Now, when we are talking about the orofacial pain, what are our targets? How can we stimulate the facial nerves? So first of all, our targets will be either inside the brain or outside the brain, which are the peripheral nerves which are connected to the brain. So coming to the peripheral nerve targets, we all know that we have a trigeminal nerve. That's the first thing. Second, we have the greater auricular nerve. Third thing is we have occipital nerves on the back of the head. Then you have glossopharyngeal nerves, which are inside the mouth. Then you have the spinopalatine ganglion. So this is the ganglion, which is an autonomic ganglion, which is present behind the nose and the eye, underneath the eye. So we've got all these things which are helpful to control the pain. So these are roughly on the picture. You can see the location of some of these nerves. Now, how do these work? So when you stimulate a nerve or a nerve ganglion, how does it actually produce a pain relief? So stimulating of the ganglion or a nerve on the face will activate what is called as the trigeminocervical complex. So what is this trigeminocervical complex? So this is a set of nerves which are present in the medulla and then into the upper cervical region. What you can see, this is the medulla and the upper cervical region, which is the trigeminal nerve complex, and the cervical complex together is called this TCC. This extends from the above said sources. So from there, it receives inputs both from the face, scalp, as well as from front and back of the neck. All of them reach into one place. So the significance of this is, for example, if you want to control facial pain, when I stimulate the cervical part of the TCC, still you could achieve pain relief. Likewise, if you have a problem in the facial, the cervical part of the neck, And then if you want to stimulate the trigeminal component or the nerves on the face, you could still achieve pain relief on the scalp. So this is all controlled and located in one area. That's exactly what I was trying to say. This phenomenon is called convergence of nerves. All the nerves are converging into one area is what I was trying to say. And these are all the different targets. How it goes is what I'm trying to explain. So when it comes to the cervical area, where you have two types of fibers, I already mentioned. The A delta and C fibers are the pain fibers. You have other things called as the A beta, and other fibers are the touch fibers, touch, pressure, proprioception. They are non-pain fibers. So both of them will be traveling. One will go straight and decussate in the medulla. The other one travel in the spinal cord, immediately decussate. This is the spinothalamic tract. And there are lots of other target nerves, which we are talking about, the receptors here. So there is what is called as the ascending nociceptive fibers. So they travel and they activate through these different pathways. So lots of these chemicals are there, endocannabinoids, opioids, GABA receptors, which is stimulated by the gabapentins, the glutamate, substance P, all these kind of things are the ascending nociception. So those can be blocked by these nerves. At the same time, there is a descending inhibitory pathways. They should be activated. So if your inhibition is activated, your pain will be controlled. So for example, the serotonin, which is the happy chemical, dopamine, serotonins, the opioids, noradrenaline, and the acetylcholine. So now we are talking about neuromodulation. When you talk about neuromodulation, I'm broadly dividing it into two parts. One side, you have non-invasive devices. The other side, we are talking about the implantable devices. So when you're talking about the non-invasive devices, you have TENS machines. There is an external pulsed RFs. You have transcranial direct current stimulation. There is a repetitive transcranial magnetic stimulation. And there are a range of devices, including lasers, Botox. All these things are relatively non-invasive or minimally invasive. The other part we are talking about are the implantable devices. These can be implanted in your brain, which is the DBS kind of thing, deep brain stimulation. The other thing is the peripheral implantable devices, which are occipital nerve stimulation, various other nerve stimulation devices like trigeminal, spinopalatine, glossopharyngeal nerve stimulations, right? So now, more accessible ones are the non-invasive ones. Let us talk about the non-invasive devices. Most of you would have heard about the TENS device, right? So the TENS device for facial pain, it is approved. They deliver low voltage electrical currents to the nerve which is sitting underneath that, and they help to modulate the transmission of the pain signals. And as I described to you, the TENS works on the gate control theory of pain, where the touch and proprioceptive fibers are activated. When they are activated, they suppress the pain fibers which are passing through the fine nerves. So this is what the gate control theory roughly translates to. And then it is helpful in various conditions. For example, the TM joint disorders, trigeminal neuralgias, facial nerve pains, various other nerve pains, myofascial pain syndromes, muscle tensions and spasms, and you have the post-surgical pains. And there are good meta-analysis coming out. It has got good effectiveness. TENS is very effective, where you have significant reduction of pain, both for headaches, and you have got good response rates for all of this. So TENS is a device which can be used at the start. The second thing that you have is external pulsed RF. So what is external pulsed RF? So you have a superimposition of two waves, which is like a TENS wave. What you have is a general waveform, direct current waveform, which is present. And you also have got a radio frequency waveform, which is coming as a pulse. So these two are superimposed. It gives a better response to pain. So this is one of those devices which manage to the pulsed RF, not by putting a needle, but even through the skin. It's a transcutaneous device. it has got an electromagnetic waveform, and it alters the cellular and metabolic activity. And the studies actually show that it has made a significant difference to various kind of neuropathic pains of the face. So this is for a trigeminal neuralgia, where you can see the pain scores are dropped from 8 or 9 down to about 4, which is 4, 3 and things like that. It is like a moderate reduction in pain, both for short term as well as for long term duration. But the only downside is you require multiple settings. You need about 10 settings to improve. The next thing we're talking about is the repetitive transcranial magnetic stimulation. RTMS is what we call. In this one, cortical nerve centers are activated. Normally, we target what is called as the motor cortex, dorsolateral prefrontal cortex, and the somatosensory cortex are activated. How does it work? It basically, as you can see in the picture, there is electrical signal which is traveling in this 8-shaped device. As it is traveling through that, magnetic waveform is produced, and that will go and activate the nerves underneath. And what are nerves again? There is electricity which passes through the nerves, and this waveform will activate the electrical current inside the necessary nerves underneath. So that is how electricity converted into magnetism, converted again into electrical current, activating the areas that are required for us. So this is how the RTMS works. Basically, how it is used is, you have different kinds of frequencies here. You have high frequency, which are excitatory, and there are low frequencies, again, which are inhibitory. So these are different things, how you can modulate the cranial nerves or the brain, and thereby producing pain relief. In this picture, what you can see is where it can be used. There are a number of indications for RTMS, starting from anxiety, depression, sleep disorders. You can see all of these, fatigue, speech and voice impairments, dysphagia, lots of things. But the top one that you are seeing, they're all for various pain indications. It has been used extensively. And then out of that, specifically, you have headaches, where you have primary headache, migraine, tension headaches, they're all there. And then you have secondary headaches. So various other trigeminal neuralgias, post-herpetic neuralgia, there is good evidence that it is working for all of these. And how does it work? Basically, what you have is this RTMS. These are all neuropathic pains. How does it activate? So there is an activation of NMDA, which is NMDA is for someone who is not fully aware into pain. It is a receptor which is present in your nerves. When activated, it gives neuropathic pain. This is an NMDA receptor that gets activated in the central neuropathic pains. But what it does is RTMS suppresses that by activating the long-term potentiation and synaptic plasticity. It activates these things, thereby producing pain relief. Similarly, some inflammatory chemicals such as IL-10 and TNF-alpha, it reduces the inflammation. So there are various other things where it is activating some of these thalamic neurons. And mind you, thalamus is the center for your pain. So those things are also activated. Thalamus in the brain and dorsal columns in the spinal cord, they're activated. So you can activate all of these things to produce this pain relief. Another device which works on a very similar pattern is transcranial direct current stimulation. Earlier, what we have seen is your magnetic current, when magnetic stimulation which is produced, it is activating the current inside, but then you can also do the same thing using direct current. But it is a little more unpleasant to the patient. This is what the problem is, but it will target the same kind of nerves. Another device that we can use, or which we are using, is lasers. Here in this one, it is called as photobiomodulation. You can see there are two words in this. So when the nerve is getting modulated and the tissues are getting used, you can use light to modulate this thing. So there are two varieties of lasers. One is called as the low level laser and the other one is called as the high level lasers. So they alter the cells and the tissue function. As you can see, it can be used for oral pains, various other facial pains. It can be used very effectively. For example, in trigeminal neuralgia, post-herpetic neuralgia, various myofascial pain, and even mucositis and toothaches, laser can be of quite a help. How does it help? Essentially, laser light, when it is transmitted into the patient, it passes through the skin subcutaneous tissue into the affected tissues. In the affected cells, you have mitochondria. When the mitochondria are activated, it will activate three things. One is the ATP, reactive oxygen species, and nitric oxide. All of them will cause healing, repair, and it will also decrease the inflammation in the patient. And that is how these lasers help. And there are a number of mechanisms which people are proposing that how it is helping. So we don't have time to go through all of those. So that's lasers for you. And the next thing is minimally invasive techniques like botulinum toxin. So you have what is called as the onabotulinum toxin A is something which is very commonly utilized for various kinds of facial pains. In this one, what it causes? It releases a neurotoxin. Botulinum is a neurotoxin. When it is released into the area, which is generally it works on the striated muscle. And then it helps to relax the muscle. But then there is another way how it is helping neuropathic pain. How does it help? So when you inject botulinum toxin, it travels both anterograde and retrograde along the nerve roots. Along the nerves, when it will travel through the microtubules and it will affect the synapses. Thereby, it changes the transmission of transmission of pain inside the nerves. And hence it is given in the transdermal into the subcutaneous areas. And when it is given in the subcutaneous submucosal areas, roughly about 75 micrograms into the area of neuropathic pain, it will give a significant amount of pain relief. It is relatively easy to do for everyone, and it will have a significant improvement for the responders. I would have to say not everyone is a responder for a botulinum toxin. And this is how these are the different sites, and these are chosen according to the nerve plexus that we have. For example, you've got the corrugator, procerus, frontalis, temporalis, and all these kind of areas where you have plexus of nerves sitting around. And when these areas are stimulated, even in the neck, you have paraspinal and the trapezius group. When these are stimulated and they travel along the nerves and reach the trigeminocervical complex that I have mentioned and cause a decent pain relief. Rather than giving Botox, there is another device these days which is called Kefli. This Kefli is a device which will work on the principles of TENS machine, and you give a 60-minute interval for an acute treatment of chronic refractory migraines, but you can also use it as a preventive device, a 20-minute device used every day to prevent the onset of an episode of migraine. So there are good studies which are backing it up. So that is Kefli. Similarly, vagus nerve can also be stimulated. When vagus is stimulated, when the vagus, this is connected to what you call craniosacral outflow is what we call it as for parasympathetic ones. They are present from the neck, reaching above into the spinopalatines and the stellates. So these autonomic nerves can be stimulated using this device, which is gamma core. In the gamma core, you are stimulating non-invasively, you are stimulating the vagus nerve. And good studies are supporting for use of cluster headache and migraine. And again, the same vagus can be stimulated in other devices. So these nerves are present even around the ear, pinna of the ear, and you can stimulate it around those areas. And you will even go through percutaneously, not just transauricular. So you can see there are so many nerves in the ear. Maybe you would have observed it in acupuncture, where when you activate some of the nerves around the ear, the whole body can be activated in acupuncture. Very similar kind of technology, but when you activate this, you get decent pain relief. So coming to the minimally invasive technique, we have what is called as a pulsed RF. What is pulsed RF? So this is radio frequency current. given in tiny pulses, maintaining a temperature of about 42 degrees, and then you deliver these repeated pulses to the patient. The nerves are getting some amount of energy, which will help to modulate the pain. So this is how it will work. And pulsed RF, I've published a paper on trigeminal neuralgia treated with pulsed RF. So basically, what you find here is when you deliver these pulses, even without causing an ablation of the trigeminal, you can reduce the pain. So this is what you are saying. From the baseline of about 6, it will drop down to about 2 to 3. So this is something which can be used where you cannot use RF ablation or balloon compression of the trigeminal. So now we are moving on from non-invasive or minimally invasive to implantable devices for the for neuromodulation for facial pain. Here we're talking about peripheral nerve stimulation. In the peripheral nerve stimulation, you can use either nerve stimulation or you can also cause field stimulation. The picture above that you are seeing is the peripheral nerve stimulation. You can see when the patient has got postherpetic neuralgia in one area on the top of the face, which is covering the supraorbital area. So you can stimulate it by putting electrodes in the supraorbital area. Similarly, when you have pain in the facial area, you can put subcutaneous electrodes and stimulate the field of that area. You are not specifically stimulating any particular nerve, but you are stimulating a field of painful area. So you put 2 electrodes on this particular patient to cause stimulation in that area. This is field stimulation. The problems with any of these things is lead migration. You can cause about 30% cases lead migration. Again, we published it on for occipital nerve stimulation. That's the number that we get. This is occipital nerve stimulation. Patients who have got occipital neuralgia or chronic refractory migraines, sometimes even cluster headaches, very refractory kind of facial pains and headaches, you can actually put and stimulate the occipital nerves. The electrodes are implanted on the back of the head. On the back, you can put 2 electrodes if it is bilateral headache. You can see on the picture, these octrodes, 8 lead electrodes which are put on the back of the head, and the nerves which are going on the scalp, they can be stimulated by this. It is connected to a device, and then electrical stimuli are sent. You can deliver this pain relief. So this is how an X-ray picture after the procedure looks like. So this is the occipital nerve stimulation. Similarly, you can do supraorbital stimulation, infraorbital stimulation, or auriculotemporal. So many areas, depending on the location of pain, you can target those particular nerves and achieve pain relief. This is auriculotemporal stimulation, as I was talking. Again, this is used for TM joint pains. And then it can also be used for migraine headaches. So various things are there for various indications for auriculotemporal stimulation. Yeah. Spinopalatine ganglion stimulation. Here you have a special and a new device which has been manufactured for spinopalatine ganglion stimulation, where you have episodic cluster headache. I hope audience would be knowing about the cluster headaches. This is one of those extreme severe pains which is present around the eye. Patients will have autonomic cephalgia kind of symptoms, which are like tearing pain inside the eye with swelling, redness, lacrimation, usually present on one side of the eye, and the pain lasts up to 3 to 4 hours, and patients will be scared to experience another episode because it is an autonomic cephalgia, autonomic headache. What we are trying to do here is, on the picture you can see there is an electrode which has got 8 leads, and then you put the electrode here, and then you stimulate the spinopalatine ganglion, which is the autonomic center for the face, and it has got a small IPG, which is an implantable pulse generator, and you have a remote in your hand. So when you stimulate this, the electrical pulses will control this extreme severe headache of the patient. Mind you, most of these patients do not get any response with any of the medications that we attempt, nor the interventions that we do. If nothing is working, this will be a very invaluable tool for them. Similarly, you have vagal nerve stimulation. So the vagus nerve, which goes from the brain down into the diaphragm and the abdomen. So this is how the vagus is traveling. On the picture, you can see. Usually, neuromodulation has been attempted for refractory epilepsy and depression in the 90s. But then now FDA has approved this for cluster headaches and migraines. Thereby, various varieties of facial nerves can also be treated by vagal nerve stimulation. But as you can see, it is a surgical procedure that involves using a device which will go around the nerve. It has to be wrapped around the nerve. The lead is wrapped around the nerve to get response. But as I showed you earlier, the gamma core can be used to activate the same vagal nerve from outside as well. So with the advancing technology, we are getting more and more options to treat patients' pain. And now we've got the trigeminal nerve stimulator. When you are stimulating the trigeminal nerve, you can see in the picture, it can reach out to the Gasserian ganglion, which is present at the base of the brain. And you can leave an electrode there and stimulate in that particular area. You can target either your ophthalmic branch of the trigeminal, maxillary, or the mandibular branches. Sometimes you can even activate the supraorbital, infraorbital, or the auriculotemporal, which are the sub-branches or the distal branches of the trigeminal. So, so many things can be done. Most of it is on the trigeminal. So we're coming to the end of these things. For facial pain, as I told you in the trigeminocervical complex, even though it is in the neck, you see, you are putting an electrode in the neck here, and when you stimulate this area, you are actually stimulating the trigeminocervical complex here. When the TCC is stimulated, facial pain can also be controlled. So this is something which has been found to be quite effective for cluster headache as well as for various other facial pains. So this is what we call it as understanding the pathophysiology as well as the physiology of human brain and the nerve nuclei. When you understand that, you can stimulate the neck, which is far more safer than stimulating into the brain. So still you can achieve good pain relief. And here in this particular case, what we are using is the high frequency spinal cord stimulators are available these days. When you use these high frequency stimulators, you can activate far bigger areas than normal stimulators. This is an advancement in neuromodulation that is coming up these days. So all you have to do is just whenever you get a complicated case, just reach out to us. So then coming to the deep brain stimulation, where there is a thin electrode is placed onto the thalamus, and then you are stimulating it. 2 more minutes. So in the deep brain stimulation, you identify the sensory target. What are your normal sensory targets? Sensory thalamus, lateral and the medial nuclei, which is present around the internal capsule, periaqueductal grace. And these electrodes, when they are placed in that area, as you are seeing here, and it is connected with a lead and an extension to the pulse generator, electrical pulses will be stimulating these areas. So a lot of advancements are coming in the DBS as well. Previously, as you know, it was used only for Parkinson's and some other general neurological conditions. But these days, we are using it for various pain conditions as well. And then you have motor cortex stimulation as well. Again, for central neuropathic pains, it is used for like post-stroke pain, multiple sclerosis, phantom pains, spinal cord injuries. We are using all these things. Yep. And coming to the end now, in summary, what I would say is there is therapeutic alteration of the neural activity by delivering electrical or chemical stimuli, or sometimes even various other technologies that you are using like light, magnetism, electricity. All of these things can be used to modulate your nerves, and thereby producing pain relief is what we can achieve. There are explosion of devices which are coming up. We just have to keep our eyes open and see what best suits our patients. Third, various understanding of these non-invasive and implantable devices and understanding their indications helps in selecting the ideal patients for us. I think that will give you a flavor of what neuromodulation for orofacial pain would be. Thank you.
Yeah, thank you, Dr. Vijay. And seriously, what you were saying that we need to refer you the cases. I have a lineup of cases now. So I am sure this kind of intervention and collaboration will definitely help our patients. And the basic idea for the whole conference or why we keep such sessions are so that we have better patient care modalities or treatment modalities with us. So thank you so much, doctor, for all the time. And I'm very sorry regarding the time. I'm sure you had some commitments and you have taken time from your busy schedule and our part here. Uh, Doctor, there are certain questions for you, and I would like you to visit the chat room and check the questions because there are certain questions which are really eye-opening answers. I'm sure they will get from you, but due to the time schedule, I will not ask them here. So you can just answer them in chat section.
In the chats. Okay, ma'am. Thank you very much.
And with that, I would like to call in our next speaker, Dr. Meenal. Dr. Meenal Chandra, are you there? Dr. Meenal? Dr. Vijay, can you stop sharing your screen, sir, so that Dr. Meenal can share her screen?
Okay.
Yes. Hello, Dr. Meenal?
Yeah. Am I off now?
Am I audible?
Yeah, Dr. Meenal, is there any device which is working with the same presentation is going on?
Yeah.
Okay, thank you, dear. Okay, Dr. Meenal Chandra specializes in pain management and works as a consultant pain specialist at IOPCON. I don't know.
IOPCON Pain Management.
IOPCON Center for Pain Relief and beyond. Dr. Meenal has worked as a pain specialist in some of the prestigious medical organizations of India. In a stint of 5 years as a pain specialist, she has treated over 1,000 patients with chronic joint pain and who has had pains and aches and treated them successfully. And during please mute. Others, please mute. Dr. Nurul. During a fellowship under Dr. Dara, a pioneer in pain management, Dr. Meenal gained invaluable experience, and she also specializes in treating a magnitude of complex cases of chronic pain conditions. Dr. Meenal, welcome to International Orofacial Pain Congress 2024. I'm Dr. Sonal Yerpude, and I think this is the first time we are interacting. And see, pain management is all we are looking for, and I'm sure Dr. Vijay has already covered up a major aspect of pain management through wherein our collaboration as a dentist and physicians can work through. But I'm sure your lecture is going to be also something like an eye opener for us, and we have one more referral number henceforth then with us. Thank you, Dr. Meenal, and your screen is visible and you can start sharing. I hope the other device is off now so that there won't be any echo.
Yeah. Thank you, Dr. Sonal. I've switched off my other device, and the screen is seen, right?
Yes. So please go ahead,
Yeah.
ma'am.
So just now, Dr. Vijay Bhaskar was talking about all the neuromodulation techniques and how things have been moving since ages until and now how many techniques are available to battle all these type of chronic pain. So here I am. I'll be talking about regenerative medicine. We have stepped a step forward from from the era of neurolytic blocks and nerve blocks to neuromodulation, and now we are in a place where we talk more about regenerative medicine. Here we are not only treating the pain, we are not only taking away the pain, but we are also trying to correct what is the disease. So I'll be talking about PRP therapy for TM joint dysfunction, and
So like I said, that we have moved from this era of nerve block to ablation to era of neuromodulation, and now this era of regeneration. Why? Because we all know that our cells, these are composed of lots of cells which have that potential of growth. So stem cell is quite popular, and it started basically for dermat and plastic surgery, and now we have come into musculoskeletal arena also. And TM joint is the pathology of temporomandibular disorders are not so uncommon. So after chronic back pain, TMD disorders are again the largest causing disability in population. So regenerative medicine into battling the TMD disorders have also taken a good path. There are lots of publications that have been published which favors in terms of PRP, in terms of how it decreases the pain, how it improves the disability, how it improves the movement, and how it prevents the further degeneration, especially in cases of osteoarthritis of TMJ. So again, just talking about the basics of the platelet rich plasma therapy, I'm sure you must be aware of PRP, because PRP is also growing so much into dental, for orofacial things, into neurology. So platelet rich plasma therapy basically is a part of regenerative medicine, where we extract the blood, and extract the cells from the patient, and through specialized technique we identify what is the concentration of the platelet that we are extracting, and according to the need of the patient we inject it. Now again, we have moved from an era of blind techniques to fluoroscopy guided and ultrasound guided procedures, so that the efficacy is improved, the complications have decreased. So again, anything which is image guided, done under proper supervision, is going to give good results. Can I have the next slide, please? So whenever I talk about regenerative medicine, which is a process of replacing, repairing, and restoring the normal tissue and function, but I always mention that there is a work in progress. It is something that it started somewhere in 1960s, but still there is a lot of work that needs to be done, and there are lots of things that is happening. 5-6 years back, when I actually got introduced with regenerative therapy. Since then, initially in my lectures I used to tell that we fall short of literature where we can actually talk much about regenerative therapy, but we have now come to era where we have more than around 15,000 publications talking in favor of regenerative medicine, and there are lots of guidelines approval coming from government, be it FDA or be it ICMR and DCGI, where these concerned authorities are giving us guidelines to do it in a proper way. But still there is a lot of thing that needs to be done. There is lots of guidelines that needs to become and that there are lots of protocol that needs to be formed to get a better efficacy. So I always say, for regenerative medicine, work is in progress, and we have a lot of work to do, and so awareness about this branch is very, very important. So, since 3 days, I'm sure we must be reading about the TM joint. So we all know that what are the, pathologies and disorders that we are tackling. Like I was saying, apart from chronic low back pain, the temporomandibular disorders is the second in the musculoskeletal pathology. And this figure shows that this needs to be addressed, and we cannot leave our patients suffering with, these kinds of disability, because again, this is something that we use on a daily basis. We need to talk, we need to eat, and all these muscles are continuously active. So we need to take care of it as soon as we diagnose, and as soon as the patient starts complaining of any kind of discomfort. So the TM joint disease comprises of around 5 to 12%, and in which the osteoarthritis of TM joint is around 18 to 85%. So this is the rate of this is the incidence prevalence of TM joint pathologies which need to be addressed. And the good part is that we have techniques, we have minimally invasive procedures through which we can actually give real good results rather than patient suffering.
So again, why we need to understand the pathology is because unless and until we understand what is the pathology behind, not we need to understand how much is the discomfort, what is the scoring of the pain, and what is the restriction of the joint, and how are the muscles, how are the supporting structures. So understanding the pathology before we plan any intervention, and especially when we plan PRP, is very important. So whether it is a traumatic injury, or whether it is hormonal changes that has caused this, or because of the age related joint changes are there, is there any displacement or disc degeneration, and when it comes to osteoarthritis, again, how much is the destruction and loss of articular cartilage, is there any osteophyte formation, synovial inflammation. So all those things are there which we need to see. And as far these pathology we identified, we also need to assess the patient, so that we identify what are the associated symptoms. Associated headaches, earaches, toothaches, nerve pain are really common. And a lot of time patients will have psychosocial factors like stress, depression, anxiety, somatization. So unless and until we understand everything, we address it in a holistic way, only PRP or only any kind of injection is not going to give proper relief or what we expect. So understanding the pathology is important. Noting the points, noting the score, the joint movement, the muscle strength, and how much is the joint movement, the mouth opening, deviation, restriction, everything has to be identified, has to be noted, explained to the patient, and then we can form a protocol. So now we need to be very clear on what are the aims that we are going to achieve. And like I said, that it has to be in a holistic way, not only PRP, but we also need to have some kind of pharmacotherapy, and some kind of physical therapy, exercises, lifestyle modifications. Everything is going to play a very important role, and that is why a holistic approach in any muscular disorder is very, very important. So here, what are our aims is, we need to, if first thing is pain. Patient always want their pain to be reduced. Then to improve the mouth opening and the jaw function, prevent the further progression of the joint disease, and then strengthening of the muscles and the other structures which is supporting the joint. So these are the aims, these we need to achieve as a target when we are dealing patients with TM disorders. Counseling of the patient for any, not only related to TM joint disorders, but to any musculoskeletal disorder. Especially in my practice, what we practice is regenerative and other kinds of interventions in pain management. The first very important thing is counseling of the patient, because most of the time the patient needs to understand what is my problem, how much is my problem, and the solution is going to come both ways. It is not always the doctor who is going to help them out, it is also the patient need to understand that what are the homeworks that the patient needs to do, and also how the family member and the people around them is going to help them out. So we need to explain the condition, explain the procedure, explain what will be the success rate and what can be the failure rates. And then sometimes maybe one sitting can help, sometimes we may need multiple sittings. And when we talk about PRP, it is regenerating, so we are trying to heal the whole process, and it is not an immediate relief that we are going to give to the patient. So we need to understand that we need to buy some time till you get the pain relief, and during this time what are the things that you need to do. And very importantly, you need to counsel the patient for the need of the rehab. And we always see, in my practice, we always see that how much the patient is compliant to do these rehab modules and lifestyle modifications, because unless they do, we are not going to achieve.
Yes, for some reason, I think Dr. Meenal is... Dr. Nooral?
Yeah, so sorry for this interruption. Am I audible?
Yes, dear, you're audible. And yeah, you can... Yeah, the screen is already shared, I guess, from the team. So continue.
Yeah, yeah. So unless and until we give them a clear picture And we explain them the condition and the treatment. Things are not going to work in our favor and also in patient's favor. And one very important thing that we practice at IOPCON is no giving false hope to the patient. We need to give them what are the proper solutions. We need to tell this is the condition, these are the options available. These options are going to have these side effects, these benefits, and let the patient choose for themselves. And no false hope, then only patient is going to be they are going to adhere with what we are going to tell. So very important counseling of the patient in any case whenever we are doing, especially for regenerative medicine, because it has a lot of controversy where there are lots of researchers which says that it may work, it may not work, and there are so many guidelines which are not properly formed, but still we do practice. So when we talk about PRP, patient should also know what we know as a doctor about the treatment. Very important is counseling of the patient. So again, now coming to what is platelet-rich plasma. Platelet-rich plasma is just a normal plasma with a concentration of something which is more than 2 times to be called it as platelet-rich plasma. And the ideal concentration that we want for for ideal scenario is around 7 to 8 times of the concentration from the baseline to achieve a certain kind of efficacy. And now, why we are choosing this platelet-rich plasma is because we know that there are lots of numerous millions of proteins and cells which are going to help in regeneration by proliferative cascade, by starting the healing and hemostasis cascade, and more than 30 bioactive proteins are going to help us in doing that. The active secretion of these growth factors by the platelets will happen within 10 minutes once we have injected it into the desired structure. And the 95% of the growth factors will be secreted within 1 hour. So within 1 hour, the entire process of whatever we are injecting will happen. And from there, when the cascade starts and the process of proliferation to the process of inflammation proliferation starts, it's going to take around 2 to 3 months. And in most cases, we have seen when we want good more than 70 to 80% success, it is going to take 6 months. So 6 months sounds easy from our side to tell, but the patient may not accept it. So we have to be very clear in telling the patients that it is going to take at least 4 to 6 months for you to get better relief. And to accept this treatment, we also need to tell them during these 4 to 6 months what they are supposed to do. Then only patient is going to be compliant with us. So, mechanism of platelet-rich plasma therapy is by its antimicrobial action, anti-inflammatory action, by its process of angiogenesis, healing, promoting the healing, regenerating the damaged tissue, restoring the function, and also the chondroprotective nature of PRP. So, like I said, PRP is going to take a longer time to give results, but because of its anti-inflammatory properties, we have also seen that the patient will have a quick pain relief, like in 2 weeks or 3 weeks. So that is because of anti-inflammatory action, but that is not the case in all the patients. So these are the mechanisms by which PRP is going to be helping in helping us in battling the degenerative conditions of any musculoskeletal disorder. So there are lots of commercially available PRP now, which is available, and there are what we prefer to do is a double spin technique. Also, we have growth factors where we don't need double spin, but this is a flow chart where I'm showing a double spin technique. This is by Remy Dr. PRP, where we take around 20 to 25 ml of blood and then we process it in their commercially available kit. And the first spin or the soft spin, which is around 2500 to 2800 RPM at around 7 to 8 minutes. And then this hard spin is around 3200 RPM for around 5 to 6 minutes. But these are, again, every machine will have their own protocol. And this, what I was telling about the RPM and the time, is the machine that we follow. But there are lots of machines available which will be which varies different in their RPM, and some are temperature compensated and some are not. So accordingly, we need to have those RPM settings and time settings done. But by and large, we do a 2-spin process where soft spin is going to first settle down all your RBCs, and in the second spin, we are going to get the platelet-rich plasma. We also have now practicing growth factors where we use around 8 to 10 ml of the blood, and then we allow it to settle down. And after some time, we give a single spin. And with the single spin, we get around 2.5 to 4 ml of platelet-rich plasma, which is also yield better results. So not much reports are there comparing platelet-rich plasma with growth factors. But people say, and there are literatures where they have said that growth factor have a little higher success rate as compared to PRP. But in my personal experience, I don't find any much difference, which should be stated that GFC is better than PRP or PRP is a little less efficacious than growth factors. So, like I was mentioning, we have so many commercially available kits, and every commercially available kit will have their own protocol. We need to follow that to get the best efficacy. So, the first one is by Dr. PRP, the second one is the Tricell, and the third one is what I was telling is the growth factor and the Ocenext kit. And these needs to be in accordance with the guidelines. So now the technique, the first very important thing is the consent. And second thing is monitoring the patient. We need anything into the joint, we have to be very sure that we are doing everything with aseptic precautions. And like I said, doing it under image guidance, whether it is ultrasound or CM, is going to give us better results with minimal complications or side effects. And I usually, whenever we do for TM joint, we always prefer, mostly we prefer doing it under fluoroscopy, because again we can check, we can ask the patient to open their mouth and close, and we can do a dynamic testing. And because it's a very small space, so we use a very small needle. First, we give local anesthesia using a 26 gauge needle, and then whatever PRP we have prepared, we can inject around, for a joint like TMJ, 1 to 2 ml of PRP is good enough to take care of the joint degeneration. And again, like I said, monitoring the patient is very, very important. So very basic technique, but has to be done everything within aseptic precaution. So again, this is the image that we have taken, and this is under fluoroscopy guidance. I prefer doing it under fluoroscopy guidance because, again, ultrasound may sometimes, it will be difficult for us to understand, but those who are skilled with ultrasound can do it with better efficacy. But in my personal choice, I prefer doing it with fluoroscopy. So we can see under fluoroscopy, we are in the third image, we see our needle being placed. And with the dynamic testing, we can ask the patient to move or open the mouth, and we can see whether the needle is into the joint or not. So again, this is 1.5 ml of PRP that we are going to inject. First, we give a dye. We confirm that we are correct. And again, dye, when we are injecting, we have to be sure that we are injecting only very, 0.2 to 0.3 ml of dye, because again, the joint may be filled with dye. So a very small amount of dye just to confirm, and then followed by PRP. Now, very important is the post-procedure care. So we need to understand that what are the things that we need to make patients aware of. So we need to tell to, if we are doing it on the right side, so we need to tell the patient that, do not chew from the right side, or eat soft food from the, take some soft food for a couple of weeks. And importance of how important is the activation of muscles, because these muscles are giving support to the joint. So very important that we keep on activating and strengthening these muscles. And post PRP, there can be some kind of inflammation and soreness. Patient can feel discomfort. Patient can feel pain for initial 2 to 3 days. So ice application is something that we try to tackle post PRP pain with ice application. It works wonderful. So for every patient of PRP, we tell that compulsory you apply ice for 2 to 3 days. Then again, after 2 to 3 days, when the patient is completely fine, when there is no soreness, the patient does not complain of any pain, that is the time when we'll start with rehab. And rehab, the aim is to increase the range of motion. So to increase the range of motion, to activate the muscles and strengthen those muscles, and very important are the post care after the procedure. And contraindications are patient refusal, definitely thrombocytopenia. Patient is on an anticoagulant therapy, we need to stop. Any kind of active infection, tumor and metastatic diseases, and pregnancy are these points where the patients we contraindicate the use of PRP. And these are few literatures which have stated the positive effect of PRP on TMJ. It has decreased the pain, it has improved the range of motion, it has improved the quality of life. So very wonderful technique where, minimally invasive way, we are giving good relief, not only with respect to pain, but also we are preventing the further damage, and we are correcting the pathology of whatever the patient is suffering with. So this is again another article which suggests in favor of platelet-rich plasma therapy. So we are no short of literature for any muscular disorder for platelet-rich plasma therapy, and TM Joint has again made it, is assured that PRP is going to help you. Now, why we need to choose PRP is because, it has a scientific underpinning. It's relatively easy to do, non-invasive in nature, no side effects, no complications, and there is the well-established safety record. That's something which does not have any side effects at all if we use all the protocol. So this is something that we can always offer to our patients with the best results. But again, the most important thing is the patient choice. Very important that, how not all patients will be suitable for PRP. So we have to be sure that, whenever we are offering PRP, we assess the damage, we assess the patient's need, and then offer them PRP. And the take-home message is very important for successful treatment is patient selection, multidisciplinary holistic approach. The result will depend upon how good you're doing the technique, the preparation, and also how good the patient is compliant to us. Image guided gives the best result. Definitely, we need to explain the do's and don'ts. And when compared to other techniques of steroids and hyaluronic acids, the literature are in favor of PRP. So the take-home message is holistic approach with PRP is going to give wonderful results with TM joint disorders. So these are my centers. We have currently 5 centers, 3 in Hyderabad, 1 in Chennai, and 1 in Bangalore, 2 pain management center and 1 sports center. And we are again expanding to the entire India, and we are also looking for collaboration. So those who are interested in expanding this arena of regenerative medicine and pain management, they can join us, collaborate us for better service to the patient and the mankind. Thank you so much.
Thank you, Dr. Meenal. It was really enlightening, and I wanted to know about this PRP therapy. And thank you for enlightening. In fact, one of our paper presentation also was there on the same topic. And I'm happy that new techniques have been incorporated in our practice so that things are much more better for our patient healthcare. So thank you so much. And there are certain questions. If you can just check the chat box, if there are any, just answer.
Right.
Yeah, and to
Sure,
wind
I'll do
the session, we have Dr. Sumit Gupta with us, who is going to be talking about oromandibular dystonia. In fact, it is more like a summary of the whole session, 3-day session of Orofacial Pain Congress. So, Dr. Sumit, the stage is all set for you. I need not introduce you again. So, please start sharing your screen, Doctor.
Yeah, sure. I hope my screen is visible.
Yes, you can go to the presenters mode.
Yeah, okay.
Thank you, Doctor.
Okay. Yeah. Yeah. Good evening, everyone, and hello once again. So we are coming to our final presentation of our 3 days excellent webinar on orofacial pain. And I'm sure by now a lot of audiences who are present for all the 3 days would have started their journey as an orofacial pain specialist and would have started to think differently, removing their dental hats, putting on their medical hats, thinking like true physicians, and even would have gone back in time and started to think about what they did for their patients and what they shouldn't have done. We saw some excellent presentations in these last 3 days. A lot of entities were covered by a lot of speakers who are present. And we end up this talk with one more entity which orofacial pain encompasses, which is a movement disorder known as oromandibular dystonia. So let's see how interesting these movement disorder known as oromandibular dystonia can be, and how perplexing it can be for dentists, and what we can do for these patients. Don't know, my slide is not moving. Okay. I'll be putting on some videos. You will be seeing how interesting these cases were, and then I'll be talking in brief about what these patients were in the coming slides. So just have a look at, and look carefully what these patients are doing. And this is how they had come to our clinic, reporting with different movement disorders. I'm sure a lot of you would have encountered these patients in your practices, and a lot of these patients are often misdiagnosed. They undergo months or years of useless treatments for malocclusions, for TMDs, for myofascial pain and dysfunction. And they are even labeled as psychogenic and referred to psychiatrists. Why are these important to us dentists? Because clinicians, including dentists, must be able to recognize and become involved in the multidisciplinary management of these rare disorders, because such disorders and behaviors can cause considerable pain, especially headaches, jaw pains, jaw dysfunction, can interfere with normal physiological functions like talking, chewing, swallowing, and even facial expressions. One of the most common movement disorder which we dentists encounter is sleep bruxism, which earlier used to be considered as a parafunction. No longer to be considered a parafunction, it's considered to be a movement disorder, something which is going on in the CNS and causing the movement disorder of sleep bruxism. I'll be talking on a disorder which is again a movement disorder, somewhat related to sleep bruxism, but in a way quite different as well. So whenever we are talking about movement of a muscle, we see this gentleman, everybody is very well is aware of him. Two groups of muscles are involved. One are the agonist muscles, the muscles that are contracting and moving the body part. And the other group of muscles are the antagonistic muscles, which relax or lengthen and help to bring back the body part to its original position once the movement is completed. So it's excellent coordination between these two group of muscles which takes place. And these are very skilled movements which we see on the screen. But whenever there's a loss of coordination in between these two group of muscles, for reasons which we'll be seeing in our presentation, a movement disorder can develop. So what are movement disorders? Again, just a minute. Okay. Movement disorders, they are, my slides are not moving. Okay. They are defined clinical sign and symptoms patterns, or also known, can be syndromes as well, which alter normal functional movements. The movements can be too fast or too slow. They can be too frequent or infrequent. They can be too powerful or too weak, too rigid or too flaccid, overly deliberate, or maybe spastic. They are capable of affecting all voluntary muscles in the body. They can result from a CNS neurological disease, or they may be a result of a pathology in the basal ganglia. So if you see here what a basal ganglia is, it's a nuclear gray matter structure which is composed of 5 structures: the caudate nucleus, the globus pallidus, putamen, the subthalamic nucleus, and the substantia nigra. The principal role of this of the basal ganglia is to process motor commands and to execute complex motor activities. So if there's any failure in one of these motor components of the globus pallidus, a motor disorder can develop. I was talking about the cortex in the morning, the somatosensory cortex, which was controlling pain sensations. Now we are focusing on the motor cortex, which is controlling the motor movements of the body. It can be movement disorders. They can be considered as a psychophysiologic, noxious habit or a neurotic disorder, and they can be classified into hypokinesia, which is a slowing of the movements, and it can be either bradykinesia, akinesia, or hypotonia, or they can be classified as hyperkinesia, which is excessive movement of the body of the muscles, and they can be either tics, myoclonus, chorea, as well as dystonia. So what is dystonia? It's a movement disorder, the third most common movement disorder after essential tremors and Parkinson's disease. It is characterized by co-contraction of the agonist and the antagonist muscles, which I was just talking about. And this can result in abnormal, often repetitive postures or even uncontrolled movements or both. They can be sustained or intermittent, and intermittent contractions may occur spontaneously or in a task-dependent manner. They can be typically patterned, they can be twisting or maybe tremulous. They can be initiated or worsened by voluntary action and can affect any body region and thus has varied manifestations. How can we classify dystonias? Based on the clinical characteristics and based on the etiological factors involved. This was a classification which came up in 2013, and a genetic component was added in 2022 to know the movement phenotype. So according to the clinical characteristics, they can be classified according to based on the age of onset. They can be either infantile, childhood, adolescent, early adult, or seen in late adults. Based on the body distribution, they can be either focal, where it affects only one part of the body. It can be segmental, where two contiguous body parts are affected. Can be multifocal, which progresses, which two or more distant body parts are affected. It can be generalized, which progresses from one part to another and progresses towards progresses in the body, or hemidystonia, which can be at least a half of the body is affected. Based on the temporal pattern, these can be either persistent action or task specific. Certain actions like writing, even typing, dancing, cycling, running can precipitate this. They can be a diurnal fluctuation, or they can be paroxysmal, and also can be classified based on any coexisting clinical feature. They can be isolated or can be combined with any other neurodegenerative disorder such as Parkinson's. And based on the presumed underlying etiology, certain identifiable nervous system pathology might be present, and they can be either inherited, acquired, or idiopathic. This picture shows us the common locations of dystonias. It can be seen in the hands, affecting the extremities, affecting the neck, where it is cervical dystonia. It can affect the pharyngeal muscles, causing spasmodic dystonia, oromandibular dystonia, as well as blepharospasm. We'll be seeing what blepharospasm is. So in talking about oromandibular dystonia, it's a focal dystonia affecting the motor aspects of the cranial nerves 5, 7, and 12. Dystonic involvement of various jaw and mouth muscles, including the lips, tongue, corners of the mouth. Most dystonias are diagnostically challenging, mainly because they have varied presentations as well as severities. Triggers may be very hard to be identified, and orofacial movements may be quiescent during periods. And consequently, they may be mistaken with other disorders like TMDs, dislocations, even hemifacial spasms, and psychogenic disorders. The uncontrolled muscular contractions frequently leads to muscular overuse, which results in jaw tension, pain, spasms, and even bruxism. Functions of speech, facial expression, chewing, and swallowing are affected, and activation of the muscles through these activities results in symptomatic worsening as well. So what is the prevalence of OMDs? It has a wide variability in prevalence, influenced by race as well as in ethnicity. Approximately 70 per million people are affected, women more than men in the ratio of 3:1. The typical age of onset is in the 6th decade of life, varies between 45 to 75. and the age appears to be an independent risk factor for OMD. What is the etiological factors? It can be either primary, idiopathic, where there's no known involvement of the CNS or any CNS pathology, brain lesion or tumor is in. It is one of the most common ones. And secondary, the most common form of secondary dystonia can be tardive dystonia, which is secondary to medication usage. It can be caused by neurodegenerative disorders like Parkinson's, Wilson's disease, Huntington's disease, and even multiple skeletal atrophy. Brainstem lesions and cerebrovascular diseases can cause them. Also, traumatic brain injuries, fractures, and even trigeminal nerve deafferentation can cause. And even a genetic involvement is seen with DYT1 gene involvement. Oromandibular dystonias have also been seen to be precipitated or caused by certain dental procedures like infiltrating dentures, tooth extractions, endodontic treatments, gingivectomy and apicectomies, crown and bridges, implants, and even TMJ arthroscopies. What are the triggers for oromandibular dystonias? All the physiological functions of our body, like speaking, chewing, yawning, swallowing, daily activities like driving, reading, playing, or looking upward or downward, and even stress can precipitate oromandibular dystonia. What are the signs and symptoms seen? There's unconscious, forceful opening and closing of the jaw, or chewing-like movements. There can be twisting of the lower jaw in front or sideways, uncontrolled and repetitive movements of the tongue, lip sucking or smacking or pursing of the lips, retraction of the corner of the lips, rapid blinking of the eyes or forceful closure of the eyes as seen in Meiggs syndrome. We'll just see a video of this. Grinding or clenching of teeth, damage to the teeth, failure of restorations and implants, frequent oral ulcerations, especially seen in closing mouth dystonias, open locks, trismus, dislocations as seen in TMDs. There can be difficulty in chewing and swallowing, spasmodic dysphonia where there is a strange and whispering voice, decreased secretion of saliva, tightening of muscles of the nose and face, breathing difficulties, involuntary movement of the neck, headache, facial muscle pain, and fatigue. And one of the main distinguishing features from sleep bruxism, most of these masticatory muscle spasms disappear during sleep. And on the contrary, sleep bruxism, the onset is seen during sleep. Of course, there is awake bruxism as well. But if you are comparing sleep bruxism with with oromandibular dystonia, it disappears during sleep, whereas sleep bruxism starts during the sleep. What are the consequences of oromandibular dystonia? It can cause difficulties with speaking, chewing, and swallowing, weight loss, severe social impairment and withdrawal, difficulty in performing daily activities, a reduced quality of life, can lead to stress, depression, and other psychological issues. How do we classify oromandibular dystonias? Based on the locations, they can be classified as jaw opening, jaw closing, jaw deviating, lingual, perioral, or pharyngeal. So identifying the muscles involved is the basic and of paramount importance to diagnose the kind of dystonia and to institute the correct management. And they can also be classified based on the etiology, whether they are drug-induced, idiopathic, neurodegenerative, secondary to brain disorders, or peripherally induced, like because of trauma, infections, and even dental interventions. So what are the subtypes of OMDs according to the muscles involved? So in jaw closing dystonia, the elevators of the mouth, temporalis, masseters, and medial pterygoids are involved. Jaw opening, the inferior lateral pterygoid and the submentalis complex muscles like the mylohyoid, digastric, and geniohyoid are involved. In jaw deviation, the contralateral inferior lateral pterygoid, ipsilateral medial pterygoid, as well as ipsilateral temporalis are involved. In lingual dystonia, the genioglossus. Perioral dystonia, a lot of oral muscles like ranging from orbicalis oris, zygomaticus, mentalis, levator and depressor anguli oris, as well as platysma are involved. And in pharyngeal dystonia, the stylopharyngeus, salpingopharyngeus, as well as palatopharyngeus are involved. Here we see a case of jaw closing dystonia. This was a case brought to us by Dr. Saurabh Jain, who attended one of our courses. It is a case of jaw closing dystonia. If you'll just see what this patient is doing, it started with the tongue biting, and just to safeguard the tongue, the patient started to clench. This is what the patient feels, that he was clenching to safeguard the tongue, but later he recognized that even when he started eating, trying to open his mouth to put a bolus, he was not able to open, and involuntarily the muscles were contracting and the mouth was not opening properly. He saw numerous dentists, orthopedicians, swallowing and speech specialists, didn't get any relief from this, and his symptoms have progressed a lot since then. So you will see how forcefully he's clenching his jaw. Even while speaking, he constantly keeps on clenching. So this is a jaw closing dystonia. Here we see a case of jaw opening dystonia with blepharospasm, which is known as Meiggs syndrome. You see how she's opening her mouth, and her forceful closure of her eyes, the ocular muscles are involved in this. There's rapid blinking. And here we see a case of jaw closing dystonia with blepharospasm. This is again Meiggs syndrome. So this is jaw closing and this is jaw opening dystonia. Here we see another case, which is a case of jaw opening dystonia coupled with jaw deviating dystonia. So we'll see what this patient is narrating. This was a very tricky case because the patient, along with jaw opening, had a jaw deviating dystonia as well. So if you see, when he opens his mouth gets deviated towards the left, and he feels that it's happening involuntary. Something is happening, something is pulling his jaw towards the left. And he also feels a stretch in his throat muscles. Whenever he starts to speak, it's triggered. So he has learned not to speak much to avoid all these involuntary movements from happening. Okay, lingual dystonia. This is one of a rare oromandibular dystonia involving tongue protrusion, curling, and cause excessive drooling. Most commonly occurs while speaking, can cause problems with speech, eating, and swallowing. It is substantially disabling and socially embarrassing. Patient experience difficulty in feeding and wearing dentures because of the excessive dystonic movement of the tongue. It tends to push the food out, and even dentures are thrown out. And severe forms may obstruct upper airways, and we have seen patients who require intubation and even respiratory support. And if it coexists with jaw closing dystonia, tongue biting may cause severe lingual mutilation. Moving on to our next entity, which is tardive dyskinesia, which is another oromandibular dystonia secondary to medication overusage. It has an insidious onset, relatively rhythmic, repetitive, and stereotypic movements secondary to neuroleptic medications. Repetitive jaw movements, we can see tongue protrusion, puffing of the cheeks, lip smacking, lip puckering, or even lip pursing, which is known as orobuccolingual tardive dyskinesia. We'll be seeing a case in the next slide. It can extend to other body parts, including trunk and the extremities. Here, this is a case which came to Dr. Nilesh Deshmukh, one of my close friend and colleague in Aurangabad. This patient was undergoing treatment for depression. She was on antipsychotics for the past 4 years, and she started experiencing these weird involuntary movements, which had progressively increased. So you see how she brings her tongue out, there's puckering of the lips. She started developing pain in her TMJ because of the constant movements, for which she consulted a so-called TMD specialist, who, thinking it to be anterior displacement, did arthrocentesis for this case, went on to give her a splint. Patient problems worsened. She threw the splint and she was there with us seeking a relief for her problem. So as I said, tardive dyskinesia can be caused by a lot of medications, especially typical as well as atypical antipsychotics, certain antiemetics, particularly metoclopramide, calcium channel blockers like cinnarizine and flunarizine, SNRIs like duloxetine, SSRIs like citalopram, paroxetine, and fluoxetine, certain tricyclic antidepressants, and lithium. So that's why taking a detailed history, including past and present medications, even including over-the-counter medications, if the patient is taking any vitamins or supplements they are taking, is of paramount importance. There's something known as geste antagoniste. These are sensory tricks which patients learn themselves to cause neurosensory distraction, and this may help to ameliorate OMD symptoms temporarily. They do not seem to provide long-term benefit, but mostly requires actions that interfere with normal functional activities. It was first introduced by a French neurologist, was documented by Meg as geste antagoniste. The concept is it's a conservative treatment modality which might not work for everyone, but it can provide partial relief. Oral appliances have shown to be useful, especially when they mimic patient sensory tricks. We give certain appliances to be worn, full coverage appliances, which can help to mimicking the sensory tricks for the patient. Sensory tricks may work better for jaw opening dystonias rather than jaw closing dystonias. What are the common sensory tricks patients learn themselves? They start to learn to clench forcefully, pressing their teeth or the lips with fingers, touching the tongue on the roof of their mouth, chewing gum, or holding or biting onto objects such as a pencil or a wooden spatula, and even singing and humming. So all these help to distract the mind and thereby giving temporary relief from these excessive movements. So how do we diagnose these cases? A complete dental and medical history, including past and current medications, which I just said. A thorough physical exam, looking at the patient. As Dr. T used to say, we observe the patient as the moment he enters our operatory, looking for his gait, demeanor, posture. If there's any sign of subtle dystonia, and if there are any focal neurological signs. To aid these, we go in for neurophysiological tests like EMG, polymyography, accelerometry, as well as electroencephalography. MRI in cases where neurodegenerative disorders are suspected. Serum celluloplasmin levels, and a slit lamp exam to rule out Wilson's disease. Wilson's disease is an inherited disorder where there's excessive of copper, which gets deposited in the brain, liver, as well as in the eye. The slit lamp exam helps to rule out something known as Keisha-Fleischer rings, which are seen as brownish deposits around the cornea of the eye. And even genetic studies help in the diagnostic evaluation. So what about the management? So the management depends on the patient's age, the diagnosis, the dystonic muscle involved, and it is tailor-made, including pharmacotherapy. A lot of classes of drugs can be used. The anticholinergic drugs like diphenhydramine, clonazepam, baclofen, which is a skeletal muscle relaxant. Dopaminergic drugs like dopamine, benzodiazepines like diazepam. Botulinum, a neurotoxin, which is considered to be the first line of therapy. Dr. Vijay was discussing about, he was discussing it for pain management. Here we are discussing for a motor movement disorder. Muscle afferent blocks, behavioral modification, rehabilitation, dental and surgical appliances, deep brain stimulation. Again, Dr. Vijay had discussed that, as well as focus ultrasound. So Botox for OMD is considered to be the first line of treatment, causes chemodenervation by blocking the release of acetylcholine at the neuromuscular junction. Thereby signals to the muscles are temporarily blocked, and hence preventing repetitive muscular movements. Jaw closing dystonias tend to respond better to Botox than jaw opening or mixed dystonias. It is found equally effective in tardive as well as idiopathic oromandibular dystonias. What are the commonly muscles which are injected? Depends on the type of dystonia. For jaw closing dystonia, the elevators are injected. Jaw opening dystonia, the inferior lateral pterygoid, as well as the submentalis complex of muscles are injected. For jaw deviation, the inferior lateral pterygoid of the contralateral side and ipsilateral temporalis and medial pterygoid. And for lingual dystonias, the genioglossus and the hyoglossus. So here we see the common injection sites for the temporalis and the masseters. Here, obviously, this is done under EMG guidance, ultrasound guidance for injecting the lateral pterygoids. Either an intraoral approach or an extraoral approach can be used. This is a case of jaw deviating dystonia, where the medial pterygoid on the ipsilateral side and contralateral side inferior lateral pterygoid was injected, again against using ultrasound guidance. A case of open mouth dystonia, where the digastric muscle is injected, and Botox for lingual dystonia. So here there's a submandibular approach can be used or an intraoral approach. Botox obviously comes with complications causing dysphagia, dysarthria, can cause facial swelling, muscle weakness, difficulty in chewing, and often patient becomes resistant to the therapy and thereby repeated injections are needed. For OMDs refractory to medical management, surgical management can be used. Selective peripheral denervation, deep brain stimulation, which Dr. Vijay was talking about. In oromandibular dystonias, deep brain stimulation targeting the globus pallidus is done. It has its own complications causing intracranial hemorrhage and infection. So a multidisciplinary approach using occupational therapist, a speech therapist, physical therapist, behavioral therapist, and a psychologist is very important. What are the lifestyle modifications needed? The patients need to learn the sensory tricks which can avoid these movements. Use electric toothbrushes to maintain oral hygiene. Bite guards in case of lip and tongue biting. Physical exercises, meditation, and yoga to manage stress, as Dr. Shefali had covered in the previous lecture. So what are the key learning points? Oromandibular dystonia is characterized by sustained or repetitive involuntary movements of the jaw, face, and the tongue. A thorough history, including a detailed history of past and current medications, is very important, followed by a thorough clinical exam. Commonly involved muscles need to be identified, and when they are palpated, they are usually tender and hypertrophied. OMDs can be successfully managed using multiple modalities with a tailor-made approach. And Botox is one of the first line of therapy for it. Thank you so much for the patient listening. If there are any questions, I'm happy to take them now.
Yeah, thank you, Dr. Sumit, and it's always a pleasure to listen to you. And thank you for summing up this whole orofacial pain conference. Actually, I'll just check if there are any audience questions, but there are certain questions which I would like to ask you. Out of them, the first thing is that how can we diagnose OFP? But then I'm sure, does it require an MRI or any techniques as such? Like,
yeah, you mean for the OMD, for diagnosis of OMD? Yeah, I think as I showed in my slide, I mean, the first thing is the detailed history taking, ruling out if is it secondarily caused by any drug overuse or medication is causing it, followed by a thorough clinical exam. Also, we do neurophysiological tests like EMGs, polymyography, and electrophysiology. And if we are suspecting any neurodegenerative cause like Parkinson's and Wilson's and all, then we go for MRI. So MRIs will be helpful in diagnosing if any secondary cause is involved in it.
And do you think it is curable?
Wow, that's a great question. I mean, research is definitely ongoing.
And we manage, orofacial pain is all about managing.
Absolutely, yeah, exactly. As we have always been discussing that the best we can do is to manage our cases, especially oromandibular dystonia. If it is secondary to medication usage, it can be managed because we can identify the drug involved, change the drug, substitute it, reduce the dosage. In that way, it is curable. But if it is secondary to like Parkinson's, or it is secondary to any neurodegenerative disorder, I think symptomatic management is what is achieved best.
If you could enter the chat box and answer some certain questions are there, then just if you could wait and answer till that time, I'll give my vote of thanks to all the participants. And
yeah, sure.
Ready? Yeah, with Dr. with your permission, Dr. Nurul, I think we should call the conference done.
Yeah, of course. Yeah.
Okay. Yeah. So I would like to take this opportunity to thank each and everybody who were part of this conference. Conference like this, which spans over 3 days, it is not a one-man's job. It's a team effort, and it starts with the person who was the backbone behind it, Dr. Nurul. He was the one who organized everything and charted out some things for me to fill the spaces in for speakers. So then came the job of me hunting for the speakers. And mind you, I just took I think 24 hours or 48 hours and my speaker list was done because I had to just message them and they said, yes, we are there. We are a team, Sonal. We are there. So it was like within my job that, and I thought my job is done. And that's when the job began, and I was taken aback by seeing what can be the whole, how to frame this whole conference and how to plan the scientific sessions, and quite an overwhelming experience, I would say. And to top it all, we got in touch with Dr. Davis Thomas. He was gracious enough, and he totally humbling experience for me because he said, okay, I'll be the mentor, I'll be the patron here. And it was such a guiding light, I would say, that it totally changed the whole format for me, because I had somebody who was there to help me around, who was there as a support system. And then my friends joined in. I mean, I can name them, all of them are by now are my friends. Karthik, Jaimin, Akshay, Sumit. I call them by name because they are my friends now. So they joined in and they literally handheld me also. At times I was crushed. At one day I was literally down, and Dr. Sumit was like, don't worry, it will work fine. A website will go out tomorrow. And that, those encouraging words, that makes a lot of sense. And when I had a personal trauma at home also, and there were messages flooding in, Sonal, Tukkar, we are there. And this makes this gives that courage to carry forward such a big responsibility. And with that, I would really thank each and everybody who were a part, who are a part, and they're not just speakers, they are a part of this whole conference. And without their support, it was not possible. Each and everybody who participated, and most importantly, the audience, the participants. Today, now also 42 of them are in the room, and many of them are still watching on YouTube and the website also. Website, the numbers have gone in thousands, and it was overwhelming. So all in all, totality, thank you so much. It is not possible to achieve something like this without the audience. As I always say, audience is the heart and soul of a conference. Speakers and students, it's mentors need the students, students need mentor. So thank you so much for being such patient listeners. And it is 8 o'clock and I'm sitting here since 9 o'clock in the morning. And all of them are also sitting with me and listening patiently. Thank you so much. And actually, the list goes on and off, and it can keep on continuing. I have shared my number. Henceforth, even if there is any query, please get in touch with me in case if I can help. Whatever little bit I know, I will be able to help you all. And thank you everybody who has helped me. Even if I have missed out on certain names, please don't mind. Consider it as a flaw on my side. But I'm really thankful to everybody and the team, Dr. Nurul's team, for that page. Actually, I'm a taskmaster when it comes to perfection. For me, a straight line has to be a straight line. I cannot accept it as anything else. So they literally took into that flaw of mine, that she has OCD and she needs everything perfect. So that the whole idea was that this conference has to go perfect. So thank you for bearing with me. And it was not possible without the technical team who were there with us. So thank you everybody. Thanks to the audience, the patron, and most importantly, our jury members, Dr. Ratin Das and Dr. Rathi, who were a participant, who helped the participants, actually handheld them. And it was very overwhelming to see Dr. Ratin Das participating as if it is his home event. So thank you, Dr. Ratin, for everything. And thank you each and everybody. And I'll hand over, with this, I conclude International Orofacial Pain Congress 2024 on my side. And I hand over the responsibility to Dr. Nurul now for future. Thank you so much, Doctor. Thank you, everybody.
Congratulations, Sonal, madam.
Congratulations
to you for organizing such.
Dr. Sonal,
Sure,
could you
Dr.
engage for more minutes? There is
Yeah,
a very azan is happening very close to my area. So could you please
yes,
continue? And I'll join in 30 seconds. 30
yes,
seconds.
that I consider as a blessing. Could not have been better then. Dr. Abhay, thank you so much because you have been an active participant. And since Dr. Abhay, you made appreciate that if I calling out one name as my favorite would have been a little unjust for everybody. So I'm distributing the goodies to all the participants who are connecting with me. And Dr. Abhay, I have shared my number. If you can connect with me, I will give you the goodies. But nevertheless, you were a champ audience, I would say, who made the session so
Thank you.
exciting, and Dr. Sandeep also. And then many of them are there. I mean, if I try taking the names, because I'm very bad with names. So, but all the participants who were there till the very last minute, now also they are there. Each and every one of you deserve that goodie bag, because that is a foundation by which that is like a Bible for us, what I'm going to be distributing. So I'm sure that has helped me in many times, many a times, because I go back to those books a lot. So if at all it helps you, even 1%, the purpose of this conference is achieved, and me distributing those goodie bags has achieved a purpose. So thank you so much, and thank you everybody. I'm receiving messages of great work, but I will tell you one thing, it's a team effort. So thank you so much.
Thank you very much.
Yeah, and the chat session is something I think I should frame this chat session, because this is an overwhelming moment for us. So thank you so much. I'm receiving so many chat messages from chat session also saying that they enjoyed the conference, and it's an overwhelming moment for us now. And with the due respect, God is also on our side. Azan at the right moment. Couldn't have expected or anything else more than this. Thank you so much.
At the end, we have blessings that azan is happening. In the vote of thanks. Okay, so God Almighty is also thanking us and giving thanks to us.
Yes.
So with Dr. Sonal has done a tremendous job, very tiring as well. But look at her face, look at her energy. Yes, so overwhelming experience really, and how a woman can manage for sitting uh, 10 11 hours in one place and handling 40 speakers across the globe. It's really amazing. It's can't be a one person job, but really she did. She's one man army, one person army rather. Yeah, and Dr. Sonal, she is dentist. Apart from that, she is a responsible mother. She is a responsible wife, daughter, and what I would say, if you watch the updates of her WhatsApp, you will see the birds chirping, and she's a nature lover, and she's also a globetrotter, traveling very much, accompanying with her husband. We are thankful to Mr. Samir Yarkude as well, because without her help, it can't be happen actually. Samir helped us a lot to spare, he have given Sonal to us. So that's
So
why
he was happy that I was away from the whole scenario in this conference. And actually, this conference also took me away from the trauma, personal trauma. So I was engaged into this. So mentally, I was little at peace that it took away that burden. Thank you
yes,
so
yes,
much.
yes. So I think Samir is with you, or is it somewhere else?
No, he is in a meeting.
Okay.
He's attending a meeting separately.
And your daughter? Is
She's out. She's right now giving her semester exams for her engineering. So she's also busy. So maybe in some other time I'll make them meet.
Sure. I'll try, make her live as well. I want to, meet her as well.
Thank you.
And this is the front end actually. Sonal, you are over long last say 30 hours you are seeing the face of Dr. Sonal and all speakers and all, but there is a huge effort which is done on a back end, behind the screen, and there is a huge team, those who are working tirelessly to make this happen. And
I'll take not much, 5 to 6 minutes because you are there. So we'll conclude before 8 actually, because Sonal has some guest in his house, and she has invited someone for a dinner. So I won't disturb Sonal, so that at least she has a refreshing dinner at the end with the tiring marathon 3 days. First of all, I would like to thank our marketing head, Mr. Sayyad. Why I'm thanking Mr. Sayyad? Because this time we have started one initiative that we started visiting college personally. So he with one more team member went to 9-10 colleges in Delhi NCR, because we are based in Delhi. So my team went to meet the chairmen and principal dean of these colleges. He went to Manav Rachna College, Faridabad, then SGT University, Gurgaon. Then he went to Faculty of Dentistry, Jamia Millia Islamia, the government college. Then Maulana Azad Institute of Dental Sciences in New Delhi. Then he went to Sharda Dental College, ITS Dental College, Santosh Dental College, Sudha Rustogi Dental College, and Indraprasth Dental College for meeting them, and we are also giving them subsidized registration, because we are meeting them, and we have just given 99 rupees for students and 199 for faculty to make it more engaging and all. Then we have a customer relationship team headed by Rehan and Ahmad. There are two persons who keep on emailing, calling to people. Then we have a cable management team, Rayan. Rayan is always handy with the speakers. He keep calling them, taking their what I would say, their profiles, informing them about the Zoom link, etc. Then we have IT head Israfil Khan. He is with us for a long last 3-4 years here with us, and he is doing all the this all IT thing is being done by him only. Then we have telecalling team who keep on calling to the people, letting them know how to enter, how to go to the Zoom, how to fill the form, etc. We have Shadan, we have Shama, Zareen, Dia. They are in our team. They keep on calling to the all people and keep them informing. Then we have Khalid. He is making our this brochures and all, because Dr. Sonal is very perfectionist. He keep on disturbing me in late 12 night or 11 night, and he is not satisfied. I keep on changing the brochures. We are creative. He is not satisfied with theme as well. So theme is very important. Keep it blue, keep it gold, keep it, he keep on changes things and all. And he keep active my, the Khalid, my designing team, and he keep changes on website as well. And he want urgent, work actually. So he keep all my resources on toes, so that they are delivering on time. So thanks, Sonal, for guiding all our team. I am thankful to my parents, my mother, my mom, my father, who nurtured us, who taught us how to respect people and all. So, and they are in their hometowns, and they would be joining us in Delhi in a coming week. So I'm fortunate that after this huge meeting, I would be spending time with my mom and dad.
Inshallah.
Then I would like to give you a forthcoming. It's a, I have taken 3 minutes now, so I'm particular about the time. So I'm just giving 2 more minutes, and then I will sign off. So we have a very good there are few programs which is already being organized yearly basis. So this is our 4th edition of International Oral Cancer Congress that would be happening on February 7 to 9, 2025. Then International Pink Dental Congress will be happening on March 7 to 9, and would be handled by Dr. Sonal only. So this time we are making it international. Last time we did as a Pink Dental Congress PDCon, but we would be involving the women dentists across the globe, so that people would be joining overseas. Then we would be having on occasion of World Sleep Day, International Sleep Medicine Congress. This is our 4th edition that would be happening on March 15 and 16. Then our 3rd edition World Liver Congress that is happening on World Liver Day on April 19 and 20. I'm just giving you the idea. There are 8-10 events which is lined up. Then we have International Oral Health Congress on World Oral Day. Will be happening between June 21st and 22nd. Then there is a one concept while my team is going visiting to these dental colleges. There is an oral medicine day happening around in the month of April actually. So on occasion of that, we are making one program, IOPCON, oral medicine, oral surgery, and oral pathology, and it would be happening on April 26, 27. Then there's a new concept for dental surgeons. I am announcing here because most of our people are dentists. So I'm announcing the program which is related to dental. They can join the program as well. So there is a International Young Dental Congress on International Youth Day, and it would be happening on 16th and 17th. And here we have the people who are below 40. So I am not qualifying for that. I am 45, so I won't be any in any team. I would be in a back end. I don't know, maybe Sonal would be join.
No,
Sonal looks
I'm
young.
also, I've crossed the 40 line. I've
No,
already
no, no, no. Yes,
So
women doesn't, the woman doesn't disclose their age actually. So maybe she is younger than 40.
no, I'm
So
60.
then we have one upcoming medicine which is happening, International Sports and Exercise Medicine Congress 2025, that is happening between September 6 and 7. And on occasion of World Child Day in India, Children Day is organized on 14th of February on the birthday of Chacha Nehru, but internationally it is celebrated on 20th of November. So we are organizing International Child Health Congress, where we are involving pediatricians and multiple, multidisciplinary specialists who are dealing with, problem of, child and adolescent. And I forgotten one thing where, International Women Health Congress, which Dr. Sonal mentioned in his program as well. It is happening on June with the help of Dr. Indra. She is a professor at All India Institute of Medical Sciences, and she's also regular member of us. So with these all announcement, and it is now we are still 3 minutes for 8. So we would be signing off. And there is one announcement for certificate. You would be getting the certificate on 10th of December, 10th onwards on the portal. You just log on the portal. There would be a button called Get Certificate. You're just supposed to fill your email ID. We are giving one chance because we are facing that people on hurry. They are writing wrong name. It is software generated certificates. So they get one opportunity to correct their name. They put doctor prefix before their name. Otherwise, it won't come on the certificates. So those who are PGs, they can put prefix there, and those who are faculties, they are or private practitioners, they are putting their name, and also keep it on a title case. Otherwise, title case is better rather than a block letter and all. Then my backend team will ask one or two questions, means a marketing question, like from where you get this information to make their future efforts well to get. So there is not much, one or two question, and then you submit it, and you will get this certificate on your PC or a laptop or whatever you are using. You can easily download that. So with this announcement, over to Sonal ma'am again, because she is the master and she is the driver. She took the engines. He is a torch bearer. So I think she would be, a leader of this orofacial pain experts in India now, and she will take us through her leadership forward, and she will guide us how to take this specialty forward. Over to you, Sonal.
That's a lot of
Thanks a lot. Thanks a lot for
Thank you
you.
so much, everybody, and thanks to Dr. Thomas for being a part
Yes,
of
sorry,
being a mentor.
yeah.
And he was there for all the 3 days, wherein I had asked him to join in for only half an hour or 1 hour, but he was kind enough to leave his cruise holiday and be a part of our Congress. And it's very overwhelming. I take it as a blessing. And see, I'll tell you what, saying thank you is not enough now. It is just that next year we will do much better. So if this is the bar, so next year you will see the bar has been risen to quite high, and the expectations also have been are multifolds now. So thank you, everybody, and thanks for the patient listening. And if at all there has been any mistake on my side or the team side, we apologize for it. And thank you so much. Thanks for being a part of International Orofacial Pain Congress 2024. And with that, I would like to conclude this congress. Thank you so much. Thank you.
Thanks, we are signing off.
Yeah.
We'll join again
Bye.
next year in the month.